till your 60s. I have to tell you, I've worked alongside a lot of the physicians that I worked with were 60 plus. And I have to tell you, it's a more difficult job as you get older. I'm looking into the audience, and when I was 20, 30, 40, 45, doing a night shift was easy. It's more difficult now that I'm in my mid-50s. And I still do them from time to time, but they're much more difficult than I recall them being when I was younger. So I think the issue here is there probably needs to be some type of seniority for the older emergency physicians, that they work less nights. And so I think that is probably the best solution. Maybe they work a few more weekends and a few less nights. I think that seems to be the right mix. That also takes off a little bit of the younger physicians that have time with their kids during the weekends. So I think that's the mix right there. It's, not a perfect system, but I think that's how I would address it.
Thanks. You've got a microphone. Great. Thank you.
Hi, I am Carlos from Mexico. They are the grandfather, but we are the second one. We have 37 years, and we had 37 years of emergency medicine in the world. So we are the second one. One of the things happening in the emergency medicine is that we need to tropicalize the emergency medicine in different countries. Every country has its own problem. So if you try to compare with the United States or with France, they have problems for the states because the medicine practice in the states is defensive for the states. If they don't do it correctly, they sue, and they have big problem for this. So I think the emergency medicine, I see the evolution for the 37 years. So at the beginning, like Paul said, we have less tools and we resolve the problems. Now we have a lot of tools and we make more mistakes. Why? Because if we have, one of the things happen is when, I remember 15 years ago when in Bahia, Gunnar Ollner, probably you know Gunnar Ollner, was the president of the USEM. At that time, he came to Puerto Vallarta in Mexico and he said, well, now in Switzerland, we are closing the emergency room. And say, you are closing the emergency room? So we are overcrowding all the time. How you can do that? So, because they start to organize long time ago. But when you compare this with the countries like Mexico, other countries in Latin America, also in the United States, all the time they are overcrowding. You see in the States, patients start hour and hour waiting for something. In Mexico, if you go to the emergency room, you need to wait 1 week or 2 weeks to get CT. So I think every country has its own problem. My suggestion is, first of all, we need to see. Europe, they don't have all countries recognize the emergency medicine, first of all. Second, for example, Spain, 4 weeks ago, they go to the Congress and they don't accept it. But they have fighting for 25 years or something like that. Eric, you know better than me how many years they're fighting, but they don't recognize. So we need to training that the people is working in the emergency room. I know many people is general practitioner, internals, but if you want to work in the emergency room, you need to resolve the problem for the emergency room. So probably you don't want to be specialized, but you need to take the correct courses to improve your knowledge to resolve the problems, first of all. Second, who held the doctors in the emergency room? The nurse. Sometimes the level that they have the nurse between the doctors is too high, too different. So we need to prepare people to help the doctor to resolve the problem. Because sometimes, who make the triage? For example, in Mexico, you arrive, one people is secretary, he have probably elementary school, and she decide this patient is sick or this patient is not sick, and waiting. In similar countries happen the same. So we need to do something that the access to the emergency room need to be quick, good, gentle, and effective. But you don't need to spend too much money to do that. You need to prepare the right people in the right place, in the right hospital to resolve the problem. The pandemic showed us how important is the emergency room. At the beginning, we saved a lot of lives. At the beginning, we are heroes. 2 weeks later, 4 weeks later, the heroes was the ICU doctors. Excuse me, we take the care for the patients, but they don't remember exactly what's going on. So if we work together, we'll be stronger and better, and we can resolve many problems around the world because we are similar ideas, similar knowledge, and work together and be successful in the couple of days. We need to make re-engineer to create ways in the wayside to fix it, the holes that create the pandemic in the emergency room and also in the system.
Carlos, thank you. I think there's some, if I can pick out some very important points that you've made, is that I call it the hero to zero phenomena, and it's something that we face in emergency medicine all the time. And you've encapsulated it well with how it applied in the COVID response, is a hero 1 minute and a zero the next. The second, I think, is the way that emergency departments are being used by the population is often a reflection on the expertise that are perceived to be there. And it's something that's being picked up by Eric in his presentation and by Paul and Srinath, was that we are seeing an increase in the number of emergency department presentations in favor of other areas within health systems. And that may be from a financial perspective, it may be an availability perspective, but I think a lot of the time it is seen as an expertise. If they go there, they will get the problem diagnosed and sorted because that's what emergency physicians do. There's also a perception that they will wait less time, which I don't think they've, certainly if they've sat in my waiting room of my emergency department, that's certainly not true. But thank you for your comments. I think some very valuable input made there. Sorry, could we have the mic back on there? I can't hear you. There we go.
One point more. When you're talking about the retire, you need to think about it. What is the period of the time for the sport guys? For example, Messi, Cristiano Ronaldo, Jordan, they have one period of the time. 37 is all. Like Paul say, when do you try to work in the emergency room? I think the best time to work is at the beginning, 20s, 30s, 40s. And then you need to take other positions, like training, like teaching, but you don't need to go out all the time because you are the values that you have, you need to teach for the new guys. The new guys need to understand better than us to advance quicker and in the best way. Because one of the things happen now is that many of doctors, like you said, the burnout around Europe and around the world they affected our population. So we need to create, don't go away the old doctors, support for the teaching, support for the program, but stay there because you are very helpful for the system.
All right, any more questions?
May I add a comment?
Yeah.
Yes.
Go ahead, Eric. Yeah.
A quick comment about, to summarize what you said, and I agree with one main point that Roger said. We are always on the front line, and emergency medicine, the creation of emergency medicine was in 1974 in UK, and then in Ireland and USA, and that evolution of emergency medicine are still the same concept. We are on the front line. When we create the pre-hospital EMS in France, it was just because we had a lot of road traffic injuries and we have patients dying before they come in the emergency department. It's not the problem anymore. We reduce to 10,000 to 2,000 patients who die for road traffic injuries. But the main thing we had, with the exception of India and China, they still have a lot of concern, and Turkey, about the road traffic injuries. In Europe, it's mainly medical problems that are coming through emergency departments. But the thing we are facing for now is we still are pioneer of emergency medicine, and we live day after day a new concept. Take the example of the COVID. No one in the room, and no one like myself, have faced the pandemic like that. We were the first to face that, and we deal with that, and we try to organize. So emergency medicine is also to adapt our system to the disease that like we have, and we will have to face it. And I agree with Carlos Garcia, as he said, that we do have a lot of things in common, but we have to adapt our system on our own system of our own country, because we have a different concern about the system. I will be really lucky to take the example of the emergency physician in USA. I would love to have a huge number of emergency physicians in my department, but we don't have, so we try to find some issue for that. But that's very interesting talk we have together, because I think we still are pioneer of this creation of the specialty. Thank you.
All right. Thank you, everybody. Thank you.
Enjoy lunch.
Thank you, guys. Take care.
Thanks, Eric.
Bye-bye, Eric.
Bye, friends.
And I want to give the mic to my close friend Hikmet from Ata Yurdu, Uzbekistan. We are in very good collaboration between Turkey Emergency Medicine and Uzbekistan. Yes, Hikmet, please.
Thank you very much. Yes, indeed, we are collaborating for more than 5 years, and it's a great honor and pleasure for us. It's quite challenging to start after lunch session as usual, and this is an endless battle of curiosity with physiology, but nevertheless, let's start. So, as Bajar Hojam has said, it's our really great pleasure and privilege to invite here Professor Giuseppe Brugada for his topic, sudden cardiac death. Por favor, toma la palabra.
Thank you very much, Dr. Andarov, Dr. Canterbury.
This one next page.
Okay.
Next page, and laser.
This laser?
Push, yes. Hold push button. Yes.
Okay. Thank you very much. So I will talk in the next minutes about sudden cardiac death, and I will try, first of all, to remind you the definition of sudden cardiac death, which is a form of death which is natural, which is due to cardiac causes, unexpected in time and form of presentation, that is always preceded by sudden loss of conscience, that happens in the next hour after initiation of symptoms, and this happens in someone with or without a known cardiac condition. As you know, the final rhythm that produces sudden death is, in the majority of cases, ventricular fibrillation. But there are other rhythms that might lead to the same situation, which is the asystole, complete AV block, or electromechanical dissociation. But basically, in our interest, the most important one is ventricular fibrillation. Practically any form of cardiac disease can, at the end, produce sudden cardiac death. but basically we are dealing with ischemic causes, with myocardiopathies like hypertrophic, dilated, or arrhythmogenic, but also some electrical conditions like the long QT, the short QT, Brugada syndrome, but also other conditions like the postoperative congenitals, cardiac amyloidosis, etc. All of them at some moment can produce sudden cardiac death. So if we talk about ischemic, we're talking about #1 cause of sudden death in our environment. In Europe, #1 cause of sudden cardiac death is acute myocardial infarction. So during the acute phase of the myocardial infarction, the cells get with ischemia, and they complain about this ischemia by having pain, but also by producing ventricular arrhythmias that can produce ventricular fibrillation and sudden death. So if we want to fight against sudden cardiac death in our environment, we have to fight against acute myocardial infarction and prevent acute myocardial infarction. When we are dealing with patients that have already gone through an acute myocardial infarction and have survived the myocardial infarction, in the chronic phase of the myocardial infarction, there is also a risk of having sudden cardiac death because of the occurrence of electrical circuits in the area of the myocardial infarction. The bigger the myocardial infarction, the most chances that during follow-up ventricular arrhythmia or sudden death might occur. Although in the last years we have learned that it's not only a matter of the size of the myocardial infarction, but you see here that a small myocardial infarction, very homogeneous, is a non-arrhythmogenic scar, but also a huge myocardial infarction, but very homogeneous, it's also non-arrhythmogenic. On the contrary, you can have a small myocardial infarction which are very inhomogeneous, or large myocardial infarctions, very inhomogeneous, which are really arrhythmogenic. So the point is that probably in the future we'll be analyzing the risk of sudden death in a patient post-myocardial infarction, not only because of the size of the infarct, but on the quality of this infarct and the survival of cells producing an inhomogeneous scar, which is more prone to arrhythmias than an homogeneous one. When we're dealing with dilated cardiomyopathy, we're dealing with probably what has been called the pandemic of the 21st century, because the increase in the number of patients suffering from cardiac insufficiency, dilated cardiomyopathy, because of the increasing age of the population, increasing risk factors like hypertension, diabetes, obesity, etc. Remember that 50% of the deaths in patients with dilated myocardiopathy are sudden death because of ventricular arrhythmias. So we have to treat the cardiac insufficiency, but also we have to prevent the arrhythmias in this population. When we're dealing with hypertrophic cardiomyopathy, here we are dealing with a genetically determined disease that produces a hypertrophy of different parts of the muscle, and this hypertrophy produces arrhythmias, many of them ventricular, many of them polymorphic, and many of them lethal, that might kill the patient by sudden cardiac death. And remember that hypertrophic cardiomyopathy is the principal cause of sudden death in patients younger than 40 years of age, especially sport practitioners. We also have arrhythmogenic right ventricular cardiomyopathy, which again is a genetically determined disease that produces changes in the muscle, basically in the right ventricle, but also sometimes in the left ventricle. And these changes produce the occurrence of islands of tissue in this muscle, being the basis for the occurrence of ventricular arrhythmias and sudden cardiac death, again in young population and again in sport people. However, there are a number of patients, around 20%, who had sudden cardiac death but do not present with a structural heart disease. They have a normal heart, and these are the patients like this one having ventricular fibrillation but a completely normal heart. In the last 30 years, we have learned about a new category of diseases that was unknown to all of us 30 years ago. That's what we call the channelopathies. And the channelopathies are the long QT syndrome, the short QT syndrome, the Brugada syndrome, catecholaminergic polymorphic VT, or malignant early repolarization. All of them are diseases that were unknown to all of us 30 or 35 years ago. And we understood that by looking very carefully at the electrocardiogram, we could identify some signs in the electrocardiogram that were explaining us that something was wrong in this heart, electrically speaking. Why we call that channelopathies? Because these are diseases which are familial, so they are genetically determined, but affect the channels that regulate the flux of ions across the membrane. And these channels, if they have a mutation, they will not work properly, and they will produce some signs in the electrocardiogram, but also might produce some electrical gradients in different parts of the heart, these electrical gradients leading to the occurrence of ventricular arrhythmias and sudden death. This is a patient with a long QT. Please look at the very prolonged QT interval, 640 milliseconds, corrected by the frequency at 584, extremely prolonged QT interval. When we have this type of ECG, and this ECG belongs to this lady here, you see that 7 members in her family have died suddenly because of the prolonged QT interval, and she was the only survivor in this family. So it's a very, very malignant form in this family of the long QT. This is a patient with Brugada syndrome. Look at the ECG, which shows this ST segment elevation in right precordial lead, simulating a myocardial infarction, which he has not. And when you find this type of ECGs, there is the risk in some patients that ventricular fibrillation occurs and the patient might die suddenly. Again, we're dealing with a familial disease. This is a family with Brugada syndrome. This guy here died suddenly. There are other 8 members affected in this family, and this allowed us to identify a mutation in the sodium channel that was responsible for the disease. This is the first patient we ever saw with the Brugada syndrome. That was in '86. In '92, we published the first paper. We defined the characteristic electrocardiogram. We understood the mechanism leading to these anomalies in animal models. We understood that the patient should be protected with an ICD. We could define in 1998 the first mutations in the families with Brugada syndrome. In late 2010, we could, for the first time, do some ablations in patients with Brugada syndrome in the epicardium, and certainly the future will tell us how to change the genetic defect in these families to normalize everything. Look, that it took 30 years to go from the initial description to the actual reality in the patient with Brugada syndrome, and we have learned a lot, we have advanced a lot in how to diagnose, how to risk stratify the patients, and how to treat the patients. We have also mutations in the potassium channels, like this one, producing this very prolonged QT interval. Look at this T wave, very abnormal, giant, negative T wave in left precordial leads. This is a very dangerous situation. This is a very high instability from the electrical point of view, and this patient might go into ventricular fibrillation at any time because of this very highly unstable electrocardiogram and repolarization defect that might produce certainly some arrhythmias and producing sudden death. So when we're dealing with the long QT, we have the long QT3, which is the one affecting the sodium channel, but then we have the 1 and 2 that affect the potassium channel. So the result at the end is the same by different mechanism. The result is that the repolarization is prolonged, so the QT interval is very much prolonged, and at the end, ventricular arrhythmias, sudden death can occur because of this gradient between different parts of the heart. Also, we described in the year 2000 the short QT interval, the short QT syndrome. We saw these patients, these first initial patients in the year 2000, especially this one here, that was a lady, 25-year-old, that had a syncope. And we received the ECG of this patient, and we thought that it was a mistake because the QT interval in this patient is no more than 200 milliseconds, extremely short QT interval. So at that time, we asked for a repeated ECG because we thought that the machine was not working properly, and we received the same ECG, so we understood that this was probably the first case of short QT syndrome ever described. Unfortunately, this lady, this was a Friday evening, and we asked the lady to come to our hospital, but the lady was living 100 kilometers away, so she decided that she will come to our consultation on Monday because she had a very young boy of 5 or 6 months of age, and unfortunately on Sunday morning, this lady died suddenly. So then we learned that this was a familial form. Here you have some families with a short QT syndrome. Look at these very short QT intervals, very tall T waves, and very short QTs in families with sudden cardiac death. So probably this is the most malignant of all the channelopathies because of the very short QT interval. There is a huge window of vulnerability in these patients, and any arrhythmia, any extrasystole might produce ventricular fibrillation and sudden death. That's why probably there are very few patients described with the short QT syndrome all over the world, probably because they are dead. This is a polymorphic, bidirectional ventricular tachycardia, and this is specific from a condition called the catecholaminergic polymorphic VT. Again, a familial disease, genetically determined disease produced by a mutation in the ryanodine channel. The ryanodine channel is the channel that regulates the flux of calcium inside the cell. And during mental or physical stress, the flux of calcium increases. If the patient has a mutation in the ryanodine, this flux cannot occur, and there is an accumulation of the intracardiac calcium, and this produces an intoxication of the cell, and finally produce this type of arrhythmias that you see here appear during a stress test or mental stress test. This is the ryanodine channel and how the calcium accumulates inside the cell and produces this type of arrhythmias. Finally, the last situation described is what is called the malignant early repolarization, which occurs in patients having this abnormality at the end of the QRS complex, like an early repolarization that in some cases might be responsible for the occurrence of ventricular fibrillation. In some patients, there is an overlap between this early malignant, early repolarization and Brugada syndrome, and still it has to be studied in the future. At the end, all of these diseases produce ventricular fibrillation because of this electrical gradient between different parts of the heart. So we can say that genetic studies have identified a new category of diseases responsible for syncope and sudden cardiac death in patients without demonstrable structural heart disease. That's what we call channelopathies. The good news is that if you look carefully at the ECG, you will find the signs to identify the patients at risk. So be careful and read carefully the ECGs and learn how to identify the patients that might be at risk. So, of course, in the patients that are recognized as patients at risk, we have to protect them. And we protect them basically by using implantable defibrillators. As you know, implantable defibrillators are extremely reliable devices that identify the ventricular arrhythmia and treat them very effectively in the majority of cases. But we know, and you know as emergency physicians, specialists, that time is what counts. So not everybody can be identified and can have an ICD implanted. The majority of patients that are at risk for sudden cardiac death do not have an ICD implanted because they have not been recognized. And we know that every minute that lasts, we have 10% less chances of surviving. So we need early defibrillation, and early defibrillation requires, of course, very good emergency systems, but also we need public access defibrillation that might allow for the general public to use these devices and to treat the patient waiting for the emergency system to arrive. There is a study in Japan that compares the number of public defibrillators installed in the countries and the number of patients that are shocked when they have a cardiac arrest. And of course, the more devices you have in the street, the more probability that you will be shocked by a bystander if you have a cardiac arrest. And this is my last slide. This is the number of deaths in car accidents in Spain all over the last years. And you see that they did a very good job, because you see that from the 60s we had an increase maximum in 1989, and since then the decrease is dramatical. So they did a lot of very good jobs, a lot of investment, a lot of money, a lot of fees, a lot of fines if you were too fast in the street, you were not having your protection, whatever. So a lot of money invested to go from almost 6,000 to 1,000. Do you know how many patients died suddenly in Spain? 10 times this number. And the number or the amount of money that is invested is 10 times less. So, of course, this is very important, because the politicians should also understand that sudden cardiac death is a major public problem, and investment in preventing sudden cardiac death should be at the level that it deserves for the number of patients suffering from it. Thank you very much.
Thank you very much for this great presentation. I think we can take the question, the last. Yes. Yeah, okay. Okay, thank you very much. We will take the question later. Okay. Yes, yes. Now I want to invite the second speaker, Dr. Hikmet Anvarov, about aorta dissection.
Thank you very much. Herkese merhaba. So it's a really great honor to me to be here with you again. And as I've taught you this morning, the main focus in our hospital in Uzbekistan is on the ascending and descending thoracic aorta. Yep. Closer. Okay. Is it good now? Thank you. So some protocol things, I have nothing to declare, only I would like just to stress the contribution of my angio and cardiovascular department in designing these slides. So the dissections of aortic aneurysm is, as you know, all the condition characterized by a rupture of the inner wall of the artery intima with the formation of the false passage for the blood. And about 50% of patients with untreated aortic dissection will die within 2 days, maybe, is a risk of death within the first hour for acute aortic dissection is about 1%. So time matters. In large medical study, including almost 1,000 patients with aortic dissection, almost a third of them died within 2 days, and 2/3 within 2 months, and almost 90% within 3 months, and almost all of them within 6 months. So it's really a huge problem. The frequency of occurrence due to several studies is it's about 3 per each 100,000 population, and average almost 1,000 cases per year in my country with a population of 33 million people. So all of us, we well known about the types of classification of aorta aneurysms. There is grades, 5 grades by Svensson, and also the most common things is Stanford's and DeBakey classifications. So the aim of the study, what we held in this year in our hospital, it was to evaluate the direct results of the first experience in surgical treatment of ascending aortal dissection aneurysm type A by Stanford. So these are materials, the retrospective analysis. We had 6 patients which we underwent for the surgical interventions, because the closed transcutaneous interventions has been described on the morning sessions. I would like just to stop more on the surgical ones. So 2 of these 6 patients had concomitant ischemic heart disease. In one case, we obtained grade 3 of aortic valve insufficiency, and in one patient also the intimal tear was located on the proximal part of the aortic arch. So all surgeries were performed using the method of the in the stopped heart or the own pump with the artificial blood circulation. And here are the results. So average duration of the circular arrest was about 45 minutes, and the temperature we decreased it for less than 22 degrees. And of course, the retrograde hypothermic cerebral perfusion we provide in all patients. Here are some demonstrated things. We used the prosthetic for aortal arch and for descending aorta. Here are some stages from the surgical part. In 4 cases, the patient underwent supracoronary replacement of the ascending aorta. In one case, the aortic root replacement as a Bentel de Bono surgery. In one case, supracoronary replacement of the ascending aorta was supplemented with arch replacement. And Vascotec vascular prosthesis was used in all surgeries. Biological glue also we applied. We didn't apply it. And coronary artery bypass graft was performed as a concomitant interventions in 2 cases. As I said, this was that Bentel de Bono surgery. So, in postoperative period, we saw the 2 patients with signs of stroke, unfortunately, and the mortality also obtained in 2 patients. In one case, we obtained encephalopathy, but required early tracheostomy for prolonged ventilation. The average blood loss was about 900 milliliters. So in tape A, aortic dissection, about half of the patient within the first 48 hours, the perioperative mortality in half of the patients with ascending aorta and more than 50% in aorta arch. In type B, the presence of the complications mortality is the same almost, and the perioperative mortality is in between the one third and half of the patients. And other types of the surgery in ascending aorta, it's average about 5%, no more than 5% in our hospital. In a big dissection involving the thoracoabdominal elements, it's about 11%. And in abdominal aorta, we consider more, moderately more easier. It's about 5% mortality nevertheless. So, obtained experience of surgical treatment of descending aorta aneurysm showed that timely detection and surgical treatment, of course, can achieve satisfactory result with, let's call it, satisfactory, of course, in comparison. Mortality, it's about 1/3 of all patients. Otherwise, all of them will die. And further improvement of our result associated with the increase of the experience, of course. Thank you. Teşekkür ederim.
Thank you very much, Dr. Hikmet. We will take the question later, and I want to announce the last speaker. Everybody in Turkey know him, Roger Dickerson from South Africa. Please.
Short presentation.
Yes, it's very good. Wow, wonderful. I understand it. I understand. I understand that. Short translation is very good. Very good.
Emre said me 2 days before that.
Yes.
I have to do it.
Because there are lots of topic and yes, they interest, but very, very tired.
Good afternoon, everybody. I'm a great fan of movies from the 70s and 80s, and one of my favorites was Dirty Dancing. I don't know if anyone remembers that, or looking around the audience, I'm not sure if anyone was alive when that was actually on the silver screen. But one of the comments made was, nobody puts baby in the corner, and I hate getting poked into the corner. So I tend to move. I apologize if I make you seasick, but we'll see how we go. So this is my hometown of Cape Town, and I work at New Somerset Hospital, which was actually the first hospital built in South Africa, purpose-built, and was actually the first teaching hospital of the university in South Africa. It is positioned in the waterfront, and so it's a really difficult place to work. But when it was first brought about, it didn't quite look the same. And this was when they were still constructing it back in 1806. But let's talk about this afternoon. Now, it's an interesting topic, and I must admit, I have to declare that I was a substitute. It was a topic that one of our esteemed colleagues had chosen, and he was unable to make it. And I must admit it was a very interesting topic. And so I'm literally hoping that whilst I know Prof. Kande is a great fan of soccer, I'm really hoping that I don't score an own goal when I go through this topic. And what we're going to be looking at this afternoon is the what if. We're going to be looking at the what if our gold standard of managing patients is not available. And I hate what if scenarios, but it's something that we do need to plan for. Because unfortunately, we don't all work in scenarios that are often portrayed in Hollywood. I have never been in the situation where I have been able to park my high-heeled shoes under a bed, or where martinis are brought to me in an on-call room. But the one thing that Hollywood has shown is that in a golden standard environment, anything can be done. Now, I'd like to ask a question. If I look around the room and I ask the question, who here has access to PCI in their facilities? Can I ask you to raise your hands? Hold them up high. Okay, so it's probably about 5% of people in the room. Can I ask you to keep, for those who put your hands up, keep them up for me? Nice and high, wave them. I'm old, I don't see so well anymore. Good. All right, keep them up. This is your calisthenics for the afternoon. Okay, keep your hands up. Now, for those of you who've got access to PCI on a 24-hour basis, or is it only during certain times? So we're looking, if I look around this room, thank you for your participation. If I look around this room, very few of us have actually got access to the gold standard in managing some of these cases. And so I'm going to talk through an approach. Now, for those of us who don't have PCI, thrombolysis does tend to be that savior of the universe. If we select it for the appropriate cases, and we select it for the appropriate individuals, it can certainly save lives. Now, if we think about the indications for thrombolysis, there are many applications. Some of them apply to acute cardiological emergencies, but there are many others that apply. So looking at the management of acute stroke, for instance, or for pulmonary embolism, or looking at peripheral vascular matters. But if we're looking at it specifically with regards to cardiological emergencies, they tend to become far more narrowed. So if we think about the concept of the acute coronary syndromes being a scale or a realm, a continuum, where it starts with something as simple as angina pectoris on the one side, it then progresses from angina, it will progress onto unstable angina. We'll then end up looking at something like a non-ST elevation myocardial infarction. And there we can make true interventions with regards to thrombolysis. We're looking at your true STEMIs. Now, if we look at this continuum, the spectrum of the acute coronary syndromes, the application of thrombolysis is actually in a rather small subgroup. And the reason for that is that not only do you have to have a STEMI diagnosed, you need to confirm that it is not one of the channelopathies that Prof. Brugada spoke through, that we often can mistake it for. We also need to look at things like, do we have access to PCI? And if we don't have immediate access, what time frame would we have access to? And there's been various timelines that have been postulated. But the suggestion is that if you don't have access to PCI within 2 hours, we should be proceeding with thrombolysis. Now, in the facility that I work, we do have a cath lab, but it doesn't operate on a 24-hour basis. And so, depending on the time of day, will change our approach to these cases. So time is an aspect. There are indications and contraindications that need to be applied from a patient perspective, and they need to meet the diagnostic criteria. And so it really is a very small subgroup. That very small subgroup of the acute coronary syndromes that can, in fact, be thrombolyzed. But now the problem that we often run into in these scenarios is that we use it as our base therapy. But if we are not able to access it for our patients, we start getting ourselves into a bit of a quandary. Because as you're aware in medicine, it's never as simple as a yes or a no. Because if we look at the things like the contraindications, and if there are absolute contraindications, that makes a lot of sense. And you'll see contraindications listed on thrombolytic checklists in many organizations and published in many journals, etc. Those are fairly finite. Those we can accept. The ones that pose quite a difficult thing for us are the relative contraindications. Because here, we are needing to apply our minds and balance risk. Balance the risk of an event occurring from the therapy that we are instituting versus the risk of a patient having a worse outcome from their primary pathology. And what it really does is that it ends up being a yes, a no, or a maybe. And it's the maybe group that gets us into a quandary. Because our decision-making isn't binary. Our decision-making in offering in emergency medicine is based on a lot of input with regards to how much information we've got at the time. And this can lead us to a vicious circle. We've got a patient who needs to be thrombolyzed, but meets a criterion that would be a contraindication. If we don't have access to PCI, what do we do? And if we look at all of the treatment protocols that have been published, it starts primary PCI is really the way to go. If you can't do that, then thrombolyze. But now if you can't thrombolyze, those patients should be going for PCI, but that's not available. And we end up getting ourselves into quite a vicious circle. I'm going to try and simplify this a little bit. And it's because I tend to operate best at 3 a.m., and when I'm operating at 3 a.m., I need to have things simple. So, you've diagnosed a true ST elevation myocardial infarct. You ask yourself, do I have PCI available? And the 20 or 30 people in the room that have got PCI at their facility and have got easy access to it round the clock, that's the route that they will go. They will say to themselves, that's great, let's say yes, we've got PCI and we're going to proceed with PCI, and we know that that does have the greatest, better outcomes. So that's a green, that's good. The difficulty comes is that if our PCI is not available, and that is where we are needing to consider the thrombolysis. But before we can do that, we need to look at those contraindications. And again, it's not a yes or a no. If there are no contraindications, the decisions are easy. We can proceed with thrombolysis, and we need to do that as soon as possible to restore perfusion and save muscle. If the answer is yes, there are absolute contraindications, then we can't proceed with thrombolysis. And we'd have to consider them alternative maximal medical therapies to try and improve a patient's outcome, but we're not going to be able to save that muscle. But it's the middle group that often leads us to quite a bit of difficulty, and those are the maybes. And in that group of the maybes, we're needing to balance the risk. And I think this is where we find ourselves often in a position of difficulty. The green is the easy, the red is the easy. The difficult one is where we as clinicians are having to balance risk. Balancing the risk of an adverse outcome from our therapy versus the risk of an adverse outcome from the original pathology. And we can go round and round and round in ourselves trying to find a solution. But we know that in emergency medicine, there is something worse than a bad decision, and that is no decision. And that's often where we run ourselves into difficulties, that we're needing to make a decision with limited information at the time. Now, there are a host of medical interventions which I'm not going to be going into here. We can look at the antithrombotic therapies, the good old aspirin, to try and stop that clot getting any bigger or propagating elsewhere. We can look at other medical therapies in an attempt to try and limit the damage, or if there has been damage, to try and improve the outcome. But it all comes down to that balancing of risk. Now, in the international session earlier this morning, Eric Review spoke about the pressure keg of the emergency department, and he very kindly put my head in a pressure cooker. And so, with tribute to Eric Review, who presented earlier today, I think we need to take an approach that I'm going to give his nomenclature. We need to evaluate the risk, the indications, and the contraindications. So we need to do an ERIC. And if you think about it, we're reviewing those factors, and we can do an ERIC review, or rather, an ERIC review. We need to evaluate the patient, evaluate the risk, and then make a decision. And it needs to be timeous. The longer we wait, the greater the pathology. The maybe group is the most difficult one that we have to manage. It is non-binary. We take risk ourselves, but at the end of the day, the patient takes the ultimate risk. Thank you very much.
Thank you very much. Baie dankie.
Dis 'n groot plesier, baie dankie.
Yes, thank you very much. I think we have time for the question or comment. Any question or comment for all speakers? Okay, we can start from Emre. We have question.
Hello, my name is Emre Atish from Karabük University. I have a question for Professor Brugada. Before your presentation, Professor Brugada, we had a patient who suffered long QT and VTAC. After we analyzed the ECG, we found that ECG axis was changing constantly. Is it a common sign of long QT syndromes, or is a bizarre thing?
Sorry, did you get the question? I'm sorry, did you get the question?
Sorry, could you just repeat that question? We were just struggling to
yes,
hear.
Yes. Before your presentation, we had a patient with long QT and VTAC. After we took the ECG, we found that ECG axis was changing constantly. So is it a common sign for the VTAC with long QT syndrome, or is it a bizarre thing?
I'm sorry, I'm having a result of the sound again. I'm getting close to it.
It's a personal consult.
Yes. I'm sorry. Before your presentation, we see a patient who had long QT and we take a test. And after we took the ECG, we found that the ECG axis constantly changing. Is it a sign of the long QT channelopathies or a bizarre thing?
What was the sign? What the?
Axis, ECG axis changing constantly.
Oh, the axis.
Yes.
Okay. Sorry, I'm sorry for that. No, the T wave, yes, but not the axis of the ECG. I mean, the axis of the ECG, if you mean the QRS complex axis, this is not a long QT sign. This is a conduction system disease sign. But if you have a changing in the axis of the T wave, then of course this is something that you should take into account because it's clearly related to the repolarization. It is a very poor sign, normally indicates a very high risk.
Okay, thank you. And Iqbal, okay.
And thank you for all the professors for their great presentations. I want to add something about Professor Rogers' questions about the PCI. I think we couldn't get the question or we misunderstood. In our country, more than 90% of the patients from ST elevation MI, they are underwent to PCI. And I have a question for Professor Brugada. The patients are coming to emergency or emergency department for the syncope or loss of consciousness or chest pain, and we diagnosed Brugada syndrome. But even they are stable. Are all the Brugada syndrome patients must underwent to the ICD replacement before discharge, or can it be delayed?
Prof. Brugada?
Okay, so the first thing, we have to make sure that he has a Brugada. And that's the first thing, okay? Why I say that? Because there are many patients that do have what we call a type 2 or type 3 ECG and not a type 1. And this should not be classified as Brugada. This is just an ECG which is suspicious, but it's not diagnostic, okay? So the first thing is that you need the type 1 ECG to make the diagnosis of Brugada. If the patient has a cardiogenic syndrome, I mean, if the patient has had a cardiac arrest and has been recovered, of course, you have to do whatever you have to do, and probably the patient should be on a defibrillator before it leaves the hospital. If the patient has a cardiogenic syncope, so syncope which is clearly cardiogenic with no prodromes, and you have a type 1 ECG, probably this is a patient that should receive an ICD. But be careful, because this is the minority of patients. The majority of patients do have a syncope or do have a chest pain or do have palpitations, and then they are diagnosed because they have a type 2 or type 3. Be careful. This is not yet a Brugada syndrome. This is not yet something that you have to treat as a Brugada. You have to do the test. Sometimes you have to do pharmacological tests to see whether you get the type 1 or not. And in our hands, you will always do an electrophysiological study to make sure that the patient is inducible before implanting the patient. You know that this is controversial in different departments, but we always do electrophysiological study.
If I could just, it pleases me greatly that you've got access in so many of your facilities to PCI. It's certainly not like that in other parts of the world, where we find that healthcare is very stratified, and cardiology, for instance, in the system that I work in, is considered a super specialty, and it's housed at the tertiary level hospitals. So it is a very small minority that will have primary PCI. And it's not only with regards to getting the patient to, and so if I look in working in the metropolis of Cape Town, we should be able to get a patient to a PCI suite within the necessary timeframes. The difficulty is that we've got large rural areas with long distances, and getting a patient to those facilities becomes problematic. I previously worked at Krishnani Baragwanath Hospital, which is in a township called Soweto, a very large tertiary academic hospital, but with a cardiology department that I used to have to pull out of the emergency department because they would come hunting for patients to take to PCI. And what it meant is that none of my residents ever learned how to thrombolize because the cardiologists were so active, which is, it's not a complaint, it's great for the patients, but when I move to, and our residents go to other places, they've never had the exposure to the difficulties that thrombolysis can have. And it's easy when it's a true yes or a true no, that's easy. It's making that maybe call, balancing the risk of the relative contraindications versus the risk of the patient actually dying from the myocardial infarct. And also the difficulties of which thrombolytic to choose. Do you go a fibrinolytic or a thrombolytic, or what is going to be best for the patient? It also comes down to finances. In my facility, we have limited access to the true alteplase or any of the TPIs, but we've got free access to streptokinase. And so it becomes that difficult scenario of not only deciding whether the patient should get thrombolized or not, but then which agent to do it with. And I think it thrills me that you've got such free access. May I ask just to sign who here has thrombolized myocardial infarct? Maybe that was a better question to have asked.
Okay, thank you, Roger.
Okay.
Any another question or comment? Yes, Dr. Ayman, please.
Thanks, Dr. Borogada, for this excellent presentation. Do you know sudden cardiac death is a disaster, actually, and it's common in poor country like South Asian. Do you have any recommendation to have a screening plan, for example, in the school, for the student to screen for ECG to pick up who has the channelopathy, and is this any patient who has channelopathy, the ECG finding, it's present since birth or it changed with the age? From this, we can know what age we can screen if it is possible. Thank you.
Thank you. That's a very good question. That's one of my fights with administration and politicians, is that everybody should have at least one ECG performed during lifetime. I'm a teacher, professor in the university, and I always ask my people in the room, I will say how many they are, 22, 23 years old, my students, and I always ask them, how many of you have ever had an ECG? And it's always less than 50%. And these are medical students. So imagine in the normal population that is even less. So I've been fighting, and I keep fighting for the possibility that everybody has one ECG performed in life that will detect, of course, Wolff Parkinson White, long QT, short QT, Brugada. I might suspect hypertrophic cardiomyopathy, rhythm disturbances, whatever, you know. It's cheap, it's easy, it's innocuous, it's without complication. I do myself, in the area where I live, which is an area of about 50,000 inhabitants in the north of Barcelona. I do every year an ECG to every single boy and girl in the school at age 14. Okay. Why 14? I don't know it very well. I decided some years ago, but I don't know very well why I decided 14 and not 16 and not 12. Probably 14 because there are diseases like hypertrophic cardiomyopathy that the abnormal ECG is only visible at a certain age when the heart is already big enough. It's true that you might miss some patients with some conditions before that, but normally if this is a patient with a genetic disease normally you have some suspicion in the family, and then of course you do the ECG. But as a general screening, I think 14 is a good age. If you only have one bowel, you only have one in your life, I would say 14. If I have 10, then I would say at 2, at 10, at 20. But if you only have one bowel, I would say 14 is a good age. But I don't know why, but that's my feeling.
May I ask, in those screenings, how frequently do you pick up issues with these children?
Okay, so we do about 500 ECGs per year, okay? The first thing that is very curious is that 12% of the parents do not allow us to do an ECG on their child, which is something incredible for me. I still don't understand, you know. Say, look, this is free, I will do it, there is no problem. So, of course, we ask for a small record on medication or symptoms, family history, etc. And then authorization of the fathers to do the ECG. And 12%, every year, 12% say no, so which I do not understand, but that's okay. Then, on the 88% that we do, which is about 500 per year, we found 3% of ECGs which are suspicious of something, which are, let's say, not normal. And then, of course, we exclude here incomplete right bundle branch block and things like that. We don't care about that. So, abnormal. And then in this 3%, basically what we do is an echocardiogram, sometimes a Holter, sometimes a stress test, but basically an echocardiogram. And finally, we find 0.7% of ECGs that have something which is really abnormal, which does not mean that requires treatment, okay? But that they are normal and the patients should be followed up every year, whatever. So it's about between 3 and 4 ECGs per year, or patients per year, that has something that should be followed. Of course, we found Wolff-Parkinson-White, which is asymptomatic. We found some long QT. We found some suspicion of cardiac hypertrophy, or patients that do have a lot of extrasystoles, ventricular extrasystoles, and then you have to follow them. We had one with a suspicion of how you call that, an abnormal coronary artery that we could suspect on the ECG, and it had to be operated, so we found things.
If you take those numbers and extrapolate them to a country's population, those become huge.
Sure.
And those are numbers of lives that could be saved.
Yeah, but if you do that, it is like, why should you not do that once in lifetime, you know? And we're doing it at 14, but maybe when you get your driving license, whatever. At some moment that the majority of people do, not the military service, which was before, because now there is no obligatory military service, so you cannot have it. And of course, you will find things, and you will find things that you might, you know, see every year, new patients coming, or patients that should be suspected of something, and of course you will have to do echoes and stress tests and whatever. That's true, but that's prevention.
Yeah.
Thank you very much, Brigada.
Thank you.
And we finished the time, and we have to give very 10 minutes, only 10 minutes. After 10 minutes we will come again for Satellite Symposium. Arkadaşlar 10 dakika sonra uydu sempozyumu sadece bu salonda var. Çekiliş yapacağız. İsimlerinizi yazdırın. İstediğinizi veriyoruz çekilişte, ona göre. Tamam. Thank you very much. Ortam. Çok teşekkür ediyorum. Burada bize verdiğiniz destek kongrenin bir parçası olmak, burada bulunmak, hepsi her şekilde bize güç veriyor. İşte bu güç veren şeylerden birisi de uydu sempozyumlarımız. Bugün kardiyolojiyle başladık, kardiyolojiyle devam edeceğiz. Biliyorsunuz akut koroner sendromlar acil tıbbın en önemli kısımlarından birini oluşturuyor ve bizim uzun dönemde baktığımız acil vakalarında büyük oran kardiyolojik aciller olabiliyor. Yani %20'nin üzerinde, %25'in üzerinde gerçek acil vakalar için söylüyorum. Kardiyolojik aciller oluyor ve bunlara müdahale ederken çok daha dikkatli olmamız lazım. Çünkü gerçekten iyi tedavi, iyi sonuç. Yanlış, eksik tedavi, kötü sonuç çok belirgin olan bir hasta grubu. İşte bu önemli sendromda çok önemli bir tedavi, eski bir dostu inceleyeceğiz. Şimdi eskiden bilirler, filmler, bilmiyorum, bir Mehmet Hoca var benim bilen, bir de Zeynep Hoca, Zeynep Hoca küçük bize göre de, o eski filmler olur ya Yeşilçam'da, göğsü ağrırdı, bir tane cebinden bir teneke çıkardı, sarı teneke. Üstünde ne yazar onun bilir misiniz? İşte bilene ödül vereyim. Efendim? Firma olmaz ama firma söylemesin, o bilir. Trinitrin, sarı bir kutu. Nitrattı yani, trinitrat. Onu alırdı, iyileşirdi. Şimdi o dönem bitti. Ondan sonra spreyler geldi ya. Spreyler çok avantajlıydı bizim için. Filmlerde yer almadılar ama iyiydiler. Sonra spreyler ortadan gidince biz tablete kaldık. Şimdi yeniden hani popüler olma, daha doğrusu yeniden önümüze gelme şansı yakaladık. Onlarla ilgili de güzel bir sunum olacak. Profesör Doktor Zeynep Gökçen Çakır alkışlarınızla kürsüye davet ediyorum.
Daha fazla adım olsun diye biraz uzağa oturdum. Sahneye çıkmam zaman aldı. O arada adımlarımı da saymaya devam ediyorum. Ben kazanacağım inşallah diyorum. İndirdiniz mi uygulamayı? Evet, Başar Hocam zaten neredeyse benim anlatacaklarımı anlatıp bitirdi. Ben de size yine de kısa etkili nitratlarla, Başar Hocam'ın dediği gibi o eski dostla ilgili bir şeyler söylemek istiyorum. Yani çağları deviren, çağları yıkan, yeni çağ açan, orta çağın karanlığını sona erdiren kara barutun icadından sonraki en önemli kimyasal icat, ilk kullanışlı patlayıcı olarak icat edilmiş bir madde, gliseril trinitrat veya trinitrogliserin dediğimiz madde. İtalyan kimyager Sobrero bunu icat ediyor. İlk patlayıcıyı geliştiriyor ve kendisine progliserina diyor bu madde için. Ama daha sonra Barış Ödülü'yle tanıdığımız İsveçli kimyager Nobel bu patlayıcıya çok büyük bir ilgi duyuyor ve en büyük gelişmeleri Nobel'in şirketi kaydediyor ve bu patlayıcıdan bir dinamit icat ediyor. Bu patlayıcıdan dinamit icat ediyor çünkü hem savaşların hem teknolojide hem sağlıkta en önemli gelişmelerin yaşandığı bir yüzyıl. Çok önemli gelişmelerin olduğu bir yüzyıl. Ve sağlıkta da aynı şekilde, aynı teknolojide olduğu gibi daha fazla ne yapabilirim, yeni ne üretebilirim çabaları var. Bir İngiliz doktor bu trinitrogliserini inceliyor ve bundan ne için kullanabilirim sorusunu kendisine soruyor. Ama ondan önce Alfred Nobel, Sobrero'nun bu icadından dinamiti icat ediyor demiştik ve İsveç'te ilk dinamit fabrikasını kuruyor. Maalesef kardeşini dinamit kazasında kaybediyor, kendi erkek kardeşini dinamit kazasında kaybediyor ve ondan sonra ilk nitrogliserin fabrikasını Almanya'da açıyor ve sonra da Amerika'ya sandıklarla tren yolu yapımları için Amerika'ya sevk ediyor. İşte Red Kit hikayelerine nitrogliserinin konu olması bu nitrogliserinin Amerika yolculuğuyla başlıyor. Epey bir zaman geçtikten sonra daha birkaç sene önce Beyrut'ta yaşadığımız o kanlı patlamanın sebebinin de yine nitrogliserin olduğunu söyleyip insanoğlunun bu patlayıcı icadının, bu büyük keşfinin nasıl sağlığımıza faydalı bir şeye döndüğüne geçmek istiyorum. İlk kez William Merrill tarafından 1878 yılında anjina krizlerini tedavi etmek için kullanıldı ve aynı yılda Merrill bunu yayınladı, duyurdu. 1896'da ölümünden hemen önce de Nobel bir arkadaşına yazdığı mektupta, ki mektubu görüyorsunuz, orijinal halinin fotoğrafını da buldum. Dahilen kullanmam için bana nitrogliserin reçete edilmiş olması kaderin bir cilvesi anlamına gelen bir arkadaşına mektup yazıyor. Çünkü bu olaydan, özellikle de kardeşinin ölmesinden zaten çok etkilenmiştir Nobel. Nobel Barış Ödülü'nün de bu yüzden konulduğu söylenir. İnsanoğlunun bu patlayıcı icadı 130 yıl süren, Başar Hocam'ın söylediği gibi çok eski bir dost kazanmamıza sebep oldu. Tıp dünyasının çok eski bir dost kazanmasına sebep oldu ve güçlü bir vazodilatatör olarak şimdiye kadar tıp camiasındaki yerini aldı. Nitrik oksit üzerinden salgıladığı yıllar, bu vazodilatasyon yapan maddeyi nitrik oksit üzerinden salgıladığını yıllardır biliyoruz ama 2002 yılına kadar hala bu konuda gelişmeler o kadar cazip ve incelemeler o kadar fazlaydı ki 2002 yılında da aldehit dehidrogenazın buna sebep olan mitokondriyal enzim olduğu keşfedildi. Kabaca organik ve non-organik nitratlar olmak üzere ayırıyoruz. Bugün üzerine en çok duracağımız gliseril trinitrat, nitrogliserin organik bir nitrattır arkadaşlar. Dediğim gibi nitrik oksit üzerinden yapar vazodilatatör etkisini ve guanilat siklaz bu dönüşümde rol oynar. Düz kas çeperinde, endotel hücrelerinin yüzeyinde meydana gelen bu enzimin indüklediği reaksiyonla nitrik oksit salınır ve vazodilatatör etki gelişir. Nitrogliserin nitrik oksit üretimini tetikleyerek veya onun eylemlerini taklit ederek birçok özelliğe sebep olur. Damarları genişletici birçok özelliğe sebep olur veya bizim istediğimiz vazodilatatör etkiyi sağlayacak birçok farklı eylem yapar. Bunlardan bir tanesi zaten bildiğimiz nitrik oksit üzerinden yaptığı doğrudan vazodilatasyon. Vazokonstrüksiyonu inhibe ederek dolaylı bir vazodilatasyon da yapar. Ayrıca vasküler endotolyuma trombosit salınımını engelleyerek antitrombotik etki de yapar. Antienflamatuar etkiyi lökositlerin vasküler endotolyuma yapışmasını engelleyerek yapar ve aynı zamanda antiproliferatif etkisi de vardır. Anjinadaki, daha doğrusu akut koroner sendromlardaki yolculuğumuzda Başar Hocam zaten ufak bir giriş yaparak başladı. Bu konudaki en son kılavuzdan aldığım bir cümle ile ben de sunumun en can alıcı bölümüne başlamak istiyorum. Nitratlar yalnızca arterleri ve arteriyolleri genişletmekle kalmayıp aynı zamanda seçici venöz dilatasyonunu da indükledikleri için hem art yükü hem de ön yükü azaltan benzersiz vazodilatatörlerdir diyor. En son 2020'de yayınlanan Avrupa Kalp Cemiyeti'nin kılavuzunda, akut koroner sendrom kılavuzunda. Bu özelliklerini de ve çok kullanışlı bir preparat, farklı farmakolojik şekillere girme özelliğine sahip tablet formu, sublingual tablet formu, ayrıca transdermal formu, sprey formu, birçok farmakolojik yapıya da ticari şekle dönüşme özelliğine de sahip çok kullanışlı bir preparat. Bugünkü konumuz aslında kısa etkili nitratların acil serviste kullanımlarıyla alakalı. Tabii ki en önemli yeri de akut koroner sendromlar burada teşkil ediyor. Ana kullanım alanlarımız. Çok yeni bir çalışma, Türkiye çapında yapılmış geniş çaplı TÜRKMÜ çalışmasında bizim toplumumuzda en yaygın akut koroner sendrom bulgularının tipik göğüs ağrısı ve dispine olduğu vurgulanır. İşte nitrogliserinlerin çalıştığı ana yerde burasıdır. Tipik göğüs ağrısı ve dispineyi düzeltmek için çalışırlar. Gördüğünüz gibi şöyle kabaca size bir antianjinal ilaçları sınıflamış oldum. Nitrogliserinden hala 130 yıl geçmesine rağmen burada çok önemli bir madde olarak yerlerini alıyorlar. Farmakolojik ajan olarak yerlerini alıyorlar. Ve hala 2022 yılına geldiğimiz zaman hala daha nitrogliserinle ilgili review'lar, çalışmalar yapılacak kadar da önemli bir yeri var. Kardiyolojik özellikle olaylarda ve birçok tıpla ilgili birçok alanda çok önemli bir yeri olan ilacımız. Acil serviste kullanımıyla ilgili aslında tabii ki akut koroner sendromlar ve şimdi sıralayacağımız birçok nitrogliserinin etkili olduğu tıbbi durum acil serviste gerçekleştiği için, ilk başvuru yeri acil servis olduğu için aslında nitrogliserinin de en çok kullanılacağı yerler acil servislerdir. Yine işte az evvel sunduğum çalışmadan aldığım bir bölüm diyor ki özellikle semptomların başlangıcından sonraki ilk 10 gün içinde mortalite başta olmak üzere erken kullanımın ne kadar erken başlarsa nitrogliserin kullanımı o kadar fazla etki eder. O kadar çok etki eder. Burada erken kullanımın altını çizmek istiyorum. Ne kadar erken başlanabilirse bu erkenlik saniyelerle, dakikalarla ölçülen bir erkenlik düzeyi. Onu saniyeleri, dakikaları geçtiğiniz zaman da günler içerisinde başlanabilmesi, mesela stabil anjinada bir an evvel reçete ediliyor olabilmesi çok çok önemli. Eskiden kullanıldığı, artık kullanılmadığı bir yer var güncel kılavuzların vurgu yaptığı. O da tanı amaçlı kullanımı. Eskiden göğüs ağrısının tipik vasfını değerlendirmek için nitrogliserin verilip eğer nitrogliserine cevap veriyorsa bu ağrının koroner sendrom olduğu yönünde, koroner arterlerden kaynaklandığı yönünde bir genel kanı oluşurken daha sonra özofagus üzerinde de özellikle özofagus spazmlarının da aynı şekilde nitratlara iyi cevap verdiği görüldüğü zaman bu ayırt edici özelliğinin olmadığı ve tanı koyma amaçlı kullanılmaması son kılavuzlarda özellikle vurgulanıyor. Bu görmüş olduğunuz 2014'ün AHA kılavuzu. Halihazırda 2020 en taze kılavuz 2020'de ESC'nin yayınladığı kılavuzdur ve Klas 1C bir öneri olarak sublingual veya IV nitrat kullanımını erken başlatılmasını çok şiddetle önerir. Herhangi bir kontraindikasyon yoksa der. Sınıf 1C oldukça yüksek bir öneri düzeyi bildiğiniz gibi. Ve hemen algoritmanın başında burada gördüğünüz gibi antianjinal tedavi olarak ağrının tedavi edilmesinde nitrogliserin yine tedavide yer alır ESC'deki akut koroner sendrom algoritmasında. Bu çalışmanın önemi benim için şu, burada yer almasının sebebi, sizlere sunmamın sebebi şu. Bu çalışma nitrogliserin dilaltı spreyin 5. dakikasında, kullanımının 5. dakikasında hastaların %48'inde koroner dilatasyon yaparak iskemi bölgesinde reperfüzyon ile hasar oluşumunu gerilettiğini iddia etti. O yüzden benim için önemli. Güzel de planlanmış, güzel yapılmış bir çalışma. Tek merkezli, çift kör, prospektif, plasebo kontrollü bir çalışma. Ve 96 hasta sayısı da az değil böyle bir çalışma için. Dolayısıyla 5. dakikada hastaların yarısında neredeyse ciddi etkili olabilecek bir vazodilatasyon olduğuna vurgu yaptı. Ve tabii bu şekilde de Circulation'da yayınlanma hakkını elde etti. Bir review konuyla ilgili bunu şunun için koydum. Oral kullanım dozları için net bir öneri bulunmamakta diyor bu review'da. Biz IV dozlardan yola çıkarak oral dozları tahmin yoluyla buluyoruz diye hatta bir iddiada bulunuyor. Fakat klasik kaynaklara geçmiş, klasik review'larda, kitaplarda yer alan dozlarımız aslında belli. Translingual spreyde gördüğünüz gibi doz 400 mikrogram sprey 1-2 metreden puflanacak şekilde ve 5 dakikada bir tekrarlanabilecek şekilde ağrı iyileşinceye kadar verilebilir. Sublingual sprey için söylüyorum. Acildeki önemli kullanım alanlarından bir tanesi de acilin yine mayor hasta gruplarından birinde akut hipertansif kalp yetmezliği ve pulmoner ödemde tabii ki. Bildiğiniz gibi akut hipertansif tedavi ve pulmoner ödem, akut hipertansiyon ve pulmoner ödemin tedavisinde, temel farmakolojik tedavisinde vazodilatatör ve diüretikleri kullanırız. İşte nitrogliserin burada vazodilatatör olarak önemli bir rol oynar. Çünkü neydi? Az evvel gösterdiğimiz o kılavuzda yer alan cümleyle, vurucu cümleyle hem ön yükü hem art yükü azaltacak vurucu bir vazodilatatör etkisi vardı. Ve kalp yetmezliği belirtisi olan kişilerde oldukça faydalıydı. Bu da yüksek doz nitrat kullanımının düşük mekanik ventilasyon, düşük endotrakeal entübasyon yapılma ihtiyacı, kan basıncında iyileşme, miyokard hasarında azalma, hastanede kalış süresini kısaltma ve yoğun bakımda kalma süresini kısaltma ya da yoğun bakım ihtiyacını azaltma gibi kriterlerin iyiliğiyle alakalı olduğunu vurgulayan bir yayın. Ve yüksek doz IV nitrat kullanımının altını çiziyor. Fakat ben bu yüksek doza bir de erken kullanımın vurgusunu yapmak istiyorum. Ne kadar erken o kadar iyi diyen bir makaleyi de sizinle paylaşmıştım. Bir an evvel başlanmasının bu açıdan da yanınızda olmasının ve hemen kullanılabilmesinin, Başar Hocam'ın anlattığı Türk filmi sahnesi benim gözümün önünde. Çok da aradım aslında buraya görsel olarak koyabilmek için ama bulamadım. O beyaz saçlı amca cebinden işte ilacını çıkartıyor ve kısa süre içerisinde toparlıyor. Çok da aradım buraya koyabilmek için, bulamadım. Çok dramatik ve kısa sürede başlandığı zaman çok belirgin etkisi olan bir ilaç olduğu için bir an evvel başlanılması yüksek doz kadar önemli. O yüzden ben bu yayının yaptığı yüksek doz vurgusuna ve bir an evvel diye de bir etki faktörünü eklemek istiyorum. Bunun için de sublingual uygulama şeklinin hastanın cebinde taşınabilmesi, acil servislerde, prehospital ambulanslarda bulundurulması, bir an evvel kullanılabilmeye başlaması açısından bir artı değer olduğunun altını çizmek istiyorum. Bu sublingual tabletlerin burada kullanım dozunu görüyorsunuz bu hastalarda. Bu iki çalışmada yani özellikle hem prehospital hem de acil servislerde yüksek dozun diğer farmakolojik ajanlara bir üstünlüğü var mı? Yani zaten belirgin, kendisini ispatlamış bir tedavidir nitrogliserin kalp yetmezliğinde, ama yüksek dozun acaba burada ekstra bir etkinliği var mı? Bunu vurgulayan makaleler. Evet, peki aort diseksiyonu ve anevrizması yine mayor kardiyaklarımızdan, korkulu kardiyak hadiselerimizden bir tanesi acil servis için. Biliyorsunuz tipik olarak tip A ascendant ve tip B descendant diseksiyonlar başlıca diseksiyon tiplerimiz. Tip A tamamen cerrahi bir diseksiyon tipi, ama tip B'de başlangıçta süreç medikal olarak yönetilebilir. İşte bu medikal tedavi hasarlı aort duvarındaki kan basıncını azaltmaya ve hemodinamik stabiliteyi sağlama amacına yönelik olacağı için burada bir vazodilatatörün işimize yarayabileceğini kabaca tahmin edebiliriz. Bu guideline'da aort diseksiyonu ile ilgili guideline'da önceliğin labetalol ve ezmolol gibi beta blokerlerde olduğunu, çünkü aynı zamanda hem kalp debisini azalttığını, sol ventrikül hızını azalttığını ve refleks taşikardileri önlediğini, nitrogliserin veya nitroprusit gibi vazodilatatörlerin nikardipin veya klevidipinlerin ardından eklenebileceğini tedaviye vurguluyor diseksiyon kılavuzunda. Acildeki mümkün kullanım alanlarından bir tanesi, yani çok mayor kullandığımız, elimizin alışkanlığı olan bir alan olmasa bile preeklamsi ve eklamsinin sebep olduğu hipertansif durumlarda kullanabileceğimiz yönünde bir takım bulgular var. Tabii ki sizin de bildiğiniz gibi preeklamsi, eklamsinin asıl tedavisi bebeğin ve plasentanın doğurtulmasıdır. Fakat bu arada da anne ve bebek için bir risk dengesi gözetilir. En uygun doğum zamanı seçilmeye çalışılır. Doğum eyleminin başlatılması ile ilgili bir takım özellikler vardır. Ve biliyorsunuz ki oldukça mortal de seyredebilecek bir hastalık olduğu için bazen çok ciddi kararlar vermek gerekir. Bu arada antihipertansiflerle yönetmek durumunda olduğumuz klinik durumda hidralazin, labetalol, lifedipidin gibi antihipertansifleri kullanabiliyoruz. Preeklamsi özellikle kardiyojenik pulmoner ödemle komplike hale geldiyse, oradaki hipertansiyon kardiyojenik pulmoner ödemle komplike hale geldiyse, o zaman nitrogliserin bir olası tedavi seçeneği olarak aklımızda yer edebilir. Normalde çok birinci basamak tercih ettiğimiz bir tedavi seçeneği değil. Bunu ilginç bulduğum için burada yer almasını istedim. Çok yakın zamanda bir Cochrane derlemesi nitrogliserinin tokolitik olarak kullanımını araştırmış ve nitrogliserinin erken doğum eylemi için uterus kasılmasını da önleyebileceğini, özofagus düz kas üzerindeki etkilerinden dolayı mesela özofagus kasılmalarını önlediğinden bahsetmiştik. Aynı şekilde uterus kasılmasını da önleyebileceğini öngördü ve bunun üzerine bir derleme yayınlıyorlar. Bu özelliği açısından diğer tokolitiklerden daha üstün değil. Fakat nitrogliserinin yan etkileri, olumsuz etkileri daha az olduğu için yine de kullanılabileceği yönünde kafamızda bir işaret oluşuyor. Burada gördüğünüzde pardon, ne yaptık? Dozlarla devam ederken tabii ki.
Evet, alttakinden.
Evet, yanlış yerde kaldığım için. Burada da dozlarını, eklamsi ve preeklamsideki dozlarını görüyoruz. Son olarak acil serviste hipertansif inmelerde, ensefalopatide ve sempatik krizlerde acaba kullanılabilir mi? Ne derece yeri var? En çok çalışma, bu konuda en çok çalışma prehospital alanda, özellikle de kanaması olan hastalarda, hemorajik stroke olan hastalarda gliseril trinitratın daha etkili olabileceği, yüksek doz kullanılması, IV kullanılması durumunda etkinliğinin olabileceği konusunda çok sayıda çalışma var. Fonksiyonel sonuçlara fayda sağlayabileceği ile ilgili bir takım veriler var. Fakat yani nitrogliserinin hipertansif ensefalopatiyi tedavi etmek için tercih edeceğimiz bir antihipertansif olduğunu gösteren çok güçlü elimizde kanıtlar yok. Sempatik deşarj konusunda da kokain kötüye kullanımının sebep olduğu koroner vazospazm hariç sempatik hiçbir krizde nitrogliserinin yeri yok. Sonuç olarak ben şunu söyleyebilirim. Birçok farmakolojik molekülün aksine zaman geçtikçe modası geçeceğine, değerden düşeceğine, değer kazanan 130 yıldan beri devam eden kullanımımızda olan sarsılmaz bir yeri olan bir molekülden bahsediyoruz. Ve bu molekül sublingual sprey formuyla kolay taşınır, çok çabuk elde edilir. Yanınızda taşıyabileceğiniz, o anda yanınızda olabilen bir form halinde çok özel bir kullanım alanı sunar size diyorum ve çok teşekkür ediyorum.
Evet, çok teşekkür ederiz güzel sunum için. Tabii konu hepimizi ilgilendiren çok önemli bir konu. Çünkü hepimiz kullanıyoruz nitratları. Hatta bir ara son slaytlardan nitrat hipertansif ensefalopatide de kullanmaya mı başlandı tekrar diye kafam karıştı. Sonra yaptık, yani hızla değişiyor, bir kullanıyoruz bir kullanmıyoruz. Ama özellikle sprey formu bu konu daha gündemimize geldi. Biz de bunu anlatalım istedik. Burada şimdi yönetici pozisyonda hocalarımız var, dekanlarımız burada. Hem Mehmet hocamız hem de Ayhan hoca da geldi, sağ olsunlar. Şimdi biz bunların acil servislerde kullanımını destekliyoruz. Mehmet hocam, ben bu konuda aslında 112'nin işte genel müdürlükle görüşüp ambulanslarda olmasın, çünkü prehospital alanda da dediniz değil mi? Olmasının uygun olduğunu düşündüğümü ifade ettim. Ne dersiniz, ambulanslarda kullanılsın mı bu açık hastane öncesi?
Tabii ki, yani Türk filmi sahnelerinde kullanıldığına göre bundan yıllar önce çok
ben prehospital'la ilgili makaleleri özellikle de koydum Mehmet abi, bu konudan bahis açarız diye. Ambulanslarda kullanımıyla özellikle acil servislerde zaten bulunması
Zeynep
lazım.
hocam, şöyle bir şey de var ama acil önce deneyimleyecek, öne çıkartacak. Yani bizde işler öyle yürür. Yani bizim önce acil serviste bir defa nitratlara ihtiyacımız var. O yüzden sayın dekanlarımıza iletiyorum. Bir defa acile alalım. Acilde olduktan sonra bu kullanım deneyimini biz mutlaka ambulanslara yansıtmamız lazım. Yani Ambulanslar acilden aldığı bilgilerle hareket edebilir. O yüzden direkt onlara şunu kullanın demeden önce bizim acilde önce bir şeyimiz olsun da kullanım alanımız olsun. Ondan sonra oluşturalım diye istiyoruz ama her halükarda sprey kullanımının avantajlı olduğunu görüyoruz. Nitratların kullanımının herkesin bir deneyimi var. IV nitrogliserin kullanmayan yoktur aramızda acilci olduğumuz için. Bir de böyle alternatif formların çıkması çok iyi. Soru katkı alabiliriz salondan. Pek soru katkı yoksa biz soralım falan diyormuşum. O zaman çekilişi getirin bari. Çekiliş yok mu? Kimse sormuyor. Çekiliş yapalım. Nitratlar tanıdık. Onu da söyledim. Bak bu soruya ödül ver. Trinitrin de hatırladın mı Mehmet Hocam? O sarı kutu. Bir de o şey vardı. Yaşlı amca alıyordu böyle göğsüne alıp iyileşiyordu hemen. Şimdi arkadaşlar ben bunu karıştırıyorum. Ondan sonra bir tane isim çekeceğim. Emine Aykol. Emine Aykol burada mı? Yok, şansını kaybetti maalesef, üzgünüm. Bence ikinci şans. Emine Aykol yok. Ona da söyleyeyim biraz içi yansın. Derste olmadı. Şimdi şunu çekiyoruz. Bir dakika, şu geldi. Bunu okuma şansım yok ya. Şimdi soyadı Değer ama. Soyadı Değer.
Rabia Değer. Olabilir mi?
Rabia mı? Vay, Rabia Değer. Evet, alkışlarımızla. Tamam Rabia, ne istiyorsun? Sen böyle bir kura gördün mü? Bak, ne istiyorsun? Ona bırakalım.
Vay, çok güzel.
Yani hocam haddimi aşmasam az evvel Menderes abiyle standın başında konuşurken ATLS kılavuzunu gördüm. Biz satmıyoruz dedi. Satar mı ne yapar bilmiyorum. Efendim?
Çok da mütevazi bir isteği var. ATLS kılavuzunu
Yani ilk aklıma gelen oydu diye.
Tamam, ATLS kılavuzu içeren bir kitap istiyorsunuz. Tamam, anladık. Ama çok mütevazisiniz. Ben de daha doğrusu bunlar
kursu da isteyebilirim ama yani ilk aklıma geldi.
Bir şey soracağım. Rabia, öncelikle cevap şöyle. Hocam canınızın sağlığını isteriz diye bir cevap oluyor. Bunları öğretelim asistanlarımıza. Önce can sağlığı. Evet. Şimdi Rabia Hanım'a o zaman ATLS kılavuzu içeren bir kitap istediniz. Tamam, bunu temin edeceğiz.
Bence kongre falan istiyor.
Ben kitabını kendi adresine gönderebilirim.
Tamam. Behçet Hoca sponsor oldu kitap. Behçet Hoca mı gelmiş? O Behçet Hoca mı?
Odur, evet.
Galiba
tamam, hoş geldin hocam. Behçet Hoca size kitap gönderecekmiş. Tamam. O zaman siz başka bir şey isteyin.
Behçet Hocam ATLS kursu hediye etsin Rabia'ya.
Tamam.
Behçet
Neyse, yok, başka bir şey yok artık. Başka bir şey yok. Evet.
Teşekkür ederim hocam, sağ olun.
Behçet Hocam, siz baklava yollasanız daha iyi olmaz mıydı? Neyse. Evet. Behçet Hoca da geldi, renklenecek şey tabii. Kongremiz biraz daha renklenecek. Evet Mehmet Hocam, buyurun. Sayın Dekanım, buyurun.
Şimdi bir devlet büyüğümüz bir seçim sonrası yüksek oy alması nedeniyle bir şehre geldiğinde ben benden ne dilerseniz diye söylediğinde şehir halkı demiş ki ya sizin sağlığınız Rabia da biraz öyle oldu ama buna cesurca şey yapmak lazım. Behçet Hoca herhalde onu tamamlayacak.
Evet. Tamam, ben de huzurunuza ATLS kursunu arkadaşımıza hediye ediyorum. Tamam.
Teşekkür ederim hocam, sağ olun.
Behçet Hocam, yanlış anlamadıysam siz hediye ediyorsunuz. Bizi karıştırmıyorsunuz değil mi? Tamam. Evet. Tamam. Tamam. Behçet Hoca hediye ediyor, tamam. Ona göre. Tamam, peki. Teşekkürler arkadaşlar. Şimdi arkadaşlar, bugün performansınız için teşekkür ediyorum. Burada olduğunuz için teşekkür ediyorum. Daha fazla vaktinizi almayalım. Diğer şeye geçelim. Ama bakın, bugün Avustralya'dan gelen bir konuğumuz var. Kaç saatte geliniyor? En uzak uçuş herhalde Yeni Zelanda ve Avustralya. Yani lütfen arkadaşlarımız, özellikle buradaki arkadaşlar öyle hani bu ne demek istediğimi hemen anlıyorsunuz. Bu misafirlerimize bilimsel saygımızı gösterelim. Ve burada onları dinlemeye çalışalım. Gerçekten elimizden geldiğini biliyorum. Bu çalışkan bir ekip var. Her tarafa koşturuyorsunuz. Bildiriler, A salonu, B salonu. Bir de diğer ekip var. Ona da bir o havuza, bir diğer havuza, bir şunun da tadına bakalım. Bir de şuraya bakalım. Ama ne yapalım? Biz böyleyiz işte. Onlar öyle, biz böyle. Bu taraf onun. Biz eninde sonunda kazanan çalışan olur diye düşünüyoruz. Onlar da yadırgamıyoruz. Yani ne yapsınlar? Onlar da bir şekilde şey yapıyor. Ama artık buraya da önem verelim. Hemen yani B salonunda, C salonunda gitmek zorunda olanlar gitsin. Sayın hocam, başka bir soru gelmiyor anladığım kadarıyla. O zaman sizi de yormayalım. Teşekkür ediyoruz. Farmetik firmasına teşekkürlerimizi iletiyoruz. Ayrıca bu ürünü Türkiye'ye kazandırmanız da bizim için büyük mutluluk verici. Siz bakmayın, biz bunun peşini bırakmayız. Biz onu ambulanslara falan isteriz. Su sağlık için önemli yani, sizden bağımsız olarak. Biz bunun tecrübesini biliyoruz. İnsanlarımız için bunu isteyeceğiz, merak etmeyin sonuna kadar. Tabii burada bir sürü öğrencimizi de yerleştirdik oraya, biliyorsunuz. Onlar da yardımcı olacaktır bakanlıkta. Evet arkadaşlar, 4'te diğer sunuma geçiyoruz ve bugünkü son iki sunumumuz, burada da yabancılar, kalabilen arkadaşların burada kalmasını istiyoruz. Hatta burada kalanlara sürekli şey yapalım, sürekli çekiliş yapalım. Madem birini de Behçet Hoca verdi, burada kalanlara bir çekiliş daha yapacağız. Ama kaldıktan sonra. Teşekkür.
Department and Poison Center for taking any kind of an help. So with this, I thank you all very much for giving me an opportunity, and I welcome you all to MCON 2022, which will be happening from November 24th to 27th in India, in Trivandrum. It's a God's own country, it's called as. So welcome you all. Thank you very much.
Thank you, Doctor, for interesting lecture. Thank you.
Thank you.
Next speaker will be by Dr. Ahmed Dhoum. Dr. Ahmed is a Lieutenant Colonel in the Royal Medical Services, emergency consultant, European and France, emergency fellowship, Lewis Pasteur University, ICU and critical care training, Basket University, director of NIMSIC. He will speak about the role of the NIMSIC Training Center at Royal Medical Services to improve the quality of the emergency medicine. From Jordan. Thank you, Doctor.
Good afternoon. It gives me a great pleasure to be among you. Thank you, IBAD colleagues, for invitation. And thank you, Professor Bashar, also, and the organizing committee. It's give me honor and great to introduce my organization, Jordanian Royal Medical Services, in a few slides. As you see, we have around 24,000 Royal Medical Service personnel, 11 or 12 institute and military hospitals, 4 military hospitals. Our Royal Medical Service mission, it's multi-focus organization working under the mission of providing, improving and developing efficient by using optimal using of available resources. As I informed, the RMS Jordanian rules, military rule, national rule, international humanitarian rule, crisis and disaster management. Our Royal Medical Service structure, we have around 12 hospitals from north to south, east to west, 6 field hospital, 4 military battalion hospital. This is our King Hussein Medical City, the largest and most disciplinary medical institution in Jordan. It contains around 6 special hospitals and preventive medicine, also nuclear medicine and ophthalmology center. The capacity of beds around 1,400 beds. Also, we have 4 military academy, Prince Muna Royal Medical Service College and Institute Biomedical and my National Emergency Medical Service Training Center. With pleasure to share with you our experience. I am the director of the National Emergency Medical Service Educational Center at the Royal Medical Services, and how we have the courses to increase the efficiency for emergency physicians. Our vision, excellence and leadership nationally, regionally and globally. Our mission to provide state-of-art training program that keep evidence-based guidelines through optimal use of available resources, including well-qualified instructors, modern technology and appropriate setting. In 2009, our training center, NIMSIC, was accredited by American Heart Association, and we started to conduct basic life support, advanced cardiac life support, pediatric advanced life support, pediatric emergency recognition and stabilization, in addition of neonatal station program, and also triage courses. Also, it is these courses for physicians, nurses, midwives, paramedics, and also for non-healthcare providers. In 2013, our center accredited by American Cardiac of Surgery, and we conduct advanced trauma life support for physicians, for doctors. In 2015 also, we are accredited by American Society of Trauma Nurses in cooperation with American College of Surgeons to conduct advanced trauma care for nurses also. In 2015 also, accredited by American National Association of Emergency Medical Technician, NAMIT, and we provide PHTLS, pre-hospital trauma life support for doctors, nurses, and paramedics. In 2019, we accredited by American Academy of Family Physicians, and we started to conduct basic life support in obstetric and advanced life support in obstetric. Our training center, at NIMSIC, has ability to conduct different type of courses to cover all target group in the community. It's not also for doctors, for nurses, for midwives, across designed also for non-healthcare providers. As the models of emergency medicine, we know there is two models of emergency medicines: stay and play philosophy or scoop and run. So that in our center, we started to have both of them, to have a courses pre-hospital and also in hospital. It is our accreditation from training center. This slide, it gives us information how many participants in our training center. It is not only for emergency physician, but also GPs. And what we are did that the all medical or Royal Medical Service doctors, they didn't have promotion from rank to rank, or from, for example, specialist to senior specialist or consultant, if he didn't pass some of these courses. As you see, basic life support around 150 per 1 year. We have advanced cardiac life support, pulse, peers for pediatrics, NRP also for program of neonatal, emergency triage, PALSO, and also basic life support, advanced life support for doctors. They are working in as pediatrician or gynecologist, advanced trauma life support for doctors. They are working with a trauma or surgeon, pre-hospital trauma life support also for all paramedics and doctors. They are working in the field. Also, we have TCCC, Tactical Compound Casualty Care, Tactical Emergency Casualty Care, and also Tactical Medic, Emergency Medical Technician Basic and Intermediate. To rising the paramedics we have for newcomer and emergency medical technician qualification. As I mentioned before, our American Heart Association courses, it's basic life support. I think you are familiar with these courses: advanced cardiac life support, pediatric advanced life support, pediatric emergency assessment and recognition. Also trauma courses, advanced trauma life support, ATLS, and we congratulations Professor Bahjat that you are instructor of ATLS, I think, in Turkey. ATCN also for nurses, as I mentioned before, pre-hospital trauma life support, and all of these courses, it's very important to rising the efficiency for emergency physicians. They are working at emergency or at the field. The importance of courses that conducted at our training center, that they provide conscious of easy to remember framework for the medical personnel who involved in the courses. When they come across with any medical emergency, they will be able for optimal using of available resources and teamwork dynamics. Others courses we have like Diploma of Emergency, Neonatal Triage also, and tactical courses for non-medical health provider. This is the average of our courses during the year. We cover around 90% from our military Royal Medical Service, and the statistics 10% from the civilian people. Thank you very much.
Thank you, Dr. Ahmad. The last speaker at this session, he will be Professor Dr. Rajadoura. He is Senior Consultant and Head Department of Emergency Medicine and Critical Care at Apollo KH Hospitals in Milfishar from India. And he will talk about evolution of pre-hospital care in India and the way forward.
Okay, we can do it. Thank you for that nice little introduction. Thank you for the opportunity. So I'm going to talk about the journey of pre-hospital care in India since a decade. And the good news is I'm going to talk within 10 minutes. And I'm going to keep my lecture short as possible. Well, not this short. So who said the thank you slide have to be only in the end? So I take this time to thank the organizers for giving us the kind of opportunity. Professor the President, EPAT, and all his team, our SEMI team, and all the organizers for giving us this wonderful opportunity to speak on the platform, which deserves this kind of topic. Is this topic important? So most of my presentation will have this slide as a mandate, where I'll usually engage the participants about whether the pre-hospital or the topic what I'm going to talk is important. So here, the pre-hospital care, probably after some slides you'll understand whether the pre-hospital care is important or not. So these are all some of the statistics across the world, where we see 80% of the deaths occur outside the hospital. So please note that it is not the deaths which is happening only inside the hospital. In a developed nation or a developing nation or in the Western countries, we come across more deaths outside the hospital. And this is a statistics which was taken 5 years before the COVID. So it is still rising. Over 2 lakh people die of sudden cardiac arrest every year. And the single most strategy to improve the victim's chance of survival is always bystander CPR, and the single most effective intervention that has saved maximum lives in the history is CPR, which is bystander CPR. So let's talk why we need early CPR. I am sure this is a crowd where you all know aware of about the platinum 10 minutes and the golden 1 hour concepts, so I'm not going to talk much on this. To be more precise, CPR increases the sustainability of rhythm and the chance of survival, which is the platinum 10 minutes. So this is a familiar slide to all the emergency physicians across who are sitting here, the trimodal death distribution. So do not take only, this pattern is only for trauma. This is for all medical as well as surgical emergencies, including trauma patient who comes to our emergency department. The first, you can see the 3 peaks here. The first phase within minutes, second phase within hours, and the third peak within the days or months. So the first peak usually, they say it is not unable to prevent. So when we have a good pre-hospital care, the chances of the peak is coming down is very highly. That is what we have demonstrated in our country. And the second phase, when we have a good ER, good functioning ER with all good emergency physicians, trained emergency physicians to take care of ACLS, the cardiac life support and trauma life support and all emergencies, this peak also can come down. When the accessibility and the emergency physicians, the ambulance services, which all I'm going to talk in the next coming slides, we can bring down these peaks also. And the third peak, which happens mostly inside the hospital, either in the ICU or in the wards. So death due to infection or multi-organ failure, when you have a good team of doctors working along with you, and when you have good pre-hospital care and the emergency care, the chance of you reducing the third peak of death is also inevitable. Right, so this is a trauma statistics. This is our country, India. Most of you all know. So by the time I was talking, I was talking for the past 2 minutes, a death would have happened by now. Death related to trauma and other medical emergencies would have happened. So every 2 minutes a death is happening because of trauma or related to it. And these are the various state-wise representation of deaths which is happening inside our country. So how do we prevent or how do we reduce the chances? So we need to improve the pre-hospital care. As I said, the first peak have to come down because of the good pre-hospital care. The second peak, we need to improve the knowledge of our emergency physician, improve the basic structure, and improve their skills with regards to treating those critically ill patients, and you need to form a good team in our critical care units and the wards to reduce the third peak. Whether we have done it is not a one-day process, it is a gradual process. And so as it has been mentioned in AHA's chain of survival, you need to follow this interlinked chain of survival without any break. Any break in this interlinked chains reduces the chance of survival for patients. So now you guys tell me, based on the statistics, is this topic important? The pre-hospital care, what we are doing for the past 10 years? Definitely yes. So I'm going to talk a little bit about the journey of our pre-hospital care for the past 10 years in our country. And I'm not going to include, I'm unable to include all the people's work here. So we have included maximum what we could do for this objective. In short, the short objective would be to save lives. So a typical scenario on Indian roads, a road traffic accident. So what do you think people would be doing there? Or what do you think a healthcare professional would be doing there? A good summation, ADMAX even now would try to ask for an ambulance, to try to call for an ambulance. Why they are not coming forward to help these victims? Of course, there are places where people are helping and people are doing resuscitation. People are trying to help each other, but not everywhere it is happening, particularly not only in our country, almost all the countries. Why? When we assess the reasons, we found that it is lack of awareness, because people are scared when somebody is fallen, collapsed, and with a lot of blood, and somebody screaming or screaming next to the patient. Somebody has fallen unconscious because of various reasons. They do not know what they exactly need to do. So it is lack of awareness, fear about the loss. People think that most of the time the bystanders are also harassed after the incident, and they fear about the loss. We don't have a good communication system. The transport ambulances are all short, because I'm from a country where about 1.4 billion people are there in that single country, as Dr. Srinath was telling. So we and China together can match the rest of the population throughout the world. So accessing to the ambulances, communication system, access to the healthcare, and a trained emergency physician are all pitfalls. So what, as a group, as Society for Emergency Medicine, as each and every emergency physician in India have done so far. So what we thought is we have to give widespread CPR training, develop rapid responses, establish high quality CPR and training to them, where like fire extinguishers in Western countries, we also need AEDs throughout our country, and we need to have a good definitive care. So this is a huge task, and as I told you, we didn't establish this in an overnight, and this is a decade of efforts which I'm going to show you all. Of course, nothing happens unless we dream. We dreamt of the same, and to some extent we have, arrived to this. A dream of every emergency physician, at least one BLS provider in each and every home. This was a dream since a long time, and we need to create mass awareness, that is large volume, high frequency, large volume, low frequency, and as well as low volume, high frequency training is what we aimed at, to create awareness to the general public as well as to the other people. So this is, ladies and gentlemen, this is a red letter day for throughout all the emergency physicians in India. On April 7, 2016, we trained about 50,000 people. Can you all imagine? We trained about 50,000 people in CPR, and it has been in the Guinness World Book of Records. We as a society have participated, and we have done it in the institution where I was working. So by this, we created a mass awareness. Each and every emergency physician society, after this, we thought, when I was having a meeting with the media, one of the media person asked me, when do you think this record will be broken? I told to them, I wanted this record to be broken the next day. Even the organizers was slightly not happy with me, having spent crores when I was telling that I want this record to be broken, because we didn't do record for records, we do this record for awareness. So more and more such records, where it comes, more and more people will be aware, and as expected, like a chain reaction, a lot of people attempted. And of course, ladies and gentlemen, this record still remains unbeaten, and many of the people have done subsequent records in CPR in different categories. So this is one such scene from that. This is me. I think we need to, Dr. Srinath will agree, we need to perform Guinness World Record to keep ourselves slim, isn't it? So this was me training about 5,000 people at one go. So we had about 8 sessions where we trained about 40,000 people, and subsequently there was a relay about 10,000 people. So on that particular day, that is on 2016 April 7th, we trained about 50,000 people, and this was marked in the Guinness World Book of Records. But creating a record, as I told, it is not good. It is a one-time event. It is not going to help much. We need to focus on the low volume, high frequency training, which we are aware, and we identified the end users, the school, college students, police, fire, and district officials, and we started training for them too, which has been happening for the past, from the time we established as a society in emergency medicine. Each and every physician is doing their part to do the same, and we are also doing the same. So this is the present hospital where I was working. Of course, every hospital, every emergency physician are donating AEDs to make AEDs available in different parts of India, and we are training people to the first aid thing. And this is the integration of first aid and school curriculum. Most of the emergency physicians across the world go to the school, train them in CPR, and then come back. Instead, what we have made in our group is, what we have made in our places, we have integrated first aid in the school curriculum, like how the kids will learn maths or physics, they will learn CPR. CPR is a non-exam subject. So it is it has been taught in each and every, the school student of that particular school, and he will be trained in CPR. That is our goal. So once he's trained, he's been certified, we have a process, and he's been certified, he's been retrained. So we see to that the integration of first aid in school curriculum happens even now in the right way. Of course, as I was telling you, the small volume, concentrating on the small volume, we as a SEMI was doing this national level basic life support and cardiac life support. It is a replica of AHA's, American Heart Association's basic life support. For the people who are unable to participate there, we have formed this. It is an interactive session where we train a lot of people on every day in different cities. So this is the National Trauma Life Support. So this platform is a peculiar or an interesting opportunity, I would call, because I'm sharing all these things in front of our academic chair, Dr. Srinath. So this is the training report what we have from the last year. This training is provided to all the government doctors, and this is done as a pilot course in Tamil Nadu, a state in India, which has pioneered this aspect of spreading training to the doctors, combining with the government. This shortly will be adapted to all the states. We are spearheading for the same, and more people will be trained for the same. So these two, Dr. Srinath and Dr. Sarana Kumar, are the program directors who developed the group of people and organized the team to teach each and every medical colleges. So we are doing this for the past 2 years. We have trained about 15 medical colleges in across Tamil Nadu. As it is again like an advanced trauma life support 3-day course with interactive lectures, hands-on training, Kahoot online quizzes, and pre-test and post-test. On the completion, they will be given a certificate. So we didn't do just the course, we assessed the outcomes also. As the graphs clearly mention, the knowledge post this NTLS course was very high to the participants, and this is what exactly we wanted at the end. So when it comes to the ambulances, of course, the drone ambulance is coming into the picture, which I'll be talking in the newer advances. We have road ambulances. Of course, we have pioneered the air ambulances across India, and we have separate teams to take care of air services as on date. And we have what is called as bike ambulances, which we introduced a decade before in our country, to assess the narrow roads to help the victim as soon as possible. So of course, we cannot be expecting everyone to be a good Samaritan. So we have, approached the government to look after a few guidelines to help the victims. So in that way, we have suggested that, the bystander have to help if there is a patient suffering from the unconsciousness or after a polytrauma. So he has to be trained, and the legal system should not harm the Good Samaritan in any way, is what we have suggested to the legal system, and it has been carried out in a right way. Hopefully we have a system where people will be helping out and will be scared if they don't help out. Of course, I was talking about the innovations. We have drones. We have developed drones to help people. This is in the pilot project, and hopefully we'll have drones all across in the country in a short while. Of course, the telemedicine, Dr. Srinath was mentioning about the telemedicine, which has played a vital role during our COVID scenarios. And we have developed several applications for the patients to approach the hospital, the ambulances, in a way it is very effective. Right. So this is the slide which I am projecting again. So for your country to develop the pre-hospital care, you cannot do that on day one or within a short span of time. You need to have a specific period of time for which, and of course it is an ongoing, so you need to have widespread CPR training, both large volumes as well as small volumes. We need to develop rapid response and AEDs and definitive care. So there is no I in teamwork, right? Everyone can be a superhero if they combine together when it comes to emergency medicine. Once again, thank you for the opportunity given to me.
Thanks for all speakers at this session, and it was interesting lectures, and they have enough time to listen to your comments or if you have any questions to them.
Thank you very much. This is Dr. Behçet from Istanbul. Each speech was really very nice. Great. Thank you to everybody, to all speakers. Just my first question to Dr. Srinath. Can we hope for new antidotes in toxicology? This is for you. infection especially. And for the Dr. Ahmed, Prof. Ahmed, is it necessary to have all these trainings in Jordan? Is it must? I just want to learn it. Then for the last one for Raja, thank you very much for your sharings. Just firstly, I want to appreciate and say congratulations to the Savitri University in India for their basic life support and first care that they teach to the community. But the photo should be specific to India. It must be really very difficult to teach basic life support or first care to 1,000 people in stadiums. But it is specific to India. As you said, as you mentioned, over 18% of the deaths happen in also hospitals. So I'm really agreeing with you. Your question is really very important, definitely, very important. All, as you mentioned about the dreams, I think all the reality should be given from the dreams. You know, there is a philosopher in your country, one of your previous presidents, he says, the dream is not the thing that you saw while in your sleep. The dream is thing that doesn't make you to sleep. So that's why I want to appreciate you. You are teaching the community about the first care, first aid in India. This is one of my dreams. I just have a suggestion. Can we achieve it? To teach all the students graduate from the university, and it could be must to teach the basic life support or first care to all the couple that are going to marriage. Thank you very much.
Antidotes in
The second question.
Yeah. So the first question is towards the antidotes. Yes, there are a lot of things which is happening, and especially in, if you visit to many emergency departments now, they have created the disease-specific antidotes in those emergency departments where they see commonly. If you take me, I have created a full box of antidotes which comes commonly. I have taken an epidemiology of my system where last 2 to 3 years which have come to my emergency department, I have seen that this is what is required. Now the next question is about the newer antidotes, like lots and lots of patients are coming with the chemical poisoning, especially those requiring the methylene blue. So methylene blue is not available readily in every emergency department. So nitrates have become a biggest poisoning in most of the countries today in Asia. So there we have started using the methylene blue, and it has shown much results, and the patient outcome is also good. And regarding the training, what Dr. Rajdari was mentioning, it was a mission which he took it for almost 6 to 7 years. And then he ensured that all the people come together and it was being done, so that it gave an impact of emergency medicine in the whole country. That is all. Thank you.
Thank you. Thank you, Professor Bahjat, for your nice question. Really, we are share a knowledge. Our technical training department.
We as a society, there's too many, we call them merit badges. It's everyone's another badge. And so philosophically, we believe that all of that training is already incorporated into our residency, so we do not necessarily require each one of these badges, so to speak. So I hope that answered your question. But yes, it's important that we're all doing the same thing. You know, we incorporate ATLS into our training programs. We obviously do ACLS. We do periodic updates for all of our doctors, not just our doctors in training, but our doctors beyond training. And so once they get certified in emergency medicine, you know, every 7 to 10 years, they have to recertify. This used to be a big problem for us in the US, but now what we do is we do a little bit each year. And we find that to be a better situation than having to retake a test every 7 to 10 years.
Thank you for all. No any more question? Thank you for all. Our session is finished. 5 minutes later, we'll start the last session of today, okay? Thank you.
It's quite an exciting session. My name is Athar Ali Mohammed. I'm one of the ED physicians from Australia, and I have got Dr. Ahmed Al-Joom with me. So there's a slight change in the program. I think the first session we will be kind of starting with the pediatric ocular trauma by Dr. Hesham Kaftan. Thank you, Dr. Kaftan. So Dr. Kaftan works in the emergency trauma team at the King Hussein Medical Services in Jordan, and he works in the head and neck emergency trauma division.
And after this, next page. Next previous page. Laser. Okay.
Good evening. I'm glad I'm here with you. Our lecture is about the pediatric ocular trauma and emergency. Pediatric ocular trauma is the preventable causes of the visual impairment in the world. Up to 40% of the all injury occur in the person less than 17, especially in the small age. Why it is important? Because, as we know, trauma to the eye in the first 6 years is critical, because it leads to lazy eye, amblyopia, as we know. So, eye injury are leading causes to the visual disability and non-congenital unilateral blindness in children. Very commonly, eye injury occurring during the sport and even at the home or school, anywhere. Speak fast about the anatomy of the eye. You know, our eyelid, lower eyelid, cornea, sclera, and the retina and cornea and iris, everything. The most important thing we know about the orbital wall is the lamina papyracea. Lamina papyracea, which is the thinnest bone in the orbital wall. Approach to the eye examination. The history. The details of the mechanism and time of the injury. Where, when, how, and with what. Chemical or alkaline. Change. First, we ask about the change in the vision, flashes, floaters, or any shadow. Symptom: pain, visual loss, double vision, photophobia, or any other symptom. The eye examination. The vital sign, as we know, is the visual acuity, external eye anatomy. Look for trauma, foreign body, or any other. Pupillary response, equal rounded, reactive, full, visual field, extraocular movement. If there's any limitation, we must keep in mind, because there is trauma make the fracture to the orbital wall, so the entrapment for the muscle. Fundoscopic examination is the last and the important thing. If there is chemical bone, proceed for provide copious irrigation before history and before examination, before anything. Imaging study, plain X-ray to look for orbital wall fracture, CT scan to look intraocular foreign body, MRI. If there is metallic foreign body, MRI is contraindicated. Keep in mind. Emergent eye situation, eye trauma, blunt versus sharp, chemical, infectious. First, eye trauma, eye laceration, maybe superficial or deep, special care to the involving the lid margin and the tarsal plate and levator muscle, and the lead maybe lead to the apoptosis and that canaliculum, the medial canthus. The latter need tubing technique to prevent it before after healing. Check for associated foreign body or globe injury. Treatment: primary closure or delay closure after 12 to 24 hours if a human bite or contaminated wound. Tetanus prophylaxis for all and skin injury. Full thickness, this is picture like this presented to our emergency. Okay, maybe trauma lead to the subconjunctival hemorrhage. As we know, this is treated with a cold compressor and artificial tears of the symptomatic, and avoid aspirin or NSAIDs and heavy lifting. And this take to 1 or 2 weeks or maybe more to resolve. And maybe trauma lead to corneal or conjunctival foreign body, which is the The patients complain of the pain, tearing, photophobia, blepharospasm, and foreign body sensation. We must avert the upper eyelid to look for any hidden foreign body or any entrapment. Treatment: topical anesthesia and remove with the foreign body by the needle or cotton, triangular swab, or topical antibiotic drop or ointment. We must avoid patching in children because it leads to the lazy eye. Like this foreign body, maybe in the upper eyelid, on the inner surface of the upper eyelid, or in the cornea directly. Corneal abrasion ulcer. It's an epithelial defect due to the trauma occurring by the pain. Foreign body sensation, tearing, blepharospasm, and decreased vision. Dramatic response with installation topical anesthesia because it's pain relief. The ulcer could be sterile or contaminated or infected. If you're the upper eyelid, always as foreign body maybe it is the causes of the ulcer. Treatment: lubricant and topical antibiotic and cycloplegic to relieve the pain. Like this ulcer. Orbital anatomy, as we say previous, the most important is lamina papyracea, which is the thinnest point in the orbital bone. Orbital wall anatomy, orbital wall fracture, orbital floor fracture, maybe blowout fracture. The most common, as the floor is the weakest part, the roof of the maxillary sinus, usually due to blunt trauma. Symptom and sign: eyelid swelling, diplopia, restricted eye movement, especially upward, due to entrapment of the muscle. Enophthalmos, hyperesthesia over the cheek. Imaging study: plain X-ray or CT, observation with the tetanus prophylaxis prophylactic antibiotic with a broad spectrum, and nasal decongestion by 2 for 2 weeks. No nose blowing because this is increase the air under and delay the healing. Ice pack 1 to 2 days. Go for surgery if entrapment muscle, oculocardiac reflex, heart rate decrease with eye movement. Facial hyperesthesia, sympathetic diplopia with minimal improvement over the time, or large floor fracture leading to the enophthalmos. Surgery is the most commonly performed if indicated after 1 to 2 weeks if indicated. Like this, there is a restriction as we see in the picture because the entrapment of the muscle inferior rectus. Define hyphemia. Hyphemia is the blood in the AC. The anterior chamber usually results due to blunt trauma, projectile, or penetrating trauma, but can be spontaneously, as in juveniles and the granuloma. Commonly, in the pediatric population, sign, symptom, pain, decreased vision, and irregular pupil. Clinical grading from 1 to 4 according to the level of the blood in the AC. Complications: secondary hemorrhage, rebleeding, high risk in the first 5 days, and high rate in young children, and cerebrohypemia. Corneal blood vessel stain, anterior, posterior synechiae, optic atrophy. Prognosis outcome: the lower the grade of the hyphemia, the better the prognosis. Management of the hyphemia: complete bed rest, risk of hospitalization or outpatient. Most important is bed rest. Risk of the bleeding, grading of the hyphemia, according to all this control. Treat the patient as hospitalization or as outpatient. Elevate the head 30 to 45 degree. Eye shield to prevent the wrapping of the eye. Pain control, avoid antiplatelet effect, certain NSAIDs. Topical cycloplegic, atropine, atropamide to reduce the ciliary muscle spasm and dilated of the iris to decrease the rebleeding risk. Topical maybe need drugs to decrease IOP, and topical or systemic steroid to decrease associated iritis and development of the synechiae. As this picture of the hyphemia, blood in the AC. Okay, retrobulbar hemorrhage. As we know, retrobulbar from the most important and cases presented to the emergency can result in the rapid elevation of the orbital pressure because of the orbit is a relatively closed compartment. Untreated orbital compartment syndrome may result in the optic nerve ischemia and irreversible vision loss and less than 90 minutes. This is maybe spontaneous or traumatic. Sign symptom pain, decreased vision, diplopia, proptosis, and lidichemosis and tightness, and subconjunctival hemorrhage all over 36 degree, with chemosis and limited muscle motility and increased IOP. Decreased visual acuity and people response positive rapid treatment, lateral cathetomy and catalysis, or maybe can you give hypertonic saline 20%, 20 milli slowly over 20 minutes. Like this, retrobulbar hemorrhage. Okay. Iridodialysis, separation of the iris may be result from the trauma to the eye, blunt trauma. Separation of the iris from its root due to blunt trauma. Or maybe the result of the trauma is ectopia lentis, subluxated of the lens from its normal position, maybe downward or in the anterior chamber, according to the mechanism of trauma. Optic nerve avulsion, which is very rare to happen. Partial or complete avulsion of the optic nerve as a result of the trauma that lead to the sudden extreme rotation of the globe or sudden anterior displacement of the globe. Retinal detachment is immediately post-traumatic or maybe delay up to several months. Separation of the neurosensory retina from its base. Rupture of the globe may be a result from the trauma. For thickness, laceration of the globe as a result of the trauma that may be within blunt or penetrating or perforating object. Can be corneal scleral or combined corneal scleral. Symptom, pain, greatly decrease in the vision, diplopia. Sign, low IOP, teardrop pupil, prolapsed iris, hyphema, maybe with normal or high IOP, 360 degree subconjunctival hemorrhage all over. Management, if suspected rupture, minimize manipulation of the globe and apply the protective eye shield. CT orbital or brain axial coronal with thin cut, coronal thin cut to evaluate for the intraocular foreign body. And keep patient NPO in order to prepare for the surgery under GA. IV antibiotic to cover, especially in the children, and antiemetic pain medication, surgical repair is the definite treatment. This is rupture of the eye, like this picture presented to our hospital. Okay. The most important, again, ocular chemical burn. Being irrigation immediately before complete history and examination. We must directly start it by irrigation, especially if alkaline, because alkaline is more detergent than acidic. Alkaline burn are worse than acidic burn. Acidic burn lead to coagulative necrosis, denaturation of the tissue protein, act as a barrier to prevent further diffusion and further penetration for the acid, as battery fluid and chemistry lab solution. Alkaline liquefative necrosis don't denature tissue protein, tend to penetrate deep in the eye, like cement cleaner, drain cleaner, fertilize, any other alkaline burn, because they contain sodium hydroxide. Clinical finding, conjunctival hyperemia, blanching. The latter has bad prognosis and indicate severe ischemia, hemosis, corneal epithelial erosion, and corneal haziness and edema, and severe corneal opacification, limited ischemia all over. Complication, corneal melting, severe corneal and conjunctival scarring, uveitis, glaucoma, and maybe lead to the loss of the vision in this eye. Like this chemical injury, which is very dangerous. Ocular chemical burn, continued management, immediate irrigation with normal saline or lactic ringer or ringer lactate for at least 30 minutes until the pH is normalized, maybe require up to 8 liters. Do before checking VA or hospital or a history or an examination or fluorescein, and recheck pH 5 minutes later in order to be sure that his pH is normalized. After irrigation, check the visual acuity and complete the examination. Treatment, give any ointment like erythromycin 1 to 2 hours with cycloplegic atropine, and may need IOP lowering or steroid. Eye infection in ophthalmic neutrum is conjunctivitis within the first month of the life. Common causes is chlamydia, and this is from the cases presented to the emergency because it's a small baby and her parent is very fair, like chlamydia, trachomatis, and staph aureus, strep, Neisseria, gonorrhea, and herpes. Sign: purulent gonococcal and or mucopurulent discharge, conjunctiva injected, and eye edema, chemosis. Management: conjunctival scrubbing for gram-positive and stain, chlamydia antibiotic test, culture, blood and chocolate agar, and viral culture for treatment with topical antibiotic, eye drop, and or ointment, and guided by the result of the gram and negative. If chlamydia trachomatis, treat with the systemic erythromycin, and since pneumonitis and otitis media can coexist with the erythromycin ointment 4 times per day. Acute conjunctivitis, the last, may be viral, chemical, bacterial. Conjunctivitis, mucopurulent discharge, viral watery discharge. Treat as bacterial, topical antibiotic, and expectation is the gonococcal, which is the required systemic antibiotic and topical drop. Viral supportive treatment with cold compressor and artificial tears, which is highly contagious for 1 up to 10 days. So we must be careful with the deal with this patient with the virus because it's highly contagious. Cellulitis. Cellulitis may be preseptal or orbital cellulitis. Common organism: staph aureus, staph epidermidis, or strep pyogenes, and Haemophilus influenza. Preseptal cellulitis involve soft tissue of the eyelid and preorbital tissue anterior to the orbital septum. Patient presented with erythema, swelling, tenderness, eyelid, and surrounding preorbital area. Orbital cellulitis, more serious infection, involve extension of the infection posterior to the orbital septum, which is more danger than preseptal. And the risk, it's danger due to the risk of the cavernous sinus thrombosis, and meaning that's brain abscess. Proptosis and ophthalmoplegia decrease vision, significant pain on the eye movement, and abnormal pupil, and decrease in the vision and the color vision defect. Like this, orbital cellulitis picture. Treatment of the cellulitis: mild preseptal cellulitis, oral antibiotic may be enough. Severe preseptal or orbital cellulitis, you must admit the patient and start on the IV antibiotic with a broad spectrum until the infectious agent is identified. Can add a topical antibiotic ointment. So we must ENT consulted if the sinusitis or mucopurulent, and if the patient is immunocompromised, consider mucormycosis and severe fungal infection with a black Jar's sign in the nose or roof of the mouth. Immediate surgical debridement and antifungal treatment. Thank you for attention.
Thank you. Thank you very much, Dr. Hisham, for your presentation. All the questions, it will be after the finishing of the session. We are, as emergency physician, really we are looking to deal with these cases in ophthalmology. With the pleasure to introduce our next speaker, Major Dr. Arij. She is family medicine specialist, training fellowship in community medicine, master degree, working as representative of infectious disease at the Royal Medical Services. She will talk about public health emergencies in our Royal Medical Services. Please, Dr. Arij.
Good evening, everybody. Thank you, Dr. Ahmed, for introducing me at this sweetie way. And also thanks for organizing committee for kindly invitation to me. And I'm really so happy and proud to be here with you today as a guest speaker. Today I'm going to talk about public health re-emerging disease, and I will give more details or focus on one disease of it, which is seasonal flu. And really I have chosen really flu, this topic, because influenza familial, okay. I have chosen this topic because influenza familial for all of us, and is constantly re-emerging disease because it's, as we know, it has genetic variation and rapid adaptation, which allow virus to serve up new strains each cold and flu season. And that occurs because immune system or our body is not primed to fight. Let's start. First, we must differentiate it between, both of it are epidemiological terms, which is emerging and re-emerging disease. Emerging disease defines as disease that haven't really appeared in a population or have existed, but are rapidly increased in incidence or geographic range. And the most important example, it's a COVID-19 of emerging disease. About re-emerging disease, we can define it as diseases that reappear after they have been on a significant decline, or re-emergence may happen because of breakdown in the public health measures for disease that were once under control. And the most important example for it nowadays, which is cholera. Cholera in most Middle East countries and all over the world, we can see more cases of cholera, but now in Syria we have epidemics of cholera. And what we mean by epidemics, it's also epidemiological terms, it's occurrence of disease in normal of expectancy. And all the countries around Syria or had refugees from Syria now prepare new guidelines to control these cases if we have more cases in our country. They can also happen when new strains of unknown disease-causing organisms appear. I will give more details about influenza, seasonal flu. It's RNA enveloped virus. It's related to family called Orthomyxoverdi. It's very, very, very small. This picture, it's under microscope. It's about 80 to 200 nanometers. We have more than 400 types of viruses, but we will focus mainly on the 3 types, A, B, and C. And about the B and C, we have not genetic mutation over it, more the mutation we can see with the strain A. So also we will focus on the serotype A. About the A, it have something which is called glycoproteins over the surface of the virus, glycoprotein antigens, which is called H and N. H refer to hemagglutinin and N refer to the neuroaminidase. These pictures give us more details about how these glycoproteins present on the outer surface of the virus, and if we have any genetic mutations, it will be happen at these glycoproteins. In the influenza, how its mutation or that mutation happen? It through something which is called antigenic shift and drift. What we mean by antigenic drift and shift, at what's the main differences between it? About the antigenic drift, it's a it's a slow change, and the main difference between the antigenic shift and drift, it's a slow change in the viral genes due to replicating error or random mutations result in the new virus strain, and that's what happened with seasonal flu every year. But about shift, it's rapid and large antigenic change in a virus and requires at least, we need 2 different types or serotypes or strains to combine to form new viral serotypes. Also, we have another name for it, which is called phenotyping change. And the most familiar example of us, what happened in the swine flu, H1N1 and H5N1. Let's give more details about influenza flu. Why it's important? Because we have every year about 9 to 41 million cases. And despite how common is it, it's a serious disease. And every year we have 450,000 deaths and about 650,000 hospitalization occur in all age groups because of it. We have high-risk group. We can see the more number of deaths in this high-risk group. Healthy children can die from the flu. The younger the child is the higher risk for serious flu complication. And this complication we can see in this high-risk group, which is older age than 60, younger age than 2 years, and if it's neonates, also we can see more complication with it. Also, any immunocompromised patient due any cause, they are on the chemo. On the chemoprophylaxis drugs. Also patients with a chronic disease such as hypertension and DM for long period. They will suffer more if we have influenza flu, seasonal flu. So when we give vaccine and talk about the flu vaccine, we will focus on this high-risk group. Young children are at high risk for serious flu complications such as secondary bacteria pneumonia, ear and sinus infections, and also dehydration. Now let's give you some information about seasonal flu. As we know, seasonal flu incubation period about an average from 5 to 7 days and average about 4 days. We have symptoms appear about 2 days before the patient will be infectious to others about 2 days before appearance of signs and symptoms. And about signs and symptoms, all of us are familiar with it, which is general weakness, headache, low back pain, also low-grade fevers, and بالإضافة اللي هي عندنا اللي هي respiratory symptoms such as productive cough. About the treatment of it, as we know, antibiotic is not effective for treat because it's viral, so we use antiviral. And the most important prophylaxis measures, which is اللي راح talk about اللي هو الvaccine, الفلو seasonal flu vaccine. Mainly we have 3 types of the vaccine. Contains اللي هي عندنا أول شيء the first weakened pathogens اللي هي life attenuated, which we called life attenuated vaccine, and inactivated, or which we called inactivated vaccine or killed vaccine. It's the same pathogen. It can't make us sick. And also we have, if we have made the vaccine from subunits of the virus, which is a smaller part of pathogen like an antigens. What's the main differences between 3 types? A life attenuated vaccine, it give us something which is called lifelong immunity. So in the future we don't need extra or booster doses of the vaccine. But about inactivated, we still need more doses and booster doses of the vaccine because it doesn't give us lifelong immunity. And about اللي هي subunit like طبعا اللي هو الانجريكس or hepatitis B vaccine, the most example of it. Life attenuated, the most example of it, which is the mumps, measles, and rubella vaccine. And the inactivated اللي هو seasonal flu vaccine, example of it. All vaccine mechanism of actions contains antigens which trigger the immune system to create specific antibodies, which is we called memory antibodies, and it will give a signal for pathogen destruction in the future. What's the benefits of the vaccines? It provides us protection from pathogens which can kill or make you sick. Also, we use this to control and eradication of once common pathogens like polio, smallpox. Polio, it's one of the re-emerging disease. It stops outbreaks and global epidemics, and that's what will happen with the COVID-19. The COVID vaccine, it have a great role to stop outbreaks and the global epidemics. About the risks and challenges, we must know about the vaccine. We must know no medicine is 100% effective. So people can sometimes still catch the pathogen, but this is very, very, very rare. Side effects, maybe we have side effects, and we can classify it into local and systematic side effects. Local side effects such as the swellings and fevers. And also we have the most dangerous side effects, but also it's very rare, which is anaphylactic shock, and it's need emergency. Not all pathogens have a vaccine. For example, still now malaria, it doesn't have specific vaccine for it. The benefits overweigh the risk, so vaccines are given to people. We must give it. And also scientists work to make and improve vaccines. We will give more details about the flu vaccine. Who should get vaccinated? As I said, mainly focus on the high-risk groups. Who are high-risk groups? Everyone, we can give it for everyone 6 months and old. We have mainly two types of the vaccines. We have injectable one and nasal spray one, and I will discuss or give more details about the main differences between them. About that, اللي هو هون بحكي, I'll talk about the shot flu vaccines. Who should get vaccinated? Everyone 6 months and older can receive it, especially individual at high risk of developing flu-related complications, and or if you live with or care for people with high risk for developing flu-related complication, or if you are medical staff, so especially in emergency rooms, so you are always in close contact or direct contact with patients, maybe they are flu patients. What's the absolute and relative contraindication for the vaccine? Who should not get vaccinated? People who have severe allergy to chicken eggs, and because the vaccine is prepared at chick embryo, anyone who had known allergy to chicken pox, it's absolute contraindicated, so we must take a good history from the patient before give him vaccine. People who had a severe reaction to the vaccine in the past, people who developed Guillain-Barré syndrome after prior dose of the flu vaccines, and people with moderate or severe illness. People with moderate or severe illness, it's not, it's relative contraindication. We will wait until the patient gets well, and after that, give him the vaccine. About the nasal spray, the injectable vaccine, it does about 0.5 ml. We can receive it IM, and as we said, it's given to the age from 6 months to the 65 years, and it's a type of it, it's inactivated or killed. But about nasal spray, we are in Jordan, we don't have just injectable type, we don't have nasal spray, nasal spray vaccine. Nasal spray vaccine, it's life attenuated vaccine, so any absolute contraindication to any life attenuated vaccine should not receive the vaccine. And about nasal spray vaccine, اللي هم بياخذوا healthy people aged from 2 years up to 49 are eligible for this type of the vaccine, and absolute contraindication for it, they should get the flu shot instead. Adults 50 years of age and older, or children from 6 through 23 months of the age, children younger than 5 years with any of this condition, asthma or one or more of episodes of wheezing within past years, the pregnant lady, because as I said, it's life attenuated. Injectable, it's safe for pregnant lady at any stage of the pregnancy. She can receive it from the first stage, from the first trimester of the pregnancy. People who have certain long-term health problems, muscle nerve disorders or weakened immune system. Also anyone in close contact with someone whose immune system is so weak, because it's, I said, life attenuated, and they require care in the protected environment. Also children or adolescents on long-term aspirin treatment. Does the shot cause the flu? It's the most common questions we received from the patient? The answer, no, the flu vaccine doesn't cause the flu. Maybe it causes flu-like symptoms, but it's not a flu. The viruses in the vaccine are weakened, as we said, it's attenuated or killed, inactivated, so the shot and the nasal spray won't cause you to get the flu. The vaccine will prompt your body to develop the antibodies necessary to fight, and it's the mechanism of action, as we said, of the influenza viruses, and a slight reaction to the shots, such as soreness, redness, hotness at the site of the injection, and maybe we have mild muscle or fever may occur. Thank you for listening.
Thank you, Dr. Arich, for your nice lecture. All the questions, as I said before, at the end of the session. With the pleasure to introduce our last speaker today, Dr. Attar Ali Mahmoud. He is consultant of emergency medicine, clinical lecturer, University Melbourne, Director Advanced Life Support in Australian Station Council, Emergency Medical Service Trauma, Advanced Trauma Life Support Instructor, Stream Lead Clinical Service of Clinical Governments, and also Australian of Emergency Medicine. He will talk about transformative scenario planning in healthcare.
Previous page, it's laser, but old push.
Okay. Good evening, everyone, and it's an absolute pleasure to be here today, and thank you very much. Merhaba, that's the only word I learned from the taxi driver, so apologies and forgive me for that. I'm not learning more of Turkish. Transformative scenario planning. Transformative scenario planning, so what exactly is this? It's actually a very complex social technology that kind of uses all the existing social models which actually kind of use for change management in our healthcare system, but using various combinations of it. It's about a transformative leadership. It's about transformative facilitation, where we actually bring people together to bring this change. It's a diagnostication tool. When we are actually stuck in a situation, it's actually kind of, it works. We'll go through that later. So, unfortunately, with the kind of growing demands for the healthcare systems and our kind of limited resources, we are faced with the change management all the time. So when we actually have this systems change, processes change, or whatever that's happening, we either actually faced with this choice. Either we actually accept it, adapt to the situation, or we challenge the situation to change it. Unfortunately, there's not much room to say, I don't want to change, because then perhaps we may not be part of the system anymore. I found this maxim very helpful at times to me. Niebuhr was an American theologist of the 19th century. And he said, Lord, grant me the serenity to accept the things that I cannot change, the courage to change the things I can, and the wisdom to know the difference. The last line, I always look back to it. I want to know which I cannot change and which I can change. So in today's talk, what we're going to talk about is, we're just going to talk about a bit of historical perspective about where this transformative scenario planning process actually has come in. We'll give a bit of introduction about how change management happened that you must all have faced in your institution, in your hospital, in your health service, in your country. We talk about Moy's theory that the grandparents' health, we kind of took a major endeavor there, and how we use this technology, these systems in our health service. And we do a bit of more delve into the principles of transformative scenario planning. Thanks to Adam Kahan. Adam Kahan done a lot of work, and he's one of the pioneers actually establishing transformative scenario planning. Adam Kahan, he used to kind of work first in the scenario planning division of Royal Dutch Shell Company. So Royal Dutch Shell Company was the 7th largest oil producing company at the time, and they had a division. This division of team would actually write different scenarios. So what would happen? What could happen? What may happen? And they would write these scenarios across globally, across regions, governments, political, geopolitical, wars. But their interest was, if something happens, what do we need to do? Their interest was money. And they also say that their interest had environmental impacts and all. Kahan worked in this division for about 2 decades, and he did not stumble across. He did stumble on the transformative process. It's purely by an accident. He was invited to Montfleur scenario planning meeting. This is the transitioning of South African post-apartheid government into the new government, into the newer systems. There was a lot of conflict, the conflict between the government, conflict between the rebels, the unionists, civil societies. Everybody had a different vision for how they want the change to happen, how they want the country to change. And there was a very famous joke at that time in South Africa. We are faced with only 2 options, a practical option and a miraculous option. A practical option is we all kneel down and pray to some angels come and take our problems away. And that was the practical option. Whereas the miraculous option was we all sit together and work and bring this change forward, and that was miraculous. So Kahan stumbled upon Montfleur. And then what he noticed, that has changed, that has actually developed into transformative scenario planning process. He kind of worked after that in the Colombian transition, Guatemalan transition. He worked in Ethiopian, the conflict management. So initially it went on to the high conflict zones, then it actually came to some civil society movements, health movements. There's a lot over the next 2 decades. He has worked a lot, and if any of you interested, these 2 books would be very, very useful. I refer still often to these books, and it gives me always kind of a bit more insight about certain things. When I'm stuck, I don't know how I'm actually bringing this change. So what the Australasian College of Emergency Medicine did is they took Kahan's work, saying it's been applied in societies, it's applied in various big institutions, it's applied in the country transitioning. Why can't we use that in our healthcare? And they developed this changing module, leading change module. And I was fortunate enough to be the part of that module. That led to a second opportunity that we worked on that, to use those kind of principles into my next major project. So conventionally, whenever we are actually talking about change, we actually see these 2 models. Institutions, generally hospitals follow this longitudinal facilitation model. Once, because we don't have time, say what happens? The bosses decide, said we have the right answer. They say we need to agree. We know the way forward, and we will decide, and we must fix this. With longitudinal facilitation, it's much coordinated. It could be cohesive because everybody in the organization knows that I have to follow. I don't have a choice. So this could be quite rigid, and it may not give you much opportunity to think laterally, saying, hey, we could do something else. Whereas most of the social change the conventional process uses is the horizontal facilitation. In horizontal facilitation, when the organization says, we have the right answer, the people say, we each have our own answer. We need to agree. And the people say, we each need to keep moving. Or they say, we'll each find our own way. We each decide for ourselves what we need. We must each put our houses together so that for change to happen. The problem with this is it could be too lateral. Sometimes containing could be quite difficult. In transformative facilitation, what happened is we're going to move the facilitator. That's a sign of leadership. They move forwards and backwards, stop, iterate, go backwards, go forwards. So they use various types, various decisions, and using this various combination, it's most like a spiral thing. The beauty of transformative scenario planning and the transformative facilitation is we don't push change. We bring people together. We kind of take the blocks away, remove the blocks, and the results from the change happens. It's like actually removing the boulders from the mountains so that the streams flow. It's done, but it's done, there's an art to it. So when does it work? Whenever we find our situation is unacceptable, unstable, and unsustainable. Pretty much that's the state of emergency medicine services or emergency department across the world. We are overwhelmed, and this is the situation we are facing. This also gives one more concept. When people realize that we cannot change by ourselves or my mates, I need to go across the aisle. And they also realize we cannot change our situation directly. That's when the transformative scenario planning works. So how we use these principles at my place. We are the tiniest state in Australia. For some reason, we have over 190 health services in this tiniest state. And you can imagine what happens. Each health service has to have its own compliance, its own governance structure, its own employment systems. That's a lot. There's a lot of duplication. And that kind of is giving a bit of big problem for us to kind of recruit people into smaller health services because everybody wants to be in Melbourne. So this is kind of a detailed map, and I would just kind of like to point out, so I work at this place called Ballarat, which is about an hour from northwest of Melbourne, and we are the second largest regional receiving unit. So we were faced the task that we take this region. That's a huge region. Okay, please do not compare Australian population to the size with any European nations, because our population size is a lot smaller than for our geographical areas. So the 4 health services, which is the Ballarat Health Services, was where I'm primarily based, and we were actually had to bring another 3 health services under a single entity of Grampians Health. Just a 2020 snapshot that actually when we looked into our service, that was the population in the first column, and then the second column actually talks about how much admission rates that we had. So what are the service challenges we were getting? The Wimmera Health Group, which is our second biggest hospital in there, we almost spend about 10 million for the year on locums. And there was issues with actually having these people consistency in providing the care. Whereas the smaller hospitals, which is the Eden Hope and the Stall, we actually seen there's a less public engagement there. The public did not have trust because of, again, the staffing issues and all other. As a result, we were kind of underutilizing those capacities there. Whereas at Ballarat, our surgical wait list gone up by 12%. Our bed occupancy was almost kind of 90. We were running at 90 to 95% bed occupancy per day. And we all have noticed our population is getting older. So we had to do something about it. Okay, we realized if we bring all these health services together, there are a few things we can achieve. There's a local community access, so the people actually don't have to travel for long distances. We want to kind of build some strength and some capacities. As a bigger organizations, perhaps we would be able to do that. We want to deliver a more effective healthcare system. And plus, we want to have that community engagement that they don't have to travel 100 k's down the line, right, to kind of just accept the same cases. So whenever we actually face with change, this is the behavior change paradigm. What happens when there is a drive to change is very high, and also there is enough support for the change to happen, that change in behavior can happen. If there is any mismatch, unfortunately, this change doesn't happen. So we had to form kind of a massive project team. I don't want to dwell into much into that. And I was leading the clinical services and governance structure of this team. So we have to make one governance structure, we have to make one clinical services plan. And there are a lot of factors, a lot of players in this. And the biggest thing would happen, the smaller units felt threatened, saying, oh, we're going to be actually, the big guy is going to come and tell us what to do because they are from a bigger unit. And the other hospital which was struggling, they were just taking anything we would say as threatened. And the people from the main hospital were saying, oh, some more additional work for us. So we approached them by making 10 clinical divisions initially. However, once we started kind of working them, we realized the pharmacy services did not want to be part of it because they did not identify themselves as the part of the diagnostic group, which is fair enough. So we had to actually create an 11th division, and then we worked with the scenario planning process with each of these services.
You have 5 minutes, Dr. Attar.
Thank you. So what happens in the transformative scenario planning process? It's a 5-stage process. You want to start with co-initiating, co-sensing, co-presencing, co-creating, and co-evolving. The first step as a co-initiating is quite important. You want to kind of recruit people. the system-wide representation. You want to have as much wider group that you want to recruit. But there's few things that you want these guys to be. Before you recruiting them, have a bit of exercise, whether it will be individual level, whether it will be systems level, that what barriers you would come across. And when you have barriers, you always find some enablers as well. That will give a good opportunity to see who do you want. You want a whole team, whole system people. They have to be a bit insightful, influential, interested people. And more importantly, you may notice that when you actually form this team, some people just don't want to be there. Some people come there just because they've been told to come. Some people have lost faith in the systems, that the systems will ever improve. Some people are burned out, they just don't have time. To bring these people, you need to actually kind of build a very strong container, not a physical container, but it's a form that they feel safe. They can come and tell anything they want. And you have to have some processes developed, how you want to kind of manage these people. You start with having a few people to start a convening team. Don't give more than 10. Probably 10 is a bit useful. And then you want to construct from that 10 members, you want to discuss with them, and you want to have a large team. So what we're going to do, we're actually kind of bringing people together who are influential, insightful, and interested for this change to happen, for the drive to happen. We want to give them the safety container that they can express anything they want. Let's learn together. The role of facilitation here, the transformative leadership here is, it's quite important. You need to have this very fine balance. You want to be part of the group, because if you're not part of the group, the people don't get engaged with you. But equally, you have to be outside as well. So you want to have a circle. You want to be inside the circle, and you want to be outside the circle. So outside the circle, so that they see you as a third party who's there to kind of brokerage a deal here. But they shouldn't actually see you as a threat either, because if you kind of give a lot of your expert knowledge, then people actually perceive as a threat. It's a bit of delicate balance. But the other thing about this facilitator plays is he or she plays a game, an inner game and an outer game. Outer game is, we want this change to happen. Whatever the change may be, I don't know, because I haven't actually unraveled the mystery. But I want to be. So the inner game is, that's when we call it a reflective inaction, that I do not have to do anything, but what I need to do so that I do not have to do anything. It's a very interesting concept of the reflective inaction. I would encourage you to read if this actually kind of philosophical concepts interest you. Once you bring these people, you listen to them. Let them tell their stories.
Try, Dr. Attar, to finish in 1 minute, please.
Okay, so sorry guys, I have to just kind of, so towards the end, once we actually kind of have listened to the stories, once we have actually found out what's happening, you start building some relations. Unfortunately, I had some couple of good examples, but I have to kind of let it go. So what we do is, then once people have felt comfortable, they share their stories, there is a bit of relationship building up happening. That's when you actually get the strength. And the strength, actually, people open up more. There's trust building happening. At that time, you just ask people, okay, so tell what can happen, what should happen, or what might happen. The last stage, the fourth stage, is very important as a kind of facilitator. You module how this would do. So this is a likely scenario when the systems is moving slow to fast. So from the left side is the systems. And on the vertical axis, if you use people moving slow to fast. The scenario one, what happens is when people and systems move, so one is moving very fast, the people are moving very fast, or the process is moving very fast. But so like an organization saying, we need to do this very fast, but the people are not ready. That's a disastrous situation. That actually results in capsize. The second is a situation that where both the systems and people both move forward to bring this change. This is good. You want to capture this. But this cannot last long. People get tired, exhausted. The resources, resources we don't have. A scenario 3 can happen, which is portage. In portage, what's happening is everything is moving at a pace and adapting. And again, a scenario 4 is they're both very slow. The people in the and the systems, they're both very slow. So really change doesn't happen. You look at these likely scenarios and use 2 different analogies here. So you want to kind of start kind of a adaptive process. So if this happens, what I need to do? Whereas you look at a transformative process, in transformative process you say, hey, this is the possibility, which one I want? Which one is in my best interest? But once I know which one is my best interest, I want to write that scenario. So it's like, what are my threats if I want to achieve this? What are my weaknesses if I want to achieve this? How can I achieve this? You get your answers about the situation that you're stuck in. You remove the roadblocks. It gives you a very clear picture that lets you to act on it. So you transform your understandings, you transform the relationships, you transform your intentions. With all those transformations, you transform your actions and change your systems, change your situation. And you fly together. The flight of flamingos was actually the theme of Montfleur, going back to the same situation. Thank you very much.
Thank you, Dr. Attar, for your amazing lectures. Now we are open the session for the questions. Any question, please? As usual, Professor Bahjat, please. Please give microphone to Professor.
Thank you very much to all 3 speakers for their nice speech. I have a question for Dr. Hisham and one for Arish, and a comment for you, Dr. Akhtar Ali Mohammed. To me, in emergency department, the most difficult physical examination of the patient is ocular emergencies. For example, I am working in emergency department since 23 years. 2 years as GP, 4 as residents, and the remaining as physicians. But I'm still afraid to examine a patient with ocular emergency because it involves a very small area, and there are so many different disease. So really, as I said, I'm working in ED since 23 years, but it is a scare for me. Do you have any suggestion for me? to be much more better to examine the patient and care and do their management. And please let me finish my question. And one question for Dr. Arish. In your third slide, you mentioned we have 450,000 deaths, annual deaths, and 650 hospitalization. According to this knowledge, the average of the mortality is over 70 for the hospitalized patients. Is it right? I might got wrong. Is it right? The average of the mortality in the hospitalization patients is about 76.
This percentage, it's...
Dr. Arish, Dr. Hisham, please be in the front of listening.
Okay.
You can come here, please.
And for Dr. Ali, Akhtar Ali Mohammed, thank you very much. It is really very impressive, very interesting for me to listening to such a lecture, and it is about transformative scenario planning. You mentioned about many things that are really, really very important for a success. I mean, you talk about the coordination. Okay, I think it would be better to have additions such as communication, a well communication, have communication, when to communicate, to whom to communicate. And also we may mention about the responsibility, sharing the responsibility. And also to accept the mistake. If anybody accept the mistake, they can find a solution. Otherwise, never. They can. If I do not accept my mistakes, I cannot find any solutions. Then, and to always we mentioned about the self-protection. I think it is wrong. It should be a group or whole protection. We may mention about it, and changeable. Everybody should be prepared as changeable, change their mind, their skills, their, practice, and like this. And we may know about our limitation, knowing or aware about the limitation. Nobody is a hero alone. Nobody is here alone. So you shared and philosophy sentence. I want to share one of my. There is a problem. You have a problem, and it needs a solution. If you have a solution, do not wait. Do it immediately. This is the first step. The second, you have problem, but there is no any solutions. There is no any solution. Please and please, do not hurt anybody and neither yourself. Thank you very much.
No any question. Okay. First, thank you, Dr. Bahjat. The cases I speak in my lecture, we must manage by any doctor in the emergency, even by the GB doctor, because if there's cases presented to you to the emergency with chemical injury, acidic or alkaline, we must keep in mind first step irrigation before sent or before even sent to the ophthalmologist, or even before the ophthalmologist come to the emergency in order to examine the patient. This first message. Second message, we must keep in mind maybe the patient is presented to the emergency after midnight. You must keep in mind everything, every step first. You must examine the eye. You must know this case is orbital cellulitis or retrobulbar cellulitis, retrobulbar hemorrhage. We must deal, because the time is very important. We don't delay up to the ophthalmologist come, because maybe this is affect the patient and maybe lost. If you try to examine the eye, maybe you manage the patient in proper way. But maybe you fair because it's a small area. No, this is wrong. You can deal even before the ophthalmologist come. According to from the history, take the history of the patient and try to examine the eye. If there's foreign body, we can remove by triangular swab or by anything. If there's trauma or rupture, we can by under the good light, we can manage the patient. And solve the problem before the ophthalmologist come, because the time is very important in these cases. Thank you.
That's number are estimated from CDC, and the total number of deaths, it's among complicating cases. From complicating cases, not from all the number of all of total cases over the world. So it will be less than the world. You have any that else?
No, I think, do we have time for Dr. Akhtar to share his story? Dr. Ahmed, do we have time for Akhtar to share his story?
Yes.
He has a story.
Thank you. I think one of the things that is, as you said, mistake.
Except mistake.
As an organization, as people, we need to learn to forgive people. We can't be holding people for mistakes. Mistakes happen. We all can make mistakes. So in a conducive environment and a good organization, you want to achieve this balance of power, balance of love with sense of justice. When this balance prevails in any organization, you have a much healthier staff, you have a much healthier organization. So forgiveness, we need to have incorporated into our systems. The second aspect is, as you said, that if you see that you have seen, if you know how to fix a problem, perhaps it could be the right approach in that situation, but not necessarily always. Because we again, going back to that longitudinal model of command, we're saying, I know this, I have seen this, this will be done. But if you ask a story from a different person, that could be quite different. So yes, there's no right or wrong answer. There's no hard and fast rule. We just kind of adapt. But again, how we are adapting, how we're getting that balance. And sorry, just remind me the last part of the question was.
No, you had a story. You want to share a story, one of your stories.
Oh, the story. Okay. So apologies if I'm taking a bit longer time. So when Kahan was actually working with the Colombians in the 2017, so when the Colombians were actually brought in, so they had the guerrillas, they had the military, they had the government, they had the academics, business people. And one of the priests got up and said, so how the relations got built up. The priest got up and said, I happened to go to this mass grave, and I found bones mixed with adults and very young children. And I asked the forensic pathologist there, how did this happen? So this is a mass grave of pregnant women. The moment he said that, there was an absolute silence in that group. And that is your aha moment to bring these people together. And the same guerrilla said, we are here for this meeting because we don't have to do this again. So this is the art of transformative scenario planning, how you bring people together. Thank you.
Any questions, please? Any more questions? Okay, thank you very much. At the end of the second day of our sessions, we wish you good luck and success. And tomorrow we will meet with another speakers. Professor Bashar, please.
Okay, no. Thank you very much. Okay, time is very hot, and we have only lotto. Bir çekilişimiz var. They wait for the lotto. Okay. Çekiliş yapıp öyle göndereceğiz.
We have a sweep scare. Sweep scare. There are so many names written in the piece of the paper. And one person, I think Dr. Akhtar is going to get
Take one person, please.
What is the gift, Professor Bashar?
I will say later. Okay, after name.
So it's Apollyon Ozan
Döndü oğlum.
döndü.
Okay.
Ozan döndü.
Ozan. Okay, I will extend the gift. Tiran sempozyumunu veya gelecek ilki kongre arasında seçim yap. Kayıt olarak.
Hiç sevinmedin lan.
Teşekkür ederim öncelikle. Gelecek kongreyi seçeyim ben.
Okay, adam bilimsel ya. Tiran gideceğine okay. Choose for the next kongre.
He's going to be full sponsor.
No.
Well done. Congratulations. Thank you.
Hayırlı olsun.
Teşekkür ederim, sağ olun.
Thank you very much, Hannah, for this very nice invitation. It's a privilege for me to be the first speaker of this huge Congress, and I think that what you did in this session is to address the importance of invasive technology as a new opportunity to increase the powerful of emergency medicine worldwide. I really am happy to address this topic, and this topic is coming as the need, and we will see during my presentation, to work together. Not only emergency physicians, but radiologists, interventional cardiologists, to produce more evidence and publications, as we did into the great network, worldwide academic research organization that is with WASM worldwide try to increase the powerful of publication in our group. And I really appreciate that you put in the backs many journals, because this is the future of emergency medicine, to produce evidence. So let's go now and see, after my disclosure, what are really the need for technology support after clinical evaluation. Before starting my talk, let me tell you that no technology can support a bad emergency physician, because the best technology emergency physician has is his holistic opportunity to visit the patients and make clinical decisions. By the way, in the last 25 years, we saw an important increase in quality of laboratory testing, especially biomarkers in acute disease and point-of-care biomarkers, but also technology of imaging. So laboratory testing and imaging are going to be the big revolutions in our job to increase the quality of our medical effort and, most importantly, increase patients' outcome. When you talk about imaging, for sure you know that ultrasound are totally changing our ability. Every emergency physician now are able to perform ultrasound, and I'm very proud that we were the people that teach cardiology on how to use chest ultrasound to detect many diseases they were not able to do. But nevertheless, besides the ultrasound that are growing impact, there are other technologies such as point of care, looking at the computer-assisted imaging, but last but not least, the angiography. Angiography is really important, and I think it's something that can really improve our knowledge and also quality of heart delivery system. But of course, the issue here that angiography need a cath lab, or let's say radiology interventional box that should be as much as possible close to the emergency room. So this is the first example. 250 years ago in my regional city, Naples, these researchers put some substance into the vessels of humans. And these skeletons are still there in Naples, one man and one woman. And you see, he put this injection, but unfortunately, patients died. But luckily now, we have many different radio contrast possibilities that are able, thanks to invasive medical imaging technology, to use this iodinated contrast material to visualize the lumen of blood vessels. And this is very important because thanks to the angiography, now we can have very clear opportunity to see the brain, the neck, the aorta, the chest, gastrointestinal tract, and so on. But what is important, not to abuse the technology, but to make the right decision. First of all, now, blood vessels should be evaluated also with non-invasive technologies such as ultrasound, echo Doppler, TC scan, and magnetic resonance imaging. Nevertheless, although these new non-invasive technologies are going to be every day much more precise, we still need angiography, catheter-based, in the cases you need immediately decision-making to transfer the patient to surgeon, or last but not least, to have access to intervention radiology procedures that can impact the length of stay of our patients in the emergency room, and also to reduce the length of stay in the hospital and the costs related. So this is the way you have to think about how angiography can really increase our emergency department job every day. So I have one question for all of you. How many of you today have an angiography service available 24 hours, 7 days in your emergency department? Please raise your hand. Not so bad, 15%. Okay, let's see if the other 85% could be convinced at the end of my talk to try to insist to have an angiography box in their emergency department. So, and I think this is coming to the fact there are so many acute diseases that are elencated here, such as acute myocardial infarction, multiple pulmonary embolism, trauma, that can benefit having an angiography area into the emergency department. First of all, let me address my special topic, acute coronary syndrome. We know that time is myocardium, so you really want to start as soon as possible in the emergency department to reopening the vessels in the case of MI. These recently published 2019 guidelines on how and when to perform angiography in acute coronary syndrome is very clear that in the case of elevated ST myocardial infarction that is within 12 hours, you should do evidence 1A, in all this case, a PTCA. And then that is a delay opportunity, still evidence 1A, if you have no cath lab available, that you can do fibrinolysis. So in any way, you are going to perform in many patients as soon as possible angiography, coronary angiography, and then opening the vessels. This is a cartoon that I would like to take in mind, but I'm sure everyone in the audience is aware. In the case that you are able to make EKG in 10 minutes and you are going to refer an hospital where the cath lab is not available, you have two choices. If you are the STEMI in between 120 minutes, in that case, you can refer for 90 minutes, transfer the patients. Alternatively, if you have 2 hours that the STEMI is started, you can start fibrinolysis there, and then you can reperform in 10 minutes, transferring the patients. But if you have the cath lab, angiography, and the coronary PTCA available, you should do this in less than the 60 minutes. I think it's very important to save as much as possible lives in acute coronary syndrome in our patients. What about if I have a patient with not ST myocardial infarction elevation? In this case, there is the opportunity, if the patient is very high risk, also to go for invasive procedures if the patient is hemodynamic instability, if there is life-threatening arrhythmias, and also acute heart failure. So still in these patients, you can do PTCA within 2 hours. So something that you could do there, because you are going to save and increase the number of lives in the emergency department. So let's move now. Another important frequent reason of patients coming, pulmonary embolism. In this consensus statement for multidisciplinary physicians, it's very clear that in the case there is a big embolus that is very close, massive embolus, very close to the original pulmonary artery, you should do catheter thrombolysis and removal of the thrombus. So it is very important also to consider in patients presented with the syncope, massive TC scan, pulmonary embolism, to do angiography and remove the clot. Now, what about the need also to look at the aorta during patients coming in? I'm sure experience with patients coming with chest pain, you are looking for acute myocardial infarction, the patients can have aortic dissection. So aortic dissection is really a situation where the emergency physician can have the need to make an aortoangiography. What the guidelines say that the most risk is the ascendant aneurysm and the dissection, where the patient should be immediately treated with the beta blockers. All these patients should have beta blockers and then transfer immediately to cardiosurgeon in order to make a decision. So aortic dissection is another really important situation when you need angiography to perform as soon as possible. Now, I'm sure also in your daily practice experience, you are managing with the patients come in with acutely cool, painful leg, and in this case, you really are going to clinical put a suspicion of acute limb ischemia. In this case, you can perform a Doppler that is mandatory, and in the case of Doppler, you can have three possibilities. Assuming that you have no artery in the, let's say, pink area, sound, no vein sound, don't waste time. Ask the surgeon to make amputation on the leg. On the other side, in the green area of this cartoon, if you have a presence of audible artery and veins, you are going to do angiography because you want opening the vessels that bring blood to the limb. So I think it's very important also in the acute limb ischemia after the clinical judgment and also non-invasive assessment to go for an angiography. Now, another important issue where the angiography is going to be increased, the role is a stroke, both ischemic and hemorrhagic stroke. In ischemic stroke, in the case of these 6 possibilities, pre-stroke MRS score between 0 to 1, causative occlusion of the internal carotid artery of MCA segment 1, age greater than 18 years, NAIHSS score greater than 6, aspect greater than 6, treatment of removal. The occlusion of the artery should be done after angiography, but in the case of the symptoms are greater than 6 hours, and you cannot do thrombolysis. But what is important, this leads to the need, like the recommendation, guidelines 2018 are going to put out the importance of a multidisciplinary team that is my auspicious in this conference. Opening the ceremony, I think is a very good opportunity for me to tell that we have to work all together in order to improve our skills and patients' treatment. And also it is important that angiography should be there in the case of ischemic stroke. And also it is important that you want to monitoring. So our job is not only to start appropriate treatment, but to monitoring patients' outcome and publications on the results. What about hemorrhagic stroke? There is no doubt there are a lot of situations where you can use clipping or calling of the hemorrhagic site after brain angiography, and then you can save the patients, especially if he has hemorrhage due on cerebral aneurysm. So it is very evident that so far we addressed the important possibility to check in the case of acute coronary syndrome, acute aortic disease, and acute stroke, the possibility to use angiography. Now, what about trauma? There is no doubt that looking at a lot of bleeding that are going to be not able to stop because of what you're doing with the medical treatment, you should need an angiography. In this case, what is important as an example of the very severe trauma is liver trauma. In the liver trauma, you should consider 2 classifications. AAST, liver trauma classification, but also when you put together, let's say, the injury type, the grade, and injury description, you should also put one important, very, very important evaluation, the hemodynamic instability. So I would like to emphasize this important clinical judgment of hemodynamic instability, because if hemodynamic instability is present in the case of a liver trauma, you can go a very severe lesion to WHS, ESIV, and go to operating room immediately after an angiography. So there is no doubt that also in the case of liver trauma, you can have a lot of possibility. And I think that this is going to be of a great importance also in other trauma. Now, you know, our neurosurgeons are very good and with the intervention radiology to make spinal arteriography. And in the case of spinal trauma, they are able also to make embolization of very small vessels of our spinal doors and resolve the issue. So now let's move to the last but very important topic, that is acute gastrointestinal bleeding. I'm sure you are fighting every day with a lot of geriatric people coming in, taking anticoagulants, even decumarol, or new anticoagulants that have a lot of bleeding, especially if they take decumarol, because they are able to control INR. So there is a very important, again, the need for the emergency physician to assess the hemodynamic instability and then immediately to perform an upper endoscopy. If the endoscopy is negative, you can go to check the colonoscopy, but if it is not possible to be prepared because you need colonoscopy, you need preparation, then you can go immediately for angiography. That is really something that emphasizes the need to have angiography area where you can do a lot of important setting decision making. Now, what about embolization? I am sure this has been during the last 10 years, the revolution in stopping bleeding. And you can see from these data coming from registry, you can see that in trauma, the overall success of embolization is around 100%. Amazing. Amazing. You can solve the issue in many trauma, and also in the case of gastrointestinal bleeding, both from upper or lower sides of the enterical system, you can have embolization that are going to save lives. So it's not only a problem of hemorrhagic situation, but also of ischemic. Acute mesenteric ischemia is another important situation where, again, starting with the clinical suspicion, you are going to look about the possibility to have acute mesenteric ischemia and then to do CT scan and angiography. And also, in this case, you can have arterial thrombus that you can find, and then you can open the vessel. So I think it's very, very important to make important decision where to move or not from non-invasive clinical assessment to angiography. It seems to me there is a lot of room to improve and to need of angiography in acute setting. Let's talk about the contraindications. Last 2 minutes of my talk, I will address this important situation. Let me tell you that there are not really many contraindications in the case of need to perform angiography. You just need to make sure the blood pressure is quite controlled. You don't want to make sure that there is a renal insufficiency, so that the iodate contrast material is not going to deteriorate the damage, the function of the kidney. But thanks to the new quality of a new product, this issue is going to be very low. So in the future, my friends, we are going to have a lot of people, especially because life expectancy is worldwide increasing. And for the reason of that, we should, and also geriatric people, they have a lot of bleeding. We should really think about to increase our angiography performance into the emergency room. And these are my conclusions. After an initial clinical and non-invasive technology evaluation, I put this in red, because it's the starting point. Please don't go immediately to angiography unless you have not made clinical judgment. In any case, it represents angiography a cornerstone in various clinical situations in the emergency department. It is also important because you are going to reduce the time of saving life and in hospital length of stay, so you can also save a cost. And in the future, I think it's very important that we are going to increase working together in the skills of angiography. But what do we need? We need research, data publishing, because like this consensus statement on academic emergency medicine pointed out a couple of years ago, in order to optimizing emergency department, diagnostic imaging has the potential to improve the quality, safety, and outcome in the emergency department. Because also don't forget the radiation are potentially dangerous for your patients. You really want to vote for the right patients, and we need the data. So my final auspicio will be to produce more data in this setting. And thank you again for giving my talk. So just in the last 20 seconds, how many of you now are happy to have an angiography service next day in your emergency department? Yeah, I think it's increasing. I was expecting more, but that's okay. It's coming from 15% to 30%. Not bad, actually, without our auspicious. So, in any way, if you want really to contribute to our research, please come to Edinburgh or this biomarker, but last but not least, in San Diego, where we are working in implementing the geriatric emergency medicine, where I think angiography should be a big value. Thank you very much for your attention.
Thank you, Dr. De Soma. That was fantastic. At this time, are there any questions? I have a question for you. Good. That was a fantastic review of all the ways that we can use angiography in the emergency department in acute setting. It's not only diagnostic, but it's therapeutic as well. Do you see angiography at some point replacing the need for surgeons or surgery?
That is really the most important question. And I think, yes, this is the way we have to go, together. To produce evidence, if you saw last slides, I was making the evidence that we have to compare the value in any kind of innovations in emergency department that are two objective, patient outcome and cost related. So if you are going, as you said, to demonstrate that we can reduce surgeon length of stay and mortality due to therapeutic angiography, we are going to get the goal. And this is possible only with emergency physician skills in this topic.
Now, how many people want angiography in their emergency department?
I want. Thank you.
Okay, I want to invite with my pleasure. He is chairman of from Stanford University, chairman of Emergency Medicine Department, and he's very popular in Turkey, if you remember from last Congress, and I think he has very excellent textbook of emergency medicine in United States. He will talk about retrograde intubation. Mr. Mahadevan, with my pleasure.
Good afternoon to everyone. How are you? Good, good. It's great to be here. Instead of retrograde intubation, I spoke with Dr. Chandler about talking about video laryngoscopy, so I'm going to focus on that today. And first, oops. go. Sorry. Okay. Just want to show you where I'm from. I'm from Stanford University, which is in the United States in California. So yesterday, approximately yesterday, 24 hours ago, my wife and I were there at that star right here. And now we're obviously in beautiful Antalya. And I just want to say this is my 5th visit to Turkey and love it here. I've been to Istanbul, Kayseri, Izmir, Konya, Çatalhöyük, and now this is my 2nd visit to Antalya, and I had the pleasure of attending a prior Congress, also getting to sing on stage. Hopefully I don't do that today and scare everyone away, and spend time with Bashar, which is always fantastic. In my talk today on video laryngoscopy, I'm going to define what it is. I'm going to talk about the different classes, the different kinds of video laryngoscopes, the advantages and disadvantages of this new device, and then most importantly, the current literature about video laryngoscopy and how it's maybe taking over how we approach airways. Very quickly, show of hands, how many of you are using video laryngoscopes in your department? Okay, fantastic. So quickly, with regards to the definition, video laryngoscopy is indirect laryngoscopy, which means you're not looking directly at the cords, that you're using a digital device, a digital laryngoscope, to show you the vocal cords in the glottis instead of line of sight. And generally, for what we need them for, acute intubations, we're inserting these devices intraorally. And why would we need to do this? Well, our goal is to see the glottis, and that hopefully will help us improve our success with intubation. And ultimately, we want fewer failed intubations. Obviously, we want to reduce our failure rate. So there are 3 big classes of video laryngoscopes. The first is the channeled video laryngoscope, where the endotracheal tube is part of the device or is inserted into the device, and this matches the anatomic curve of your pharynx and allows you to direct it towards the larynx. But unlike the other approaches where you are manipulating the endotracheal tube separately, this is all one device. So if you want to adjust where the endotracheal tube is, you have to adjust the device. And so the other issue with this, as you can see, is it's bulkier. It's larger than some of the other devices. And so if you have someone with a small mouth, it may be difficult to insert it. The next device I want to describe is something called a Macintosh-style video laryngoscope, where the technique is similar to what we're doing with direct laryngoscopy. And in fact, you could either use the video or do direct laryngoscopy. And for this reason, since everyone in the room can see what's going on and you can give advice, it's great for teaching and training institutions. And then finally, the glide scope or glide scope-like devices are acute angle blade video laryngoscopes, where they're really good at showing you the very anterior structures, but if it fails for whatever reason, you cannot convert to direct laryngoscopy where you can see the cord. So let's take a look at this. A glide scope-like device inserted into the pharynx, and then you're looking at the monitor, you're looking at the screen when you're inserting the endotracheal tube, and so you're looking at the monitor but performing the function in the patient's pharynx. So what are the advantages of this approach, video laryngoscopy? Well, first of all, we always struggle when we're doing direct laryngoscopy to line these 3 axes. There's the oral axis, the pharyngeal axis, and the laryngeal axis. And if you look at this diagram, what you can see is that it's impossible for us to see like this. We have that line of sight. And so what we do is we try and get the patient into the sniffing position, as you can see here, and then by using the direct laryngoscopy and just raising their soft tissues, we achieve line of sight. And sometimes it can be very difficult, as you know, to see the glottis. And especially in patients like this. This is a trauma victim where you're not allowed to get the patient into the sniffing position because you're keeping them in the neutral position, and that makes it very difficult to align these axes. And in this particular case, the patient couldn't be intubated with the video or with the direct laryngoscopy. The other advantage in trauma patients specifically is the video laryngoscope can be inserted and manipulated in a way where you don't have to move the patient's head and potentially cause injury. Here's an example of a patient with an inferior anterior C2 fracture, but if we look at their cervical alignment, it's normal. So the spinal cord at this point is doing just fine. But what happens when you try to intubate the patient and you put them in the sniffing position? As you can see, this patient has a complete disruption of the ligaments holding the vertebral column together, and now the bones have moved and impacted potentially the area where the spinal cord is. So the last thing that we want to do is move the patient's vertebral column and potentially cause injury, which could happen in theory with direct laryngoscopy. And then finally, we're looking at a very narrow, small area and trying to insert an endotracheal tube through that area. Well, what if we were able to enlarge it, make it easier to see? And also, more importantly, as a teaching physician, that not only I could see what was going on, but everybody in the room could have confidence that this was being done properly or that we could assist. So those are the advantages of video laryngoscopy. What are some disadvantages? Well, if there's secretions or blood and it gets on the end of the scope, potentially you wouldn't be able to see. Or if the device fails for some reason and that's the only way, that might be an issue. There are a lot of different kinds of devices, so you have to be familiar with all of them, and we're not sure which ones really are the best. And there's no real evidence to tell us this is the best one at this time. And the technique for insertion is different than what we're used to. And it may be more challenging, just in the same way that if I play video games with my son, he's going to beat me every time because I'm not used to playing video games. Learning how to do a new approach may be challenging because you're not doing it under direct visualization. You're holding the device and then trying to look at a screen and perform the technique. And a number of studies have shown that when you're doing it indirectly, it can be more challenging. So now let's go over 5 important studies that might change the way that you think about video laryngoscopy as part of emergency medicine. And the first one to bring a lot of sort of attention to this was this systematic review, Cochrane review, that was done in 2016. This Cochrane review wasn't specifically focused on emergency physicians or critical care physicians, but looking in general at comparing direct laryngoscopy to video laryngoscopy. So they looked at a lot of studies, 64, 7,000 plus adult patients, but again, mostly in the operating theater and not in the emergency settings. They compared different kinds of video laryngoscopy to direct laryngoscopy using a Mac blade. And here are the primary findings of the study. There were fewer failed intubations with video laryngoscopy, and this was statistically significant. When dealing with difficult airways, there were fewer failed intubations with video laryngoscopy. And then when they compared the incidence of hypoxemia, it was similar between the two. So, major headlines, bottom line from this large Cochrane review: fewer failed intubations overall, fewer failed intubations when dealing with difficult airways. Next, we decided, since that was a focus on all comers and primarily the operating rooms or operating theaters, what about for those of us that practice outside of the operating room? Well, this systematic review and meta-analysis looked just at those places. So this was 32 studies with over 15,000 intubations. And you can see that there were about 6,300 video intubations and 8,700 direct laryngoscopic intubations. And these studies were outside of the operating theater, outside of the operating room. So they were in the pre-hospital setting. They were in the ICU. They were in the emergency department, places that we practice. And again, they use different kinds of video laryngoscopes as opposed to just one kind, and multiple kinds of providers. So there were beginners, there were experts, there were paramedics, there were emergency physicians, there were ICU doctors. So a whole mix of different kinds of providers. And what they were interested in is how often do you succeed intubating the patient the first time that you try. So let's take a look and see what they found. With regards to first pass intubation, there was no overall difference in this study between video laryngoscopy and direct laryngoscopy. However, if you were in the ICU, video laryngoscopes were better, but if you were in the emergency department or pre-hospital area, they were similar. What about the glide scope, which is one kind of video laryngoscope, and direct laryngoscopy? Well, they were similar. But when the CMAC, a specific kind of video laryngoscope that allows both direct and indirect laryngoscopy, was compared to direct laryngoscopy, it was better in terms of getting that first pass intubation. If you were a novice or a trainee, video laryngoscopes were better. But if you were experienced or a paramedic, it was the same. And then with video laryngoscopy, there were fewer esophageal intubations and more arterial hypotension. So what are the big takeaways from this study of non-operating theater, of emergency situations, ICUs, emergency departments, pre-hospital? Well, if you're in an ICU, video laryngoscopy was better. CMAC was better than direct laryngoscopy overall. And that if you were a novice or a trainee, that video laryngoscopy was better, and that there were fewer esophageal intubations. One of the themes that you're seeing here is that in many cases, in different facets, it's better, but it's never worse. And that's a very important thing as we move forward. Finally, I want to look at a study that it was a systematic review and another meta-analysis, but this time they looked at difficult airways and experienced providers. So most of you are experienced providers, and all of us that practice emergency medicine have had a difficult airway. And one of the things I think we can all tell you is, though we try and figure out who might have a difficult airway, sometimes it's very difficult to predict. And in this study, published in Anesthesia in 2015, of patients going to the operating room, the anesthetist could not predict a difficult intubation 93% of the time. They could not predict a difficult patient to mass ventilate 94% of the time, which tells us all of those tools and rules that we have don't work very well, and that any intubation could be a difficult intubation or a difficult airway. So in this study, which looked at experts and difficult airways, how did video laryngoscopy do? Well, it was better for first attempt at success, and you can see on average, when using a video laryngoscope, 95% of the time you were successful the first time versus 86% with direct laryngoscopy. And you got better views of the glottis and less trauma to the airway overall. So again, the take-homes, we're talking about experienced providers, difficult airways, and video laryngoscopy perform better. So it begs the question, this was an editorial that was in the British Journal of Anesthesia, about whether we should be using video laryngoscopy as the first approach all the time. And here's the analogy that they used. They basically said, how many of you still have a huge bulky cell phone like you did in 1995? None of us, right? We're all using some kind of iPhone or new phone equivalent, and none of us are using dial-up phones either. So as technology progresses, why are we relying on old technology when new technology is potentially superior? And they went one step further. They said it should be used on every intubation, and that we should record the video and put it in the medical record so that if the patient ever came back, they could review the video and determine if there was an airway problem or not. Two more studies to review before I finish. This is a group of anesthesiologists that decided to replace all of their direct laryngoscopy with video laryngoscopy. So I'm going to show you what happened. First, they assessed all of their team about their attitudes towards video laryngoscopy. And then for 2 months, they removed all the Mac blades from their operating room and from the places where they worked, and they only had CMACs there, okay? Which CMACs where you can do video laryngoscopy and direct laryngoscopy if you needed to. And then they did serial assessments over a course of time to see what attitudes were by the anesthesiologists towards video laryngoscopy. So here's what they found. When they started, about a third, and a third either said we fully support only video laryngoscopes, or we have some reservations, or some people said they don't support it. At the end of the trial, the 2 months of just using video laryngoscopes, there were fewer people that didn't support, but it certainly didn't have unanimous support. 6 months later, you can see a lot more of the anesthesiologists supported it. And then 18 months later, uniformly, everybody in their department supported having only video laryngoscopy. And the reason that they said was they felt it was better for patient safety, team dynamics, human factors, quality of care, and quality of training. So they changed after being forced to use them for a period of time. Their attitudes totally changed. And for many of us, it's the same. We're so used to direct laryngoscopy, we don't want to change, even though it might be good for us. And the last study I want to show you is one that's done in the pre-hospital setting, where they looked at a protocol where they used the CMAC, again, this video laryngoscope, and a bougie in all rapid sequence intubations. And so this was done in Finland, where for a period of time, they said you're going to use video laryngoscopy and a bougie, in particular it was a Frova introducer for all intubations. And then they compared that 22 months where they were doing that to the year before where you were able to do direct laryngoscopy. And here's what they found. Before using video laryngoscopy and the bougie, the first pass success rate was 85.7%. After being forced to use this protocol, using the bougie and the video laryngoscope, it increased to 98.2%. And think about it, intubating, doing RSI in a helicopter is a difficult airway situation. And here they went all the way up to 98%. And it begs the question, we always think of video laryngoscopy as a rescue device or a difficult airway device, but what if we used it routinely? What if we used difficult airway devices routinely? We can see that we would have an increased success rate, which we all want, and that, again, a bougie may be easier to pass with a video laryngoscope than an endotracheal tube. So a couple of takeaways from this study. So finally, what do we know? What's the bottom line? What can we say about video laryngoscopy? It improves the view of the glottis. It may improve first attempt intubation success rate. Remember the study I reviewed from Peters et al., 95% success rate with video laryngoscopy compared to 86% for direct laryngoscopy. The Cochrane review found that it may reduce the number of failed intubations. Again, fewer failed intubations when for overall and also when dealing with difficult airways. We know that it's already become part of our difficult airway algorithm, but it may be the primary approach for all intubations in the near future. And if you're using a device like I like, and I don't have any ties or affiliations with stores or the CMAC, but a device like CMAC, which allows you both direct and video laryngoscopy, is a device that might allow you to embrace the future without abandoning the past. And so those are my big takeaways about video laryngoscopy. And I want to thank you for your attention. Thank you very much.
Thank you very much, Dr. Madam, for fantastic presentation. Any comment or question? Yes, please.
First of all, welcome to Turkey and thank you for your presentation. I want to ask that I work in a hospital where approximately 1,000 patients apply per day. And I think that means that we manage disaster every day. And in my country, there are so many centers. While we are examining the cold or myalgia, on the other side, we may need to intubate the patients. And I think it's more difficult about us. What do you think about the practicality of this process in crowded emergency departments? Thank you.
Thank you for your question. I believe the question is that in settings where maybe you have less experienced providers, yet are crowded, what about having a device like this in those settings? And I think, you know, it's, the studies pointed out, those who are less experienced with intubating actually showed the greatest benefit in first pass success. And so it probably behooves us, if you're intubating all the time, you might have some expertise, but if it's an infrequent procedure, having a video laryngoscope might be of benefit, especially if you're doing it infrequently. But the other study I showed also revealed that even in experienced hands, it's hard to know when we're going to encounter a difficult airway. So rather than take a chance, my feeling is that we are progressing towards where we'll be using this exclusively, and that direct laryngoscopy will be something of the past.
Okay, thank you very much. Any another question?
Yeah, here, yeah. Okay.
Okay.
No, Bashar, I have a question.
Okay.
Thank you very much for this nice presentation. And it's clear we have the evidence for using this kind of tools. My question is, do you have information about the cost? You know, if you compare CMAC to the direct, laryngoscopy, this is very important, for different countries in the world.
So the question was a very good one, which is it fiscally responsible to replace a device that may be working with something that may be more expensive? There's two ways of looking at it. If you already are adding a device like a CMAC as a rescue device, then you're already purchasing it anyway in addition to the direct laryngoscopes. And the other one is more philosophical, which is that if your complication rate goes down and you have one less patient who has anoxia as a result of a difficult airway encounter, and the hospital isn't sued or doesn't lose money as a result, or the family doesn't lose money as a result, then that could justify, that cost savings from fewer complications could easily justify the cost difference between a laryngoscope and a video laryngoscope.
Okay, thank you very much. Last question, please. Last question. Yes.
Thank you very much for your presentation. I will ask, you said that some kind of video laryngoscopy is better than direct laryngoscopy in difficult intubation, but was it expected difficult intubation or unexpected, or was it well-designed criteria?
In the study that I presented, it was anesthesiologists who predicted a difficult airway based on patient characteristics or prior knowledge, and in that case, video laryngoscopy was more effective, even though they were experienced. But there was one study that I presented also that just shows we are not good at figuring out who is going to be a difficult intubation or difficult mask ventilation. And that's the problem. If we could just look at them and say, oh, you've got a beard or you've got a short neck, you're going to be a problem. But we've all encountered somebody that we're really worried about, and then we go in and it's an easy intubation. And we've also had patients where we say, oh, they've got a long neck, it's going to be fine, and then you go to try and intubate, and it's much more challenging. And so it's just, we don't have good tools, and we should just basically, my feeling is, approach every patient like they're going to be a difficult intubation. Thank you again for your question, and thank you for your attention. Thank you.
Thank you. Next speaker. It's a very important topic for emergency medicine, new topic. Reboa in ED. Dr. Yosuke Matsumura from Japan. Thank you.
肺結性 E 軍らベニムアディムヨスケ松村ジャポニアダンゲティムI'm an emergency medicine physician, and I also cover the ICU. And my another subspecialization is endovascular therapy. I cover the interventional radiology and of course reborn, and I also love to perform ECMO. So I am very interested to be here. Thank you for having me. So here's my disclosure. So let me introduce some reborn practice in Japan. So this is the procedure video. The first thing you need to do is get the access. The access at the common femoral artery. You need to puncture between inguinal ligament and bifurcation. Of course, you should use ultrasound routinely. You can see the bifurcation directly. And you advance the guide wire to the aorta. Then remove the needle and insert the arterial sheath over the guide wire. Then you can put the reboard over the guide wire. In this setting, the balloon is going up to zone 1. And next step, you need to exchange the guide wire for a stiff wire. This stiff wire will strengthen the shaft of the catheter. Then, then you can inflate the balloon. So by the way, the term reborn was published in Journal of Trauma in 2011. But in Japan, we start to use reborn catheter in 1998. So we have a very long history. Oh, sorry. But unfortunately, we didn't publish a lot of research paper in this field. 2003, 2009, 2015. Sorry about such long silence. Only small case series were published from Japan until 2015. But in this year, one case series was published in Journal of Trauma. The title is Safety and Feasibility. But I need to give a question to this paper because they reported the rate of lower limb amputation at over 20%. Surprising number. Next year, another paper was published. This is a database analysis using a propensity score match analysis. And they reported higher in-hospital mortality in reward group. This is negative data from Japan. A similar study was published very recently in JAMA surgery from the United States. This is again propensity score matching. And they reported higher rate of AKI, amputation, and high 24-hour mortality in reward group. So lower limb amputation. These two studies, the research period was before 7 French reward device. In the United States, they used to use 12 French, and in Japan, we used to use 10 French catheter. But now, we have 7 French small profile Ebola catheter. So probably this problem can be solved with such small profile catheter. This is our publication. So we demonstrated the fewer complications in small sheaths. We didn't require any fasciotomy, amputation, or PTA. But what about higher mortality? How should we use Rebord? One possible answer is here, algorithm. This is the classical algorithm suggested by Shock Trauma Center in the United States. And this is another algorithm from the Denver. This is another algorithm presented in the Western Trauma Society. How many Rebord algorithms do we have to learn? I hate to memorize many things. I believe to learn trauma strategy is more important to learn algorithm. So this is the summary of today's my talk. The first is thoracotomy plus Rebord can be the good solution in a critically ill patient. And second is early access, undelayed but short occlusion. These are the key issues for the successful management of Rebord. And third, I'm going to mention the education and research briefly. So let me introduce our recent case. 17-year-old boy, he fell from 11th story of the building. Actually, he jumped from the building. He collapsed 5 minutes before arrival, and CPR was initiated by the EMT. So first, we performed resuscitative thoracotomy and aortic cross clamp. And he was resuscitated after 8 minutes of the CPR, and chest X-ray didn't show any significant injury. And the fast exam was negative, and pelvis showed the fracture. So I identified the cause of the shock was here. So we got bilateral arterial access and the large venous access, and the massive transfusion was initiated. Then the fast turned positive at right upper quadrant. So I decided to go to laparotomy first. Can you see this picture? Before going to the operating room, we converted thoracotomy to zone 1 Rebord. And the patient was transported with partial Rebord. And in the operation room, we could defrate the Rebord within 20 minutes, and the surgeon found a liver injury. But it was not so severe, and fortunately, no other organ injury was found. Instead, retroperitoneal hematoma was expanding rapidly, and so the surgeon simply performed perihepatic packing, and abdomen was left open. And next, this is my turn. I embolized bilateral internal iliac artery approximately within 10 minutes. And now, we didn't see an apparent extravasation in this patient. Now we scanned the patient, but we found a chest wall bleeding. So we reclosed the chest wall in the ICU. So first, the thoracotomy plus Rebord. So we performed thoracotomy first, then converted Rebord. So this is a comparison between thoracotomy and Rebord. The thoracotomy is absolutely more speedy and definite, but we need to make new chest wound, and sometimes the chest wall bleeding is significant, and thoracotomy may induce hypothermia. The Rebord is less invasive and adjustable, but we need to puncture the common femoral artery. Sometimes this is troublesome, and the patient has a leg ischemia. So this, in Japanese educational course, we suggest this strategy. If the patient is impending cardiac arrest, or if the patient doesn't have arterial access, don't hesitate to do thoracotomy. But if the patient is shock but not cardiac arrest, and the patient has the arterial access, consider the Rebord. This is a comparison between thoracotomy versus rebore. So one study showed the benefit in rebore, and the other did not. This is a study from the United States. It concluded rebore has a benefit in selected patient. What is a select patient? It means no CPR, but hypotension at arrival. But do we have to compare thoracotomy versus rebore? My answer is no. We can perform these two aortic occlusion methods in one patient. I know thoracotomy is not strongly recommended in pulseless blunt trauma patient. And of the 106 trauma rebore patient, we experienced 30 thoracotomy plus rebore population. And of these, 6 patients survived. And interestingly, all of them received CPR before rebore. It means thoracotomy plus rebore may give a chance even in a pulseless blunt trauma patient. Theoretically speaking, conversion prevents hypothermia, and closing the chest may prevent chest wall bleeding. The second, the early access. So we obtained arterial access simultaneously with a thoracotomy. So we got bilateral arterial access. In the top stent textbook, this was published by the EVTM Society, the guys with the Swedish or European guys, and we suggested AABCDE concept. What is AA? Artery, airway and access come first. Of course, there are some disadvantages in arterial access, such as vascular injury or hematoma, but delayed access can lead to more significant catastrophe, like less palpable cardiac arrest, more hematoma. So I investigated the benefit in arterial access in rebore patient. So I analyzed 109 rebore patients, and naturally, in non-survivors, presented a higher ISS and lower SBP, pre-occlusion, lower SBP, and longer total duration of occlusion. And non-survivor showed longer arrival to access. The survivor got access earlier. So I performed a binary logistic regression analysis, and the result showed arrival access time was significantly associated with the survival outcome. The odds ratio of 0.989 seems small number, but this is every minute. So if the access delayed 10 minutes, the patient's survival rate decreased 10%. This is a big number. And then I defined the cutoff value about 20 minutes. In early access group, they showed significantly better survival curve. So I believe there is a benefit of early access in rebore patient. And next, the undelayed but short occlusion. We could deflate the balloon within 20 minutes. So how long can we occlude? This question is very good but difficult to answer. So I couldn't answer this in a good answer, but the survivor shows the pre-occlusion pressure of 70, and survivor shows total duration of occlusion of 30 minutes. So this is not the cutoff value, but undelayed but shorter occlusion can be will lead the successful management. So there is a different trauma system in the world. So let's compare Japan, Turkey, and the United States. So I found a lot of similarity between Japan and Turkey. For example, I'm in emergency medicine, and we are responsible for the resuscitation of the patient. But in the United States, the statement recommend acute care surgeon or vascular surgeon should perform the rebore. But in Japan, we, emergency medicine, perform rebore. So in my mind, resuscitation must not be delayed, so first responder should perform rebore. So in this country, this is you should perform rebore. Because emergency medicine, we have the good friend, ultrasound. We can see the bifurcation of the common artery, and we can see the guide wire in the aorta. This can lead to safe procedure. And next, the patient population and the mechanism of injury. We have a lot of geriatric population, so we often have the coagulopathy, and we often have such tortuous aorta. So you may encounter such difficult patient. So that is why education is very important. So regarding the education, the endovascular workshop is the key education, key occasion. And there are several endovascular workshops in the world. We start the DIRECT Society. DIRECT means Diagnostic and Interventional Radiology in Emergency and Critical Care and Trauma. We start a workshop in 2011, and we create a program including such a simulation or a 3D vessel model. Sometimes we use live animals, sometimes we use cadaver. This is zone 1 occlusion, this is a zone 3 occlusion. And in the United States, from 2013, the BEST course, the Basic Endovascular Skills for Trauma, started in the US. The shock trauma is the center for the BEST course, and I've been working as a visiting researcher here. So I supported the course. And from 2014, in Sweden, the EVTM, the Endovascular Resuscitation and Trauma Management workshop, started. I met the Turkish colleague here, the Dr. Acil, Dr. Uzleb here. And in the UK, from 2016, and they are teaching to the emergency medicine and paramedics. This is a very unique system. And last year, South Korea started the similar course. Then finally, I will mention the research briefly. Rebora seems very useful tool, but don't forget, we have negative data from Japan and from the United States. I found some limitation in this study. The higher AKI, higher amputation, higher 24-hour mortality. So I wrote the letter to the editor, to the editorial office. Looking at the table in detail, the reward group shows the SBP of 109 and GCS was 14. The patients are too stable. And this is the comparison between survivor versus non-survivor. The survivor patient showed SBP 140 and GCS 15 and head AIS 0. So probably, the survivor received only 1 unit of transfusion of red blood cell, plasma, and platelet. So the patients were too stable to require rebore. Probably in the United States, they are overusing rebore. So this suggests unnecessary rebore placement in a stable population, and it induced the unnecessary complication. And then they didn't consider the physiological derangement, so resuscitation time bias might decrease, may happen. So ideally, time-dependent propensity score matching should be performed. So we are going to start the international prospective observational study in the very, very future. So in conclusion, the first, the thoracotomy plus rebore that may give a chance in blunt cardiac arrest, and early access and delayed but shorter occlusion, these are the key issues for the successful management. And education and research, it means endovascular workshop and international multi-center study, these are required. So let's proceed education and research together. 이기니 이친 teşekkür ederim.
Any questions from the audience? Yes. 1 second, microphone's coming.
Congratulations, it has been a great talk. I have a couple of questions just on the base of your results. And first of all, I agree 100% what you said about the need of more data, multinational study, and also this allow me to emphasize the importance of angiography into the emergency room. One question would be, in your experience, you are using a less dimension French catheter. That is going to be less occlusive, and then is ameliorating acute kidney damage and limb acute ischemia. But on the other side, I assume that is going also to not reduce too much the hemorrhages. So this is the reason why you are taking 10 minutes. Assuming that I'm not going to take a TC scan that is actually mandatory in polytrauma patients, I will use echo. I think there is other solution that I know that is the cardiosurgery used today. They put a hole in the way that is the catheter make occlusion, but another part of the catheter is going to give blood. So I think the technology, we should together to think about the different catheter they use in cardiosurgery. Because I don't like the idea to use too much my question is, how much is the bleeding in your less French dimension catheter compared to occlusive one?
Bleeding from where? Bleeding from the organ or bleeding from the...
I mean, using a less French dimension, you have more bleedings, right? Because you are not making occlusion.
No. Oh, even in the small proper catheter, the balloon can occlude the aorta completely.
So which is the value?
Yes. So, but as I mentioned before, the small shaft, sometimes the balloon can migrate downstream, but the balloon can occlude the aortic flow completely. The balloon sizes are same.
Okay, understand. And then what about the opening another hole downstairs?
Yeah, that can be a good idea. We often use in
We are using that.
Yeah, but this is technically difficult. So we need to the skilled surgeon and ultrasound, hopefully in the fluoroscopy.
I agree.
Thank you very much. Any another question or comment? Okay, I want to know, after last topic, we have very fantastic opening ceremony. It was to join all to this fantastic, I think, never seen like this opening ceremony till this time. So, and after the opening ceremony, we give book for everybody, okay? Thank you very much. You can continue. Yes. Yes.
Next, I'd like to introduce Acil.
Bu alttaki yazıları görebilir miyim? Okay. Hello, everyone. It's a great pleasure to be here with you today. We have seen excellent presentation about the future of the emergency medicine. The last presentation is about Reboa and EVTM. In Turkey, EVTM concept started in 2018. I hope it will be lead to use angiography in emergency medicine. Dear Dr. Talhörer, he is not here today, and our friend Dr. Yasuka Matsumuro helped us so much for EVTM concept. Also, I would like to thank to Dr. Jander for supporting us in the learning of this concept. Here is some problem, I think. I can't control this. Evet. Geçiş yapamıyorum.
Beyler bir sonraki slayta geçebilir misiniz mi? Tamam, bir deneyin hocam.
Sona attı. Home. En başa gelmeniz lazım.
Kaç? Hemen bir en başına. Tamam hocam.
Evet.
Tamam, buyurun hocam.
Bununla.
Onunla da yapabilirsiniz, öbür videoda.
Tamam.
Tamam, nasıl harcayın?
Okay, sorry about it. ECMO can be used in many different situations in the emergency room, especially in case of cardiac arrest. Its use has become widely accepted and widespread in the world. In addition, ERDC and cardiogenic shock due to intoxication and pre-arrest conditions such as pulmonary embolism are other indications in the emergency department. Resuscitation is one of the priorities of emergency medicine. In spite of all efforts, it's not possible to achieve satisfactory results in conventional CPR. Survival of both in-hospital cardiac arrest and out-of-hospital cardiac arrest treated with conventional cardiopulmonary resuscitation is very low, estimated at 20 and 10% respectively. Use of eCPR can restore perfusion more rapidly and can prevent mediator storm. A recent meta-analysis of 6 trials containing 2,200 patients concluded that eCPR improved both survival and long-term neurologic outcome. Here are the results. Here are some observational studies about eCPR. First one is from ELSO registry. 270 patients were included in the study. Percutaneous cannulation rate was 70%. One-third of the patients underwent coronary intervention. Median duration of ECMO was 47 hours. Overall survival rate was 27%. The second study is from Canadian ECLS organization registry, and nearly 3,000 adult patients cardiac arrest over than 15 minutes duration and not responding to conventional treatment was included in the study. Okay. The third study was systematic review of adults with refractory out-of-hospital cardiac arrest. Survival rate was 22. Refractory circulatory shock and severe ERDC, which occur in poisoned patients, is still a challenge to treat. Hypoxemia from ERDC results in multiple organ failure, which is incompatible with life. ERDC is still a severe lung disease with a high associated mortality rate. In the most severe forms of the disease, mortality rate may exceed 60%. First successful clinical application of ECMO for ERDC was described in 1972. Until 2008, only 100 patients per year in which ECMO was used for ERDC. Following the influenza A pandemic in 2009, there has been a significant increase in VBA ECMO utilization. In the last 5 years, more than 400 cases per year of VV ECMO for adult respiratory failure have been reported in the ILSO registry. Now let's look at the VV ECMO studies. First one is EOLIA. Randomly assigned 249 ERDC patients included the study. They compared conventional therapy to VV ECMO therapy. There was 11% lower mortality rate in ECMO group, but not statistically significant. The study was terminated because the analysis could not reach the expected mortality decrease rate of 20%. The second trial is CESAR trial. ECMO significantly increased survival without disability at 6 months compared to conventional management. This is a very good study for ECMO, but there is some limitations. There is a lot of patient crossover the ECMO group. Okay, case from Turkey. This is a patient who had ECMO therapy in my clinic. He was found unconscious in bathroom. He was diagnosed with major depression and has a history of psychiatric medication use. He was suspected of having a large amount of medication from his own drugs. The benzodiazepines was positive in the urine drug tests. So we administered flumazenil, but he did not respond. After that, lipid emission therapy was started due to worsening condition. Patient did not respond to lipid therapy either, and therefore the patient was intubated. On the second day, hypoxia occurred, and despite the low volume protocol, hypoxemia worsened. On the third day of his admission, the patient was diagnosed with ERDC due to severe hypoxemia and radiologic findings. Then patient connected to ECMO. ERDC may be occurred due to the drugs, or it may be developed due to our lipid therapy. I need help again. This is a short video from the cannulation process of this patient. In case of intoxication, VA ECMO is usually required due to cardiogenic shock. Our patient was a ERDC case, but we use VA ECMO, not VV ECMO, because we worried about hemodynamic of patient will deteriorate in following days.
Anlayamıyor şu an.
Nasıl sağlık yok?
Okay. Pulmonary embolism is an important cause of death in the emergency department, as you know. There are very few centers in Turkey that are able to make thrombectomy, and they are not available 24/7. Thrombolytics are the only treatment option in the cardiogenic shock and arrest due to pulmonary embolism. ECMO can provide support to patient until the clot dissolves or until the thrombectomy is performed. Yusuf and colleagues published a review of the reported case of the pulmonary emboli managed with VA ECMO. A total of 78 patients were reported. Half of them had a cardiac arrest. Overall survival rate was 70%. For patients who presented with cardiac arrest has a survival rate of nearly 50%, compared with historical rate as high as 75%. Now, I want to talk a little bit about the ECMO process, because the emergency staff is new in this area and there are important points to consider. ECMO is a risky and expensive procedure. Criteria for the initiation of ECMO include acute severe cardiac or pulmonary failure that is potentially reversible and unresponsive to conventional management. Peripheral cannulation is performed either percutaneously or by vascular cut-down. Ultrasound guidance is mandatory. Advantages of percutaneous cannulation include decreased bleeding and infection risk. Percutaneous cannulation is more suitable for emergency physicians, but emergency physicians should also know about the cut-down method in order to apply them when things process go wrong. Many physicians prefer the right femoral area, both artery and vein cannulation for VA ECMO. And for VV ECMO, right or left femoral vein and right jugular vein preferred. Sometimes an extra second venous drainage may be required to increase the amount of the blood in severely hypoxemic patients. Maintaining optimum blood stream is the most important and difficult part of the process. Blood stream is affected by cannula dimension, body fluid volume, and resistance to reinfusing current. The revolution of the pump is defined by per minute RPM. If you increase RPM, the blood flow and also blood pressure increase, but it causes negative pressure at the venous tip. High levels of pressure cause erythrocyte trauma. Another important part of the ECMO is anticoagulation process. Heparin is used for this purpose. If the heparin is contraindicated, direct thrombin inhibitors can be used. Platelet counts tends to decrease, so we should follow them, and the circuit should be observed for thrombus. When we are taking weaning decision, we have to see improvement in radiographic appearance, pulmonary compliance, arterial oxyhemoglobin saturation, and ventricular output. Then we can go to weaning trial step. In weaning trial step, for VV ECMO, it performed by elimination gas transfer and while maintaining the blood flow. For VA ECMO, it performed by clamping both drainage and infusion lines. The patient must follow at least 6 hours, then we can consider to decannulate. Severe bleeding from arterial site is the main problem in the decannulation step. For VA ECMO, at least 30 minutes of compression is required. Also, vascular closure device can be used. Bleeding occurs in 30 to 50% of the patients who receive ECMO, and it can be life-threatening. On the other hand, systemic thromboembolism can be occur as high as 16%. We should know about managing serial arterial bleedings. We must have experience bypassing the leg to ensure blood supply. We should know what is special conditions such as left ventricle decompression, such as coronary and cerebral hypoxia. And etc. Lots of things. The priority of ECMO is eCPR in emergency practice. ECMO can also be used in the ERDC and cardiogenic shock, particularly which caused intoxication, post-restorative syndrome, and acute coronary syndrome and pulmonary embolism. Emergency medicine professionals should know which patients can benefit from ECMO. ECMO management requires a trained and experienced team. Okay, at the end of my presentation, there is a question here. This one or this one, which would you like to have? Yes, I know your answer. Last words, in many diseases, the patient should be kept in life until the treatment heals the patient or until the body overcomes it. Many patients die because they cannot exceed this critical threshold. We must help the patients to overcome this threshold, and ECMO can do it for us. Of course, it is not an elixir of immortality. We just had a new bunker to survive until attack ended. The first thing we need today is to reduce the costs of ECMO, because ECMO costs are not only our problem, but also the problem of developed countries. In the future, we need a device that's smaller, more practical, and easier to manage. Okay, thank you.
Thank you very much, Dr. Mujahid. Yes, ECMO plays in the future of emergency medicine. Any question or comment? Okay, thank you.
Thank you very much.
Sorry? Okay, thank you very much. After 10 minutes, we will start opening ceremony. Arkadaşlar 10 dakika sonra burada toplanalım. Açılış töreninde herkesin burada olmasını istiyoruz. Gerçekten çok özel bir tören hazırlamış durumdayız. Şimdiye kadar gördüğünüz törenlere benzemiyor. Bu törene katılan arkadaşların hepsinin zaten isimleri de burada belli. Onlara da kitap hediye edeceğiz. Onun için hepinizi burada bekliyoruz. 10 dakika sonra. 10 dakika sonra buradayız.
Scientific feast with more than 75 foreigner participants from more than 43 countries. On this meaningful day, now I would like to invite Professor Luis Garcia Castrillo Riesco, President of the European Society for Emergency Medicine, EUSEM.
Esta noche quiero Good evening to everybody. Yes, I come from this small country that looks like a square, and it's at the end of Europe, as far as Turkey is. So we are in the opposite side. I am really pleased to be here. It's not my first time. Fortunately, I have been with you during the last 4 congresses, and I hope that in the future we can share also our experience here in this wonderful venue. I am also pleased to be the USEN representative, very proud of, but I have to say that I am not the only member of USEN. Fortunately, to show the support that USEN is providing to your organization and to this Congress, we have an extended group of members of the USEN board. We have past presidents, board members, and I will say future presidents with us today, acting as speakers and taking part in this Congress. But there is a small problem. The organization offers me the opportunity to share some thoughts with you, and I don't want to resign this offering. So in the next minutes, I am going to share with you some personal thoughts. As president of USEN, during the last years, in my mind it has been struggling the idea of what is the role of scientific societies. And I want to share now with you my ideas. We are all going to agree in the idea that the first objective of a scientific society is to look for the excellence in the care of the patients. And for doing so, we have 2 tools. One is the continuous medical education, and the other one is research. And this Congress is a good example of both things. Here we are going to be exposed to the state of the art of the situation of care. We are going to be exposed to new technologies. We are going to be exposed and trained on skills. And this is one of the objectives and the main objective of a scientific society. Research is the other one. And here we are going to see the last results of research. But mainly we are going to join other colleagues here, and we are going to think about research ideas. We are going to do exchanges of opinions in between us. Our learning is not going to come from the speakers only, it's going to come from the speakers and from the colleagues. Probably discussing a poster, we are going to learn as much as hearing a speaker here in this room. I want to say that after the Congress, the scientific society work is not finished. It has to continue provide updated information, and this is done through journals, letters, workshops, online systems, and all this is part of the activity of the scientific societies as EPAD and as EUSEM. But this is not the only role. I would like to stress the idea that scientific societies has to be opinion leaders. We have to create guidelines, we have to promote the established guidelines, and we have the ones to have the knowledge to define the type of care that we have to provide to our patients. We have to define the systems of care, and with system, I include the pre-hospital part of our activity and the in-hospital part of our activity. It's impossible to think on emergency medicine without these 2 elements. And the scientific societies have to lead and have to be the opinion leaders on this. But we don't have to forget that we are working for a specific society. And our society is continuously changing. When I started doing my work, the society was completely different as it is now. Changes occur continuously. New diseases are appearing. New problems are appearing. New procedures are offered to us, as we have seen with the previous speakers. And we have to adapt to these circumstances. We are commonly exposed to the idea that the society is aging. And with the aging of the society, more fragile patients are arriving to our departments. But that is not the only problem. Isolation is a huge problem. You know that in Europe, 30% of the houses are occupied by only 1 member, meaning that the society is losing the network of the social group. And this is going to offer a new situation to our departments, to our services, and we have to consider and take in consideration this aspect. To deal with all these problems, We cannot do it alone. The scientific societies cannot do these things alone. So we have to look to generate links and synergies with other organizations, with other scientific societies, with other groups, with other federations, not only dealing with emergency medicine, but also dealing with other aspects, social aspects, technological aspects, and we need their collaboration. But mainly we need the collaborations of individuals. And from here I encourage everybody who is not member of a society to become member of a society and be part of this big project that I have been showing you. For those who are members of societies, I encourage them to be more active. Probably my words are going to be taken also by IPAD. We have our hands open and looking for more members to collaborate with us. Now I would like to finish these brief commentaries expressing my gratitude to the organizers that allowed us to try to reach our goals, to improve the education, to improve the research, to improve the network in between the groups. This Congress is the right place for do all these things. So thank you for the organizers.
Thank you, Luis Garcia Castillo-Resco, for your opening remarks. Now, I would like to invite Professor Jill McEwen, past president of the Canadian Association of Emergency Physicians.
Smoking in mirrors keep us waiting on a miracle, on a miracle. So through the darkest of days, having to break away, never let you go, never let me down. Holy Spirit has our right, hiding the edge of a night, never let you go, never let me down. Don't you give up, nah, nah, nah.
Good afternoon, ladies and gentlemen. President Professor Dr. Bashar Kandar, Emergency Physicians Association of Turkey, Organizing Committee. As a past president of the Canadian Association of Emergency Physicians, I'm honored and delighted to attend your 6th Intercontinental and International Emergency Medicine and Critical Care Congress and your 15th Acil TIP Congressi here in Antalya, Turkey. I'd like to thank the organizers for their kind hospitality. You know, it's the 5th time that I've been here in Antalya, and each time I come, it gets more, the quality of the conference gets better, and I'm very impressed with everything that you guys are doing here. It's fantastic. I'm also an emergency physician like you and have worked for 32 years at Vancouver General Hospital in Vancouver, BC in Canada, where we see over 100,000 patients a year. I've had a few other positions as assistant dean in UBC, University of British Columbia, and continued to be the undergraduate education program director at UBC. So I'm going to begin by telling you just a little bit about the Canadian Association of Emergency Physicians. We have about 2,500 members who represent the EPs of Canada. And we are organized around 4 pillars, very similar to what we are doing here. So education and research are 2 of our top priorities. We do an annual conference, and our conference is coming up in May in Halifax, Nova Scotia, and all of you are invited. If any of you are able to attend, we would be delighted to have you there. We also have road shows throughout the year, and we do some other continuing professional development activities across our country. Research, we offer modest seed grants to researchers in Canada that have led to some pretty impressive careers. And we do, the Canadian Journal of Emergency Medicine is our association's journal. The other 2 pillars are advocacy, and we advocate for the specialty of emergency medicine, mostly for our patients and also for emergency physicians in Canada. And our 4th pillar is advocating for emergency physicians. So we have a number of committees and special interest groups that our members can join, and whatever their interest is, and to connect and promote various subspecialties of emergency medicine. But no matter what country we come from, we emergency physicians have a lot in common. So the pride and enthusiasm that I see amongst my colleagues at home, I also see in all of you and in this room and in all the countries that have emergency medicine conferences. So no matter where we come from in the world, I think that we share the common attributes for the fast-paced emergency treatment of our patients, the unique opportunity to be a part of our patients' lives 24 hours a day, 7 days a week, from all socioeconomic statuses, and the ability to quickly diagnose and treat conditions from all walks of medicine. So I don't think global boundaries separate us, and you know, we are truly blessed to have such an amazing career and be part of our patients' lives in the world today, with all of the division and the tumult that is happening all around us. There's no better time for us to get together at international conferences like this to share our knowledge and to become friends with each other. So I'm really happy to be here. On behalf of CAPE, I wish you all an excellent conference, and I hope you all learn a lot from both the academic sessions and the research that has been done, and from connecting with each other. And thank you for your attention, and once again, thanks for your hospitality.
Thank you, Jill McEwan, for your opening remarks. Now I would like to invite Professor Carlos Garcia Rosas, first president and founder of the Mexican Society of Emergency Medicine and Mexican Academy of Emergency Medicine.
This is Latin flavor. We have on the brain, we have on the veins, on the heart, the feeling of the. First of all, I want to thank you for the organization to invite me to be here. Really, it's nice to be here to share a couple of words that we want to do. Let me tell you briefly about my life. I born in this town 33 years ago. No, just kidding. It looks like, but no. I born in this town. They are really a small town. The town, the particular thing is that they have founded by British. We have Bull Ring, the church, and the symbol of the city is the railroad, because this is part of the connection between the Gulf, Mexican Gulf, and the Mexico City. And then I moved for the university, because it's a small town, they don't have medical school at that time. I moved in 1986. Mexico City, the name is Distrito Federal. Everything is changing. Now the name of the Mexico is Mexico City, that's it. So I live in Coyoacán, in Mexico City. It's a small county in the big city, very nice neighbor. And when I started 33 years ago, probably many of you, they don't have that date. 33 years ago, we started emergency medicine in Mexico. So we don't have men control the emergency room. The land is like desert. We don't have rules. We don't have program. We don't have regulation, anything. At that time, we start to build everything in Mexico City. But it's not easy, because we arrive like monkeys. The king of the jungle was the surgeon, and if something happened very strange, they call for the internal medicine because they have a very strange diagnosis. I don't know what, but they think that they know. Over the years, when we started in Mexico City. This is the pioneer of the Mexico City and the Latin America. 15 people started the emergency medicine program in Mexico in '86. And this, believe me or not, I am one of these. These 4 people, we organize the society, we continue to organize the board, we organize the Mexican Academy, and we organize the World Organization in Emergency Medicine for the rest of the world. And then in 1994, we spent for more than 60 places teaching emergency medicine now in Mexico. But we not promoted. The best promoting for you and for me, because we are relatives, only different is the language, but we saw similar patient, we are similar life. The best promoting was the ER talk show. They have 10 years on the top in the television and spread the rest of the world. Now the people know a little bit more about what the emergency physician doing. And they have different top shows in different countries, in different language. This is why one of the things I am worried about, to know the artists and say, well, who is these Hollywood people doing? And I met, do you remember this nurse? The nurse was for the TV show. And then I came in 1990 to come to Europe. What Europe doing something, and they don't have program in 1990. Few countries, they have a program in emergency medicine. And I met one of the leaders, is Dr. Herman Deluz and David Williams, and then met Dr. Pateron in France, and then we went to different conferences with the other part of the Europe, and also I met Roberta Petino. I don't saw her, but she was involved in many organizations of the conference, and she was the past president of SEM. And also, what is the reference if you want to study emergency medicine, because you don't have books. You have internal medicine or surgery. So we're looking for the guys, they have the New Testament and the Old Testament. Peter Rosen, the 3 tomes for the books in emergency medicine, and Judith Tintinelli for the books to read. And also I write my own book. Now we have 3 of the people that write books for emergency medicine in the rest of the world. So in 1990, I invited the first time Judy come to Mexico, because we need to get reference how emergency medicine doing outside of Mexico. And this is why I invite her to come and participate. But this is the evolution in the rest of the country, in the rest of the world. We are the same. You speak Turkish, I speak Spanish, this guy speaks English, but the evolution was the same. We start like monkeys, and now you look tired, you look handsome man and pretty woman. But at that time, nobody believed in us, and this is the normal evolution and then we have. Until here, I saw many leaders that I know for the last 30 years doing these things, and very interesting points. But remember, those who cannot remember last, they are condemned to repeat the same mistakes. So be careful. The younger guys, if you want to do something, pay attention in the people was before of you, because you don't need to make the mistake, and you advance quicker than us. And remember, the doctors and emergency physicians is like the wines. The more older, the better. Emergency medicine is this style of life. I lived 33 years like emergency physician, and I feel fine. I feel very well, like many of you. And I made a lot of friends. The life is not only emergency room. We need to socialize. This is why many people organize now conference. We need to outside to the emergency room, share, dancing, praying. And I met many people over the years. And remember, welcome, everybody is welcome for the National Congress in Emergency Medicine in Mérida this next November. Thank you.
Thank you, Carlos Garcia Rosas, for your opening remarks. Now I would like to invite Professor Roger Dickerson, President of the Emergency Medicine Society of South Africa.
To the goal, cause everyone's depending on me. See, we ain't got nowhere to go but up. It's our destiny. Choosing to win. Do what it takes to get to the top.
That really rouses my blood pressure. Merhaba. Guni Afrikadan selamlar. What I should also be saying is I'm learning some Turkish, so I'm going to teach you some isikoza. What we refer to as a conference in isikoza is umbuzo. Now everyone, let's try together. Buzo. Now put it together. Umbuzo. And what an umbuzo is a time for the wise to learn from the young, and a time for the young to learn from the wise. And note there's no mention of old, it's only wise. And that's what this is all about. Now, you know that I come from the southern tip of the African continent. We have strange creatures like the Big Five. Now, the undoubted king of the Big Five is the giant cat called the lion. And I think Professor Kande is your version of the lion, certainly the king of the jungle in these parts. And it's a pleasure to be part of a conference that you've once again organized so incredibly well. But it's something that we can, as emergency physicians, and it's been interesting hearing all of the previous speakers standing up and saying, almost like an Alcoholics Anonymous meeting, going, I'm an emergency physician. But I think it's something that we can learn from the Big Five, because in order to survive in emergency medicine, you need to have the courage of a lion. You need to have the cunning of a leopard. You need to have the stubbornness of an elephant. You need to have the patience of a hippopotamus. And then, when our patients' lives depend on it, you need to have the temper and aggression of a wounded rhinoceros. Because that, and it's something that Jill mentioned earlier, we need to be advocates for our patients. And I think that's what we're all here to do. We're here to learn, we're here to develop. We're here to take the specialty that is being carved out so delicately and enhanced. I was standing chatting to what have become really good friends, and it was really the past, the present, and the future of USAM. And in fact, they're starting to talk about not just the past, the present, and the future, but the past, the present, the future, and the future. And that's really where we should all be looking towards. And so I would like to express my sincerest appreciation to the organizers, not only for tremendous hospitality, but the amazing opportunity for me to learn from the wise, and the wise to learn from me. So thank you very much to the organizers, and congratulations.
Fraser Dickerson for your opening remarks. Now I would like to invite Dr. Hikmet Anvarov, Deputy Director of Emergency Health Services of Ministry of Health of Uzbekistan.
Günaydın. Sayın Profesör Candır, sayın kardeşler, ata yurtunuz Özbekistan'a sıcak selamlar. Ben için bu kongrede konuşmak büyük onurdur. Dear ladies and gentlemen, it's a great honor for me to stand here on this fabulous place and greet you from my personal and from all entire system of emergency medicine from my country, which I will be happy to introduce you in this part of the world. Tomorrow I will have an opportunity to talk about more detailed about my country, about the system of emergency medicine in Uzbekistan. But today, as per our tradition, with your kind permission, I would like to present a small gift to our common host, Professor Bashar Jander. This is not just a part of protocol. This is not just a part of our culture, which is, but is pure and sincere symbol of our appreciation and gratitude.
Thank you very much.
Thank you very much, and I wish all of us successful and fruitful Congress. Thank you.
Thank you, Hikmet Anvarov, for your opening remarks. Now I would like to invite Sivaminata Mahadevan, Professor of Emergency Medicine at Stanford University.
The confusion, everybody who meets me in my life, they go, he's Indian, but when he opens his mouth, he sounds like an American, and that is because I am both. I am both. First off, I want to extend my sincere gratitude to Dr. Bashar Chander and the organizing committee for inviting us to this fantastic conference. As you can see from all the luminaries who are here speaking at the conference and just the agenda, it's going to be a fantastic Congress. It's my 5th time to Turkey and 2nd time to Antalya, and I'm very excited to spend the next 3 days with you. Just reflecting on what some of the other speakers have said, when we get together as emergency physicians, our histories, our challenges, our successes are mirrored in each of the countries that we work in. And I've had the privilege of not only being an emergency physician and a teacher in the United States, but traveling to other countries like India to help with the development of emergency medicine and emergency medical services. And I would hope that you take the time, since we're all here, have come so far, to spend these next few days with you. Go reach out to these folks. They are very kind and accommodating and want to talk with you. I would encourage all of you, the participants, the delegates, to speak to all the faculty who have come from around the world and share your stories, and so we can do the same. And I want to wish the organizers a fantastic conference. I want to thank you again for being invited to speak. Thank you.
Thank you, Swaminathan Mahadevan, for your opening remarks. Now, I would like to invite Professor Wang Zhang, President of the Chinese International Exchange Association of Emergency Medicine.
Good afternoon, everyone. Dear Professor Basa Kanda, ladies and gentlemen. I am Dr. Wang from China, and I'm chairman of the emergency branch of the International Exchange and Promotion Association of Medical and Healthcare. First of all, I would like to say that we are very happy to be invited by President Basa Kanda to come to the beautiful Turkey. This is the first time we are here, and last night we got into the hotel at 1 midnight, so we can see nothing. And this morning when we get up, we saw that everyone are beautiful. So we hope that we can come again. In 1983, China established the emergency medicine. After several decades of development, it has formed a relatively complete emergency medical service system, including the pre-hospital emergency department, and EICU. So we are very happy to share some experiences with our international counterpart and all of you here. And we also hope to learn from you and from everyone the experiences and improve together with the colleagues of emergency physicians. The 2019 annual meeting of our society will be held in Hefei, Anhui Province on October 13th. We seriously invite every one of you to visit China and to join our meeting. And besides, we take a small gift and a formal invitation letter for Basa Kanda and the Association of Emergency Physicians of Turkey.
Thank you very much.
We wish this conference be held complete success. Thank you very much.
Thank you, Wang Zhang, for your opening remarks. Now I would like to invite Professor Paul Kivilla, President of the American College of Emergency Physicians, ASAP.
Never quite sure what the music's going to be. Earlier I was told it was going to be 50 Cent. So I was going to try and figure out how I was going to rap my way up here to the stage. So thank you again. I'd like to thank the organizers of this conference for the wonderful hospitality. And on behalf of the 38,000 emergency physicians of ASAP, I would like again to say my thanks for being here. This past year, we were founded in 1968, so this was our 50th anniversary. And as we go forward, it was great to hear what a lot of the speakers prior to me had already said. And I want to say much of the same things. I think, this is just a wonderful conference here where there's an opportunity not just to learn, but also to collaborate and work together. It is my opinion and that of our organizations that emergency medicine has no borders, that we are a world community and we should learn and work together to advance our specialty. We are one of the youngest specialties, but we've matured very, very quickly. And in many parts of the world and the United States, we are now seen as one of the leading specialties that advocates not just for ourselves, but most importantly for our patients. I think that there has been a lot of collaboration that we have started on our side here in the past year, and I look forward to working together with many other organizations, including EPAT and USIM and many, many others, of how we can work together and move things forward that we can advance research, that we can advance learning and advance technology. In the United States, our residents are very unsure what the future holds. And I think this is a great opportunity because we are doing research to look at not where we're at right now, where we're going to be in a year, but where we're going to be in 30 years. Because that is about the lifetime of an emergency medicine trained physician, of how long they work. So we have to think forward that we're training them the right way. And if you look in the United States right now, and this is going to be a world issue, technology is going to change very quickly. And we believe that emergency medicine is no longer all going to be delivered in the emergency department. That we believe emergency medicine is a specialty and not a place. We're already seeing a lot of our graduates go into technology, deliver things via telemedicine, and we think that the future is only going to be brighter in all those regards. And our specialty is the one that usually adapts the most quickly. So I would like to thank everybody for here, and I hope to reach out to you here in the next several days as we talk about how we can work together, because I truly believe that we can learn from each other. And also I'd like to thank Dr. Bashar Kanner. I'd like him to come up here, as we have a gift for him as well. Is that, here's someone that is bringing the world together. And I think, here, this is their 15th anniversary of their conference. But the scope of the leaders that are here, the scope of the training that's going on here is really exemplary. And Dr. Cantor, will you please come up? behalf of the 38,000 members, this is a plaque that just honors the contribution that EPAT has made to emergency medicine. Also something you can put on your desk or your nightstand that will also remind you of our very much appreciation to what you've done for our specialty. Thank you.
Thank you, Paul Kivila, for your opening remarks. Now, I would like to invite the mentor and the constructor of the emergency medicine training in Turkey and the president of the Emergency Physicians Association of Turkey, İPAT, Professor Başar Candar.
Çok değerli arkadaşlar, sizinle burada bulunmaktan çok büyük bir mutluluk, onur ve gurur duyuyorum. Tabii yabancı konuşmacılar var, unuttuk. Onların da trans şeyleri var değil mi? Tercüme şeylerini verdiniz. Yani şu anda gerçekten bir yıllık büyük bir gayretin sonunda son derece büyük vakitler, efor, emek harcayarak böyle dev bir organizasyonu geliştirdik ama şurada gördünüz siz de. Burası artık diğer katılımcılar da kabul eder ki dünyanın acil tıbbının birleştiği yer olmaya aday bir yer görünüyor değil mi? Aday bir ülke olarak duruyoruz. Dünya acil tıbbını birleştiriyoruz. Dünya acil tıbbının birleştiği yer gibi bir görev üstlenmiş durumdayız. Burada zor konuşuyorum, biraz zor başladım. Niye zor başladım? Çünkü çok değerli, çok büyük bir hocamız aramızda. Onun önünde ilk defa konuşuyorum. Hocam bizi mazur görün. Sayın Profesör Doktor Bingür Sönmez hocamız bugün aramızda. Lütfen alkışlarımızı. Size çok güzel bir ders anlatacak. Burada yani gerçekten çok güzel vakit geçireceksiniz. Bu yılki kongremizde de bazı yenilikler var. Onlardan size bahsedeceğim. Tabii acil tıpçıları bir araya görünce herkes konuşmak istiyor. Çok konuşmak istiyor. Çok güzel şeyler anlatmak istiyor. Sayın Carlos'un dediği gibi yaşlandıkça daha değerli oluyorsunuz. Daha değerli şeyler anlatmak istiyorsunuz. Ama ben artık acil tıpta hep acilden bahsetmekten yoruldum. Ben de size bugün olimpiyatlardan bahsedeceğim. Olimpiyatlar ilk olarak ne zaman başlamış arkadaşlar? Bilen var mı? İlk olimpiyat 800 yıllı yıllarda. Peki bu olimpiyatta bu 5 halka neyi temsil ediyor biliyor musunuz? Bu 5 halka neyi temsil ediyor? Bilen var mı? Şey sorusu değil mi? 5 kıtayı temsil ediyor. Biz ne yapıyoruz burada? Biz de 5 kıtayı, hatta 6 kıtayı temsil eden bir organizasyondayız. Yani buranın bundan sonraki ismi ne? Acil Tıp Olimpiyatları değil mi? Acil Tıp Olimpiyatlarında bundan sonra hep bir arada olacağız. Acil Tıp Olimpiyatları. Kıtalar bir arada, hepimiz bir aradayız. Peki bu olimpiyatlarda, olimpiyat deyince aklınıza hangi yarışlar geliyor arkadaşlar? Mesela hangi sporcular aklınıza geliyor? Sporla çok ilgileniyoruz değil mi? Mesela ilk akla gelen herhalde kimler var burada? Mesela yüzmede bakın 29 altın değil mi? Kaç? 23 altın. Larissa, Muhammed Ali Kılay, boksta, Hüseyin Bolt. Bu isimleri aklınızda tutun. Bu isimleri aklınızda tutun. Burada ne görüyoruz arkadaşlar? Kim bu? Hüseyin Bolt. 9.58 ile rekor kıracak değil mi? İlk aklımıza gelen atlet neredeyse bu. 100 metre yarışı. Olimpiyatların ruhu mu neredeyse bu? Bu rekor. Tek olimpiyatlar bunlarla ilgili değil. Güreş de olimpiyatlarda çok önemli. Gördüğünüz gibi.
Harika bir hareket. Bakalım süre yeterli olacak mı?
İşte bu an. Değil mi? Galibiyet anı. Ama başka sporlar da var. Mesela bizim de iddialı olduğumuz olabilir. Mesela diyelim ki ne aklınıza geliyor? Gülle atma.
Alman. Deutschland. Şşt. Ne yapıyor? Kardeş Türk müsün? Almancı mısın? Was? Ne vası? Ben hazırın dibi aynıdır.
Beyefendi müdahale etmeyin.
Hocam tamam bir şey yapalım moral batı
20-15. Son sırada Türkiye var.
Aha geldi. Aha bize sadece.
Abi hadi sana güveniyorum. Hadi abi yaparsın.
Hocam saygılar selamünaleyküm.
Hadi Recep abi. Beyefendi buyurun.
Şu arkadaşa söyleyeyim hocam çeksin buradan bu.
Beyefendi orası dünya rekorunun ötesinde nasıl atacaksınız?
Ya hocam ben yemişim dünya rekorunu ya. Şu anda sana burada kainat rekoru kuracağım. Söyle çekil şu arkadaş. Çekil şuradan.
Beyefendi buyurun atın.
Bak hocam ben uyardım. Masadakiler. Bu çekip tutmuyor.
Bizim için sorun yok tabii atabilirsiniz.
Ya Allah bismillah. Çak. Efsane adam.
Okta da iyiyiz. Okçulukta da biliyorsunuz yine olimpiyatlarda okçuluk.
Dört halka.
Evet. Şimdi bunlar tabii çok değerli sporlar ama sizce, şimdi asıl soruyu soracağım. Olimpiyatın en değerli sporu hangisi? Efendim? Maraton. Olabilir. Ama şimdi şunu izleyin. Hiç duydunuz mu? Duymadık belki de. Birçok rekor göreceksiniz. Dekatlon, hemen her branşta rekor. 9.000 puana ulaşmış. Dünya rekorları ama duyan var mı? Yok. Neden? Çünkü isimsiz. Bu size neyi andırıyor? İşte biz acil tıpçılar, olimpiyatların dekatloncularıyız. Aslında her branşta yarışıyoruz. Herkes bir branşta yarışırken biz 10 branşta yarışıyoruz. 10 branşta rekor kırıyoruz. Ama problem ne? Kimse bilmiyor değil mi? İsimsiz kahramanlarız. Bu kadar isimsiz kahramanlara bir alkış alacağım. Böyle yazılarımız var tabii. Acil tıp benzersiz bir branş. Gerçekten çok zor, çok ağır. Ama işte bunu benzersiz kılan şeyler var. Mesela çok zor şartlarda yarışıyoruz. Çok zor şartlarda hasta bakıyoruz. Kalabalıklar var. Ekonomik koşulların iyi olmaması var. Şiddet var. Bunu yıl boyunca görmüşsünüzdür. Tekrar göstermekte fayda var. Acil servislerin halini görmek açısından.
Jeg får trilla han inn på kirurgi, da. Det er ikke så ille som det ser ut. Her er halve hodet ut, ja. Det går så til seg. Hva skjer her? Jeg føler meg litt sånn pjusk. Å, herregud, slipp alt dere har i hendene! Vi har en mann som er pjusk her! Få den rullestolen! Få ut. Få den ut. Hvilke rom er det som er ledig? Og så få ut han der jævla viperasjongen. Sånn, få han her. Så få tak i noen store puter fra barneavdelingen! Herregud, han har nesten 38 feber. Sånn, ja. Sånn, ja.
Bunu istiyorlar. Bir de her şeyi muayene etmemizi istiyorlar acilde. Birkaç doktorum bilir. Yani medyanın, şiddetin, ondan sonra ekonomik durumların, hasta zor yakınlarıyla uğraşmanın, yani burada bize bir şey değil mi? Bunu kimse yapmaz. Ancak ne yapar? İşte isimsiz kahraman dedik ya da çılgın insanlar, çılgın iyi insanlar bunu yapabilir. Biz hepimiz o çılgınlarız. Bütün çılgınlar bir araya gelmişiz, öyle görünüyor. Burada da doktorun aslında şiddete nasıl maruz kaldığına dair güzel bir video var. İstiyorsanız onu da hemen
If you felt ill, what would you do?
Go to bed.
Before that,
Take the clothes off.
you would go to the doctors.
No, no doctor. Doctor killed my uncle in Madrid. See, my uncle, he has pain in the chest. He goes see doctor. Doctor, he listen and say, it's all right. 10 minutes later in the street, my uncle, finito.
What, a heart attack?
Motorcar.
Well, you can hardly blame the doctor for that.
See, the doctor, he was driving the motor.
Neyse. Tabii böyle şiddet olunca da böyle bunu tercüme edebiliyorum bilmiyorum. Şiddet sadece acillerde değil, her yerde bir şiddet var. Ama tek bizim medyamızda, mesela biz hep diyorduk ki ya ülkemizde bu dizilerde neler neler gösteriyorlar, yeter artık biraz uslanın ki Hindistan'ı görünce, Hindistan bizim imdadımıza yetişti. Hindistan'da nasıl CPR yapıyorlar bir de ona bakalım.
ಹಾರ್ಟ್ ಗೆ ಮೈಂಡ್ಗೆ ಎಲೆಕ್ಟ್ರಿಕ್ ಶಾಕ್ ಕೊಡ್ಬೇಕು ಆದ್ರೆ ಅದಕ್ಕೆಲ್ಲ ಸ್ಪೆಷಲ್ ಎಕ್ವಿಪ್ಮೆಂಟ್ಸ್ ಬೇಕು ಓ ಮೈ ಗಾಡ್ ಇಂಥ ಸಿಚುವೇಶನ್ ಅಲ್ಲಿ ನೋಬಡಿ ಕ್ಯಾನ್ ಹೆಲ್ಪ್ ಯು
Hasta arresta biliyorsunuz, defibrilasyon yapacaklar. Daha fazla gerek yok. Dünyanın her tarafında medya aynı yani gördüğünüz gibi. Bakın bizde de medyada neler var. Elektrik akımına kapılan genç matematik aşığı olmuş. Nasıl oluyorsa. Burada da Çin'den bir haber var. Çinler var. Çin'de 200 gündür komada olan hasta kendisine para koklatılması üzerine komadan uyanmış. Bu da çok ilginç geldi yani Çin'de. Velhasıl medya her yerde aynı. Ama bizim gerçekten sorunlarımız hasta yoğunluğu, en önemli sorunlarımızdan biri. Bakın Türkiye'de şikayet ediyoruz ama bu Amerika'dan bir şey. Avustralya'dan, pardon Amerika'dan da vereceğim de. Avustralya'dan. Orada da koridorda hastalar var. Yani bütün dünyada aynı sorunları yaşıyoruz. Az çok. Bakın burada hemen benzer sorun. Washington Post'ta olan bir haber bu. Bize çok tanıdık geldi değil mi? Biz bloklama yapıyoruz bunun için. Önce acilden hasta. Acil hastalarını yatırmak, onlara hizmet etmek, hep bu zorlukları aşmakla, onlarla mücadele etmekle uğraşan bir grubuz. Bunlar bütün dünyanın sorunu, sadece bizim değil. O yüzden biz diyoruz ki bu dünya bir araya gelecek, acil tıpçılar bir araya gelecek ve bu sorunlar üzerine gideceğiz. Bakın ne kadar benzer sorunlar. Burada bir doktoru görmesi için 5 saat gerekiyor. Bizim Kanuni'de 3000 hasta geliyor. Ortalama bekleme süresi ne kadar biliyor musunuz? Kanuni'de arkadaşlar vardı burada. Asistanlarımız 10 dakika. 10 dakika. 3000 hastanın geldiği yerde beklediği dakika doktoru görmek için beklediği süre 10 dakika. Tabii yani bu hizmeti nasıl üreteceğiz? Tabii bir sürü bu gereksiz hastalar var. Bu kalabalığı oluşturan. Böyle cevap veren bir sisteme ihtiyacımız var yani. Doktorların böyle koruyucu olduğunu, acil tıpçıların böyle olduğunu herkesin anlaması lazım. Rektörlerin biz geçince selam çakması lazım. Bu söz tanıdık geldi mi? Belki bir gün yani acil tıpçı bu kadar şey yapıyor, yani bu kadar hizmetle uğraşıyor. Biz bunları yaparken diğer doktorlar ne yapıyor? Yani şimdi biz onlarla nasıl bir olalım? Ama yine de bizim mesela düşünün, biz en azından şöyle, yani kötünün kötüsü var, bunlar yine iyi de bir de filozof olsaydık ne olacak? Dolayısıyla yine de herkesin bir şekilde CPR'ı bilmesi lazım. Böyle geçelim, acil tıpçılar böyle dev güçlü, dekatloncu olacak derecede büyük şeylerdir. Şimdi arkadaşlar, bir dakika anlatacağım. Şöyle, bu sene kongreye çok iyi hazırlandık. Çünkü biliyorsunuz Türkiye'nin çok büyük 2 tane şeyi var, STK'sı var. Dünyanın belki Türkiye'nin en büyük şeyleri bunlar. Biri Fenerbahçe, diğeri Atüder. Şimdi geçen yıl başımın etini yediniz, seçim yapalım, seçim yapalım, seçim yapalım. Ben dedim seçim yok dedim. Seçim yok dedim. Aha şu fotoğrafa bakın, ne görüyorsunuz? Şimdi bak, otomatik gelmeyecek, tamam. Bak fotoğrafları incelersek, bak Aziz Yıldırım ayakta, ben koltukta oturuyorum. Kaç defa dedim ona, ayakta durma, bak koltuktan kalkma. Koltuktan kalkarsan gider. Bak Ankara'da bu metot var yani. Ankara'da bakanlıkta herkes koltukta oturuyor. Kalktı mı gidecek yani, o şekilde. Ben ona dedim bak koltukta otur, kalkma ayağa. Hem kalktı hem el salladı. Sonuç Aziz Yıldırım gitti. Peki Aziz Yıldırım gitti, Fenerbahçe kurtuldu mu? Ya işte bu. Yani ben nasıl seçim yapsaydım o geçen yıl? Ben de ya tamam, biz de yıllardır Aziz Yıldırım'la beraber yönettik memleketi ama olsun yani, bir başarı geliyorsa başarısızlığa şey yapmayacaksın. Onun için sormayın bunu. Tabii Fenerbahçe eskiden iyiydi, bu kadar değildi. Yani o da burada dönmek lazım. Yani şimdi yani böyle bir efsane Fenerbahçe. Şarkısın sen. Sonraki söz anahtar kelime. Ömür boyu sürecek. Neyse canım, espri yapıyoruz yani, çok almayın. Bazıları öyle söylüyor da ömür boyu sürecek falan. Evet, yine de o hale geldi işte. 20 yıl önce de böyleydi, sonra da böyle. Ne yapalım? Onun için bakın, başkanlar değişmesi gerekmiyorsa değiştirmemek lazım. İşimize bakalım, çalışalım. Beraberce çalışıyoruz, iyi işler üretiyoruz. Bu resimleri mi koydum? Ya başarısızlıklar olabilir ama başarısızlıklardan sonra başarı gelecektir. Onun için ümidi yitirmemek lazım. Bu da Erik'in paylaştığı bir şey. Bakın acil tıbbın geleceği bizden farkı, bak bu şekilde dahi kongreye gelen insanlardan, böyle çılgın insanlardan olan bir camia bir şekilde başarıya ulaşacaktır. Şimdi arkadaşlar, tabii ben süreç çok uzadı. Ben 2 saat kadar konuşmak istiyorum ama maalesef bu kadar şansım yok. Bir de benden sonra bekleyen büyük bir hocamız var. O yüzden hızlı bir şekilde, ne kadar hızlı gidebilirsek, 365 slayt hazırladık dün gece ama bunu hızlı bir şekilde, yok, çok hızlı geçeceğim. Bakın biz kongrelerde çok ciddi aktivasyonlar yaptık. Bunu biliyorsunuz. Kongremize gelinceye kadar neler yaptığımızı hemen kısaca gösteriyorum. Bunları hızlı geçtik. 13.'üydü. 14'te bir çığır açtık. Atatürk'ün kongrelerden kimler geldi, kimler geçti bir bilseniz. Yani buradaki listeler yetmez yani. Herkese burada bir şeyimiz oldu. Çok güzel teşekkürler aldık. Hızlıca devam ediyorum bunları. Umarım takılmadan gideriz. Ve 14. geçen yılki kongre bir çığır açmıştık. Yüzlerce afiş oluşturduk. Bakın gördünüz. Her türlü afişi kullandık. Her türlü çalışma yaptık. Abdü çok teşekkürler bu video için.
To the Emergency and Critical Care Conference. It will be great.
Garcia, Başkan, Sayın Başkan'ın
I need to remind you to come to IEMC 2018. Don't forget.
Bunlarla yetinmedik arkadaşlar.
Ayer el ministro de Bayern dijo que era imposible clasificar por el final for Bayern si no marcaban aquí. ¿Estás de acuerdo con él?
Antalya Spor tamamen bir söylenti. Ben aslında Atuder'in acil kongresine gitmeyi
düşünüyorum. Yani ne kadar dinlesek zevk veren bir şey gördüğünüz gibi. Açılışımız çok fantastikti ama hepsini gösteremem. Ama şöyle bir iki şarkısını gösterelim. Yani bu yıl üstüne koymaya çalıştık. Koyabildiğimiz kadar onu göreceğiz. Bir yıl boyunca gerçekten o yılda işte gelen arkadaşlara kendi halk müzikleriyle hitap etmeye çalıştık. Kendi milli müzikleriyle diyelim. Ama bu İspanyol müziğiymiş. Yanlış çalmışız Meksika'ya. Onu sonra fark ettik. Bazen böyle farklı şeyler oluyor tabii. Bunu ileri alma şansı var mı ekibin? Biraz ortaya alalım. Zaten çok kısa da. Biraz daha ileri al, şöyle bir müzik dinletelim, evet. Roger Dickerson vardı, geçelim bir daha, bu sene de dinledik. Başka Srinat, evet biraz dinleyelim. Abdu. Biraz dinleyelim, burada duralım bir şarkı dinleyelim ya. Evet.
Lasciatemi cantare, sono un italiano.
Yani böyle değişik bir müzikle açılışları yapmaya çalıştık. Çok değerli hocalarımız hep buradaydılar. Çok güzel teşekkürler aldık. 14. kongreyi böyle büyük başarılarla bitirdik ve 15'e geldik. 15'te çok ciddi bir ekip. Yani 100'ün üstünde herhalde çalışma ekibi gece gündüz. Bakın buradaki afişleri görüyorsunuz. Her biri bir şey ifade ediyor. Yüzlerce afiş yaptık. Messi yine kullanmışız, görüyorsunuz. Videolar, afişler, bunlar hep kongre için. Sosyal medyayı salladık. Bu kadar afiş. Breaking News görüyorsunuz. Her şeyi kullanmaya çalıştık. Şunu görmemişsinizdir, dur. Şurayı mesela. Bakın şu yeni yaşam zinciri. Orada görüyorsunuz. Amerika Kongresi'nde birisi, Amerika Kongresi hakkında bir şey söylemişti. Will Rogers. Biz de onu hemen kendi kongremize uyarladık. Bizim kongremiz de Amerikan Kongresi'nden sonra diyelim. Ve biliyorsunuz yıllarca birini beklemiştik.
Biliyorum, sanatçıların bu tarz etkinliklere katılması çok sık görülen bir olay değil. Ancak Acil Tıp Uzmanları Derneği'nin bu muhteşem kongresine kayıtsız kalamadım. Harika bir otel, muhteşem bir ekip ve onlarca katılımcıyla kapsamlı bir organizasyon. Atuder'in etkinliklerini daha önce duymuştum ama katılma fırsatı bulamamıştım. Bu hepimiz için güzel bir fırsat olacak diye düşünüyorum. Kongreye katılacak olmamın bir diğer sebebi de...
Burada da güzel bir şey var. Tercüme edebilirsek de güzel olur. Bakın. Kongrenin önemini gösteren bir şey hazırlamış arkadaşlar.
I just said that you might want to think about your children.
I wish I could make you go away.
Well, good luck with that, Francis. Yeah, good fucking luck with that.
Her yönüyle kullanmaya çalıştık. Başlarda kongre hakkında tezahüratlar aldık. Bu Ankara Gücü Galatasaray maçı. Togay teşekkürler. Togay'a bir alkışlar alalım arkadaşlar bu çalışmaları için. Evet, gidebildiğimiz her yere girdik gördüğünüz gibi. Yüzlerce video hazırladık. Tabii bunları gösterme şansım yok. Bunları siz izleyin. Bak, çok güzel videolar var. Ekip çok harika çalıştı. Özellikle bu çalışmaları yapan bu mükemmel ekibi. Şimdi kimler var? Önce onu gelelim. Evet, Şükrü, o ekibi bir söyleyebilir miyiz? Kimler var bu sosyal medya ekibimizde? Ayağa kalkabilir mi ekipler? Ayça Hanım, ondan sonra M-Date ekibi, ondan sonra kimler var arkadaşlar? Hepimiz ayağa kalkabilir misiniz? Okay. Evet, bu arkadaşlarımıza İlker, Enes. Hepinize güçlü bir alkış istiyoruz arkadaşlar. Çok çalıştılar. Ve bu kongreyi farklı hale getirdiler. Her konuyu işledik neredeyse kongrede. Bakın konuşmacılarımızı tanıttık. Şu kitapları da alabilir miyim? Evet, yani burada gördüğünüz gibi bunlar aslında izlemek de bir zevk gerçekten bunları. Boş kaldığınız zamanlarda yine izleyebilirsiniz. Burada ne vardı onu da göstereyim. Evet, bu geçen yıldan kalma bir hatıra. Gala gecesinde bunu da sizi bekliyoruz aramızda gerçekten. Bello'yla, Paul'la, bu da gala gecemizden, onu da gösterelim. Gala gecemizde de iddialıyız bu sene. Daha iddialıyız. Gece yarılarına kadar ekiple çalıştık. Fotoğrafları sinemeye geldik. 12, 11 falan. Şimdi ne oldu? Şu kitabı alabilir miyim? Yani siz çantalarınızda göreceksiniz. Bazı kitapları çantaya koyamadık. Bakın arkadaşlar, yani bunu bir kitap evinde bastırmaya çalışırsanız, bir ansiklopedi var yine elinizde. Ve bunu her yere yapıyoruz. 1500 bildiri. Bu insanlar 3000 hasta bakarken 1500 bildiri de yaptılar. Asıl alkışları bu çılgın kitleye yapıyoruz arkadaşlar. Bunların 200'ünü, 300'ünü reddettik buna rağmen. O kadar aktivasyonumuz var ya, bunları anlatamam. Ama bazı örnekler vereyim. 3 kıtada, 4 ülkede aynı gün bir orada açılışa gittik. Bir orada düşünün. Yani ne kadar organize. Bakın refresh kursu. Diğer ülkede ultrason kursu. Aynı gün acil tıpta bak geleneksel tedaviler. Bu nasıl, hani ozon tedavisi, hacamat vesaire bildiğiniz, onları da acil tıbba soktuk. Ultrason ve uluslararası aktivasyonlarımız, sonosukul vesaire, bunlar aynı gün yaptığımız şeyler. Tarihler çok önemlidir arkadaşlar. Mesela size bir ay desem, mesela tarih seçseniz, mesela bir tarih seçelim. Kim var önümde? Abdullah, bir tarih, o ayın bir gününü seçsen hangisini seçersin? 2. Yanlış. 6 Kasım, bak önemli tarihler vardır hayatta. 6 Kasım'ı hatırlayan var mı? Şimdi hatırlatalım. Çünkü Fenerbahçe'nin üstüne çok gittik. Yani Fenerbahçe'nin alınacağı bir tek bu kaldı. 6 Kasım. Onu da hiç olmazsa gösterelim, bu kadar üzerlerine gittik. Ama onu göstermeyeceğim hepsini tabii. Golleri gördükten sonra nereye geleceğim? Tarih 6 Nisan. 6 Nisan da bizim için böyle bir Fenerbahçe Galatasaray maçı gibi bir şey oldu. Çünkü 6 Nisan'da 6 aktivasyon. Bir ülkede 2, 6 yerde. Düşünsenize bir ülke, yani Kıbrıs'ta 2 aktivasyon, bir yerde 2 sempozyum, bir ona koşuyoruz, bir ona koşuyoruz. Ve ülkelerin her yerinde bir aktivasyonumuz vardı. İşte burada gördükleriniz. Şimdi bizim 365 günümüz o kadar dolu ki biz hangi birini anlatalım, anlatamayacağız. Yurt dışında yaptığımız aktivasyonlar, Ukrayna, Özbekistan, Makedonya, bu yıl Macaristan, bunları anlatamam çünkü böyle bir vakit sürem yok. Bu yüzden slaytları ileri gitmek zorundayım. Ben bitirmem gerekiyor. Çünkü bunları anlatmaya kalksam herhalde akşama kadar beraberiz. O yüzden kesiyorum. Ama yani burada 300 tane aktivasyonumuz var. Ve artık yılın hafta sonları yetmediği gibi şey de yetmiyor. Ama MDT'e özel bir şey verelim. MDT çok güzel gelişti. MDT ekibi burada. Onları da alkışlayalım. MDT ekibini gerçekten çok başarılı çalışmalar yaptılar. Onu burada vurgulamam lazım. Hepsine teşekkür ediyorum. Sarper başta olmak üzere ekibe, Enes'e, diğerlerine. Bakın geleneksel tamamlayıcı acil tıbba da el attık. Onu da unutmayın. Reboa'ya el attık. Daha önce görüldü. Rize'de, Munzur'da bile sempozyum yapıyoruz. Yani düşünün her yerde. Yani Munzur bile derken, yani şimdiye kadar sempozyum yapılmadığı için söylüyorum. Gidilebilecek her yere gidiyoruz. Sonosukul'un biliyorsunuz çok uluslararası projesi oldu. Ve bunlardan en sonuçta şuraya geldik. Bakın 6 ülkeye geçtik. Sonosukul 6 ülkede yapılıyor. Çok başarılı bir organizasyon halinde. Her konuda kurs veriyoruz. Her konuda eğitim yapıyoruz. Boş saatimiz yok. Bütün ekibi çalıştırmak, yani tabana yayılmamız gerekiyor. Her ekibi, bütün bunları yaparken yine de bazı şeyleri atlıyor olabiliriz. sayı doğru en azından.
Não é para parar amassar. O médico falou, não é para parar. Alguém aprende com ele para revezar.
Segura a mão dele aqui, gente.
E não para.
Bak elini tutarak. Elini tutarak.
Alguém ajuda ele aí.
Bütün bunlara rağmen yani İKD kursları vermeye devam ediyoruz. Bir şeyleri değiştirmemiz gerekiyor gördüğünüz gibi. Neler var hayatta. EKG kurslarımız, bakın İKD kursları için aynı zamanda başkan vekilim, her zaman yanımda duran ve çok zor zamanları hep beraber yürüyerek açtığımız Sayın Profesör Doktor Zeynep Hanım'a alkışlarınızı rica ediyorum. Yine birlikte yürümekten çok gurur duydum. Bu büyük holdingi yönetirken CEO'suz olmaz dediğimiz CEO'muz Profesör Doktor Mehmet Gül hocamız. Mehmet hocam. Şimdi ATOK'lara geçtik. ATOK'larda emeğinden dolayı EKG kurslarını da çok güzel yürüttü Mehmet okumuş hocamıza. Sonos Okul'daki başarılarıyla uluslararası şeylere imza atan Erol Ünlüer hocamıza. Toksikolojideki büyük çalışmaları dolayısıyla Yunsur Çevik hocamıza. Genç Atüder'in büyük aktivasyonlarını yöneten Burak Katipoğlu'na onun akışlarımıza. Her zaman yanımda durup bir şeyler üreten yönetim kurulundaki arkadaşlarımız. Şimdi unuttuklarımız var. Nuri Bey var. Mehmet Koşar Gelir var. Hatırlatın hepsini. Onların hepsine yönetim kuruluna alkış. Behçet Hoca'yı sona sakladık canım. Genel sekreterimiz Behçet Bey. Hepiniz biliyorsunuz. Bakın kurslar bitmez, goller bitmez. Neyse geçelim bunu. Şimdi biz federasyona ders veriyoruz. Galatasaray'a, Futbol Federasyonu'na, Basketbol Federasyonu'na. Maalesef bunları hızlı geçeceğim. Bu yıl şunu göstermem lazım. Bakın her dernek bir dergi çıkarır. Biz ne yaptık? Çantada göreceksiniz. 4 dergiye ulaştık. 4 dergi. Görün işte bak. 4 dergi. Burada görüyorsunuz. Bu dergi çalışmalarından dolayı arkadaşlarıma çok teşekkür ediyorum. Yani gerçekten gazetemiz bu yıl basılıyor, yarın elinizde olacak. 10 sayfa, 12 sayfa gazetemiz var. Gazetemiz, kendi televizyonumuz şu anda canlı yayında bütün ülkelere ulaşıyoruz biliyorsunuz. Çok yerden bizi seyrediyorlar. Böyle bir kuruluşuz. Ankara'yı hiç rahat bırakmıyoruz, medyayı bırakmıyoruz. Acil'in öyküsü 2019. Elinizde en güzel hikayeler. Acil'de sözün demi, Acil'in şarkısı dinleyeceksiniz. Ve kitaplarımız. Üst üste bir sürü kitap. Üst üste bir sürü kitap. Çabuk. Üst üste bir sürü kitap yayınladık. Hızlı çalışmamız lazım. Bak hiç şey yok, nezaket yok. Gel git falan. Çünkü hızlı çalışıyoruz. Sağ olsunlar. Bu yıl yine kitap çıkarttık. Onları biliyorsunuz. Şimdi arkadaşlar tabii ki bu kadar çalışma yaptık. Bu çalışmaların çok ödülünü aldık. Çok seviyoruz. Defalarca çıkardık. 2015'te ilk ödülümüzü Sirenat, Kumar ve ekibi vermişti. Çok teşekkür ediyorum kendilerine. Geçen yılda çok güzel bir ödül aldık. Özbekistan'dan Sayın Bakan Vekilimizin huzurunda Emeritus Profesörlük ödülü tevdi ettiler. Yine Özbekistan ekibine çok teşekkür ediyorum. Katar'da çok güzel işler yaptık. Bu çalışmalarından dolayı Sayın Sagar Galvankar burada mı? Sagar. Thank you very much Sagar. Sagar'ı da alkışlayalım arkadaşlar. Vasem'in başkanı. Katar'da güzel bir aktivasyonu, Katar Sağlık Bakanı ile görüştük. Burada Ürdün'de en üst düzeyde ödüller aldık. Bulamadılar mı? Neyse, tamam. Olursa çal. Evet. Bu da Hindistan'da yaptığımız konuşmalar. Yine Srinath ve arkadaşlarına çok teşekkür ediyorum. Hindistan ayrı bir yer. Bakın orada yine onur konuğu olarak bulunmaktan çok büyük mutluluk duymuştum. Onur konuğu olmuştuk orada da. Ekiple birlikte oradaydık. Bunların hepsini ekip adına yapıyoruz. Dolayısıyla yani ne kadar anlatsak beni dinlemeniz gerekiyor. Her yerde bir şeyimiz var. Suudi Arabistan. Cemil burada mı? Cemil ve arkadaşlarına çok teşekkürler. Çok iyi işbirliğimiz var. Sayın Cemil Bey burada mı? Alkışlayalım Cemil Bey'i de. Şimdi arkadaşlar 1500'e yakın bildiri. Burada bakın sizi özellikle haklarınızı korumak adına şu girişte şeyler var. 12 saat. Sadece 12 saat derslere girmeniz yeterli olacak. Yani daha fazlasına girmeseniz de olur. Biz 12 saate sertifika vereceğiz. O kadar. Yani o kadar size kolaylaştırdık bu işi. O yüzden buralarda girişlere dikkat edelim. Mutlaka kimlik kartlarımız olsun. 12 saati doldurmamız gerekiyor. Bu yıl yeni bir uygulamamız vardı. Bir dediğimizi iki etmediler. Ve her çalışmamızda yani artık birbirimizin dilinden çok iyi anlıyoruz. Orkun Bey'e alkışlarınızı rica ediyorum. Emre'ye alkışlarınızı rica ediyorum. Sektör olmasa biz çok başarılı olamayız. Sektör bizim ana şeylerimiz diyelim, ana dayandığımız konulardan biri. Sektör yanımızda. Acili kimler anlar? Acilin kıymetini anlayanlar kıymetlilerdir diyoruz. Ve 3 firma yine bizim için bu konuda yani hani nasıl diyelim en üst düzeyde desteğini verdi ve acil için destek oldu, bilim için destek oldu. Üçüncüden başlıyoruz, adettir. Sandoz firması Nurşen Mekik. Burada mı kendisi? Buraya alalım lütfen hızlıca. Hızlıca buraya alalım. Koşarak, acilciler koşuyor çünkü biliyorsunuz. Koşturuyoruz. İkincilik merak ediyoruz. Daha önce listemizde yoktu. İbrahim Ethem firması Erinç Hanım, Erinç Çınar. Yanımızda mı Erinç Hanım? Buyurun. Alkışlarınızla Erinç Hanım. Birinci. Bilim ilaç. Kim ama? He? Bahar Hanım. Birinci. Bahar Hanım buraya, evet. Ne kadar yavaş yürüyeyim diyorum, yapamıyorum, hızlı yürümem lazım. Şimdi arkadaşlar bakın 9 salonda dersimiz var. Birinden çıkacağız. Bugün saat 6'da başlayacak, 9'a kadar bildiriler var. Bunun yanında simülasyon yarışması, bilgi yarışması, sunum yarışması. Bu yıl bir de buna satranç turnuvası ekledik. Satranç hepimizin bildiği ve Satranç Federasyonu Başkanı gelecek. Bu konudaki çabalarından dolayı da Serra Hanım, milli satranççımız, ona da teşekkür ediyorum. Kanlı ekibi olarak. Ve gerçekten şu anda kaç slayt oldu saydınız mı bilmiyorum. 365 slaytım oldu. Tabii ben hazırlamadım. Gece 3'e kadar asistanım sağ olsun Bensu Hanım onları hazırlamış. Ona da alkışlarınızı rica ederim. Bütün ekibe alkışlıyorum. Şimdi arkadaşlar biz her yıl çok önemli bir ödül veriyoruz. Gazi Yaşargil'e verdik biliyorsunuz ilk ödülümüzü. Daha sonra Aziz Sancar Nobel'den sonra bizim ödülü aldı. Sonra Gold Frank'a verdik Amerika'dan. Geçen yılda Paul Kivela'ya verdik. Şimdi Zeynep Hanım bu ödülü kime vermenizi açıklamak üzere yanıma geliyor. Buyurun Zeynep Hanım.
Çok teşekkür ederim. Herkese merhabalar. 1952 yılında Sarıkamış'ta doğdu. Pendik Lisesi'ni 1969 yılında bitirerek İstanbul Tıp Fakültesi'ne girdi. 1976 yılında tıp doktoru olarak mezun olduktan sonra burslu olarak İngiltere'de bir sene yabancı dil eğitimi aldı. 1977-1984 yılları arasında uzmanlık eğitiminin içerisinde Londra St. Thomas Hastanesi'nde kalp cerrahisi asistanlığı ve Rhein Enstitüsü'nde araştırma görevliliği yaptı. İngiltere'de aynı hastanede tekrar 3 yıl çalışarak koroner cerrahisi eğitimi aldı. 1988 yılında doçent, 1997 yılında profesör oldu. 1990 yılı sonunda kesin dönüş yaptığı İstanbul Üniversitesi Kardiyoloji Enstitüsü'nde göreve başladı ve 1995 yılına kadar aynı zamanda Florence Nightingale Hastanesi'nde çalıştı. Daha sonra Florence Nightingale Hastanesi'nde kalp cerrahisi bölüm başkanı, aynı zamanda Kadir Has Üniversitesi'nin Tıp Fakültesi'nde cerrahi bölüm başkanı olarak çalıştı. 2001 yılından beri de Memorial Hastanesi'ne kalp cerrahisi bölüm başkanı olarak görev yapmaktadır. Evli, 2 çocuğu ve bir kız torunu var. Yurt içi ve yurt dışında 100'den fazla yayını, 5 kitapta yazdığı 8 bölümü mevcut. Radyal arter greft hazırlanması, kalp yogası ve ateşe dönen dünya Sarıkamış isimli kitapları var. Birçok tıbbi derginin editör listesinde görevli olup Sarıkamış ile ilgili sinema, belgesel, kitap gibi tüm çalışmalara katkıda bulunuyor ve bilimsel danışmanlığını yapıyor. Ülkem ateş çemberi içindeyken Sarıkamış, Nargin, Kafkas cephesi, Aşıkların dilinden Sarıkamış, Sarıkamış'tan Çanakkale'ye, Güneybatı Kafkasya Kars Rumları, Esaret Yıllarım, Asteğmen Vehbi Bey'in Sibirya'dan Kaçışı isimli kitapları da yayına hazırlamıştır. Amatör bir illüzyonisttir, bilgisayar merakı var, iyi kayak yapar, aletli dalış favori sporudur. Bahçesinde organik tarım yapar, çoban kavalı yani dilsiz kaval ve balaban çalar. Boş vakitlerinde ameliyat yapar. 17 binin üzerinde açık kalp ameliyatı yapmıştır. Hasta kaybetmeyi hiç sevmez. Sonu ölümle biten operasyonları sevmediği için savaşlara hayır diyor. Yurt içi ve yurt dışında bulunan 24 derneğin üyesidir. Evet, bu sene 15.sini düzenlediğimiz Ulusal Acil Tıp Kongremizde şimdi 5. kez Altın Acil Ödülünü vereceğiz. Ve Altın Madalya Ödülü Sayın Profesör Doktor Bingür Sönmez'e gidiyor. Kendisini sahneye davet ediyorum.
Arkadaşlar, törenin bundan sonraki kısmında Sayın Bingür Sönmez hocamızın çok değerli bir dersi olacak. Çok uzun değil ama çok şiddetle ilgili, bizi çok seven ama ondan önce teşekkür etmeyi unuttuğum insanlar olabilir. Lütfen ondan sonra beni hemen inince başlıyorlar. Bana teşekkür etmedin. Özlem'i görüyorum burada. Özlem Hanım'ı alkışlayalım. Hakan Öztürk burada. Onu alkışlayalım. Başka ve herkesi, Şahin Hoca orada. Hepsi orada. İlker, özellikle İlker'i ve Abdullah. Hepsini alkışlatıyorum. Çok değerli katkılarınız için sizinle birlikte varız. Evet, söz büyük üstadımızın, Sayın Hocamızın, Bingür Hocamız Sarıkamış destanını Türkiye'ye tanıtan kişi olarak tarihe de geçmiştir. Buyurun Sayın Hocam.
Sesimiz de vardı.
Sayın Başkan, değerli meslektaşlarım, madalyalarım için çok teşekkür ediyorum. Ama Sayın Başar Cander, beni bu güzel insanlarla buluşturduğunuz için, yakınlaştırdığınız için ayrıca teşekkür ediyorum. Benim için en büyük ödül bu derneğe onursal üye olmaktır. Bunu sizden özellikle rica ediyorum. Sağlıkta şiddet hepimizin sorunu. Özellikle ön planda olan sizlerin sorunu. Hekime düşmanlık bir toplumun ayıbıdır. İfadedeki güzelliğe bakar mısınız? Doktor beyim bir çare. Biz Mektebi Tıbbiye Şahane ruhuna göre hareket eden, düşünen, vatansever, aydın, saygılı bir geleneğin devamıyız. Doktor kim, ne demiş, ne yapmış, neye inanır diye düşünmez. İdare amir değildir, savcı değildir, din görevlisi değildir, kolluk kuvveti değildir. Doktorun işi yaşatmaktır. Doktor yaşatır. Bu bilinci yitirmemek dileğiyle tüm Mektebi Tıbbiyelilere selam olsun. Ben tüm genç meslektaşlarımıza hep bunu söylüyorum. Stetoskop en değerli mücevherinizdir. Bedeli gençliğinizdir.
Anne! Dumu kazanmışım.
Anne, son sınavımı verdim, bitti okul.
Oğlum çok şükür kurtuldun sınavlardan. Onca yıl mahvoldun.
Anne, sınavlarım bitmedi anne. TUS var, en zoru o. Vallahi hiçbir şeyiniz yok, maşallah Türk gibisiniz.
Ne demek yok? Ama ben kendimi hiç iyi hissetmiyorum doktor.
Ama inanın ki hiçbir şey yok.
Önüne gelen elipton veriyorlar ya. Hastayım hasta, çok hastayım. Acıyor, yanıyorum.
Fatih abi, verdiğim ilaçları kullandın mı?
Yok, kullanmadım. Bizim bacanakta da aynı hastalık varmış. O kendine lahana suyu yapıp içmiş. Ben de kendim ondan yaptım.
Abi ilaçları kullanmayacaksan niye buraya gidip geliyorsun? Bak bütün değerlerini mahvetmişsin. Niye kafana göre şeyler kullanıyorsun?
Ama ona iyi gelmiş.
Ona iyi gelmiş, sana iyi gelmemiş.
Peki yaz madem.
Kullanacak mısın?
Kullanacağım. Belki ben lahanayı yanlış yaptım. Ya o kara lahana kullandıysa?
Şimdi Saniye Hanım, öncelikle egzersizinizi yapacaksınız. Yağlı, tuzlu, baharatlı yemek yok. Bir ay sonra gelip tekrar kontrolünüze bakalım.
Başka bir şey vermeyecek misin ilaç mı ilaç?
Şimdi ilaca gerek yok. Doğal yollarla gidelim.
Sen ne biçim doktorsun? İlaç milaç yazmıyorsun, sen beni iyi edemezsin.
Sinan Bey, maalesef sinüs olmuşsunuz. Islak saçlara dışarı çıkıyorsunuz sanırım.
Vallahi ben sinüs falan olmadım.
Ne demek sinüs olmadı?
Ha bak Google'da yazıyor işte. Kanser olmuşum ben. Bütün belirtiler var. Tümör var benim beynimde ya.
Sinan Bey, bütün tahlillerinize baktık, kanser falan değilsiniz.
Ya burada yazıyor işte. Sen beni kesin üzmemek için söylemiyorsun ha kanser olduğumu. Doğru değil mi?
Şu Google'a bakmayı bırakır mısınız Sinan Bey?
Ya ben kesin kanserim, kesin ya.
Şimdi sonuçlarınıza baktım. Bazı tetkikler yapmamız gerekiyor. Yani kötü olma ihtimaline karşı bazı tetkikler yapacağız.
Kötü dedi.
Kardeşim sen ne söylüyorsun ya? Kötü mütü ne diyorsun sen?
İhtimal diyorum. Onun için bazı tetkikler yapacağız.
Kardeşim ne ihtimali? Gayet sağlıklı kadını düşürdüğün duruma bak ya. Ya bu nasıl doktorluk ya? Kadını bak bir anda ne hale geldi ya? Ya bırak. Gayet sağlıklı kadın kötü mütü bilmem ne tutturdunuz. Uyduruyorsunuz bunları. Para koparmak için ben.
Beyefendi önce tetkikleri yaptırın, ondan sonra şikayet edersiniz.
Sen görürsün ben nereye şikayet edeceğim. Bekle sen.
Doktor bey, acil hastanız geldi, hemen gelmeniz lazım. Doktor bey, aynı anda 5 hasta geldi, trafik kazası olmuş. Doktor bey, 100.000 hastanız geldi.
Merhabalar hocam. Benim biraz akut
larenjitim var galiba. Televizyonda izlemiştim aynı belirtiler. Eşim de daha önce aynı teşhisle şu ilaçları yazmışlardı. Bunları bana yazabilir misiniz acaba?
Alo. Efendim Koray. Doktorun yanındayım ben şimdi. Ha. Öyle mi? Kimler geliyor? Tamam ben yetişirim. Tamam yetişirim. Şunları yazar mısınız? Yetişeceğim canım ben dedim sana. Ha araba var ayarlarım. Ha bir saniye. Ayağım da kaşınıyor. Ha tamam oldu.
Öksürecek gibi hissediyorum kendimi. Hasta olmaktan korkuyorum. Hasta olmam değil mi?
Doktorcuğum ilaçlarım bitti. Birçok ilaç kullanıyorum. Hangisi bitti bilmiyorum. Yazıver.
Günlük hayatımızdan küçük kesitler sundum sizlere.
Hastanın yakını kim?
Ben.
Çok mu uzaktan geldiniz?
Valla daha yoludur. Bir saatlik yolda geliyoruz, köyden geliyoruz.
Hasta bize gelene kadar çok kan kaybetmiş. Biz ekip arkadaşlarla elimizden geleni yaptık ama...
Katiller! Onlara nefes kapatsalar getirmiş. Sen bunu krampiri istedenler yok mu burada ya? Getirirsin senden öldürüyorsun sonra kimse bakmıyor ya.
Ya ne yapıyorsun böyle sakin ol.
Ben yine bayrama yakın. Sadıya bölmüş ağıtlar yakın.
Ölmediler, yaşıyorlar.
Keferatın yüzüne bakın. Sadıya gidiyorum. Ya.
Muhles. Ya doktor diyor ki ölmemişler diyor.
Günlük yaşantımızda sıklıkla rastladığımız abartılmış yaz. Şiddet, tüm ulusların yaşamında var olan bireyleri, bütün sosyal meslekleri, etnik grupları etkileyen, çağımızın en kontrol dışı antisosyal davranışlarından birisidir. Sağlık kurumlarına görülen şiddet, hasta yakınları ve diğer bireylerden gelen ve sağlık çalışanları için potansiyel risk oluşturan tehdit edici söz, ekonomik istismar veya davranış, fiziksel, psikolojik veya cinsel saldırıdan oluşan olaylar olarak ele alınmaktadır. Günümüzde sağlık çalışanlarının karşılaştıkları şiddet olayları gün geçtikçe artmakta ve yasalarla önlenmesi gereken ayrı bir önem kazanmaktadır. Hekime karşı işlenen bir suçun muhatabının sırasıyla başhekim, sağlık müdürü, müsteşar ve hatta bakan olduğu bilincine varılmadıkça bu soruna çözüm getirmek mümkün olmayacaktır. Hekime sadece kurumu değil, hizmet verdiği hastaların, onların ailelerinin desteği olmadıkça bu hizmetin yürütülmesinde çok zorlanırız. Bakın bir ilkokul öğretmenine yapılan bir şiddet karşısında bütün öğrenciler, bütün veliler bir araya geldiler, olayı protesto ettiler. Ama biz öldürülen bir meslektaşımızda ne yapıyoruz? Sadece doktorlar, sadece hastane personeli bir araya geliyoruz ve olayı protesto ediyoruz. Peki o doktordan iyilik bulan yüzlerce, binlerce insan, yakınları, hastaların sahipleri, bu meslekten geçimini sağlayan insanlar, onlar nerede? Ortada yoklar. Bir çocuğa anne ve babasından sonra en yakın kişi o çocuğun doktorudur. Bir kadının kocasından sonra en mahremi doktorudur. Çocuğa soruyorlar, büyüyünce ne olacaksın? Doktor olacağım. Olamazsan doktor düşman olacağım. Doktor döveceğim diyor. En gözde damat adayıdır doktor. Her anne kızını doktora vermek ister. Hatta bu yüzden benim kızımı ne doktorlar istediği sözü vardır annelerin. Doktor afrodizyaktır. Meslek seçerken, kız verirken, kocaya varırken, otomobil alırken, ev kiralarken doktor iyi. Ama para isterse şerefsiz. Yılmaz Özdil, Sözcü 1 Şubat 2018. Savaşta bile dokunulmazlığı olan sağlık çalışanları ne yazık ki günlük hayatta sadece darp edilmiyor, artık öldürülüyorlar. Anılarına saygıyla. Doçent Doktor Edip Kürklü 58 yaşındaydı. 1988 yılında 3 kurşunla öldürüldü. Buran cezalandırdım dedi. İngiltere'de benim elimde vefat etti maalesef. Göksel Kalaycı çağımızın Türkiye'nin yetiştirdiği en büyük göğüs cerrahıydı. En değerli hocamızdı. Benim de hocamdı. 65 yaşındaydı. 10 kurşunla öldürüldü. Hastası kanser rezidi olduğu için öldürüldü. Ölümünden önce dedi ki ikimizin de ölüm ilanı aynı sayfada çıkacak ve öyle oldu. İkisinin de ölümü aynı sayfada çıktı. Doktor Ersin Ergin her sene 17 Nisan'da artık sembol haline geldi. 2012 yılında bir 83 yaşında hastanın vefatından sonra torunu tarafından maaşını artık alamayacağı için bıçaklandı. 30 yaşındaydı.
Gaziantep'te acil serviste görevli göğüs cerrahi uzmanı Ersin Aslan hasta yakını tarafından bıçaklandı. Ağır yaralanan doktor hemen ameliyata alındı ancak kurtarılamadı. Cinayet sağlık çalışanlarını ayağa kaldırdı.
Doktor Ali Menteşe 50 yaşındaydı, göğüs hastalığı uzmanıydı. 2008 yılında Giresun'da tartıştığı bir hasta yakın tarafından koridorda kurşunlandı. Doktor Necati Yence 58 yaşında, Ok Meydanı Hastanesi'nde çalışıyordu. 2006 yılında kronik bağırsak hastalığı nedeniyle eşini kaybeden bir hasta yakın tarafından kurşunlandı. Hasta yakını çocukluk arkadaşıydı, sonra intihar etti. Doktor 4 ay komada kaldı, tedavisi 3 yıl sürdü. Şu anda böyle felçli olarak görevine devam ediyor. Kamil Fortun 56 yaşındaydı. 2015 yılında göğüs cerrahı işe alınmayan bir şahıs tarafından 3 kurşunla katledildi. Niye yaptığın sorusuna canım sıkıldı. Hoşuma gidiyor, böyle zevkler var abi dedi. Doktor Abdullah Biroğlu 28 yaşındaydı. Mezun olduğu gün memleketi olan Diyarbakır'a tayin istedi. PKK tarafından öldürüldü. 3 yıllık doktordu. Sait Belirgen 50 yaşındaydı. Elazığ'da başhekimdi. 2017 yılında bir medikal firma sahibi tarafından odasına kurşunlandı. Saldırgan intihara kalkıştı. Başarılı olamadı. Bebek gibi yüzü var. Hüseyin Ar 28 yaşında. Bir emekli polis tarafından sağlık ocağında katledildi. Katil intihar etti. Doktor Aynur Dağdemir 49 yaşındaydı. Sekreterinin eski kocası tarafından 2015 yılında katledildi. Kadın doğumcuydu. Katil intihar etti. Doktor Metin Güneş 45 yaşındaydı. Radyoloji uzmanıydı. Karabük'te çalışıyordu. Yanına çalışan bir personel kocası tarafından arabasının önü kesilerek kurşun yağmuruna tutuldu. En son şehidimiz Doktor Fikret Hacı Osman. Psikiyatri uzmanıydı. 2018 yılında kafasına sıkılan tek kurşunla katledildi. Sana yazdığım ilaçlar tam ve zamanlı kullanırsan kurtulursun dediğine sinirlenen bir hasta tarafından katledildi. Katil babasının tabancası kullanmıştı. Bir çocuğu anne babasından sonra en yakın kişi o çocuğun doktorudur. Doktor Hüsrev Çetin Hacı Osman Asaf şu şiiri yazmıştı. Çocukluğumda kasabanın tek doktor ölünce annem yaz tutup sormuştu. Doktorlar ölür mü? Büyüyünce anladım herkes ölürmüş. Şimdi ben soruyorum. Doktorlar hiç öldürülür mü? Fakültesine girebilmek için sen en başta öğrencisi olmak zorundasınız. Üniversite giriş sınavından en yüksek puan alıp eğitiminize başladığınız zaman karşınıza tüm üniversitelerin yaklaşık 1,5 misli 6-7 yıl süren bir eğitim çıkar. Hiçbir fakültede olmadığı kadar ağırlıktaki dersler, vazgeçilmez gece ve hafta sonu nöbetleri beklediğini görürsünüz. Mezun olduğunuz gün hiçbir üniversite görülmeyen bir uygulamaya maruz kalırsınız. Diplomanızı vermezler. İstediğiniz derecede mezun olsanız bile diplomanızı alamazsınız. Alınmayan tek meslektir. Bu durumda ne ulusal ne uluslararası mesleği icra edemezsiniz. 18 yaşta girdik fakülteden 25-26 yaşta çıkarsınız. 2 yıl zorunlu hizmete gitmek zorundasınız. Zorunlu hizmeti bitirdiğiniz zaman 28-29 yaşta gelmiş olursunuz. İhtisas yapmaya karar verirseniz istifa ederek 1 veya 2 yıl özel bir kursa gidersiniz. TUS sınavına hazırlanırsanız. ÖSYM'den daha zor bir sınav olan TUS sınavını geçerek hasbelkader arzu ettiğiniz veya zorunlu olarak şansınıza düşen herhangi bir uzmanlık eğitimi süresince insani koşullardan çok uzak. Çok çalışmalı, bol nöbetli, en az 4 bazen 5-6 senelik az maaşlı çok çile bir dönemi yaşarsınız. İşte bunlar yatarak para kazanan genç meslektaşlarımız. Bir başarılı beyin ameliyatından sonra doktor ve hemşirenin zafer işareti. Bu inanılmaz bir fotoğraf. Tıp tarihinin en çarpıcı fotoğraflarından birisi belki de. 1987'de Polonya'da 23 saat süren bir kalp naklinden hemen sonrası cerrah hastasını son bir kez kontrol ediyor. Asistan köşede sızmış kalmış. İnanmayacaksınız ama kalp naklinden sonra hasta 30 yıl yaşadı. Doktor ondan 7 yıl önce yaşamını yitirdi. Uzman olduğunuzda yaklaşık olarak 35 yaşta gelmişsinizdir. Sizi tekrar 2 yıllık bir zorunlu hizmet bekler. Bu arada muhtemelen evlenmişsinizdir. 1 veya 2 çocuğunuz vardır. Eşiniz de herhangi bir şey çalışmaktadır ve ailenin bölünmesi kaçınılmazdır. 40 yaş sınırına yaklaşmışsınızdır. Erkekseniz evli, askerlik sizi bekliyor. Şanslıysanız kısa dönem askerlik denk gelir. Bana denk gelmedi. Kadınsanız evlenme çağınız geçmek üzeredir. Evliyseniz gecikmiş bir gebelik, evli değilseniz çok gecikmiş bir evlilik ile karşı karşıyasınız. Eğer bir de yan dal uzmanlığı yapmak isterseniz 2-4 yıl süren yan dal uzmanlık eğitimi sonrası tekrar 2 yıl zorunlu hizmete gitmek zorundasınız. Bir kez daha eş durumundan ayrılmak zorundasınız. Merak ediyorsanız maaşınız ancak sizinle aynı yaşta olan bir subay veya polisin maaşına yakın olabilir. Liseden birlikte mezun olduğunuz arkadaşınız 4 yıllık bir iş idaresi veya yönetim fakültesi bitirmişse o günlerde artık genel müdür veya genel müdür yardımcısı olmuştur. Büyük bir odası 2 sekreteri, hatta 3-4 telefonu vardır. Siz hala hastanede 5-6 kişi asistan odasında ancak çay içebilirsiniz. Bu arada arkadaşınızın aldığı maaşı ve çalışma şartlarını hayal bile edemezsiniz. Niye doktor oldum? Çünkü babamın parası çoktu. Uyumaktan nefret ederim. En uzun eğitim burasıydı. Hayatta yeterince zevk aldım. Aksiyonsuz yaşayamam. El yazım okunmasın isterim. Arada bir darp edilmek hoşuma gider. Kütüphanede yaşamayı seviyorum. Bu saçlar kafama fazla. Gözlük hastasıyım. Hep bir göbeğim olsun istedim. Canım tuz çekti. 40 yaşından önce evlenmeyi düşünmüyorum. Özellikle son 10 yılda bu saldırının artmasının altında yatan bir kültür var. Ve kültürün oluşmasında televizyonlarda halka bol bol seslenen siyasilerin rolü elbette ki çok büyük. Yaratılan çatışmacı bir kültür, öteleştiren bir dil, haliyle halkı çok etkiliyor ve aslında şiddetin toplumun tüm kesimlerinde tırmandığını görüyoruz. Sağlıkta şiddet de bu toplumsal şiddetin bir parçası aslında.
İsteyene sebep çok. Kartı yetersiz bakiye uyarısı veren Magan'da otobüste terör estirdi. Şoförü hastanelik etti.
Birbirini yaralayan öğrenciler, hayatını kaybeden öğretim görevlileri. Şiddetin nedeni ne? Ekranlar, bilgisayar oyunları, sosyal medya, devir teknoloji devri ama özellikle çocuk ve gençlere dikkat. Çünkü şiddet fark etmeden bir anda hayatın içine girebiliyor.
Ekrandan şiddet algısını alıyoruz, yazılı basından alıyoruz, oyunlardan alıyoruz, sinemadan, sanattan, aslında edebiyattan pek çok yerden alıyoruz. Ama teknolojinin bir getirisi gene hızlanma ve teknolojiyle birlikte daha çok bizim ulaştığımız şey ekranlar. Yani internet, bilgisayar, televizyon.
İlk defa bir açık oturumda bir gazeteci şöyle söyledi.
Sağlık personeline de aynı şekilde çok yüksek bir şiddet var ve hatta doktorlar yani neredeyse yılda 2-3 meslektaşlarını yitiriyorlar ve protestolar ediyorlar. Bu konuyu gündeme getirmeye çalışıyorlar. Ama doktorlara da aynı şekilde sağlık personeli diyelim, doktor demeyelim sadece. Çok yükselen bir şiddet var. Bir kural tanımaz bir öfke var. Bu işte şu anda kendisini eğitim alanında gösterdi. İşte yarın bir hastanede gösterebiliyor, öbürsü gün sokakta gösterebiliyor. Topluma hakim olan bir öfke ve şiddet var. Biz başta medya mensupları olmak üzere herkesin biraz daha sorumlu davranması gerekiyor diye düşünüyorum. Bir noktada dizilere de bu konuda biraz bakılması lazım.
Kendisine gerçekten teşekkür ederim.
Başkent Ankara'da doktorun ihmali pahalıya mal oldu.
Televizyonların
Sezaryen doğum
tırmandırıcı
sırasında karnında bant
mesajları.
unutulan bir anne şimdi doğmamış çocuğundan vazgeçmek zorunda.
Devlet hastanesinde sezeryan olduydu. Karnımda bant unut.
Fakat meslek odalarının yaptığı baskıyla bakın ne hale geldiler.
Seyirciler, geçtiğimiz günlerde doğum sırasında karnında bant unutulduğunu iddia eden bir kadın hasta ve avukatının açıklamaları kamuoyunda geniş yankı bulmuştu. Hasta ve avukatının iddialarına
İlgili derneklerin kesinlikle mücadele etmesi lazım.
Vermiştik. Şimdi sırada
bu artık
mücadelesini ekranlarınıza getireceğiz.
Durduğu bir yer.
Tartışma sırasında bir kadın eşini bıçakladı. Adam ertesi gün hayatını kaybetti ama kadının iddiasına göre ölüm gerekçesi olay sonrasında gittikleri acil servisteki 2 doktorun eşiyle ilgilenmemesiydi.
Samsun Canikli'de yaşayan Bedriye Altun, eşi Erdoğan Altun'un ölümünün ardından 1,5 yıl hapis yattı.
Ben sadece korkutmak için bıçaklamıştım ama doktor kocamı öldürdü. Meslek o kadar dersleştirildi ki bana iyisinden bir MR yaz bakalım. Buranın başhekimi nerede? O başhekim buraya gelecek. Randevum yok ama muayene olmak istiyorum. Ayrıca işim acele. Ben şimdi sana baktırmasını bilirim. Telefon açarsam görürsün. Bana eşek gibi bakacaksın. Ama bakın genç arkadaşımız mahkemeye veriyor.
Mahkemede adam şey dedi. Ben eşek gibi bakacaksın demedim. Eşek gibi bakılacağım.
Avukatının tavsiyesi de muhtemelen diyor ki estağfurullah ben doktor nasıl öyle söylerim? Ben demek istedim ki ben eşeğim. Bana eşek niyetine bakacaksınız. Mutlaka mücadele ediniz.
Mahkemede adam şey dedi. Ben eşek gibi bakacaksın.
9.000 lira para cezası aldı. Daha hastaneye gelmeden terör başlıyor. Bakın ATV'de bir dizi. Teröre niyetli
Doktorlar
kesin.
seni iyileştirmesi.
Eğer doktor seni yetmezse hastaneye geldikten sonra
Kardeşime bir şey olursa.
bu bir başka dizi.
Beni iyi dinleyin. Bugüne kadar yaptığınız en büyük ameliyat bu. Masada yatanın sadece benim babam olduğunu sanmayın. Şu an itibariyle hepinizin hayatı masada yatıyor. Ya babamı yaşatıp ameliyattan sağ çıkarsınız.
Antalya'da tedavi gördüğü hastanede hayatını kaybeden bir hastanın yakınları sağlık çalışanlarına saldırdı. Doktor ve hemşireleri tam 5 dakika boyunca darp ettiler. 3 şüphelinin hatırlamadığını iddia ettiği o saldırının güvenlik kamerası görüntüleri ortaya çıktı.
Üzerine yürüdü, tokat attı. Saçını çekip betona vurdu. Yoğun bakımdaki o şiddetin...
Dizi filmler gerçek hayatın biraz ötesine giderek acil veya polikliniklerde çıkan kavgalar rahmet okutan, yoğun bakım ve ameliyathaneye basma,
Sayın seyirciler, bundan böyle
tehdit etme gibi olaylar sanki normal bir olay gibi sunulmakta. Şiddet normalize edilmekte.
Sağlık Bakanlığı şiddetin gizlenmesini istedi.
Bakanlık karar aldı. Doktora şiddet haberi yayınlanmayacak.
Manası.
Adana'da Seyhan Devlet Hastanesi'nde 4 güvenlik görevlisiyle bir hastane çalışanının darp edilmesiyle ilgili güvenlik kamera görüntüleri ortaya çıktı. Hastane çalışanlarını darp eden 5 kişi hakkında dava açıldı.
Tekmeler, yumruklar havada uçuştu. Hastane koridoru...
Geçmişte siyasilerin, devlet büyüklerinin sağlık personel arkadaşlarına bir göz atalım. Kenan Evren, askeri cuntanın başıydı. Mecbur hizmete gelen doktorları ağaca bağlayın, kaçmasınlar dedi. Paşamızın bağlayın dediği o sağlık ocaklarında it bağlasanız durmazdı. Evren, askerden fazla alıyorlar diye sağlık personel esasını iptal ettirdi ve tüm sağlık çalışanlarını 657'ye tabi kıldı. Fırat Sayın Hekim 18.000 lira maaş almaya başladı. Bir teğmenin maaşı 35.000 liraydı. O sırada eşi hanımefendi Gülhane'de yatıyordu. Beyin tümörüydü. İyileşmesi mümkün değildi. Tüm doktor düşmanı oradan kaynaklanıyordu. İmran Aykut hanımefendi Çalışma Bakanı'ydı. Doktorların maaşlarının 400 dolar civarına inmesi karşısında ne verirseniz verin bu doktorlar göz doymaz dedi. Yıldırım Akdoğan'a kendisi bir nöropsikiyatristti. Sağlık Bakanı iken habersi gitti hastanede. Hafta sonu bakamında bulamadı. Başhekimin kapısını kırdı. Osman Durmuş bir biyoloji doçentiydi. Antalya Devlet Hastanesi'ni denetlerken Mayıs ayında kaloriferin yandığını gördü. Doktor elleri 10 dakika kaloriferin üzerine bastırarak yanmasını sağladı. Bir Sağlık Bakanımız doktorların eli hastanın cebinde dedi. Yetmedi. Üstüne bir de Paris doktorlar gürültü yapıyor diye ilave etti. Sağlıkta dönüşüm adı altında sağlık çalışanlarının ve doktorların sağlık kölesi haline getirdi. Hiçbir Adalet Bakanı duydunuz mu benim hakimim savcım rüşvet alır? Hiçbir İçişleri Bakanı duydunuz mu benim polisim rüşvet almıştır, alabilir? Tapu Kadastro Genel Müdürü bu alınanlar hediyedir dedi biliyorsunuz. Devlet hastaneye duvarlarına telefonumuz kadar yakınız. Şikayetiniz varsa hemen arayın dediler. Bir devlet büyüğümüz ben doktora iğne yaptırmam. Doktorlar adamı felç eder Allah dedi. Doktor efendi dönemi bitti diye ilave etti. İşte felakete başlayan gibi bu cümleler oldu ve doktora saygısızlık etmeyi, hakareti kendine hak gören bir vatandaş türü ortaya çıktı. Çok kolay erişim, değersizleştirme ve sıradanlaşma sağlık personelinin önde gelen sorunu haline geldi. İster istemez hastaneler insanların sıkıntılarını deşarj edebilecekleri, istediği gibi bağırıp çağırıp benim haklarım var, diyerek devlet estirebilecekleri yerler haline geldi.
Sizin çocuğunuz olsa siz aynı şey yapmaz mıydınız? O zaman bana karışmayın. Bana karışmayın.
Bir anda hasta ve yakını efendi doktor maraba oldu. İnanmayacaksınız ama hasta ve yakınların canı istediği gibi şikayet edebileceği Sabim ve Bimer gibi telefon hatları sağlanmışken doktorun uğradığı haksızlık karşılığında müracaat edebileceği hiçbir merci yoktu. Sağlık çalışanlarının vatandaşla zorunlu diyaloğunda şiddet sarmalıyla karşı karşıya bırakılması asla kabul edilebilir değildir. Giderek hak özgürlüklerden ve eğitimden kopan bir süreç, magazinleşen bakış açısı, özendirici yaklaşımlar, yaptırımı olmayan düzenlemeler, böylesi kadim bir mesleği ve mensuplarını hızla itibar kaybına sürükledi. Bir de meslektaşlarımızla sorunlarımız var. Bakın bir meslektaşımız neler söylüyor. Kendisi Akçası Doktor Profesörü.
Hasta olduğunuz zaman mutlaka hemen hiç gecikmeden doktora gidin. Muayene parasını ödeyin. Çünkü doktorunuzun yaşaması lazım. Reçetenizi alın, eczaneye gidin, ilaçları alın, parasını ödeyin. Çünkü eczacının da yaşaması lazım. Eve gelin, ilaçların hepsini çöpe atın. Çünkü sizin de yaşamanız lazım.
Kendisi muhtemelen hastalarına ilaç vermeden iyileştiriyor. Bir başka onkolog arkadaşımız bütün kanser vakaları saçmadır dedi. Patologa bir takım olgular mikroskopta kansere benzetiyorlar ve hastanelere reyting yapıyorlar. Bu tür yayınların hepsinin ensest türü ilişkiler olduğunu farkındasınız. Bu iki arkadaşımız da İstanbul Tabip Odası tarafından disiplin kuruluna verildi. Bir de meslekte rakiplerimiz var.
Senin hayatını kurtarman için ben bir çaba sarf ediyorum burada. Bak bir doktora gittiğin zaman doktor seni bir ameliyat ediyor. Kalpteki tıkanmış olan 2 tane damarını değiştiriyor. Bacaktan damarlar alıyor takıyor ve doktora diyorsun ki doktor bey hayatımı kurtardın. Şu araba benim sana hediyemdir. Neden doktora bu arabayı hediye ettin? Çünkü doktor senin hayatını kurtardı. Tamam da hayatını kurtardı daha 10 sene 20 sene daha yaşayacaksın. Sonra öleceksin. Doktor bir şey yapabilir mi? Yapamaz. Vaizler bir doktordan daha kıymetlidir, daha değerlidir. Neden? Dünyada hayatını kurtarmakla kalmaz. Bir de ebedi hayat.
Vatandaş kendisine hiçbir fayda sağlamayacak bir muska yazarın önünde el pençe divan dururken doktor yapmadığını bırakmıyor. Onuru kırılmış bir sağlık personeli can kaygısı güderken acaba şiddete uğrayacak mıyım diye endişe ederken nasıl veriliyor sağlık hizmeti verebilir? Acaba ortada devletin görünmez bir mesleki kayrımcılığı mı var? Bir hakim, vali, kaymakam veya polise sözlü saldırı dahi olduğu zaman devlet ne yapıyorsa sağlık personeline de bu muamelelere maruz kaldığı zaman onu yapsın. Bunlar devletin adamı olabilir ama sağlık personeli devletin büyük masraflar yetiştirdiği çok değerli kamu görevlileridir. Cumhur'a göre 7 yıl ve üzeri hapis gerektiren durumlara tutuklama gerekmektedir. Fakat bugüne kadar hiçbir doktora şiddet yapan tutuklanmamıştır, ifadesi alıp evine gitmiştir. Doktoru dövdüm, evime gittim sloganı kullanılıyor. Ben çok merak ediyorum, acaba aile bu şahsa aferin diyor mu? O aile bir daha ne yüzle hastaneye giderek hizmet talep ediyor? Bugüne kadar bir aile yakınını doktor döverek daha iyi sağlık hizmeti almış mıdır? Yerden 10 kilogramlık kaldırım taşını alıp doktorun kafasına 2 kez vuran, 3. darbeye yetiştirenler tarafından kurtarılan bir insanın ruh halinin normal olması mümkün müdür?
10 kiloluk parke taşıyla doktora saldıran Abdülkadir Keskinli gözaltına alındı. İfadesinde herhangi bir pişmanlık duymadığını
Bu şahsın savcının sevki veya hakim kararıyla bir psikiyatrik kliniğe sevk edilmesi, tedavisi tamamlandıktan sonra tedavisi tamamlandı. Ancak kurul kararı verilerek yatması, ancak taburcu olduktan sonra mahkemeye çıkarılarak topluma kazandırılması gerekir. Çünkü bu sağlıklı bir davranış değildir gerçekten.
Ama bir niye doyuruyor? Doktorun hiç suçu yok mu? Ama bir niye doyuruyor?
Sorun bakayım. Niye dövdü doktoru? Buna ihkak-ı hak deniyormuş hukukta. Suçu kabul etmek.
Karaman'da bir hasta ameliyat sonrası pansuman yaptırmak için hastaneye gitti. Başta her şey normaldi ama pansuman sırasında canı yanınca sağlık çalışanını darp etti.
Önce tokat attı, sonra tekme. Pansumanda canının yandığını söyleyen hasta sağlık çalışanını darp etti. O anları güvenlik kamerası böyle kaydetti. Görüntüler Karaman'da bir özel hastaneden. Ameliyat olan bu hasta pansuman için geldi. İşte o sırada canının yandığını iddia etti, sağlık çalışanlarına saldırdı. Diğer görevliler araya girdi. Sağlık çalışanını tekme tokat darbelerinden kurtardı. Sağlık çalışanı darp raporu aldı. Saldırgan da polise teslim edildi. İfadesinin ardından serbest bırakıldı.
Farkındaysanız soldaki insan sağdaki hayvandı. Bu filmin bitiminde köpek veteriner yüzünü yalıyor.
Her name is Wunda, that it means close to die. Wunda. Wunda. And actually, her name is exactly with her, because she was in different situations that was very close to die. The last time she had a very serious illness. She was really bad. She lost weight and she was looked for she became unbelievable. And now we are going to give her paradise on the island.
Hastalarımızdan bu kadar minnet beklemiyoruz ama saygı göstermelerini her zaman arzu ediyoruz. Bakın bu çok hasta olan bir maymun. Yemiyor, içmiyor, ölmek üzere. Yıllar önce kendisine bakan veteriner geliyor. Sevinçten çıldırıyor. Boynuna sarılıyor, saçlarına uçuyor. Karşılıklı seviştikten sonra yatağında kırılıyor ve ölümü bekliyor. Sağlıkta şiddet en çok sözel ve fiziksel şiddet 2015 yılında zirve yapmış durumda. 2017 yılına bakmayın, son 6 ay sadece. Yaklaşık her yıl 10.000 civarında sözel şiddet var. Yaklaşık 2500-3000 civarında fiziksel şiddet var. Sağlık Bakanlığı'nın istatistikleri. En çok eğitim hastanelerinde, devlet hastanelerinde oluyor. Eğitim hastanelerinde çok fazla. Üniversiteler ve özel hastaneye gittikçe şiddet azalıyor. İnanmayacaksınız ama %40 civarında şiddeti kadınlar yapıyor. Daha da ilginci %36 hastaların kendileri doktora şiddet uyguluyor. Bu çok ilginç bir grafik. Polikliniklerde bakın sabah şiddet başlıyor, öğlene doğru tırmanıyor, öğlen tatilde bir dip yapıyor, öğleden sonra tekrar başlıyor, akşam saat 7'ye kadar şiddet devam ediyor. Acil servislerde sabah 7'de 0 şiddet varken başlıyor, öğlene doğru artıyor. Saat 20'den sonra çoğalıyor çünkü herkes evine gitmeden bir de doktora gideyim, bir acil muayene olayım telaşı içerisinde oluyor. Gece 24'e kadar şiddet devam ediyor. Kliniklerdeki şiddet öğlen üzeri çok artıyor çünkü herkes hastasını görmek istiyor fakat çok yanında defalarca birkaç kişi kalmak istiyor. En çok şiddetin öğlen üzeri görüldüğünü görüyoruz. Sağlık kurumunda çalışanların şiddete uğrama oranı diğer iş yerlerine göre 16 kat olduğu saptanmıştır. Beyaz kod bir kurtarıcı gibi bakıyoruz. Kayıtlar incelendiğinde sağlık ortamındaki şiddetin yaygınlığı ve kanıksanmışlığı daha iyi anlaşılacaktır. Beyaz kod istatistiklerinden geçtiğimiz 5 yılda 46.000'i aşkın sağlık çalışanı beyaz kod başvurusunda bulunmuştur. Bu sayı yalnızca başvurulanlar. Çekinen, başvuru fırsatı bulamayan ya da bu düzenekten yarar gelemeyeceği varsayımıyla çağrı yapmayan meslektaşlarımız da var. Adliye ve polisiyenin ötesinde düşünmeyi gerektiren bir sorunla karşı karşıyayız. İnsanlara yaşam sunan bir sanatın icracıları olan hekimlerin ölümcül şiddetin bu hedefi olmaları, değersizleştirme ve sıradanlaştırma ile açıklanıyor ancak. Bakınız bu bir hekim, kendisi bir sağlık komisyonu başkanı, cümle aynen şöyle. Bizim birkaç tane aklı haber başhekim hastanede ağır ameliyatlar yapmayın diye resmi yazı yazmışlar servislere. Öyle birkaç tane belge var. Tabii mazur görün, bunlar sopalık. İzmir Tabip Odası'ndan Ceyhun Balcı hocamızın yaptığı bir araştırma 2010-2012 yılında internet ortamında yapılan bir araştırma. 600 kişi telefonla aranmış. Ankete her iki hekimden biri meslek yaşamında fiziksel veya sözel şiddete uğradığını beyan etmiş. Şiddete uğrayan her iki hekimden birisi fiziksel şiddete uğramış. Bunların içinde tekmeli, tokatlı, yumruklu saldırıların yanı sıra ateşli silah, kesici delici alet olduğu ifade edilmiş. Sıra dışı bir olguda da bir samuray kılıcı var. Aynı ankette meslektaşlarımızın devlet büyüklerinin söylemlerinden şiddeti üreten ve özendiren nitelikte olduğunu ifade etmişler. Yine o ankete katılan meslektaşlarımız sağlık yöneticilerinin şiddet olaylarının yaşanmaması için çaba göstermediklerini ve şiddete uğrayan sağlık çalışanların yanında olmadıklarını ifade etmişlerdir. Aradan geçen zamanda beyaz kodun ne kadar faydalı olacağını göreceğiz. Sağlık çalışanlarının şiddete maruz kalmasının önlenmesindeki en önemli faktör yeterli güvenin sağlanmaması olmakla birlikte yetişmiş güvenlik eleman yetersizliği, bu elemandan sahip oldukları yetkiler ve sorumlulukların tanımlanmamış olmasından kaynaklanmaktadır. Örneğin, polise mukavemet suçu için uygulanan prosedür ve yasa maddeleri sağlık personeline yapılan şiddete karşı da uygulansa vatandaş cürmünün bedeli ne olduğunu bilecektir. Bizim insanımız polisi sevmez ama ona yaptırımlar nedeniyle saygı duymak zorundadır. İnsanlarımız doktor hiç zaman sevmemiştir. Doktor parası olsun diye bedduamız vardır. Ama doktor her zaman saygı duymuştur. İşte sorun bu saygının kaybolduğu yerde başladı. Bugün bir havayolu hatta otobüs şirketi sorun çıkaran bir yolcuya bir daha servis vermeme hakkına sahip. Ama hastane demin başına zarar veren, doktor ve personel darp eden bir hasta yakını aynı gün arsız bir şekilde hastaneden hizmet alabilmekte. Hastane ortamında alınan güvenlik önlemlerinin yetersizliği, yasal düzenlemedeki boşluklar ve görsel yazılı medyada yardımıyla ortaya çıkan şiddet olguları sağlık çalışanlarının kendilerini güvende hissetmemelerine neden oluyor. Sağlık personelinin önemli sorunlarından biri ani olarak şiddete uğradıkları sırada kendilerini koruyacak fizik kondisyonda olmadıkları gibi yardım alabilme imkanları da olmaması. Bu nedenle sağlık personeli oluşabilecek bir şiddet olan hissettiği zaman acilen yardım isteyemiyor.
Çok konuşma senin o. Gelsene sen şöyle.
Böyle bir doktorun ancak dizilerde olabiliyor arkadaşlar. Ne yapalım? Bu faktörleri bir de aykırı da dersini koyalım. Şiddet olaylarının nedenlerini sıralarsak, hasta ve hasta yakınlarının bir an önce kendileriyle ilgilenmesi istemeleri, kendi hastalarının daha acil durumda olduğunu, kendilerinin herkesten daha önemli olduklarını düşünmeleri, yani yüksek ego, muayene veya tetkik için uzun süre beklemeleri, personel yetersizliği, iş motivasyonu, çalışma ortamı ve kontrolsüz öfkenin etkili olduğu görülmektedir. Bakın bu Ok Meydanı Hastanesi'nde saat 16.44 sırasında çekilen 2 monitör görüntüsü. Birinci arkadaşımız 51 hasta muayene etmiş. Yani hastalığın başına öğlen tatiline düşerseniz 9 dakika. Biraz daha meraklı bir arkadaşımız. Öbür arkadaşımız 60 hasta muayene etmiş. Yani hasta başına 7.6 dakika düşmüştür. Böyle bir sağlık hizmetinden hangi hasta memnun olur? Hangi doktor bu hizmetten onur duyar? Size soruyorum. Başkaları adına ilaç yazdırma talepleri, nedensiz olarak rapor talep etmeleri ve sağlık personelinin bu talepleri haklı nedenlerle olumlu karşılamaması, hasta ve hasta yakınlarının işlerinin düzenli görülmediği veya doktora alınmada, adil davranılmadığı hakkındaki şüphelerinin olması, halkın hastane içinde sınırsız davranma, şiddet uygulama ve silah kullanmalarının bile hak olduğunu düşünmeleri, tüm bunların yanında görünürde güvenlik görevlilerinin yetersiz olması şiddete davet gibi algılanmaktadır. Sağlık personeli şiddet uygulaması her ülkeye göre farklılık gösterse de özellikle gelişmekte olan ülkelerde ve eğitim seviyesi düşük olan yörelerde acil servisler şiddet olayının en sık rastlandığı yerlerdir. Bakın bu bir ambulans görevlisi.
Yediği dayağın nedeni ise basit bir uyarı.
Ambulans parkeri oraya çekmeyin dedik. O efendim siz misiniz deyip araçları inip direkt üzerimize geldiler.
Kolu kırılan, yüzü şişen doktor şu anda çalışamıyor.
Ambulans hizmetleri de bunu takip etmektedir. Sağlıkta şiddetin en utanç verici yönünün en fazla cinsel istismara uğrayan sağlık personelinin hemşirelerimiz, kardeşlerimiz olduğundan da utanç duyuyorum. Tüm bu açıklamaların ötesinde asıl ve önemli olan konu sağlık personelinin uğradığı şiddete olan koruyucu yasal düzenlemelerin hazırlanması ve önemli uygulanmasıdır. Beyaz koddan bakalım ne çıkacak? Cezai müeyyideler uygulanacak güya, kanunlar çıktı ama hiçbirinin sonuçları yok. Bugüne kadar bir hasta veya ailesinin şiddet uygulamaktan daha hizmet almış olduğu görülmüş değildir. Yeni çıkarılan yasalar bunu emrederken şiddet uygulayıcıların ifadeler alındıktan sonra serbest bırakılmaları, tutuksuz yargılanmaları, verilen cezalar tecil edilmesi veya paraya çevrilmesi, cezaların yaptırım gücünü ve caydırıcılığını ortadan kaldırmakta, toplumda yapan kar kaldığı zihniyetinin yerleşmesine neden olmakta, bazı toplumlarda bu tip kişilerin ailenin kahramanı muamelesi gördüğü bilinmektedir. Bakın bu bir doktorun kapısı. Tedavisi beğenmemiş olabilir ama bir hakimin, yargıcın kararını veya bir kaymakamın kararını beğenmediği için o görevlinin kapısını tekmeleyebilir mi bu insanlar? Kesinlikle hayır. Olay çözümsüzlük getiren önemli nokta bu mütecaviz arsız bir şekilde hastanede bulunan şikayet masasına gidiyor, şikayet ediyor, doktorun da savunması alınıyor. Bunlara rağmen doktorun hasta veya refakatçiler için Sağlık Bakanlığı'na giderek şikayet edebilecekleri bir makam veya telefon yok. Yani ister Sağlık Bakanlığı'na, ister hastane idaresi ilgili birimine herkes doktora şikayet edebilir ama doktor adeta aslanların önüne atılmıştır.
Doktor kendisine hakaret eden hasta yakınından şikayetçi oldu. Mahkemeden de emsal bir karar çıktı. Hakaret eden hasta yakını hapis cezası aldı.
Lütfen
Niğde'de
şikayette bulununuz.
Eninde
sonunda bu insan cezalandırılacak.
Çocuk acilinde görevli bir doktora hasta yakını hakaret etti.
Bu hasta 11 ay aldı ama iyi halden ceza indirimi aldı.
Ve dava açıldı. Niğde 5. Asliye Ceza Mahkemesi'nde.
Diğer husus, doktorlar da her insan gibi hata yapabilir. Ancak bilinmelidir ki doktor hatalarının en önemli bölümü sistemden kaynaklanmaktadır. Uzun çalışma saatleri, yardımcı personel yetersizliği, ağır iş yükü, modern teşhis ve tanı yöntemlerine kolayca ulaşılamaması, yetersiz ve kötü hastane koşullarının oluşturduğu zeminde istenmeden yapılan hatalar olmaktadır. Bu hataların dışında istenmeyerek yapılan hatalar olabileceği gibi bunlar malpraktis kuralları içerisinde tanımlanmıştır ve Hammurabi'den beri suçtur. Ancak ceza yargısı tarafından değerlendirilecek bir konu olup, bu ülkede Hammurabi kanunları olmayıp ceza bireylerin kendi başına uygulayacakları bir hak değildir. Hatalı bulduğunuz zaman doktora şikayet edebilirsiniz. Yargıya gidebilirsiniz. Tıpta yanlış uygulama sebebiyle hekimin hukuki sorumluluğu kapsamında yargı yolunu seçebilirsiniz ama elinizi sürmeye kalkamazsınız. Aslında doktor tüm eğitim boyunca 0 hata eğitimi almıştır. Ama buna rağmen hata yapabilir. Çünkü doktor da bir insandır. Bu son günlerde bir diziden alınan görüntü. Çok kısaca vereceğim.
Geçenlerde doktor.
Öncesi önemli. Evet.
Günden güne kötüleşiyor doktor. Beklenen tabloymuş. Ne konuşuyorsun sen bana? Bu çocuk bir haftadır 2 kelime etmedi be. Başlatma hastanenden. Ben sanki nereye götüreceğimi
Konuşma boyunca
bilmiyorum
doktor
değil mi?
hakaret doluydu.
En iyisi
Ciddi
olduğu için sana
bir toplum
getirdik.
kuruluşu oluşturduk.
Dedik
Rütüke
ki
müracaat
bir
ettik.
şey bulanıp gönderiyorsunuz.
Tabii Rütüke müracaat
Bana bak.
ettiler.
Ya adam gibi bu çocuğu tedavi edersin.
Özür dilemek zorunda kaldı. Fakat bakın özürü bile saçma.
Geçenlerde doktora ağır davrandım. Ne bileyim Nedim'i öyle görünce
Geçen doktora kötü davrandı. Bir akşam beni çağır da gönlünü alalım.
Değil tabii.
Bakınız Kayseri Memur Hastanesi'nde bir genç arkadaşım sponsor çocuk malzeme satan firmadan biriyle direkt görüşme yaparak sponsorluk çekmesini sağladı. O kadar basit ki o dizideki sponsor firmayı arıyorsunuz, sponsorluk çekmeni istiyorsunuz ve bakın sizden kendi adımıza özür diler, göstermiş hassasiyetten ilgili alakadan da teşekkür ederiz, sponsorluğumuzu çektik dediler. Ben böyle bir protesto hazırladım, Hürriyet Gazetesi'nde yayınlanması için yayınlamaya kabul etmediler. Sözcü Gazetesi ilan için 4.000 lira teklif etti, kabul ettim. Bir saat sonra da 9.000 lira istediler. Bakın bu da var. İlk defa böyle bir dizi oldu.
Arkadaşlar sizleri dışarı alalım.
Lütfen dışarı çıkar mısınız dedi doktor. İkinci seansta gene.
Arkadaşlar, her iki yaralımızın da durumu ciddi. Şu an ameliyata alındılar. Hepimiz için çok zor ve uzun bir gece olacak. Sizden ricamız, biz yakınlarınızı hayata döndürmeye çalışırken sakin kalmanız ve hastane personeline yardımcı olmanız. Şimdi sizi dışarı alabilir miyiz?
Doktor bey, hastalarımızın hayat riski olduğu kadar güvenlik riski de hala devam ediyor. Eğer müsaade ederseniz birkaçımız burada kalsın. Bizim içimiz rahat eder.
Muhtemelen dizi oyuncularının çoğu tanıdığım olduğu için olaya çok yumuşak bir şekilde cevaplandırdılar. İlk defa bir mafya filminde doktora ve hastaneye saygılı davranılmıştı. Bunun üzerine tabip odasına müracaat ettim. Örneklerini gönderdim. Bir teşekkür mektubu yazmalarını rica ettim. Hatta 14 Mart'ta bir plaket vermelerini, böyle onurlu bir davranış yaptıkları için, örnek bir davranış sergiledikleri için biz mafya filmine ödül vermeyiz dediler. Ama ben rahat durmadım gene. Gazetelerde kendilerine bizzat teşekkür ettim. Lütfen bunları teşvik edelim. Bakınız böyle bir korkunç olay yaşadık. Bir biyolog arkadaşımız darp edildi. Sosyal medyadan birkaç tane yayını size utanarak anlatacağım. Vallahi kimse kalkıp da sağlıkta şiddet olmaz demesin. Bazıları o kadar hak ediyor ki sanki hayatlarına hayırlarını muayene ediyorlar, azarlıyorlar. Kimse halkı dinlemiyor. Kesinlikle süper olmuş. Keşke sakat bıraksaydı. Az bile dövmüş. Sorun şimdi doktor haklı olur. O kardeşimizin ellerine sağlık. Bence iyi yapmış. Doktor önce hastasına bakar. Benim babama da yapsalar burun değil bütün kemiklerini kırarım. O çocuk acilen serbest bırakılmalı. Şov adı altında itibar etmeyin. Hasta yakını hakkı doktor ne yaptı ki? Dayağı yedi. Ellerine sağlık kardeşimin. Daha fazlasını okumaya gerçekten utanıyorum. Ne yapmalıyız? Bu doktorlarım gibi Aikido mu öğreneceğiz?
Bana bak. Çok konuşma senin o.
Mümkün değil. Taksi şoförleri gibi bunları mı unutacağız arabamızda? Bize yakışmaz. Hele bu hiç mümkün değil. Bakın Marmara Üniversitesi Hastanesi'nde şiddete uğramış bir şiddet protesto posteri. Bakın bu tür posterler eminim çok ses getirecektir. Teşvik etmek lazım. Hiç veteriner ısıran köpek gördünüz mü? Bu biraz önce bahsettiğim sponsorluğun geri çekilme yazısı. Bu benim yayınlama kabul edilmeyen müracaatım.
Okudunuz. En parlak öğrencilerden biriydiniz lisede. Çok zor girilen tıp fakültesine girdiniz. 6 yıl okudunuz. Tıpta uzmanlık sınavına da girdiniz. Onu da kazandınız. İhtisas da yaptınız. Sonra da çalışacaksınız. Halk sağlığı için sizin huzurlu ve güven içinde çalışmanız, her türlü şiddetten sizin arındırılmış, güvenli bir çalışma ortamına ihtiyacınız var.
Bir yıl içerisinde 12.000 sağlıkta şiddet rapor edilmiş. 5 yıl içinde bu rakam 46.000. Bunun içerisinde ciddi darp var, bıçaklama var, yaralama var. Sağlıkta şiddet bir toplumun ayıbıdır.
14 Mart Tıp Bayramı kutlanıyor ancak sağlık çalışanları bayram coşkusundan
Medyayla
uzakta.
olan tüm
Çünkü
bağlantılarımızı
gündemlerinin
çok iyi
ilk
kullanmamız
sıralarında
gerekir.
uğradıkları
Ben
şiddet
elimden
var.
geldiği kadar
Kalp
tüm
cerrahı
medya
Bingür Sönmez,
organlarla olan ilişkilerimi bu
meslektaşlarının
yönde en iyi
uğradığı
şekilde
şiddete
kullanmaya
bir an önce
çalışıyorum.
önlem alınmazsa hastaların da sağlıklı sağlık hizmeti alamayacağına dikkat çekti.
Artık en tercih edilen ihtisas dalı cildiye, deri hastalıkları. Fizik tedavi, radyoloji gibi hasta temasının en az olduğu.
Bakın gazetelerde bu tür haberlerin çıkması her zaman iyi ses getiriyor. Ülkenin aydınlarından özel beyanatlar istememiz lazım.
Verilecek ceza bellidir. Kim olursa olsun zaten şiddete maruz kalmışsa onun cezası hukuken bellidir. Ama eğer şiddete uğrayan,
gerek sosyal
maruz kalan
medyada
bir
gerek televizyonlarda
kimse
bu tür
hakim
aydınlara
olur.
vereceği mesajlar çok geçerli olacaktır. Bakın bu da televizyonda ilk defa yapılan bir program.
Doktor dövmek normal midir diyorum.
Değil, hayır, bu yeni bir numaradır.
Çok iyi.
Bunlar sizin hizmetçinizdir. Hizmet edecektir size. Fazla bunlara sıkıntı verme, sıkıntıya gelmeyin, hadlerini bildirin dersen, o hadlerini bildirin, dövmeye kadar gider. Yani eline bütün
bunlar
talimat
siyasetlerden
duyar,
çekinmeyen,
bunlar
beyanat
hizmet
verebilen
ediyor.
ülkenin aydınlarıdır.
Şimdi kardeşim,
Yeni yıldan en büyük beklentim benim
Temsilden
şahsen
hayvanlar için verdiği
hayvan
emek
hakları
kadar
yasasının bir an
sağlıkta
önce
şiddetsiz emek
meclisten
vermesi
çıkması.
bizzat rica
Cumhurbaşkanı
ettim.
Erdoğan
Bütün doktorlarımızın, hemşirelerimizin, sağlık çalışanlarımızın da tıp bayramını kutlamış olalım, izleyelim.
Geçen sene tıp bayramında bunu yaptık. Kanuni Sultan Süleyman'ın söylediği gibi halk içinde muteber bir nesne yok devlet gibi, olmaya devlet cihanda bir nefes sıhhat gibi.
Niye saldırıyorsun bana, niye
Televizyonlarda gerçekten çok ilgi gördü.
sinirlenip
Köşe yazarlarından özel beyanatlar isteyebiliriz. Kendisi bir bypass'tır, benim hastamdır.
Sağlık Bakanı doktora şiddet uygulayan karşısında beni bulur dedi. Türkiye'nin dört bir yanından doktora şiddet haberleri gelmeye başladı.
Bakan öyle dedi ama ülkenin her yerinden sağlık şiddet haberleri geldi. Sağlıkta şiddete mahkumiyet dedi. Çıkan kanun sadece doktor karakola gitmesine gerek yok. Çalıştığı yerde ifadesini alabilir çünkü çalışmak zorunda şekline döndü. En acemi doktor bile onlarca insan hayatını kurtarabilir ama bugün şiddete maruz kalıyorlar, öldürülüyorlar. Bu ülkede yıllardır taşlar bağlı, köpekler serbest. Ne bekliyoruz? Aslında çözüm hukuk veya kanun değil, kamu vicdanıdır. Siyasetlerimizden, bürokratlardan, sağlık çalışanlarını onore eden söylemler bekliyoruz. Dizilerde sağlık çalışanlarını rencide eden, acil servisi basma, ameliyathaneye girip ekibi tehdit etme gibi şiddeti normalize eden görüntülere Rütük tarafından izin verilmemesini bekliyoruz. Sağlıkta şiddeti kınayan kamu spotla yapılmasını bekliyoruz. Şiddete uğrayan bir sağlık personeli protesto edenler arasında o doktor hizmet görmüş veya ya da hizmet bekleyen hasta yakınlarının çalışanların da profesyonel katılmalarını bekliyoruz. Fiziki yapı, donanım, iletişim ve eğitim konularında iyileştirmelerin yapılması tek başına yeterli olmayıp sağlık çalışanlarının yasalarla korunduğu güvenli ortamlarda motivasyonla çalışması ve huzur içinde kaliteli sağlık hizmeti sunabilmeleri için sağlık çalışanlarına yönelik şiddetin caydırılacağını amaçlayan yasal düzenlemeler bekliyoruz. 2018 gerçekten bir kara yıl oldu bizim için. Sayın Cumhurbaşkanımız bir konuşma yaptı 14 Mart'ta. İlk defa güzel sözler duyduk bir siyasetçiden. Dedi ki emekleri, fedakarlıkları ve önce insan, önce sağlık diyerek mesai kavramı gözetmeden özveriyle çalışan sağlık çalışanlarımızın 14 Mart Tıp Bayramı'nı tebrik ediyorum. Canımızı emanet ettiğimiz sağlık çalışanlarını yılın bir günü değil, her günü baş tacı etsek yeridir. Sağlık çalışanlarımıza yönelik sözlü ya da fiili hiçbir saldırıyı kabul etmiyor ve bu suçu işleyenlerin en ağır şekilde cezalandırmaları için gereken yasal düzenlemeleri yapmaktan geri durmuyoruz. Sağlık çalışanlarımıza adeta mesleklerinin en yücesini, kıymetlisini icra eden, günün 24 saati kesintisiz verilen sağlık hizmetlerinde emeği katkısı olan çalışanlarımıza başarılar diliyor. 14 Mart Tıp Bayramı'nı kutluyorum. Gerçekten büyük bir sürpriz oldu bizim için. Sayın Cumhurbaşkanımızın bu vaatlerinin gerçekleşeceği günleri özlemle beklerken tüm sağlık personeline içinde şiddet, taciz, darp olmayan çalışma ortamları diliyorum. Toplumun her kesiminde şiddeti kınayarak sunumuma son veriyorum. Teşekkür ediyorum. Çok yoruldunuz. Çok teşekkür ediyorum.
Hocam çok onur verdiniz. Çok güzel bir sunumdu. Sağlıkta şiddet hepimizin sorunu. Bu yaşta geldiniz, bu kadar uzun anlattınız.
Çok teşekkür ederim.
Hepiniz teşekkür ediyorum size. Arkadaşlar törenimizi burada bitiriyoruz. Ama birkaç salonda bildiriler var. Hepinize bu saate kadar durduğunuz için çok teşekkür ediyoruz. İşlerimiz bitmiyor. Beraberiz. Burada teşekkür etmediğim arkadaşlar kalmış, onlara galada teşekkür edeceğim. Rahat olsunlar. Bölüyoruz yani. Teşekkür edecek çok var. Teşekkürler arkadaşlar.
You can calculate the surface according with the weight, total body superficie, weight, kilograms, and also for less and more than 10 kilograms. How you maintain the routine for the fluids? If the patient is more than 10 kilograms, you can increase 50 milliliters per kilo per day for the next 10 kilograms, or 20 per kilo per day if they are over 20 kilograms. So you need to be careful, because sometimes if you use more than this, you are overloaded. How is the balance between the income water is about the income oral water that you use them, and also performing water and oxidation water? And what is the expenses that you have? In sensitive losses like urine, stool, sweat, temperature, and breathing. So this is how you expense this. In this period, you have two different periods to treat the patient. The first one is the resuscitation phase in acute presentation, when the fluids is needed to restore adequate tissue perfusion and prevent the lesion. In this time is immediately, the next couple of minutes and the next hour. The second phase for the period is the trihydration phase. Is a critical window to determine what intravascular repletion has been achieved and the trajectory of the fluids gain versus losses. And the third phase, or the third period, is maintain the phase, is the moment in which the fluids must be supplied to achieve the precise homeostatic equilibrium between the needs and the losses the patient present. And the next phase is convalescence, the period in which the administration of exogenous fluids is stopped and the patient return for the intrinsic regulation of the fluids. So it's a break to invite you to come to the conference next November in Mexico. So be careful. A specific protocol's dose is not able to apply for all patients. Every patient needs to be particular way to treatment. The needs of the fluids in patient ER is very widely. So many patients depend the pathology, depend the antecedent they have because it's very different. So the choice of the appropriate type and amount of the volume require great care. So you need to be careful about that. This is why we use different type of the solution. We have crystalloids and also we have colloids. Colloids is the best expanding capacity given by the sodium and maintain the electrolyte balance. But you need to be careful. 80% of the volume of the solution go straight to the internal space. Between 20 and 25% stay intravascular space, and the next 15 minutes disappear. So you need to be careful about that because when you start to overloading the doses of the solution, you produce more damage. So the colloids is try to maintain the colloids pressure and is one of the best expander volume. So you can use other solutions like gelatin, dextran, or albumin. And you can see if you compare the solution that the crystalloids, Ringer lactate, and you compare with the plasma, and you see the tonicity, and you see the equivalence between sodium and chlorine are similar. This is why we use most of the time this solution in the beginning of the patient. So also the osmolarity, if you compare with the plasma, the first one, the isotonic, is the osmolarity is osmolar and isotonic. But also, if you compare with the plasma, the next one, the tonicity is the same. So it's osmolar and isotonic for the patient that they use isotonic crystal contain between 121 milliequivalents of the sodium per solution. So what is the indication if we want to use the solution? In emergency room, normally we use a lot of physiology solution and also we use the lactate Ringer. So what is the indication for this is for reposition volume, hypovolemic shock, and also when you use lactate is for hypovolemic shock and reposition. The other one is the artificial colloids that we use for replacement volume and also with the patient when present burns or ascites or nephropathy syndrome. You can see in this table what is the characteristic of the different states. The principal goal that you have in the first step, the rescue, is the life-saving and correct the shock. So the time that you need to use is minutes. And this is typical scenario for septic shock and major trauma and hypovolemic shock. The next is the optimization. The principal goal is rescue the organs, and also you can use for burns, ketoacidosis, and you can spend 4 hours, the next hours to use it. And the third line, this is the stabilization. The principal goal is the organ support. You can use in days and stable it, and also use for patients that they have pancreatitis or they have operating room or something. And the last is this escalation is for preserve the organ recovery. This is the principal goal. And this is the time that you see, you can use in days and the weeks, but also you can use it for patients that they are in the parenteral or they are in the other problems for the surgery and other things. So in this different stage, you can see what is the principal goal in every state that you see to try to maintain the solution. So in resume, rescue is between 0 and 24 hours. Optimization is between 24 and 72 hours. Stabilization is 72 to 110, and this reanimation is after 110 hours. So you can see the strong recommendation accord with this chapter. This is one of the papers that they wrote in the last November, and this is other one in the last December. And they showed the guidelines to this, and they are the evidence to recommend of the fluids, the use of the provide critical support for patients that they are really serious, and for that patient that they cannot provide or they do not use the enteral administration like gastroenteritis, respiratory problem, and the patient with neurology, right? So in these papers that I show you, they recommend the administration of the hypotonic solution has been the standard in pediatrics. But most of them, they have incident for the hyponatremia. So you need to be careful because the patient, when you start to use this solution, they produce more hyponatremia than the other ones. This is why in these papers and other more than this, they recommend the isotonic solution for children that they need IV solution could be prevent the development of the hyponatremia. So they don't use hypotonic, they now use isotonic because they want to prevent hyponatremia. In this paper also, they have a strong recommendation on the isotonic solution between the patient to 28 days until 18 years old, they require solution and should receive isotonic solution because with appropriate potassium chloride and dextrosa, they significantly reduce the risk of developing hyponatremia. So in that way, you can prevent more complications than the benefits that you can do. Also, you can use the personalized fluid resuscitation. Require principal attention for this mnemonic. Context, indication, target, timing, among the fluids, infusion strategy, a type of the diffusion that you want to use in case the patient requires. So this model using characterization is for every patient in particular. This was published recently in 2015, and they are not accepted and because they are not normally accepted for all people that work in the emergency room in pediatric situation. But over the years, emergency room, we create the shock units or trauma units, and they have developed over the years. One could argue that the PER has offered the ultimate environment to the real-time personal medicine. When we treat patients in the emergency room, and specifically in the bay of the trauma or burns or ketoacidosis, we personalize the treatment for every patient. So remember, in emergency medicine are significant heterogeneous, the patient. Sometimes they have one disease, sometimes they have problem for genetics, sometimes. So we need to personalize medicine for different patients that we receive. But also we have other problem, the problem with the sepsis. The treatment remains remarkably weak and highly conflicting. If you see, the diagnosis of sepsis require interpretation, no specific signs, and can therefore be subjective and variable. So this is why you need to pay attention, because the heterogeneity and intervention may be benefit for one group, but could be harmful for the other group when you have patients with the sepsis or more pathology. The future is that we need to focus on several important issues. First, we need to educate the clinician about the risk of the fluids loading patients who are not fluid respondent. The potential of the harm caused by the fluid bolus therapy should be more clearly featured in the guidelines. Other implementation is the physiology and a hemodynamic guide, conservative approach to fluid therapy in patients with sepsis, good possibility to reduce the morbidity and improve the outcome if you use correctly the fluids. The second is the effect of the fluids infusion in the immune system. On endothelial function, in the one integrity, the glycocalyx remain poorly understood. Degradation of the glycocalyx on the vascular luminal cell membrane has been identified to be early step for the sepsis, for the subvascular endothelial cell disorder. So if you see, when you start to use this in bolus, you can produce more damage than benefits for the patient, because start to destroy and more damage for the different part of the human body. So the second one is the fluid therapy has the potential to the further damage for the glycocalyx, especially when you have rapid infusion, as used when the fluid infusion results in hyperkalemia. So you have alternative fluids volume therapy for the treatment in shock that the early use and vasoactive drugs. So in that way you can prevent more damage for the kidney and also for them. And the third concept is the hypertonic resuscitation may provide effective and rapid intravascular bovine resuscitation for the patient in the emergency room. So in conclusion, there is no ideal solution that guarantees the correlation with electrolytes and normality, and it's important to individualize the liquor measure according with the physiology and the pathology of each patient that comes to the emergency room. So in London in 2013, they proposed 3 points. One is the goals, the fluid therapy for goals to every patient. The method of monitoring the patient in the emergency room and the different clinical contexts about this patient. So in conclusion, the fluid resuscitation has been one of the cornerstones in the treatment. An increased body of literature suggests that the fluid volume therapy may contribute to the fluid overload and cause harm. The effect of the fluid bolus on physiological parameters are not well studied and seen small and short life and the best. Personal fluid administration requires clinicians to integrate a normal physiology parameters into clinical decision making. So personal fluid resuscitation therefore requires careful attention for each patient with the mnemonic name that I told you before. Context, indication, target, time, amount, and everything, so and so. More of the progress that has been made in emergency medicine is the result of identifying and abandoning the potential harmful intervention in the treatment. So it's time, perhaps now, to add the indiscriminate use of the therapy for that list. Because sometimes when the patients come to the emergency room, it's like normally they order to, hey, they go glucosaline or they go glucose 5% and started this, and sometimes produce more hyponatremia or alteration in the electrolytes, and they produce more damage in the kidney or the perfusion in the cellular zone. So I think this is the new concept that they have now in the emergency room about the solution for the patient, pediatric patient in the ER. I don't know if you have a question. Question? Yes, sir.
Yeah. Thank you very much, Professor Carlos, for your nice presentation. My question is about that. Do we have an ideal mean arterial pressure or systolic blood pressure to maintain an adequate organ perfusion or tissue oxygenation for the children while infusing the resuscitation?
That I show you in the score depend what is the situation of the patient. You can see for the first one is for the rescue. So you can use the isotonic solution to prevent the alteration of the hyponatremia. This is how you use in the patient in the ER. The paper that I show you, they show that if you still use it, glucose 5%, you can produce more alteration in the electrolytes like the sodium hyponatremia than it's better if you use isotonic solution in the patient.
Excellent.
Excellent. I think we have one more question over there. Please go ahead.
Thank you for your presentation, Professor Garcia Rosas. In trauma surgery with major hemorrhage, contemporary best practice is damage control resuscitation with limited use of crystalloids and early use of blood components. That's for adults. What has been the experience of damage control resuscitation in children?
Well, first of all, if the patient they have really hemorrhagic shock severe, the best thing is use blood. If you have, but in trauma, sometimes you are not available the blood already, so you start with crystalloids to use them, and then when you have already the blood, you start to treat the patient with blood, because this is the recommendation that we have in the ER. The most important is recovery and control the damage for the patient in trauma. Trauma is a particular issue that is different like the other issues, right? Trauma, you need to be ready for number of the blood components and everything to try to control. And also, if they need a laparotomy to control the damage for the liver or for any injury inside, you need to control and start to use the blood.
My question was the difference between adults and children. What are the differences? Are there any?
For children, what age? Because the children is 28 to 18. If you're talking about teenagers, or what age, any age, at the beginning you start to use crystalloids. Then when you get the blood component, you use it. Because the point is, first of all, you need to control the bleeding. Depend what we're talking about, liver or whatever. But the second one is you start if you have the elements for the blood, you use blood or component of the blood, right? But if you don't have it at the beginning, you use crystalloids and for treat the hypovolemic shock. This is how we use it. I don't know if it's the answer or not.
Thank you. Thank you. I think that's a great answer to the question. There's very little difference. If you have blood, use it. And if you don't, try volume expansion with crystalloids until you do. Right. Are there any other questions? No? Okay. Thank you. I think with that, we'll move on to our next speaker.
Thank you.
Okay. Our next speaker is Dr. Bashak Yilmaz. She is emergency medicine physician and working at the State Hospital of Burdur, Turkey. And she's also the member of USM. Her topic is the indication of the CT in the emergency department. You are welcome.
So they gave me some room to move. Thank you for that, and sorry for my sore throat and a terrible voice. Bear with me. I'm an emergency physician, a fresh one, and all emergency physicians have their interest areas. And pediatric emergency medicine definitely is not one of mine. But it doesn't really matter if you're in emergency medicine, because well, all the emergency cases basically just show up at your door. You care for the pediatric patient or not, they will be there and you will need to take care of them. So you will need to know how to act. And the title I was given was to CT or not to CT. Well, to me, that's not the question. You know, when it comes to CTs, nothing's really all black or all white. The CTs work in grayscale. We have a lot of room in between. If you want to know all the criteria, all the guidelines, they're out in the world. You can go out, check them out. You don't even need to memorize them. There are a lot of applications right now. You can just check the criteria on my mobile phone when you see the patient. Do I need to CT them or not? But there are other sets of questions you need to ask before you try to make your mind. The first and the most basic one is, can we CT? Do we even have a CT machine? Are we in an established center blessed with a CT machine that we now take for granted during our training programs? We may be in a humanitarian aid area with a limited resource setting. We may be in a rural hospital. Our city might be out of order. That happens all the time. We might have a CT, but we may not have the skill set to evaluate the images we have. We might have the skill set to evaluate the images, but it may not be accepted as the official report by our governing bodies. So we may also need the report from the radiologist. Do we have access to a radiologist 24/7 in our centers? So do we need to refer our patients who we perform CTs on to an upper level center? So should we perform the CT? I work in a rural hospital, the only hospital in my small city, with a lot of connecting towns nearby. Two of my connecting towns have a CT, but they don't have the GP, they only have GPs on call, and they don't certainly have emergency physicians or radiologists that they can refer their CT images to during their shifts. So a lot of times, I receive patients that have pan CTs performed, but they don't have the images. I can't retrieve the images to evaluate myself. I need to perform everything all over again. The patient gets twice the dose. After the evaluation, I see something, or most of the times, I don't see anything. I discharge the patient, and the patient has no means to go back home. And this is important. If asking for a CT, if to CT means hundreds of kilometers, if it comes on the expense of hours of lack of an inter-hospital or per-hospital transfer team, depending on how they operate in your home city, it really affects your practice, your day-to-day practice. So should we CT? Will it really change our practice? This is something we should consider. Is it a minor trauma that I can simply observe in my own center and decide if I want to refer it to the upper center later on or not? Or is it something that my surgeon can handle? For example, is it an, I don't know, stomach pain, a possible appendicitis? And can I operate without the CT? Should I really refer the patient to an upper center for that? How many of you work in an environment as sterile as that? Or is it more like this or this? This is how we work in Turkey. So we work in overpressured, overworked, overcrowded environments. So we always feel overwhelmed and we try to protect ourselves. I work with a lot of freshly graduated GPs coming out, straight out of medical school and into my department, overanalyzing the patients, afraid of missing out on some important diagnosis. My whole emergency department staff loads them because this means extra workload for them. Also, my hospital administration doesn't like that because it also means extra money for them. And they constantly tell me to talk to my GPs to the number of CTs performed or the lab tests they ask for. But how can I do that? We live in a time of constant malpractice cases. We live in a time of constant medical legal fear. Most of my GPs, on top of my head, I can easily think of 3 of them who still deal with 3 medical legal cases right now in the first few months of their practices. And thanks to their overanalyzing, they will not be charged with any problems in the end. Whereas myself has been sued a few weeks ago by a patient who had a mild stomach pain, and I didn't perform a stomach CT on, and she accused me of apparently overlooking her diagnosis of appendicitis, but she haven't been operated in any hospital. And moreover, my hospital administration, when talking to me about the suit I have, asked me why the hell I wouldn't just perform the CT the patient asked me for. It would be much more easier for me, and apparently it would be much more easier for the hospital administration. So in the hassle, in this crowded place, I work 24-hour shifts. I don't know how you work, but in a 24-hour shift, you tend to forget things. You tend to forget asking for the simplest things. Do you ask the kids how many times they have been in a CT machine before? I had a patient 2 days ago, just on my last shift before I came here. She had been in a fight. She had a tender cervical spine. Her X-ray didn't give me anything. And according to the appropriateness criteria, I should have performed a CT scan. And I was trying to convince her to lie still in the CT machine. She said, no, I'm not afraid of that. I've been there before. I said, oh, what? Why? How? So her father explained me, oh yes, she fell on the road last week. A minor trauma with no need for a CT. But last week, with the trauma, apparently, she already had a head and neck CT scan already. And we all know a simple CT scan can easily increase dose-dependently the lifetime cancer incidence. It is known, radiation causes cancer. And the next question we should ask is it worth to CT? Adults, it's easy. You tell them to lie still and they do. But have you tried holding an infant or a toddler still in a CT machine? You don't want to sedate them because then it makes it harder to follow up with their neurological symptoms, etc. Then is it really worth the hassle? Or can I just observe them a little bit before performing the CT? Is it really worth all the effort? Oh, and then comes the important question. Can they ask for the CT? Because that happens a lot. Patients come in through our doors, ask for a CT scan. I want a CT for my son. I want a CT for my daughter. I want an MRI for myself. This happens all the time. Again, on my last shift, I had a woman yelling in front of my resuscitation door when I was dealing with another patient, saying that her son, age of 3, who had some food poisoning symptoms, but also happened to fell on the floor at home, was vomiting. And she thought that was worthy of a CT scan. And I couldn't convince her otherwise. And my emergency department at that time was like this. Do I have the time convince her otherwise, on expense of all the other patients there, on expense of my mental health. So I told her to just try to put the baby to sleep. And if she manages to keep the baby still enough to stay in that patient CT machine, I will perform the CT. And eventually, the CT scan was completely normal and they went back home. Very happy. But on what expense? Is it worth it? So, my last question is, not to CT or not to CT, but have to CT. With a justifiable clinical indication, does the patient really need the CT? Is it really important for my practice? And if yes, we should practice it with optimization in mind, with a radiation level as low as reasonably achievable. So to CT or not to CT is not the question, but the decision. Thank you for your time.
Okay. Okay, thank you, Dr. Başak. Is there any question or comment from the audience? No questions? Okay, there is no question. Thank you very much for your nice speak. Are you going to present? Me? Okay. Okay. Our next speaker Association Professor Dr. Afshin Emre, he's coming from Ankara, he's working in Ankara. He's going to talk about, his topic is about the choosing appropriate size of equipment in pediatric patients. You are welcome, Dr. Afshin.
Thank you very much. Dear season moderators and dear audience, good morning from a beautiful Antalya morning. Welcome to our country and welcome to this nice city. I hope you all liked our opening ceremony and this fantastic hotel. And I hope you will have a nice time in here. I greet you all respectfully. I would like to express my gratitude to the President of Congress and the Organization Committee for their invitation and great hospitality. Today, I would like to talk about choosing the appropriate size of equipment in pediatric patients. Successful assessment and treatment of injured children depends on immediately available equipment of the appropriate size. We can classify the equipments in three groups: airway and breathing, circulation, and supplemental equipments. A length-based resuscitation tape, such as the Breslow emergency tape, is an ideal adjunct for rapidly determining weight based on length for appropriate fluid volumes, drug doses, and equipment size. By measuring the child's height, clinicians can readily determine his or her estimated weight. One side of the tape provides drugs and their recommended doses for pediatric patients based on weight, and the other side identifies equipment needs for pediatric patients based on length. Clinicians and emergency physicians should be familiar with length-based resuscitation tapes and their uses. The A of the A, B, C, D, E of initial assessment is the same in the child as for adults. Establishing a patent airway to provide adequate tissue oxygenation is the first objective. The inability to establish and maintain a patent airway with the associated lack of oxygenation and ventilation is the most common cause of cardiac arrest in children. Therefore, the child's airway is the first priority. Several anatomical features of children affect airway assessment and management. The 10th Advanced Trauma Life Support Guideline divided the essential equipments to 6 groups according to age and body weight. Hereafter, I will try to explain the equipment size according to this classification. Premier means 3 kilogram child, 0 to 6 months, 3.5 kilogram child, 6 to 12 months, 7 kilogram child, 1 to 3 years, 10 and 12 kilogram, and 4 to 7 years, 16 and 18 kilogram child, and 8 to 10 years means 24 and 30 kilogram child. These 6 groups, we will classify the equipments. After the mouth and oropharynx are cleared of secretions and debris, we should administer supplemental oxygen. There is a small technical problem.
Kullandığınız için diğer ekranda kalıyor mouse. O yüzden sola doğru çekerseniz dur, sola doğru çekin. Tamam.
Okay. If the patient is unconscious, mechanical methods of maintaining the airway may be necessary. Before attempting to mechanically establish an airway, we should pre-oxygenate the child. So, we can use oxygen masks, newborn types for the first 2 groups, and the other 3 groups we can use pediatric size oxygen mask, and for the last group we can use adult size oxygen mask. An oral airway should be inserted only if a child is unconscious, because vomiting is likely to occur if the gag reflex is intact. The practice of inserting the airway backward and rotating it 180 degrees is not recommended for children, since trauma and hemorrhage into soft tissue structures of the oropharynx may occur. You can insert the oral airway gently and directly into oropharynx. Using a tongue blade to depress the tongue may be helpful. So, we can use infant and infant small types for the first 2 groups. We can use small one, the green one. For the other 2 groups, we can use medium size for 5th group, and for the last group, we can use medium or large size oral airway, the yellow and red color. In this slide, you can see 3 sizes of bag valve masks: infant size, pediatric size, and adult size. We can use infant size pediatric bag valve masks for the first 2 groups. We can use pediatric size for the other 3 groups, and for the last group, we can use either pediatric and adult size bag valve mask for oxygenate the patient. Laryngoscopy. Laryngoscopy is an important part of intubation process. choosing the appropriate size blade is also really important for pediatric patients. Why? Because the soft tissues of an infant's oropharynx, for example, the tongue and tonsils, are relatively large compared with the tissues in the oral cavity, which may compromise visualization of the larynx. So, a child's larynx is funnel-shaped, allowing secretions to accumulate in the retropharyngeal area. An infant's trachea is approximately 5 centimeters long and grows to 7 centimeters by about 18 months. Failure to appreciate this short length can result in intubation of the right main stem bronchus, inadequate ventilation, and also accidental tube dislodgement, and sometimes mechanical barotrauma. Orotracheal intubation, maybe we can also discuss the sizes of laryngoscope plates. We can use 0 straight for the first group, 1 straight for second, third, and fourth group, 2 straight or curved for the fifth group, and we can use 2 or 3 straight or curved for the last group. And orotracheal intubation is the most reliable means of establishing an airway and administering ventilation to a child. The smallest area of a young child's airway is at cricoid ring, which forms a natural seal around an uncuffed tube, a device that is commonly used in infants because of their anatomic features. However, the use of cuffed tubes, even in toddlers and small children, provides the benefit of improving ventilation and carbon dioxide management, resulting in improved cerebral blood flow. Previous concerns about cuffed endotracheal tube causing tracheal necrosis are no longer relevant due to improvements in the design of the cuffs. Ideally, cuff pressure should be measured as soon as is feasible, and below 30 millimeter mercury is considered safe. A simple technique to gauge the tube size needed for a specific patient is to approximate the diameter of the child's external nares or the tip of the child's smallest finger and use a tube with a similar diameter. We should ensure that also the ready availability of tubes that are one size larger and one size smaller than the predicted size. The optimal endotracheal tube depth can be calculated as 3 times the appropriate tube size. For example, a number 4 tube would be properly positioned at 12 centimeters from the gums. Yes, let's talk about stylets. Stylets is a device that can facilitate the intubation, and we use stylets in our routinely emergency departments. If we are using a stylet to facilitate intubation, we should ensure that the tip does not extend beyond the end of the tube. So, we can use 6 French stylets for the first 4 groups and 14 French stylets for the last 2 groups. What about suction? We can use a color reference chart to determine the appropriate catheter size for suction. Any of these catheters can be used to suck the oropharynx or gastric content or airway. So, we can use 8 French suction catheters for the first 3 groups. The 8 French catheters is blue color, and we can use 10 French, it's black color, for the fourth group, and we can use 14 French catheters for the fifth and sixth group. It's also dark green color. Circulation is really important for pediatric patients, as Dr. Rosa described, detailed. So, two equipments that we can use in circulation. Blood pressure cuffs and intravenous catheters are important equipments for the circulation of pediatric patients. Use of the largest intravenous catheter that can readily be inserted with reasonable certainty of success is preferred for pediatric patients. A child's increased physiologic reserve allows for maintenance of systolic blood pressure in the normal range, even in the presence of shock. Up to a 30% decrease in circulating blood volume may be required to manifest a decrease in the child's systolic blood pressure. This can mislead clinicians who are not familiar with the subtle physiologic changes manifested by children in hypovolemic shock. Tachycardia and poor skin perfusion often are the only case to early recognition of hypovolemia and the early initiation of appropriate fluid resuscitation. So we can use 4 types blood pressure cuffs. Premier newborn type, newborn infant type for second group, infant or child type for third group, and child type for fourth and fifth group. For the last group, we can use either child and adult size blood pressure cuffs. Changes must be treated by a rapid infusion of both isotonic crystalloid and blood by using an intravenous catheter. Intravenous access in young children with hypovolemia can be a challenging skill, even in the most experienced hands. A peripheral percutaneous route is preferable to establish venous access. If percutaneous access is unsuccessful after 2 attempts, we should consider intraosseous infusion via a bone marrow needle. 18 gauge in infants and 15 gauge in young children. So we can use these types of catheters for pediatric patients. The yellow one, the smallest one, we can give fluids by a flow rate 20 milliliters per minute. And with the green one, the largest for pediatric patients, we can give 90 milliliters per minute fluids by using green intravenous catheter. What are the supplemental equipments? Orogastric, nasogastric tubes, chest tubes, urinary catheters, and cervical collars. We can also use a color reference chart to determine the appropriate tube size. So, 8 French means blue one, 10 French means black one, 12 is white one, and 14 French is green one, orogastric or nasogastric tube. So we can use color reference charts to determine. What about chest tubes? Chest tubes need to be proportionally smaller and are placed into the thoracic cavity by tunneling the tube over the rib above the skin incision site and directing it superiorly and posteriorly along the inside of the chest wall. Tunneling is especially important in children because of their thinner chest wall. The site of chest tube insertion is the same in children as in adults. The 5th intercostal space just anterior to the mid-axillary line. Measurement of urine output and urine-specific gravity is a reliable method of determining the adequacy of volume resuscitation. Insertion of a urinary catheter facilitates accurate measurement of a child's urinary output for patients who receive substantial volume resuscitation. We can use 5-branch feeding for small child for premiers, and we can use 12-branch urinary catheter for 8 to 10 years children. And the last equipment, cervical collar. Fortunately, spinal cord injury in children is uncommon. Only 5% of spinal cord injuries occur in the pediatric age group. For children younger than 10 years of age, motor vehicle crashes most commonly produce these injuries. For children aged 10 to 14, motor vehicles and sporting activities account for an equal number of spinal injuries. So we can use small size pediatric catheters for third and fourth group, also for fifth group, and we can use medium size cervical collars for 8 to 10 years children. And thank you very much for your interest to our presentation and conference.
Thank you very much, Dr. Acil. Thank you very much for your nice presentation. Is there any question or comments from audience? There is. Please.
Dr. Mustafa from Nizip State Hospital. Thank you so much for your great presentation. To be honest with you, I'm not a clever person to memorize a lot of things, but I want to recommend some important application such as WEKEM, W-E-K-E-M. This is a great application in my opinion, and you can use it and you can choose whatever you want for management your critical care patient. I just want to talk about this one. Yeah.
Thank you for your contribution. Thank you.
Any question? Yes? I have a question to audience. Who resuscitated a newborn patient and started the initial fluid resuscitation? Nobody? Dr. Carlos? I said my question, who resuscitated a newborn patient and started the initial fluid resuscitation to a newborn from audience? Anyone? No. A second question, who is the patient less than 3 years old, pediatric? There is one. Only 2, 3, okay. As you see, this is a challenge for us. We are emergency medicine physician, but we are caring the adult patient. When we face such pediatric patient, you know how it is a challenge, and it is difficult for us to resuscitate, to control the airway or start the initial resuscitation for such patient. So we have to learn it. In Turkey, some emergency department, they are caring just traumatic pediatric patients, not normal patients. What about you, Carlos, in your country? Can you care all pediatric patients? Just
available pediatrician and trauma surgeon, but if you go for the general hospital, they don't have only general practitioner, so they call for the anesthesiology or for the other pediatrician. But in some places that they have emergency physician, the emergency physician start to do everything there. And also we have the subspecialization in pediatrician emergency medicine. So in that places, the emergency physician expertise in pediatrician, they take care for the patient about the trauma and no trauma.
Thank you. Is there anybody who intubated a newborn? Newborn? You intubated? Newborn. Nice. Okay. Do you have an extra question, or what about your experience, your practice?
Yeah, I mean, I think taking care of pediatric patients is certainly one of the most challenging things we do. In my hospital, we do see newborns. We often, sometimes end up having women that deliver in the emergency department, and then of course you have to resuscitate from, you know, day one, minute one of birth. And one of the challenges that we do have is that we have a separation of our pediatric emergency area from the adult emergency area, and not all of the sizes of things are stocked everywhere. And so, you know, definitely I think that these are challenges that we run into, but like emergency medicine doctors everywhere, we do what we can with what we have. I think that's our job. Yeah.
And I know the position in Turkey, but I'm wondering about our guest. Which country has emergency medicine pediatric training? Emergency medicine pediatric training. Especially this question for foreigner guest. Who has? You. Microphone, can you give it, please? We have time. We have time.
We started the emergency medicine in pediatric 20 years ago in Mexico, and we have pediatrician plus subspecialty in emergency medicine. And in the big hospital, they treat the patient exactly right there in the ER, but they are specialized in emergency medicine in pediatrician. If they want to board certify, now we have a chapter special for emergency physician, pediatrician for board certified.
You have. Okay. Dr. Garcia, do you have? No.
We have two different paths to emergency medicine in the United States for pediatrics. You can do a pediatric residency.
Fellowship or?
Yeah, you can do a pediatric residency and then do a fellowship in emergency medicine for pediatrics, and then you only practice pediatrics.
It is not mandatory to be a pediatrician.
No, you can also just do an emergency medicine residency and you are trained to take care of pediatric patients also. But if you are a pediatrician, you have to do a fellowship in emergency medicine for pediatrics.
Okay. Okay, any question or comment for this section? Okay. The next speaker, unfortunately, he's not here. He was set up and sent his apologies, Dr. Apostolos from Greek. He's not here now. So we are going to finish this section. Thank you very much for your participation. You are welcome.
Kongremizin ilk uydu sempozyumunda bir aradayız. Hepinize bize katıldığınızdan dolayı teşekkür ediyorum. Acil tıbbın en önemli başvuru semptomlarından biri alerjiler. Özellikle bahar aylarında da bunun daha çok karşımıza çıktığını biliyorsunuz. Yapılan araştırmalarda alerjik şikayetlerle başvuran hasta sayısının oldukça yüksek bir oranda olduğunu göstermişler. Siz de biliyorsunuz tabii ki deneyimlerinizden. Bu yüzden bu konuda bilgilerimizi tazelemeye ihtiyacımız var. Ayrıca hani yeni bir yol haritası çizmemiz gerekiyor mu? Yenilikler nedir? Bunları incelemek amaçlı çok değerli yönetim kurulu üyemiz Profesör Doktor Hakan Oğuztürk'ü bu konudaki bilgilerini bizimle paylaşmak üzere sahneye davet ediyorum.
Herkese merhaba. Uluslararası Acil Tıp Kongresi'nin bu ikinci günündeki birinci oturumun sonundaki uydu sempozyumda sizlere alerji ile ilgili temel bilgilerin dışında yeni yol haritası konusunda da bilgi vermeye çalışacağım. Şimdi alerji dediğimiz zaman iki ana konu üzerinde ben durmaya çalışacağım. Bunlardan bir tanesi saman nezlesi, diğeri ise ürtiker. Bu iki problem dünyanın her yerinde, her toplumda sıklıkla görülen önemli bir halk sağlığı sorunu oluşturuyor. Bunlardan ilki saman nezlesi.
klasik. İlk tanımlamayı 1920'li yıllarda yapmışlar. Kardinal bulguları burun tıkanıklığı, burunda akıntı ve hapşırık. Bu triyat bu problem için ilk başta 1900'lü yılların başlarında tanımlanmıştı. Fakat daha sonra başka bilgilerde bu problemi eklenmişti. Gözlerde kaşıntı gibi şikayetlerle kendini gösteren, klinikte alerjik rinit veya alerjik rinokonjüktivit olarak tanımladığımız tip 1 alerjik hastalıklarla ilgili klinik semptomları tanımlamak için kullanılan bir terimdir. Tüm ülkelerde görülüyor dedik. Gelişmişlikle veya gelişmemişlikle direkt bağlantısı yok. Tüm etnik gruplarda ve tüm yaştaki insanlarda bu problem görülebiliyor. Dünya üzerinde yaklaşık 800 milyon kişinin bu problemle birlikte olduğu söylenmekte. Slaytta da görüldüğü gibi dünyanın muhtelif coğrafyalarında %10 ile 30 arasında değişen bir rakamsal range var. Amerika Birleşik Devletleri'nde de kronik hastalıklar arasında 6. sırada olduğu ifade edilmiş. Yani görülme oranının oldukça yüksek olduğu bir sağlık problemini biz şu an görmekteyiz. Peki bu problemde olay ne? Bir enflamasyon olayı durumu söz konusu. Nazal mukozanın hücresel enflamasyonu ile karakterize immunoglobulin E'ye bağlı bir alerjik reaksiyon sonucunda ortaya çıkan bir hastalık. Bu da diğer tanımı. Yani farklı tanımlar var fakat bir enflamasyon ve ona bağlı immunoglobulin E'ye bağlı alerjik reaksiyon sonucunda ortaya çıkan bir problemden bahsediyoruz. 2 faz var. Erken faz ve geç faz. Fakat klinik bulgular özellikle geç faz sırasında ortaya çıkıyor. Ne oluyor? Mast hücresi yüzeyindeki immunoglobulin E reseptörlerine alerjen ve alerjene spesifik olan immunoglobulin E bağlanıyor ve bunun sonucunda histamin, prostaglandin ve lökotrienlerin salgılanması gerçekleşiyor. Klinik bulguların daha çok görüldüğü geç faz bölümünde ise yine eozinofil, nötrofil ve bazofillerin infiltrasyonu sonrasında çeşitli sitokinler, kemokinler, adezyon moleküllerinin salınım durumu söz konusu. Alerjik rinitin sınıflandırılmasında arkadaşlar en sık kullanılanlardan bir tanesi 2 alt grupta oluşturulmuş olanı. Bunlardan birincisi mevsimsel, diğeri de perirenal denilen yıl boyu problemle karşılaşma durumu ile karakterize alt grup. Şimdi tabii ki yani bu 2 grup oluşturulmuş ama keskin bir ayrım durumu söz konusu değil. Yılın herhangi bir zamanında veya mevsimsel olan durumda yine farklı sebeplere bağlı problemler alerjik rinit oluşturabiliyor. Mevsimsel ilkbahar ve yaz mevsimlerinde ortaya çıkıyor. Polen ve küf alerjenlerini örnek olarak gösterebiliyoruz. Devamlı yılın her ayında görülme durumu olan yıl boyu alt grubunda ise ev tozu akarları, akarcıkları, mite dediğimiz canlılar özellikle etiyolojide önemli bir oran oluşturmakta. Yine küfler, hamam böceği ve ev hayvanı alerjenleri de yine bu alt grubu oluşturmakta. İkinci bir sınıflandırma daha var arkadaşlar. Bu da intermittent semptomlara göre veya persistent semptomlara göre alt gruplara ayırma durumu. Alerjik rinitte eğer intermittent bir durum söz konusu ise 4 günden haftada 4 günden daha az bu problemle karşı karşıya kalma durumu veya 4 haftadan daha az bu sorunu yaşama durumu söz konusu. Tabii ki intermittentta durum biraz daha hafif seyretmekte ve bu problemle karşı karşıya kalmış olan kişilerde hafif uyku durumunda herhangi bir problem yok. Günlük aktiviteler, iş okul aktivitelerinde ve semptomlarda şiddetlenme durumu söz konusu değil. Buna karşın persistan semptomların olduğu durumda ise haftada 4 günden daha fazla veya 4 haftadan daha uzun olan bir durum söz konusu şikayetlere maruziyet açısından ve bunun dışında da orta ve ağır uyku, günlük aktiviteler, iş ve okul aktiviteleri ve şiddetli semptomların varlığı, aktivitelerin bozulması durumu veya rahat bir şekilde günlük aktivitelerini ifade etmede kısıtlılık durumu söz konusu olabilmekte persistan semptomlar. Bu anlattıklarımdan da görüldüğü üzere arkadaşlar bu problemler insanın günlük sosyal aktivitelerini yapmada ciddi anlamda soruna sebebiyet veriyor. Yaşam aktivitesini ciddi anlamda kısıtlıyor. Öyleyse bu problemin çözümü için öncelikle bu problemin tanısını netleştirmekte, diyagnozda bir kesinlik sağlamakta fayda var diye düşünüyoruz. Peki ne yapacağız? Alerjik tanısında en önemli adımlardan bir tanesi arkadaşlar aile öyküsü. Ve bunun dışında hastaya daha önce uygulanmış olan teşhis ve tedaviyi içeren ayrıntılı anamnez. Tıpta zaten her branşta net olarak konuşulan bir konu var. O da şu: iyi bir hekim, iyi bir öykü, iyi bir anamnez almışsa her problemin %50 tanısını rahatlıkla koyabilir diye bu efsaneleşmiş olan cümleyi tekrar hatırlatmakta da fayda görüyorum. Alerjik rinitte de öyle. Öyküyü aldığımız zaman arkadaşlar, ayrıntılı anemnezi aldığımız zaman tanısal anlamda büyük bir mesafeye kat etmiş olmaktayız. Hastanın yaşı, şikayetlerinin hangi ortamlarda ortaya çıktığı ve aile hekim hikayesi sorgulanmalı. Bir de arkadaşlar burun içindeki sekresyonun rengi ve miktarına dikkat edilmelidir. Genellikle berrak ve sulu akıntı alerjik reaksiyon, alerjik rinit lehine bir tanı koymanızı sağlamaktadır. En sık kullanılan testler cilt testleri ve serum spesifik immunoglobulin veya total immunoglobulin E. Şimdi normalde 150 ünite lik bir rakam normal değeri oluşturmakta. Fakat bu tanısal testlerde bu rakamın bazen tanı koymada sıkıntı oluşturduğunu söyleyebiliriz. Tabii ki ekstraordinary paraziter hastalıklarda bu oran artabilir alerjik reaksiyon dışında veya normalde bu problemle karşı karşıya kalmış olan kişilerde de her zaman %100 oranında bu değeri yüksek göremeyebiliriz. Preventif mekanizmayı ilk başta devreye sokmak gerekiyor tedaviye başlamadan önce. Dedik polenler önemli bir risk oluşturmakta. Bu anlamda açık havada uzun süre polen mevsiminde bu probleme sahip olan kişilerin dolaşmaması gerekiyor. Evlerin havalandırılması da yine akşam saatlerinde gerçekleştirilmeli. Ev tozu akarları. Mite dediğimiz bu mikro canlılar parazit dünyasının en önemli unsurlarından bir tanesi ve herkesin ekonomik durumundan bağımsız olarak evlerinde rahatlıkla yaşamlarını idame ettirebilecek olan canlılardandır bu mite'lar. Özellikle yatak odalarında, halıların kenarlarında, yastıkların kıvrımlarında çok rahat bir şekilde yaşamlarını idame ettirebilirler ve alerjik bünyede olan genotip yatkınlığı olan kişilerde de bu tür problemleri çok rahatlıkla gerçekleştirebilmektedirler. Bu anlamda evlerdeki nem oranını %50'nin altında tutmak, yerlerin halı ile kaplanmaması gibi basit tedbirlere başvurulabilir. Nevresim takımları da 60 santigrat derece ısıda yıkanmalı. Akarisit HEPA filtreleri ve akar geçirmeyen yatak kılıfları doktor mutlaka önerilmişse kullanılmalıdır. Bunlar basit temel mite'lardan korunma yöntemleri. Bunları uygulayarak bu kişilerin mevsimsel ataklardan korunması daha da başarılı bir orana yükseltilebiliyor. Küfler ve evcil hayvanlar, bunlar da yine sıkıntı oluşturan önemli unsurlardan. Bunlarda da yine evlerin sık havalandırılması, halı ile kaplanmaması, özellikle banyo ve küf oluşumuna uygun ortamların kontrol edilmesi de preventif mekanizmada önemli maddeler. Evcil hayvanların evde beslenmesi de yine risk oluşturmakta. Bilhassa yatak odasına alınmaması ve sık yıkanması gibi yine önleyici tedbirler yapılabilir. Bizi
ilgilendiren aşaması ise preventif mekanizmadan sonra farmakolojik tedavi arkadaşlar. Salondaki herkese sorsak antihistaminikleri kesinlikle ilk planda düşündüğünü ifade edecektir. Evet, antihistaminiklerin birinci kuşak ve ikinci kuşaklarını bildiğiniz üzere biz birçok rahatsızlıkta kullanıyoruz ama bu problemlerde birinci kuşak antihistaminiklerin genel olarak ilk basamak tedavisinde textbooklarda ve literatürde önerilmediğini rahatlıkla görmekteyiz. İkinci kuşak antihistaminikler ise daha az yan etkiye sahip olmalarından dolayı ve minimal veya sıfıra yakın sedasyona sahip olmalarından dolayı tercih edilebilmekte. Evet, bu tedavinin diğer elemanları ise nazal ve sistemik steroidler, dekonjestanlar, lökotrien antagonistleri, mast hücre stabilizatörleri ve immünoterapi gibi alt gruplarda görülmekte. Oral kortikosteroidler duruma göre düşünülebilir ama bu aşamada damardan steroid verilmesi gibi bir tedavi yaklaşımı önerilmemektedir. İkinci konu ürtiker. Buna da kısaca değineceğim arkadaşlar. Hipokrat zamanından beri bilinen deri ve mukozaları tutan ürtika denilen kaşıntılı papül ve plaklarla seyreden bir problem ürtiker. Bu lezyonların deriden kabarık, basmakla solan, etrafı kızarık, sınırları belirgin, kaşıntılı, döküntülü olduğunu söyleyebiliriz. Kısa sürüyor ve bu karakteristik özelliği ise bu döküntülerin bir günden fazla sürmemesi. Daha sonra kayboluyor veya kaybolmaya yüz tuttuğu anda vücudun başka yerlerinde de tekrar benzer lezyonlar ortaya çıkıyor. Karakteristik özelliği bu ürtikerin. Oldukça sık görülüyor. Hatta bazı textbooklarda diyor ki her insan yaşamı boyunca kesinlikle bu problemle karşı karşıya kalabilir. Ortalama da veriyorlar. 2 veya 4 defa her insan bu problemle muhatap olabiliyor deniliyor. Toplumdaki kişilerin de yine %20'si 30'unun da yaşam boyunca en az bir kez ürtiker geçirdiği şeklinde başka bir kaynak da var. Önemli bir dermatolojik problem. Akut ve kronik anlamda değerlendirdiğimiz bu problemin kronik olan grubunda ise yine %0,5 ile 1 arasında bir tüm yaşam boyunca görülme durumu söz konusu. Evet, bu benim çalıştığım hastaneden bir görüntü. Dedik, dünyanın her tarafında yine alerjik rinitte olduğu gibi ekonomik gelişmişlikle doğru orantılı olmayacak bir şekilde rastlanabiliyor. Şu coğrafyada daha fazla, şu coğrafyada daha az diye bir genelleme kesinlikle yapılamamıştır. Ve ırk ayrımı da ürtiker konusunda gündeme getirilmiyor. Akut ürtiker çocuk ve gençlerde sık görülmesine rağmen kronik ürtiker orta yaşlı kadınlarda daha sık görülüyor. Kronik ürtikerin akut ürtikere göre 3 kat daha fazla karşımıza çıktığını söyleyebiliriz. Cinsiyette ise 2'ye 1 oranında kadın hakimiyeti söz konusu. 3 önemli grup var. Akut ürtiker, akut spontan ürtiker ve kronik ürtiker. Kronik ürtikerin de 2 alt grubu var arkadaşlar. Kronik spontan ürtiker. Bunu da indiklenebilir alt gruplarından hepimizin bildiği gibi fiziksel bir maruziyete bağlı olarak ortaya çıkan subgrubu var. İşte solar ürtiker, basınç ürtikeri, semptomatik termografizm, soğukla indiklenen ürtiker, sıcakla indiklenen ürtiker, vibrasyonla indiklenen anjiödem gibi. Kolinerjik ürtiker ve kontak ürtiker de diğer kronik ürtikerin indiklenebilir alt grubunu oluşturuyor. Fakat yine başka bir gruplandırma yapacak olursak 6 haftadan kısa süren problemler arkadaşlar akut, uzun süren problemler ise kronik ürtiker olarak kabul görmekte. Akut ürtikerde sebep iyi bir anamnezde çoğunlukla bulunabiliyor ama kronik ürtikerde de az önce söylediğimiz gibi etiyolojik neden idiopatik bir mekanizmadan dolayı çok fazla belirlenemeyebiliyor. Akut ürtikerdeki en önemli etiyolojik nedenler ilaçlar, gıdalar ve enfeksiyonlardır. Birçok gıda hiç tahmin edilmeyecek bir anda insanlarda bu problemi oluşturabiliyor. İlaçları ise yine geniş bir spektruma sahip. Non-steroid anti-inflamatuarlardan antibiyotiklere kadar, basit analjeziklerden diğer gruplara kadar arkadaşlar bu problemi oluşturabilecek ilaçlardan bahsedebiliriz. Antibiyotikler de yine penisilinler, sülfanamitler başta olmak üzere bu problemi oluşturabilmekte. Enfeksiyonlarda da yine geniş bir spektrum söz konusu. Basit bir diş absesinden, üst solunum yolu absesinden, idrar yolu enfeksiyonuna kadar birçok enfeksiyon bu problemin ortaya çıkmasına neden olabiliyor. Az önce de ifade ettiğim gibi kronik spontan ürtikerde de sebep konusunda bir netlik oluşmadığından dolayı bizim anamnez konusunda tanısal anlamda dikkatli olmamız gerekmekte. Histaminin etkisiyle ortaya çıkıyor bu problem arkadaşlar. Histamin hepimizin de bildiği gibi damarlarda genişlemeye, damar duvarlarında geçirgenliğin artmasına ve bu geçirgenliğin artmasından sonra damar dışına bir çıkışa sebebiyet vermekte. Ve bunun sonucunda da cildimizde şişlikler oluşturmakta ve kızarıklıklar oluşmakta. Eğer sıvı cilt altına oluyorsa mukozal bir problem de birlikte olduğundan dolayı hepimizin bildiği anjiyoödem problemini ortaya çıkarmakta. Anjiyoödem cilt altı dokusunun göz çevresi, ağız ve genital bölgelerimizde daha gevşek olmasından dolayı bu bölgelerde diğer bölgelere göre daha fazla oranda görülebilmekte. Akut ürtikerde arkadaşlar tanısal anlamda çok fazla bir derinlemesine araştırmaya gerek bulunmamakta. Kronik ürtikerde ise sedimentasyon, tam kan sayımı, CRP, tam idrar tahlili istenebilir. Bunların hepsini bir arada isteyeceksiniz diye bir durum söz konusu değil. Detaylı analize göre seçiciliği açığa çıkarabilirsiniz. Onun dışında bizim ayrıcı tanı önemli arkadaşlar. Ayrıcı tanıda herediter anjiyoödem ve otoinflamatuar hastalıklarında atlanmaması gerekiyor. Ürtikerdeki en önemli problemlerden bir tanesi başta da ifade ettiğim gibi kaşıntı arkadaşlar. Otoinflamatuar hastalıklarda benzer lezyonlar olmasına rağmen kaşıntılı bir süreç ürtikere göre daha nadir görülebilmekte. Yani iş anamnezde bitiyor. Ürtikerin tedavisinde de yine preventif mekanizma ile birlikte arkadaşlar semptomların giderilmesi için acil tedavi durumunu biz aktive etmek durumundayız. İlaçların, gıdaların ve stres gibi ürtikeri alevlendirebilecek etmenlerin uzaklaştırılması ve sakınılması tüm hastalara zaten önerilmekte. Bu problemin, bu can sıkıcı problemin çözümünde arkadaşlar genel cümleleri yine hatırlamakta fayda görüyorum. Hastanın eğitimi ve iyi bir diyaloğun, stres ve fiziksel egzersizlerden kaçınma, sıcak ortamdan kaçınma, uyku düzeninin sağlanması ve yeterli bir süre içerisinde gerçekleşmesi, aşırı yorgunluktan sakınma, dar ve sıkı giysiler giymeme, alkol ve riskli olduğu biliniyorsa ACE inhibitörlerini, aspirin ve diğer NSAID'lerin kullanılmaması yönünde bir mekanizmanın geliştirilmesi gerekiyor. Akut ürtiker tedavisinde oral antihistaminiklerin 3 hafta kullanımı gibi bir durum söz konusu. Bu 3 hafta kullanım olayı şikayetlerin giderildi artık ben keseyim şeklindeki bir sürece girmesi maalesef arkadaşlar tedavi anlamında sıkıntılara yol açmakta. Eğer biz durumun daha şiddetli olduğunu gözlemlemiş isek tedaviye steroidleri de ekleyebiliyoruz. Daha şiddetli ve anjiyodemin mukozal tutulumun da olduğunu görmüş isek arkadaşlar, klasik yine o probleme ait tedavimizi aktive ediyoruz. Adrenalin, steroid, antihistaminik veya anafilaksi de varsa o açıdan da hastanın dikkatli bir şekilde değerlendirilmesi gerekiyor. Diğer grup olan kronik ürtikerde ise arkadaşlar, ikinci kuşak antihistaminikleri biz ilk planda aklımıza getiriyoruz. 2 hafta sonra semptomlar sebat ediyorsa, ikinci kuşak antihistaminiklerde bir doz artımını sağlıyoruz. 4 kata çıkarıyoruz. Daha sonraki aşamada yine 1-4 haftalık bir süreçte semptomlar sebat ediyorsa, daha farklı ilaçları aktive ediyoruz. Omalizumab, siklosporina ve lökotriene antagonistlerini ekleyebiliyoruz. Akut ataklar sırasında ise kısa süreli sistemik kortikosteroid de denenebilir diyoruz. Ama burada vurgulamak istediğim husus şu: ikinci kuşak antihistaminikler tedavinin başlangıç aşamasında bizim aklımıza getirmemiz gereken ilaç grupları. İşte bu gruptan bir tanesi de Bilastin arkadaşlar. Sedasyona yol açmayan yeni kuşak, ikinci kuşak bir reseptör antagonisti olan preparat. Bilastinin piperidin grubuna ait bir antihistaminik olduğunu söylüyoruz. Evet, bu da bu ajanın kimyasal yapısı. Bu ikinci kuşak antihistaminik bilastinin etkinliği ile ilgili birçok çalışma yapılmış. Literatürden araştırdığım kadarıyla bu çalışmalardan birkaçını sizinle paylaşmak istiyorum. Reseptöre afinitesi setirizinden 3 kat daha fazla, feksofenadinden 6 kat daha yüksek olan bir kimyasal ajan. Mix, hidrojen 1 antagonisti olarak davranmasına rağmen güçlü ve spesifik bir antihistaminik etki gösteriyor bu ajan. Bilastinin yine interleukin 4 ve tümör nekrozis faktör alfa gibi pro-inflamatuar sitokinlerin salınımını azaltan anti-inflamatuar bir özelliği olduğuna dair de yayınlar yapılmış durumda. Yine başka bir çalışmada, ratlarda yapılan başka bir çalışmada histaminle uyarılan endotel permeabilitesinde, mikrovasküler ekstravazasyonda ve bronş düz kaslarında gevşeme ile bronkospazmın azaltılmasında setirizine göre 11 kat daha etkili olduğu gösterilmiştir. Setirizine göre lezyonların gerilemesinde ilk 1,5 saatte daha hızlı etkinlik gösterdiği bildirilmiştir. Bu ilacı kullanırken daha fazla fayda sağlanabilmesi için kriterimiz aç olarak kullanılması. Yemeklerden 1 saat, 2 saat önce veya 1 saat önce veya yemeklerden 2 saat sonra kullanımı ve aç karna olduğumuz zaman yakın bir zaman aralığında da yine C vitaminli preparatların alınmaması ilaç etkinlik düzeyinin sağlanması açısından önem arz ediyor. Yaklaşık 1 saat sonra maksimum plazma konsantrasyonuna ulaşabiliyor bu ilaç. Etken madde. Oral biyoyararlılığı ortalama %60 ve önemli bir özelliği de yaklaşık olarak arkadaşlar %90'lık bir durumunun yüzdesinin metabolize olmadığı, karaciğer, sitokrom, P450 enzim sistemi üzerinden herhangi bir etki göstermediği, ketokonazol, eritromisin ya da diltiazinle birlikte alındığında bilastin dozunda değişikliğe gerekli olmadığına ait de literatürde bilgiler mevcut. %95'i vücuttan atılıyor, dışkı ve idrarla atılma durumu söz konusu. Bu cümleye dikkat çekiyorum. Ortalama yarı ömrü 14,5 saat. Yine yapılan bir faz 2 çalışmasında arkadaşlar 20 mg bilastinin alerjik rinitli hastalarda 10 mg setirizin veya 120 mg feksofenadine göre 1 saatte göz semptomlarını azaltmada daha etkin olduğu ve alımdan 26 saat sonra dahi bu etkinliğinin devam ettiğini bildirmişler. Bilastine santral sinir sistemi etkileri yönünden iyi bir güvenlik profili sahip olduğu söylenebiliyor. Cetirizinin aksine alkol ve lorazepamın santral sinir sistemi depresan etkilerini de artırmadığı ifade edilmekte. Şimdi tabii ki bir ilaç kullanıldığı zaman kardiyovasküler sistem ve santral sinir sistemi etkinliği konusunda da araştırmaların ve netliğin sağlanması gerekiyor. Bu anlamda bu etken madde ile ilgili terapötik dozlardan daha yüksek dozlarda kullanımında dahi herhangi bir EKG problemi oluşturma konusunda sıkıntı oluşturulmadığı ifade edilmiştir. Yine EKG'de kalp atış hızında veya sistolik ve diastolik kan basıncında da klinik olarak bir değişiklik saptanmadığı söylenilmekte. Bilastin sağlıklı kişilerde tüm dozlarda iyi tolere edilebilmekte. Tabii ki her ilacın bir yan etki durumu söz konusu ama bunlarda şiddetli veya hafif olma durumu bizim için önem arz etmekte. En sık görülen yan etkiler günde bir kez 10 mg alan, cetirizin alan hastalara göre daha az bildirilen baş ağrısı, uyku hali ve yorgunluktur. Yapılan başka bir çalışmada randomize çift kör plasebo kontrollü bir çalışmada 20 sağlıklı gönüllü art arda bir hafta boyunca tekrarlayan dozlarda 20-40 ve 80 mg dozlarda birinci jenerasyon antihistaminik hidroksitizin alıyor ve 40 miligrama kadar subjektif sedasyon raporu veriliyor bu ilacın bu sürede kullanımı ile ilgili. Ama Bilastinde ise bu problemin olmadığını, plaseboya göre dahi daha bir rahatlık olduğu ifade ediliyor. Yine benzer bir şekilde bilastinin 40 miligrama kadar tek veya tekrarlayan dozlarda alınması durumunda dahi bir sürüş bozukluğu, araba kullanma durumunda herhangi bir sürüş bozukluğu oluşmadığı ifade edilmiştir. Genel olarak yan etkilerde plasebo ile eşdeğer bir durum söz konusu. Cetirizine göre yorgunluk ve uyku hali daha az oluşmakta bu ajanda. Yine çim alerjisi olan alerjik rinitli hastalarda bilastinin feksofenadinden daha etkili ve en az cetirizin kadar etkili olduğu gösterilmiştir. Yine desloratadin ile karşılaştırılabilir bir çalışmada da daha anlamlı bir etkisi olduğu ifade edilmiştir. Birçok çalışma yapılmış arkadaşlar. Derlemelerden meta analizlere veya olgu sunumlarından makale araştırmalarına kadar bu yeni kuşak antihistaminikle ilgili olan çalışmalarda birçok detaylı veriye rahatlıkla ulaşabiliyorsunuz. Bunlardan birkaç örnek. İşte rinokonjüktivit ve ürtikerdeki tedavisiyle ilgili ana iki problem, endikasyonu ile ilgili ana iki problem bunlar. Alerjik rinokonjüktivit ve ürtiker. Sonuç olarak arkadaşlar, günde bir kez 20 mg bilastinin alerjik rinitin tüm nazal ve oküler semptomlarını ve alerjik hastalıklarda önemli bir sonuç olan, başta da ifade etmiştik, yaşam kalitesini ciddi manada negatif anlamda etkiliyor demiştik. Bu yaşam kalitesini artırdığını ifade edebiliriz. Bilastinin alerjik klinik tedavisinde kullanılan ilaçlar için mevcut ARIA kriterlerini de karşıladığı sonucuna meta-analizlerde rastlamaktayız. Ürtiker semptomlarında da bilastinin etkinliğinin günde bir kez 20 mg bilastin tedavisinin semptomların düzelmesinde ve kronik ürtikerde de yine yaşam kalitesinin artırılmasında önemli bir etkinliği olduğu sonucuna varılmıştır. Mevcut uluslararası rehberler bundan dolayı alerjik rinit ve ürtiker için ikinci nesil antihistaminiklerin kullanılmasını tavsiye etmekte arkadaşlar. Yaşam kalitesiyle ilgili veriyi az önce ifade etmiştim. Bu anlamda bu etken maddeye ait olan preparatı da sizlere hatırlatmak istiyorum. Bilaksen Deride kızarıklık ve şişlik ve kaşıntı gibi belirtileri içeren, halk arasında da kurdeşen dediğimiz ürtikerin ve nedeni belli olmayan kronik ürtikerin tedavisinde, buna ek olarak boğaz, burun ve gözlerde kaşıntı, hapşırma, gözlerde sulanma, burun tıkanıklığı veya burun akıntısı gibi belirtileri içeren mevsimlere bağlı alerjik nezlerin tedavisinde kullanılmaktadır. 20 miligramlık tabletleri olan bu preparatın etken maddesi az önce de ifade ettiğimiz bilastin. Histaminin yol açtığı, az önce de bahsettiğim bu problemlerin, alerjik belirtilerin tedavisinde etkili bir antihistaminik ilaç. 12 yaş ve üstü çocuklarda ve yetişkinlerde günlük önerilen dozu günde bir defa bir tablet arkadaşlar. Yaşlı hastalarda da ciddi bir sistemik problemi yok ise önerilen doz aynı düzeyde. Hatta böbrek yetmezliği olan hastalarda dahi ek bir doz ayarlama durumunun gerekli olmadığı ifade edilmekte. Sonuç olarak arkadaşlar, alerjik problemler hastanın yaşam kalitesini etkileyen ciddi sorunlar. Dünyanın her yerinde, her ırkta oldukça fazla bir yüzdeyle karşımıza çıkıyor demiştik. Bu anlamda arkadaşlar dünya üzerinde de 1 milyara yakın insanın bu problemlerle maruziyeti durumunu da ifade ettikten sonra çözümsel anlamda iyi bir hasta-doktor iletişiminin takip sürecinde olması gerektiğini, yeni ilaç tedavilerinin şu anki tedavi seçeneklerinin semptomatik yaklaşımda fayda gösterdiğini ifade ederek bizim yine hasta endeksli tedavi yaklaşımlarını en akılcı şekilde uygulamamız gerektiğini ifade edebiliyoruz. Ben dinlediğiniz için çok teşekkür ediyorum. Katkı veya sorusu olan var ise dinleyebiliriz.
Evet, çok teşekkürler Hakan Hocam. Bir soru katkı varsa alabiliriz arkadaşlar. Evet, ilk uydu sempozyumumuz bu. Bizim Hakan Hoca'nın da belirttiği gibi aslında alerji rutin kullandığımız genel acil semptomları içinde yer olan bir şey ve bu herhalde antialerjik ilaç verirken hepimize aklına şu soru geliyor: sedasyon yapar mı? İşi ne? Değil mi? Soruyoruz. İş durumu ne vesaire. Dolayısıyla bu konuda yeni bir nefes olduğunu görmüş olduk. Evet Hakan Bey buyurun.
Hocam adaşıma teşekkür ediyorum. Çok güzel bir sunum oldu öncelikle. Yeni görevinde de başarılar diliyorum. Allah yardımcısı olsun. Ben çok kısa bir katkıda bulunmak istiyorum kendisine ve salondaki arkadaşlara. Şimdi ben Gaziantep Üniversitesi bünyesinde Teknopark denilen bir yerde Farmagen Araştırma Merkezi var, İKU. Burada biyoeşdeğerlilik ve faz 3 çalışmaları yapılıyor. Genelde biyoeşdeğerlilik daha fazla. Ben de burada hastaların EKG'lerine bakıyorum, danışmanlıklarını yapıyorum. Genelde her çalışma için 50-60 arası hasta alınıyor. Genç erkek bireyler bunlar. Sağlıklı, tamamen sağlıklı. Taramalarını yapıyoruz ve hiçbir hastalığı yoksa onları çalışmaya dahil ediyoruz. Bazen işte bu antihistaminikler deyince aklıma o geldi. Antihistaminikler, antimantar ilaçlar, antiaritmiklerin %75'i, bunların hepsi QT, EKG'de QT'yi uzatıyor. O çalışmalarda bize diyorlar ki işte QT'nin normal değeri 440 ise siz bunu bir 10 düşürün, 430 ve üzerini almayın diyorlar. Çünkü vereceğimiz ilaç da QT seviyesini ve düzeyini uzattığı için sıkıntı olabilir diye ben 60'a yakın hastanın 2 tanesini, 3 tanesini eliyorum. Niye? Bunların QT'leri hep yüksek geliyor, uzun geliyor. İşte biz de bunları veriyoruz, körlemeye veriyoruz değil mi? Mesela EKG çekip antihistaminik veren var mı içimizde acaba? Veya antihistaminik vermeden önce EKG'sine bakan var mı? Sanmıyorum yani. O nedenle benim naçizane değerlendirmem şu yönde olacak. Özellikle bu QT, konjenital QT hastalıkları var. Onları hiç katmıyorum bile zaten hesaba. QT'yi uzatan ilaçları hastalara reçete ederken bir nebze bunları düşünmek gerekiyor. Belki de ailede hikayesi olanlarda erken ölümler sorgulanması gerekiyor. Çünkü artık öyle bir seviyeye geldi ki insanlar neresinden tutsa bizi şikayet etmeye çalışıyorlar. Yani bir ucunu tutuyorlar ve bizi şikayet ediyorlar ve muhteşem paralar kazanıyorlar. O nedenle bence bunlara dikkat etmek gerekiyor. Naçizane benim görüşüm bu yönde. Teşekkür ediyorum.
Teşekkürler. Başka soru katkı var mı? Yani salon büyük olduğu için göremiyorum ama herhalde gördüğüm kadarıyla yok. Bir 10-15 dakikalık aramız var. 11.30'da tekrar buradayız arkadaşlar. Daha doğrusu program devam ediyor. 10 dakika aramız.
Çalışırlar, yoktur boş zamanları, zamanla yarışırlar, acil.
I was crossing the street in front of my house, and my assistant chief called me on my mobile phone. And I thought, why is she calling? For once I'm late, and she's on my back. So I was a bit irritated, and I picked up the phone quickly, and I said, okay. I said, what is it? And she said, are you coming in today? And that even irritated me. I said, what do you mean? Of course I'm coming in today. I come in every day. And I thought, just because I'm late, she's on my back. And she said, there's been an explosion at the airport. And because I was a bit irritated, I really answered back to her, there was no explosion at the airport. It was either a plane crash or bombing. And if it were a plane crash, it would have been said there was a plane crash. I'll be right in. So I started walking a bit faster, and then I started running, actually, because I thought, oh my God, what's going on? I arrived in the department, we started scaling up, and I could see the fear in the eyes of my colleagues. And I thought, I must be the example of calm here. And at the same time, I thought, this is a new department. We're just getting used to moving patients from here to there, and now this happens. How many patients would there be? How severe would they be? How long will this last? Do we have enough staff? And were we really prepared? Sure, we did tests and all this, but were we really prepared? This is the real test. And I didn't have too much time to think of that either, because at about 9:15, on the television in one of the patient rooms in my department, smoke was coming out of 2 metro stations in Brussels. And that was the moment where I was terrified. I thought to myself, my world is being attacked. My city is being attacked. My home. But I knew at the same time, I really had to be the stay for my team. So I just put myself into a sort of organizational mode, focused only on practical aspects of what had to be done, and we began receiving patients. Well, I was quite proud of my team, actually, because they were working on very difficult situations. But I saw the fear, and I saw the stress. And, you know, one of the policemen, they were going from emergency department to emergency department. One of the policemen came in, who I know quite well, and said to me, hey, it's really calm in your department. And I could tell I was stressed, because normally I'm not very sharp with the police officers. And I said to him, I said, well, what do you think? I said, we don't have time to be running around screaming. Because he had said to me, in the other departments where he had visited, people were yelling, people were running around. And he said, in your department, it's so calm. Now, we received the largest number of patients from the metro station. So that does not mean that we had 2 patients in the hospital, in my department. And it was at that time where I thought, we're calm, however, we're accumulating stress. And this is just not going to go away. So I thought, what can I do? It's not with a cup of coffee, even though this one looks not so bad, that we could just sit down, grab a cup, talk a bit, and go home. it would have to take something a bit more, something organized, something structured. More or less what I imagine a board meeting to be, with the CEO and all the different operating chiefs. And I thought, I have to do it? I'm the chief. At the same time, I'm no CEO. I'd never had to address this sort of significant event before. And so the first thing that came to my mind was that horrible word that evokes a lot, debrief. And so I said, yeah, it has to be done. Because why do we debrief? To avoid errors and to maintain wellness amongst our team. So I thought, where to go from here? Well, I may surprise you with this next slide, because I used, if you want, and again, this is very important, I'm explaining to you my experience. I am not giving a recommendation. This is not evidence-based. It is a, if you want, a case study. And what I used as a basis, well, I can't, well, what I used is the critical incident stressing debriefing, okay? Why? Because it was structured. And I thought this will be helpful for me. I contacted the Department of Psychiatry, talked with the psychologists, and said, hey, look, I've never done this sort of debrief. This is what I'm thinking. What do you think? We discussed it, and we came about with a compromise. The CISD, of course, for those who read medical literature, especially on debriefing, they know that my neighbors in Amsterdam, they published a meta-analysis saying that CIDS or no CIDS makes no difference to the patients, or the victims, I should say, to the victims. So I took the chance anyways, because of course there are many, the SMD, there are plenty of debriefing methods used for rescue workers, used for victims, used for adverse effects. Let's be honest, when one debriefs for the team. When you have an adverse effect in your department, someone gives the wrong medication to a patient, you discuss it afterward. The patient has already received the medication. They are the victims. If the patient has complications, it's the family also that is the victim. However, there are secondary victims, and the secondary victims are the healthcare givers. So, what I decided was we're going to use this, but modified. Now, there were 7 steps. I did not use all 7 steps because I adapted it to this situation. Assessing the individual impact, that's sort of easy if you want. I know my team. I was there when the patients were coming in. I saw how people were reacting. I could imagine who needed a bit more care, a bit more attention, and who didn't. The second topic I really didn't use, identifying surrounding sources, that's sort of safety and security and all that sort of thing. It's not the context here. As I said, I adapted this CISD. The diffusing, I thought this was the most important aspect, because here people had to express themselves, and at the same time the discussion could go anywhere. People mad because the government did not protect the people of Brussels, realizing that we had been in lockdown since November, the whole idea about terrorism, and the innocent victims. We received terrible examples of children, pregnant women, and so it was very stressful for them, and I believe they really had to diffuse all that. Predicting future reactions, I left that for the psychiatrists. That's not my role. However, the day after the attacks, my entire team received a message saying, you can have anonymous, individual, psychological contact with a psychologist that does not work with our department. So there's no professional interference at all. And that would be anonymous, free of charge. The systematic review, that's easy. We do that normally with the debriefing, so that's nothing new. Bringing closure, a bit tricky because it's easier to start the conversation than to stop it. You have to decide when people have expressed what they individually need to express. It's not what you think, it's what they need. And that's sort of tricky because some people may be late starters in the discussion because it was a group meeting. But that's what had to be done. You had to really feel your team and say, okay, this is the time when we can close this discussion. And the re-entry aspect was simply, at the end of the meeting, I had pizza for my team. And we were able to discuss anything but the debrief. We could just talk. We didn't have to talk. We were just there as a team. Now, just a few points. I mentioned team a few times. I believe it's the key. I really do. And the secret is to be a team before something like this happens. Because during it, it's too late. And the pathway, I believe, to do it is to have in your departments a culture of forgiveness, as they say. And what does that mean? That means that you are able, when you do a debriefing session and when there's an error or adverse event that occurs, that you're able to honestly say, I didn't think about that, or I forgot that. We all forget things. We will all make errors. And it's much more helpful and supportive to be able to say to your colleagues, you know, I should have and I could have done better. This way, the communication is open amongst your colleagues, and they will be there for you, and they will be a source of support when you are before a situation where you are not sure which way to go. You can rely on them, and that is really what we do in emergency medicine. It's a teamwork. What I did, of course, here, I talk about the debrief in two parts. The technical aspects. Did we do the tetanus vaccine? All that was discussed, but with my chief, my assistant chief, and myself, and with the individual doctors and the nurses, we called them in individually. The group was just for that emotional impact. Well, this is a calendar of 2016, and I just wanted to remind you, but I can't really, well, the 10th of March was when we moved. 12 days later, the 22nd, were the attacks. It was done during what the Christians call Holy Week, meaning that the Sunday, the 27th, was Easter Sunday. The Friday and the Monday around that Sunday were bank holidays. And the two following weeks, the week that starts on the 28th and the week that starts the 4th of April, were school holidays. People had planned to travel, people had taken time off, and I wanted to respect that. It's maybe criticizable. One can say, well, you know, all the literature says it should be done 48, 72 hours. It was impossible. If you look on the 22nd, the 23rd, and the 24th, it was hellish in Brussels. It was impossible. I had meetings at the Ministry of Health. It was just impossible for me to organize it. And so I had no choice. When they came back on the 11th of April, I sent out the email on the 13th. We debriefed on the 20th, almost a month later. That's not really good. And actually what happened is my colleagues in Amsterdam, when they were doing their meta-analysis, some of the cases were done much too late, the debriefing, and that could possibly explain why this famous CISD was not any better than doing nothing, okay? Again, I did not use it. I modified it. I used it as a guideline. And I used it as a guideline with the psychologists and the psychiatrists in my hospital. I did not just do it alone. So, I'm almost out of time. I wanted to just give you some take-home messages. And the take-home message is, begin today with team building. It's really important. We are going to grow old in emergency medicine. We might as well have a bit of wellness while we're working, because we will spend almost as much time with our colleagues in the hospital than with our families and with our friends. Debriefing should be begun even with little events. Yeah, you know, maybe the EKG machine should be placed more centrally because the last time we had to do it, someone left it on the other side of the department and the nurse couldn't find it, and so the EKG was not done in the 5 minutes after the patient was signed into the emergency department. And so it's out of our protocol. That's not acceptable. It must be done in a constructive way. Seek advice if you don't know how to debrief. What you should do, there are courses, there are ways to learn how to do it. And I think the last thing is really the reason why we do it is to maintain quality and maintain wellness. We do it for ourselves. It's terribly important. Yes, of course, we do it for the future patient that we don't know when they will come, but we do it for ourselves. Thank you.
Thank you very much, Dr. Leach.
Excuse me, I just forgot one thing. Oh, it's too late. Okay, thank you for attention. I won't dare try to pronounce this. And I just wanted to have a quick reminder. There is going to be an emergency and disaster congress again in Turkey, in Istanbul, in June. It's done with IPAT, IMAT, and USAM. And a lot of the Balkan states. And I hope to see you in Prague. Now I'm finished.
Okay, well, thank you very much. We do have a minute or two for questions. Do we have any questions for Dr. Leach about this important topic? Okay, well, I don't see anybody raising their hand right now. I'll encourage you, if you had any questions, the speakers may be available after the session is over too for your individual questions. So now it's my pleasure to introduce our second speaker, Dr. Abdo Khoury. Dr. Khoury is a member of the Department of Emergency Medicine and Critical Care at the University of Franche. He's a vice president of the International Pan-Arab Critical Care Medicine Society. He's a member of the research committee at the French Society for Emergency Medicine and also the industry liaison officer at the European Society for Emergency Medicine, and is very active politically in the European Society of Emergency Medicine and in a lot of places in the MENA region. Dr. Khoury's talk this morning is entitled Difficulties in the Field Hospital. So it's my pleasure to introduce Dr. Khoury.
Thank you, Mr. Chairman, for this extensive presentation. Thanks a lot. I'm really happy to be here. I'm really privileged to be here. I want to thank the Professor Bashar Khan Chander for this invitation. I've been here for the past, I think, 5, 6, 7 years, I don't know. I feel like I've been here eternally. And I'll try to speak in this disaster session about difficulties in the field hospital. So for those who don't know me, I'm coming from Besançon, from the eastern part of France, very nice city. I invite you all to my city. This is our trauma center, level 1, 2 helicopters, EMS dispatch center. We do lots of retrieval. For this talk, I don't have any conflict of interest in any kind of disaster, neither with Mr. Kalashnikov, but lots of acknowledgement for people I work with from different countries, from Turkey, from Belgium, from France, and everywhere. And especially with Maud Michalou from the Summit of Paris, because we work extensively in training in disaster medicine, in training also in dispatch and disaster on the field. As you all know, disaster was defined by the United Nations by a serious disruption of the functioning of the community or a society. And then the impact of this will exceed the ability of the affected community to cope with this disaster and to cope with this own resources. You know the cycle of disasters, and when the sudden onset of disaster occur, it happens with little warning, and it means that you don't have enough time to get prepared. So it's going to arrive at one night, in one morning, and if you're not prepared for that, you're going to be really, really late on the response. This is how usually it happens before and after. This is a picture from the tsunami, and I think you all remember these pictures. It was before and it was after, with nothing remaining. But it's the same when you have an earthquake, when you have a typhoon, when you have war in Syria or others, when you have flooding. This is what happens. You don't even have hospitals. And the massive number of casualties and the ability of your healthcare system to cope with this will be completely reduced or completely maybe unrealistic and unreal. So it's completely compromised. And this is why when we operate in these kind of situations, we operate derived from the military. We learned a lot from the military, and we started to use field hospitals from the military and from the military doctrine and to cope with these situations. And this is how it looks like a military field hospital. It's NATO standards. This is a French one, but these are NATO standards. But these NATO standards and these army standards are not really applicable for civilian disasters. And some years ago, in 2003, in San Salvador, there were a big gathering for United Nations, for WHO, and they started to define and try to define the field hospitals and what are the requirements for the field hospitals and what are these field hospitals and how can we implement them and how can we deploy them in disaster countries. So there are lots of roles of these field hospitals, but at least they should provide early emergency medical treatment and also provide follow-up, and sometimes act as temporary facilities or substitute completely damaged healthcare system. So it's quite a huge configuration. Although it was written in like 30 pages at that time, it's a huge configuration and a huge requirement. But the problem is that one day came Haiti. And I think that all of you remember Haiti and remember the extensive damage that Haiti have had, and still these consequences are up to today, 10 years later, we still are coping with these consequences of Haiti, in terms of destruction, in terms of lots of UN and lots of international help and aid. Everyone wanted to go to Haiti, everyone wanted to be on the picture, everyone wanted to be represented, and from everywhere we came to Haiti. 44 foreign field hospitals, more than 18 countries represented. And you see some from Turkey, from France, from Israel, from everywhere. And everyone wanted to be there. And in my opinion, in the opinion of lots of others, it was a complete mess. We really messed up in Haiti. And I think this is why some years later, in 2013, we've gathered at United Nations, and they once again have tried to work on these procedures and work on the deployment of emergency medical teams and foreign medical teams and emergency field hospitals to just try to regulate all this and not have the same picture that we have in Haiti. And Dr. Gianni, who is our next speaker, was extensively involved in this writing of these protocols. So this is how it looks like. It's derived once again from the military, but once again it's applicable much more for civilian. And you see that you have 3 roles or 3 different organizations or 3 different involvement. The first one, to be able to give triage, outpatient care, emergency medical care. Then if you are more important, you can also bring inpatient surgical care. And if you are much more important, you can bring also inpatient care and much longer term patient care and field hospital. And also they specified for some more roles, some specialized team in burns, in pediatrics, in the dialysis, for crash syndromes, and all this. So you see, once again, derived from the military field, but we just applied them for civilians, and we just configured this for civilians. So we trained, and we in France have also our response team, rapid response team, and to go and be deployed within hours outside France also. And we train a lot. We train in establishing our tents. We train in doing our field hospital. We train, and you see the very nice field hospital upstairs. We train to put all this into configuration and a minimal amount of time. But unfortunately, it's not always what we expect when you arrive on the scene. We have lots of difficulties, and I won't talk about all difficulties that we can encounter. I'm going to talk about some which are important in my point of view. First of all, the configuration of the field. When we arrive somewhere, it's not that nice that we saw when we are training. Sometimes it looks like this. And this is field hospital from the Red Cross in Bangladesh. So you see, all are dispatched in the forest. All X-ray is far from triage, triage far from OR. So it's not the way we trained for that. So it's something challenging for us, and you have to cope with this, and you have to adapt to this. Second difficulty, the security. And I think the security is much more important than other things. You are in conflict zones, you are in war, you have floodings, you have lots of things, and you have also riots, and people want all of them come and gather and have the medical equipment and medical health care and the medical aid. So they are all can be of threat for you, and so you have to discuss your own security and something important. But also evacuation. When you evacuate your wounded or your people. How can you evacuate when the weather is bad? When you don't have place to land your helicopters? When you have lots of crowd that you cannot come and deliver proper aid? So these are things are challenging, and the evacuation should be considered and took in place. Otherwise, it can be very, very tough for you to do your mission completely. And when you evacuate, where do you want to evacuate? Is it close? Is it long? This is an example of the French military aircraft. It's ICU aircraft that you can transport around 30 wounded with ICU and with other ICU and non-ICU patients. But you can work a lot on them. You can do ultrasound, you can do a lot of things. It's really ICU airplane. But once again, when you evacuate, you have to know where to evacuate and what is the range of your plane, what is the range of your helicopters to know what the evacuation will be. And then one more difficulty about the length of your mission. You have to think of rotating your teams when you get deployed somewhere. You're not deployed for 2 days or for 4 days. You have to know for how many times you're going to be deployed. And if it's a longer mission, you have to think about rotating your teams because they'll be exhausted, they won't be operational, and they have to work on that. And the team you're going to deploy the first hours or the first days or the first weeks won't be necessarily the same that you're going to deploy 1 month later or 2 months later. Not the same. So once again, you have to cope with this beforehand, and you have to think of this beforehand. You have to think about your supplies. How do you have supplies to your field hospital? Okay, you have lots of things for the first week, second week, but when the mission will extend for 1, 2, 3, 4 months, how do you have the supplies? With some uncertainty, some security issues, some weather issues maybe. So you have to work on that beforehand. And as I told you have to adapt your mission, because at the first days, you are doing the emergency care, but afterwards you are doing the rehabilitation and you are doing regular health issues. And then you can cope with normal diseases, chronic diseases, and shortage of medications, shortage of supplies, and all that stuff that you have to supply for the population. It's something quite tricky, and you have to work on that. And especially you have to have in your teams different profiles. Not only emergency physicians and surgeons and critical care physicians or anesthesiologists. You should have also internal medicine, pediatricians. This is because it's going to start longer, it's going to stay longer. So we train, and we were deployed all over the world almost, different configurations with field hospitals, without field hospitals. And we're working on differentiating the crisis typology. As you know, you have short crisis and long crisis, and you have to adapt on this. Every one of this is not the same.
Objective global assessment. This is a structured approach to taking a history that includes weight change, changes in food intake, gastrointestinal symptoms, and functional impairment. And is combined with a physical examination looking for evidence of the loss of subcutaneous fat, especially at the chest and triceps, muscle wasting, especially at temporal region, deltoids and gluteals, and also an examination for edema and acids. To actually measure energy use requires sophisticated equipment, so requirements are more often estimated using formula. One such formula, maybe the most famous one, is the Harris-Benedict equation, which estimates basal metabolic rate in kilocalorie per day. The equation will usually give a result of around 25 kilocalorie per day, 25 kilogram per day, and the equation estimates basal metabolic rate in afebrile healthy individuals and will therefore need to be modified according to the situation to calculate resting energy expenditure. And when prescribing enteral or parenteral nutrition, the appropriate body weight from which to calculate caloric and protein intake, which is called the dosing weight, must first be determined. Guidelines indicate that protein requirements increase as illness becomes more severe. Practice is to give patients with only mild to moderate illness 0.8 to 1.2 gram/kilogram protein per day. And critically ill patients are generally prescribed 1.2 to 1.5 gram/kilogram per day. And patients with severe burns, that's the most dramatic one, may benefit from as much as 2 gram/kilogram per day. And also the other essential nutrients, lipids provide 9.3 kilocalories per gram, and calories from lipids should be limited to 40% of total calories. And usually, standard enteral nutrition delivers approximately 50% of calories as carbohydrate and 30% of them from fats. And it is also reasonable to provide vitamins and trace elements to critically ill patients, regardless of the type of the nutritional route. The optimal mixture of vitamins and trace elements is yet to be determined, so daily recommended allowances should not be routinely exceeded in the absence of well-designed and valid randomized trials. So I have talked about a lot of formulas, a lot of numbers. Maybe it's better to make it simple with a case. A case example of 33-year-old male admitted post-laparotomy for a ruptured appendix and sepsis with a body temperature of 39 degrees. How should we calculate the energy requirements of this patient? Let's go with Harris-Benedict formula. First, we should estimate basal metabolic rate, then modify this value according to his clinical situation to calculate resting energy expenditure. The modification for temperature and sepsis are additive, and the caloric requirement works out to approximately 2,500 kilocalories per day. As you see, the basal metabolic rate we find with Harris-Benedict formula is nearly 1,800 kilocalories per day, and we have to add 20% for temperature, 9% for sepsis, and 6% for surgery. Now, how should we give this energy? We provide 40% of this requirement with lipids, and we will provide 1.5 gram/kilogram per day protein, and in the end, the remaining energy comes from carbohydrates, and it seems that 106 grams of lipids, 112 grams of protein, and 234 grams of carbohydrate per day for this patient's requirements. But how should we give this energy? We should bolus it from the beginning, or we should start slowly? We should start slowly. An acceptable initial nutritional goal is 8 to 10 kilocalories of calories per kilogram per day, and then 18 to 25 kilocalories and 1.5 grams of protein per kilogram per day after 5 to 7 days. How should we administer it? Nutritional support can be given through oral, enteral, or parenteral routes. And if at all possible, oral or enteral are the preferred routes for nutritional support. They are far cheaper, more physiological, reduce the risk of peptic ulceration, minimize mucosal atrophy, since food in the gut lumen is a potent stimulus for mucosal cell growth and may reduce translocation of bacteria from the intestinal lumen. And the nasogastric tubes is the most common method in ICUs, but it also has some disadvantages, like it can cause malposition, difficulty swallowing or coughing, discomfort, sinusitis, and nasal tissue erosion, but it is still the most common method for nutritional support. Also, oral tubes, enterostomy, and post-pyloric feeding are the other enteral nutritional methods. Parenteral nutrition is most often given via a central vein, as the solutions are usually hypertonic. Preparations for peripheral use are available, however, they have to be isotonic, which means that very large volumes would have to be given to provide adequate nutritional support, and this severely limits their usefulness. And for a successful enteral nutrition, there is much discussion about that, but there are some simple guidelines, some simple points. For example, the first one is, let's confirm the tube position. Because otherwise, the most common complication of enteral nutrition we will face aspiration. So it should be better to confirm the tube's position both clinically and radiographically if it is possible. And also there should always be a high index of suspicion that the tube may have become dislodged, which is an easy thing, and the patient should be set up to an angle of at least 30 degrees to minimize the risk of reflux and subsequent aspiration of gastric contents. This can still occur around a cuffed tracheal tube. And maybe the most important part of my presentation is early feeding. Early feeding has been shown to reduce septic complications, length of hospital stay, and readmission rates in patients after both upper and lower gastrointestinal surgery. And that's true for also the medical patients. Enteral feeding does not appear to increase and may in fact decrease the incidence of anastomotic breakdown. And large volumes of feed in the stomach will increase the risk of aspiration of gastric contents. So bolus feeding should be avoided if possible. Also, if the patient is not tolerating enteral feed, then prokinetic agents, such as IV metoclopramide, should be given. Guidelines discourage early enteral nutrition in critically ill patients who are both hemodynamically unstable and have not had their intravascular volume fully resuscitated, since such patients may be predisposed to bowel ischemia. Hemodynamic instability by itself, unless severe, is not a contraindication for enteral nutrition if there is evidence for adequate volume resuscitation and tissue perfusion. Other contraindications to enteral nutrition include bowel obstruction, severe and protracted ileus, major upper gastrointestinal bleeding, intractable vomiting or diarrhea, severe hemodynamic instability, gastrointestinal ischemia, and a high output fistula. But despite these complications, still the most important route, the preferred route, is enteral route. And the best time is in the first 24 or 48 hours. And for parenteral nutrition, it may be given via peripheral vein if it is significantly more dilute, so-called peripheral parenteral nutrition. Because of the lack of benefit from short-term parenteral nutrition, peripheral parenteral nutrition is rarely indicated. In general, for short-term administration of total parenteral nutrition, peripherally inserted central catheter is the preferred route. Alternatively, but not preferable, total parenteral nutrition may be administered through a subclavian, internal jugular, or femoral central venous catheter if total parenteral nutrition is only needed for very short periods, like a few days. Or if a peripherally inserted central catheter is not feasible or reasonable. For long-term administration of TPN, a tunneled central venous catheter is the preferred route. Guidelines use an arbitrary cutoff 30 days to distinguish short-term from long-term total parenteral nutrition use. So if you are going to provide a parenteral nutrition which lasts less than 30 days, then we should choose peripherally inserted central catheter. If it is more than 30 days, then the best choice is tunneled central venous catheter. We very rarely use peripheral veins, and if the peripherally inserted central catheter is not feasible or not reasonable, then we may use subclavian, internal jugular, or femoral central venous catheters, but that's not the best choice, especially for the femoral central venous catheter. We face a huge risk of infection. And contraindications to parenteral nutrition includes hyperosmolality, severe hyperglycemia, severe electrolyte abnormalities, volume overload, inadequate IV access, and inadequate attempts to feed enterally. Relative contraindications to parenteral nutrition are not well defined. However, parenteral nutrition is often avoided in sepsis, systemic inflammatory response syndrome, gastrointestinal bleeding, short-term mechanical ventilation, and conditions expected to reverse quickly that temporarily preclude enteral feeding. And usually we do not suggest to start parenteral nutrition for the first 5 to 7 days, unless the patient is severely malnourished and it is impossible to use the enteral nutrition. When it comes to complications, maybe the most problematic complication is refeeding syndrome. Patients who are severely malnourished or have undergone a significant period of starvation are at risk of refeeding syndrome during the first few days of nutritional support, regardless of the route. The clinical features include weakness, respiratory failure, cardiac failure, arrhythmias, seizure, and death. Starvation causes a loss of intracellular electrolytes secondary to leakage and reduced transmembrane pumping, and intracellular stores can become severely depleted even though serum levels may be normal. When carbohydrate is available again, there is an insulin-dependent influx of electrolytes into the cells, which can result in rapid and severe drops in serum levels of phosphate, magnesium, potassium, and calcium. And it usually starts with hypophosphatemia. So, based on this pathophysiology, it's better maybe to start slowly. But how? To the feeding. At-risk patients should be identified and feeding must be introduced slowly, starting with only 25 to 50% of energy requirements and gradually increasing after 4 days. Electrolytes should be generously supplemented at the same time as starting feeding and should be closely monitored. Thiamine and other vitamin Bs should also be given IV before starting feeding and then daily for at least 3 days. As I mentioned before, it's better to start with 8 to 10 kilocalories. Then we also protect our patients from the refeeding syndrome. As you see, it is approximately 40 or 30% of the total energy when we start with 10 kilocalories per day for the first 5 or 7 days. And another complication, overfeeding, can cause uremia, hyperglycemia, hyperlipidemia, fatty liver, hypercapnia, especially with excess carbohydrates, and fluid overload. And to avoid from that, it's better to closely monitor the patients. Another important complication, hyperglycemia, is shown that critically ill medical and surgical patients who are hyperglycemic have a higher mortality rate than patients who are normoglycemic. And hyperglycemia can be related to overfeeding, but it is often not. It is not a rare thing that critically ill patients become insulin resistant as part of the stress response. And it is an acceptable approach to have a blood glucose target of 140 to 180 milligram per deciliter in most critically ill adult patients. And there are some other suggestions like targeting 8 to 110 milligram per deciliter, but it is shown that when we target this, we have hypoglycemic attacks, and it is proven that are related to higher mortality rates. And when we choose a more liberate target like 180 to 200, it is also shown with poor prognosis. So it's a simple and a good approach to aiming the 140 to 180 milligram per deciliter. And the most common risk with enteral feeding is aspiration of feeding causing pneumonia. The implementation of a combination of measures as well as a nurse education program and good oral hygiene has been shown to decrease the risk of ventilator-associated pneumonia. Diarrhea can also be a problem, but is not an indication to stop feeds. Other causes of diarrhea need to be excluded, but if enteral feeds are the cause, then a feed with more fiber can be tried. The more common adverse metabolic consequences of enteral nutrition include hyperglycemia, micronutrient deficiencies, and refeeding syndrome. which we mentioned earlier. And the most common mechanical complication of enteral nutrition is constipation. Development of a fiber bezoar is a rare complication that can occur among patients receiving enteral feedings with fiber. And fiber bezoars may be more prevalent when peristalsis is impaired, such as in patients on pressors. So fiber should be used in such patients with caution. Either constipation or a fiber bezoar can cause impaction, bowel distension, perforation, and death if not treated early, although these sequels are very rare. And insertion of a nasogastric or nasoenteric tube can also cause mechanical complications such as insertion into the lung. And the specific complications of parenteral nutrition, the insertion and presence of a central venous catheter has inherent risks, including pneumothorax, hemothorax, arterial or nerve damage, infection, central vein thrombosis, and erosion through the wall of the vein or right atrium. And it's thought that some of the increased risk of sepsis seen in patients receiving parenteral nutrition has actually been the result of overfeeding and uncontrolled hyperglycemia rather than due to parenteral nutrition itself. And nevertheless, infection is a serious risk, and the bags must be sterile and discarded within 24 hours of starting. And sterile precautions must be used when changing bags, and the lumen of the central venous line must not be used to take blood or give drugs or fluids. We should only use the parenteral nutrition rod for giving the nutritional support. And parenteral nutrition also predisposes to hepatobiliary disease, including fatty liver, cholestasis, and acalculous cholestasis, electrolyte imbalances, and micronutrient deficiencies. Thank you for listening.
Thank you, Professor Yit. Are there any questions? All right, thanks for an excellent talk. Oh, we have a question.
Firstly, thank you very much for your excellent presentation. There is our intensive care unit in university. Sometimes we ask some questions to our. When we must start nutritional support in the patients, for example, when admission to the sepsis patients, when we must start nutritional support to the patients in intensive care unit, for example, sepsis patients. When admission to the intensive care unit, or maybe the other time failure of the feeding parameters or failure of the laboratory test, what time?
Actually, that's an excellent question, which has a long answer. It may be the best answer, or maybe it's better to start with. It depends on the patient, but there are some very important points about the answer of this question. First, we have to start as early as possible. There's no doubt about that. So it's better to start in the first 24 or 48 hours. And for the sepsis patients, it's also the same. There are some contraindications, as I mentioned in my presentation, like severe hemodynamic problems. Other than that, or bowel ischemia, ileus, or such that things. But even in these positions, we have to insist to use the enteral feeding. So my answer would be in 95% of the patients, or let's say a huge percent of the patients, it's better to start in 24 or 48 hours with enteral nutrition. For parenteral nutrition, even the patient is in not a good condition, we should wait for 5 or 7 days. If it is going to be a problem about enteral nutrition and we will start enteral nutrition in 3 or 4 days, we can start in 3 or 4 days. Let's say the patient has a subileus, but it seems that in 3 or 4 days we will handle that problem and we will start. Then we should wait for enteral nutrition. In that position, we do not start parenteral nutrition.
Thank you very much.
It's my pleasure. Thank you.
Dear participant, now the second speaker, in my opinion, he is pioneers of emergency medicine and international advocate of EM and past president of USM. I invite Abdullah Bello. Your topic, patient safety reporting system in the emergency. Stage is yours.
Thank you very much, Chairman, and I'm happy to be here. First, I would like to thank again Bashar Kandar and Beset all and all the team, because it's a teamwork for this fantastic Congress. The first slide, can you? The only thing is important in the slide is my email. Please take my email. We are a project for the next Congresses to implement a global international course in quality and safety. And I do believe that this topic is one of the most important in medicine, and particularly in emergency medicine. I'm a basic researcher. I'm doing research in rat and mouse. This is my patient. And my second patient is quality and safety. I have two dreams. The first one is I don't want to be rich. I want to be happy. My second dream is I want to give to patients I'm managing in the emergency department the best care I can give to them. I want to share with you some concept and philosophy, and I will bring some data about reporting system in emergency medicine. I have no conflict of interest, and yesterday I showed you this slide. Please do something, and if you do good and this something work, do it more. If it doesn't work, stop it. Now the message is do something. I want also to share a story from Amerindian people, and this is a very nice story. One day, a big fire started in the forest, big fire, and all the animals were completely in panic. And this lion, or the big animals, they were watching this very small bird, the colibri. And the colibri was going forward, bringing water, small water, and put the water in the fire. The lion say, "Why are you doing that, small bird? Do you think that you are going to stop the fire in the forest?" And the small bird said, "Okay, I'm small, but I'm doing my job. I'm doing my part of the work." This is the message for quality and safety. We have all to do our job, our part of the work, and we have to be excellent in what we are doing. The concept of quality started many centuries ago, and I'd like to show you this slide, and particularly this Aristoteles is a very important Greek philosopher. He said that quality is not an act, quality is a habit. Yes, it must be a habit. Every day you have to be the best. And the next day, when you look yourself at the mirror, you have to say, I will be better than yesterday. I will manage the patient better than yesterday. And also Hippocrates, and Hippocrates said, the most important is not the disease. The most important is the patient. Keep in your mind. And I think we forgot this concept of patient in the center of the healthcare, and let's say now in the healthcare system. Yesterday I showed this slide. Our objective is to balance between the performance, the excellence, and the requirement. It's important to have requirements, to have standards, to have guidelines, and we are working on that for many years. For the next century, I think, the objective is to have global guidelines for everybody in the world. Quality and safety is a matter of support from government because it needs a lot of money, and you will see some figures, and it needs a lot of agency, institution, organization working together to get data which will be helpful to improve the quality of the care. You know very well, I showed you the slide yesterday, keep it in your mind. Healthcare system is killing more than aviation. Every year in America, for example, but I think we have the same figures all over the world, 120,000 patients die because of adverse events and medical errors. Put this in your mind. That means we have a lot to do to improve our quality of care. This is very expensive, very costly. You can see here that the cost in America, we have a lot of data from America, the cost for adverse events is up to 50 billion, which is huge. That means we always say that quality is expensive because we have to put a lot of money to organize better our healthcare system. But non-quality is more expensive than quality. Keep in your mind this slide, and you have to go to read this report. The journey of quality and safety started in 1999 with this report. This is a very important report from the Institute of Medicine in America. And this report has this title, "To Err is Human." To err is human. We have to stop to blame people. We have to understand why we do errors. Once we do that, we decrease the number of errors, and we decrease also, of course, the adverse event. Very important. To err is human. We have to implement a culture of safety, a just culture of safety. This is very important. I like this slide. I built this slide to show you that an accident occurs if there is no defenses. Okay? There are a lot of errors, we don't see them. We don't see them. We call them latent errors. And we have to find these latent errors. This is very important if we want to prevent the accident. And you can see here that the healthcare is a complex. It's a huge complexity. Why? Because we are dealing with human. It's not a car, it's not a plane. We are dealing with human. And you know that humans are complex. There's a relationship between medical errors and adverse events. We have this big family of medical errors. We have a lot of medical errors in the healthcare system. And we have, hopefully, small amount of adverse events. But we have to detect them. I will show you by reporting system. And among these adverse events, we have to abolish the preventable adverse event. This is very important. We can prevent adverse events in the healthcare. Human factors are very important, and today there is a lot of groups working on human factor to understand why we are making errors. Of course, we are not going to blame humans because most of the errors came because of systems error. And we have to work on the system, but also on human. We have to improve our skills, our way to manage patients in the emergency department. This is a very nice study, very old study, but very important, 1991, published in Harvard by the father of quality and safety, Lips. And you can see here that the death with the adverse event is almost 14% in this study. And the report on To Err is Human started with this study. And you can see we have a different level of disability. from a minimal impairment to a permanent impairment. That means it's important to prevent this kind of event when we manage patients. There is no difference between surgery and medicine. We have the same amount of errors, and you can see that, for example, in medicine, we have a lot of errors in diagnosis, a lot of errors in therapeutics, and we have a lot of errors related to drug. In surgery, there's a lot of error in late complication or non-technical complication. In America, they put a lot of energy, a lot of money and human resources to decrease this adverse event. And you can see here that the number of adverse events increase all over the year because they implemented the reporting system. If we declare the adverse event or errors, we increase the number, of course. The objective is to increase the numbers, then to try to decrease the number of adverse events. And the most important factor that is involved in adverse event is communication. We have to improve communication in our team. Medicine is a teamwork. It's a teamwork. Put in mind this key word. There's a lot of action, solution to improve that. And one of the most important, and focus on this topic, is to implement in the hospital, but I believe in the department, a system that will allow you to report adverse event. We need metrics. Without metrics, it will be difficult to improve the quality of care. And in America, you know, America, they do a lot of things, but you know that the healthcare system in America is the worst in the world, one of the worst in the world. We have the data, we have everything. It's worse because the social system is not good, but they put a lot of money in quality and safety, I can guarantee you. They want really to improve the quality of care, and they implemented reporting system, technical reporting system everywhere in states, and they want to get it for all states in America to get national American data on medical errors and adverse events. This is very important. I think Turkey should work on this topic. There's a lot of technology on that. One of the best in the world is the English or the UK reporting system, very interesting, and they implemented, I think 3 years ago or 4 years ago, reporting system at the national level for emergency care. This is very important. They have a report every year. And the most important keyword here in this talk is that 86% of hospital safety incidents are not reported. We have to report everything. People, they are afraid to report because they think that if I report, maybe they will fire me. Because the culture of blame is still in the healthcare system. We have to abolish the culture of blaming the people. And the objective with this reporting system is to be in the green part here, okay? And to improve the quality of care by using these metrics. In the hospital where I was in Boston, 5 years ago, they were very bad. They were in a green line, red line. They implemented quality and safety in all departments in the hospital. And now they are in the top. They are in the top now. They decrease medical errors. They decrease adverse events. That means it's possible. If there is a policy in the hospital, in each department, we can have this kind of achievement. But this is a very hard job. We have to do a continuous job. In the image department, you can read some papers, and this one is very good because this one is a systematic review, and you will see that the reporting of patient safety incident is from 0.36 to 6%. Not too much. I suspect that we are under-reporting adverse event and medical error, and 36% to 70% of these adverse events are preventable. And you know why? As I said yesterday, emergency medicine is a very special specialty. It's a unique specialty. In a short time, we manage patients, and we have to do the best for those patients. Organization is important. This is one of the examples in this hospital in Boston. It's a teamwork. You can see here, there's a QAI, Quality Improvement Committee, and this committee receives a lot of information from the reporting system everywhere, from patient complaint, from the data board in the file patient, from some criteria like you have on the top. And all of this system is connected with the hospital. They work together, administration, doctors, nurses, all professionals, to improve the quality of care. Here is the system. They have electronic system. It's very important. And with this system, you can flag. You click here. If you think that you did a mistake, you flag. I did a mistake, okay? Or I saw a mistake. You flag. Then the system will register you flag. This is very interesting. And then there is something happening in the computer. We'll give you some information here, and you click. You can also put some description. This is very interesting. This is the culture safety. All the professionals, they do the job. They understood that we have to report what we are doing in the emergency department, and we have to report our errors to be sure that we are not going to repeat the errors. You can put some indicators. For example, here, 72 hours return in the ED. You have a patient, you finish the management, and the patient go at home, for example. 3 days later, the patient come back. And then this could be a way to catch all the patients with medical errors. Or, for example, ICU transfer after 24 hours management in the ED. It's interesting. You can also measure the death 24 hours after the management. Look, we have a lot of indicators, and then you can rank the information from this flag system, reporting system. You can rank here, okay? And then, with this system, you publish. Research is very important. Without research, you will not improve quality and safety. I can guarantee you. Put effort in the research. And here, for example, patients with abdominal pain has a lot of medical errors and adverse events. You can see here, when you implement a reporting system, you can see here progressively there's an increase of number of adverse events. Increase, because you report. And this is good. This is good. It doesn't mean that you are not doing a good job. It means that you are reporting, okay? And you can compare different EDs here, okay? And you can see here that, for example, this one reports a lot of adverse events. This is very good. It doesn't mean that this one is a bad ED. It means that he's doing a good job. He's reporting to try to improve. What is the reality? We did a big study with 300,000 patients. You can see here, and we, from these 300,000, we flagged only 6,000 patients or adverse events. And you can see here that the most important indicator is the 72 ED return visit with adverse event. And the complaint from patient is increasing. Look, we have to encourage patient and family to also inform us that we did mistakes. We work together. We don't have to blame the professionals, and we don't blame the patient. We work together. It's very important. Transparency is important. Communication is important. And you can see here that the number of adverse events decreased over the year with this system because they implemented solution. But, you see, very important side. We don't know what happened here in the bottom. Oh, in the bottom here, in the hidden iceberg. We know what happened on the top there because it's visible. But many things appear here in the bottom, in the hidden iceberg. Evidence, we need evidence, we need research again, and again. We need to design, and we need to implement. And we are not very good in implementing what we've got from the research. Why? We need a continuous quality improvement. This is very important. Act, plan, do, check. This is the doing, the will, doing will. This is very important. You have to keep it in your mind. We have to be the best every day. We have to monitor also. And we have to use more and more. Yeah, more and more technology. More and more technology. But human is important. Without human, technology is nothing. And teamwork. Work together. We work together. And we have to work together, but in a right way. In the right way. Together in the same way. For me, this is personal. And I will be provocative. One of the problems we're facing in the healthcare system, we're increasing the administrators, a lot of CEOs, a lot of CIOs, CTO, a lot of people in the top, in the office, staying in the office, and we have a few doctors on the bottom and nurses. We have to increase this number over the number of administrators. I'm not saying that administrators are not good, but we need to have those people more, the doctors more and the nurse more. Last slide, last slide. If you want to go far, please go together. You have to be strong. And I like this animal. You know this animal. You cannot drink for maybe 1 month or 2 months. And you have to be a very strong emergency physician. Don't be afraid. Don't be afraid. You need a vision. Important. You have to look on the top. A vision to be excellent. We need spirituality. We need spirituality. Teamwork. We are not robots. We are human. It's very important. Thank you very much.
Thanks for your valuable presentation. Dear participant, is there any question or contribution? Okay. Mr. Ram, please.
Thank you very much, Dr. Bellew, for your nice talk. As we know, the one most important exhibition for a good quality is the supply and the request. The request that the patient are asking for us and the supply we have to present to them. I'm wondering if there is a criteria for a good approach for the number of the patients and the number of the staff in the emergency department. Is there any criteria for a good quality?
Yes, we unfortunately we are not so strong like the intensivist. The intensivist, they put everything in the law. In France, I can send you what we did for many years. I was very involved in the National Society in France. We wrote how many nurses, how many doctors we need for a number of patients. Okay? For example, we need for 150 patients a day. I know that we have more than 150. We need, for example, in my department, I used to ask my administration to have 30 senior, and 20 resident, but 30 senior, okay? In America, they're very strong, and they can't justify the number. In the department when I was working in Boston, 150, same than me, 57 senior doctor, and 34 resident. No, they are data. You can calculate the number. You cannot do quality and safety without resources. Impossible. I visited your department, Beset, 700 patients a day, and Bashar, I was in Istanbul, 3,500 patients a day. with a very small amount of doctors and nurses. Impossible. It's impossible. Donc you have to work with the government administration to get more and more and more doctors.
Hello, sir. So I wanted to add something to that, is that the National Accreditation Board of Hospitals and Healthcare Providers is like the Joint Commission for the US. In India, we have something like NABH, and National Accreditation Board of Hospitals and Healthcare Providers sits on ISQA as a national body representing India. And I think it's one of the only organizations in the world who has a separate accreditation for emergency department. So there is 109 benchmark accreditation. So what happens in the US or everywhere is when you do a joint commission accreditation of the hospital, they will do the whole hospital and then they will accredit you specifically for orthopedics, for cardiac, for critical care. But nowhere did they have a separate rating for emergency care. So because we were a part of ISQA and the red tape is less in India because of our new government, we went ahead and got experts together and we have 109 benchmark document for accreditation, and now over 45 departments in the country have a separate quality accreditation for emergency department only.
Yeah.
So you have a hospital accreditation, but if you want a rating for 5-star care, 4-star, you have a star rating through our national body for emergency medicine is the only one, as far as I know, in the whole world to give a separate accreditation.
Yeah, we have it in France too.
Yeah.
I was president of the evaluation committee for emergency care in France, and we wrote a book. We can translate. I want to translate the book in English, and this book presents all the metrics and everything. And we do audits every year in France, and we accredit emergency department. Last advice. I'm sorry. This is very important. Last advice. You have to create your own system of evaluation and accreditation. You don't need joint commission. You don't need to put a lot of money for those people. You create your agency. National Agency of Evaluation and Accreditation. Important. We have it in France, there's in England, there's everywhere, in India, everywhere. This is very important, very, very important. Because if you don't do that at the national level, it will be difficult for your country and your hospitals and departments to improve the quality. Very important.
Okay. Thanks for your excellent presentation and contribution.
Thank you.
Unfortunately, time is not enough. Okay.
So I'd like to introduce our next speaker, who's Dr. Ayman El-Manyar, who's the Director of Clinical Research in Trauma and Vascular Surgery at the Weill Cornell Medicine Hospital in Qatar. And he's going to be speaking on where are we in the management of ARDS.
Good morning. Thank you for inviting me for this session. As you know, in the intensive care, the most important complication, one of the most important complications is the ARDS with high fatality. So I'm going to summarize the management and where do we stand in this era. So before we discuss the management, we should know what is the ARDS and how to diagnose it. This is acute inflammatory syndrome with diffuse pulmonary edema and respiratory failure that cannot be explained by heart failure, but it can be combined. Acute onset of severe respiratory distress and cyanosis, which is refractory to the routine oxygen or regular oxygen therapy, with associated with diffuse X-ray, chest X-ray abnormality, and decreased lung compliance. The pathophysiology, it is acute inflammation affecting the gas exchange surface, which is very important for oxygenation, the alveolar capillary membrane. The resultant will be that exudate inactivates the surfactant, leading to the collapse and consolidation of the distal airspace with progressive loss of the lung gas exchange surface area. And you can see this how to diagnose from the chest X-ray with the diffuse lung obesity and CT scan. And also you can see what is the inflammatory role in this disaster or this disease. So it is not a disease, it is actually a syndrome. And because of this, there is no laboratory and imaging or gold standard diagnostic investigation of ARDS. It should be based on the clinical imaging and lab. So RDS is caused by a huge range of conditions, which consequence patients with ARDS are heterogeneous. It can develop in any patient in the intensive care. So there is a 4-point lung injury scoring system for quantifying ARDS severity, which based on the PEEP, the peak end expiratory pressure, the ratio of the partial pressure of oxygen to the fraction of inspired oxygen, also depend on the dynamic lung compliance and the degree of radiologic infiltration. The outcome is determined by the underlying cause, patient-specific factor and comorbidity, diabetic, hypertension, renal disease, and so on, lung disease, clinical management, and severity of illness. The survivor commonly suffer from muscle weakness and neuropsychiatric problem, and fewer than 50% return to work 1 year after leaving the ICU. But the mortality is very high. It reached 40%. This is from our center in Qatar. We collected the data from 2011 until 2018. It was 118 patients. And you can see the mortality group. The mortality is 40% in this group. And the only characteristic in this patient is the polytrauma and receiving too much blood transfusion. So back to the management, there is 10 topics based on the available guidelines. It discuss the corticosteroid, the ECMO, the extracorporeal carbon dioxide removal, fluid strategy in the management, high frequency oscillation, inhaled vasodilator, nitric oxide, lung protective ventilation, neuromuscular blocking agent, positive or the beep, prone position. So this is the 10 items for management. If you take the most important items like the steroid, and I looked for the guidelines, they mentioned some meta-analysis done for this. You can see the mortality is reduced using the corticosteroid, but is not statistically significant. For the ECMO, also the mortality reduced, but at the expense of the bleeding. There is too much bleeding, but the mortality is less. For the ACCOR, there is no meta-analysis so far about this. So the evidence about its role is very weak. For the conservative fluid strategy, using liberal fluid or diuretics versus diuretics as a policy, the mortality reduced, but it's not significant also. But we can see the renal dysfunction increase. For the high velocity oscillation, also we can see the mortality is increasing, either on hospital or 30 days mortality. For the inhaled nitric oxide or vasodilator, the mortality increased, but statistically not significant. Lower tidal volume compared to the higher tidal volume, the mortality increased, and mortality in 60 days increased, by in-hospital mortality reduced when we use low tidal volume. The barotrauma increased. For lower tidal volume plus higher beep, which is called the open lung approach, the mortality reduced. But infection is increased, which is not statistically significant. Using the muscle relaxant on this patient, the mortality reduced. But the patient developed more weakness, but statistically not significant. Higher beep, the mortality reduced. For prone position, the meta-analysis, all meta-analysis shows the mortality reduced by putting the patient in the prone position. So to summarize what we should do, the prone position strongly indicated, high frequency oscillation should be avoided. The higher beep, there is weak evidence but can be used. Muscle relaxant, it can be used but the evidence is weak. ECMO also can be used but evidence is still low. Inhaled vasodilator, the evidence is still low. Steroid and the ACCOR, it is mainly used till now for research purpose. So for mild, moderate, and severe ARDS, low tidal volume should be used, the prone position. For the moderate to severe, we can use the muscle relaxant. And for severe ARDS, ECMO is recommended. So this is to summarize again in the flow chart that increasing beep, reducing tidal volume, prone position, but in time fashion. I mean early is important. For ARDS with refractory hypoxemia, again, we should play with the ventilator setting, reducing the tidal volume, increasing the beep, and increasing respiratory rate, and consider neuromuscular block, muscle relaxant, and prone position. ECMO only for severe cases. And thank you very much.
Thanks very much for an excellent talk. Are there any questions?
Okay.
Yeah, in the interest of time, I think we'll go on to the next speaker. Thanks very much.
Final speaker, in my opinion, pioneer of emergency medicine, Poland and East Europe. According to me, an important topic in emergency medicine practice, when can I discharge my patient? Julius Jakubowski, stage is yours.
Thank you. Thank you very much for the invitation being here with you. I'm already 6th time on this conference and I'm very proud observing how you are progressing. Thank you, Bashar Sander, for being with us all the time here. I'm representing Poland, Polish Society for Emergency Medicine, Polish Academic Emergency Medicine, but at the same time emergency medicine section from European Union of Medical Specialties, which I'm a member of this board. That's my university new hospital where I'm coming from, a big hospital, saying true. The Polish emergency medicine was born in this area already 20 years ago. When I would remind you the definition of emergency medicine, which is still under discuss, to make this definition more exact, more proper, but still in the common days we are using this discipline, this definition, which I just combine definition of IFEM and European definition altogether. So as you see, it's a primary specialty established using the knowledge and skill required for prevention of diagnostic and management, urgent and emergency aspects, and so on. This includes organization, the proper medical responses for patients looking for urgent medical care. What is important in this definition, then the timing in this setting may be critical, either from side of the patient and from side of the medical point. Definition of emergency physician task is, of course, care for the patient with wide range of pathology from life-threatening. But the attendance and number of these patients is unpredictable and they mostly present with symptoms rather than diagnosis. Patient care includes physical, mental, and social aspects. So if focus on initial care until discharge or referral to other health professionals. So generally saying, emergency medicine addresses the comprehensive medical needs of all patients in emergency setting, prioritize interventions, coordinating, directing care for multiple patients at any one time. In other words, emergency physicians have a fundamental role in a modern healthcare system. That's typical view of referral emergency department, as my department is, for example. Growing number from hour to hour, growing number of ambulances with acute patients. This, of course, make a great pressure for emergency physicians working there. They are faced with numerous challenges. The first challenge is that limit of time. Time constraints occur because the severity and acuity of the illness, and also because the event presents worry that someone else will need the physician's attention. The second challenge for physicians is that they need to quickly assess and make therapeutic decisions on the basis of limited information. So emergency physician may also provide medical control for patients in the pre-hospital environment. Also need to determine what care was given prior to arrival and what impact to this intervention made. This is the classical model of emergency care for the patient passing through emergency department. There are 6 phases of this care, of this model, from one phase until the 6th one. So you see how the patient is passing through all facilities in emergency department. What we are observing, the first moment when patient is arriving, the triage, allocation to appropriate clinical area. This may happen on different settings, as you see, the resuscitation or acute treatment and subacute treatment and waiting room. Following development of emergency medicine, those 2 areas, acute treatment and subacute treatment, are growing on importance. And in fact, they are getting longer and longer with development of emergency medicine. This is also because, in between, also because there's a different mindset of emergency physician than other specialists, which means that emergency physician is concerning not necessarily the diagnosis, but process of thinking aimed at ruling in or ruling out serious pathology that are life or limb threatening. The evaluation of patients should proceed in a parallel fashion rather than time-honored method. So the mindset, the patient must be triaged and registered in the waiting room when there are beds available, must be abandoned. This is the relatively new philosophy of understanding the role of emergency physician inside emergency department having a new patient. It means that patients should be taken straight away to any available facilities with physician, eventually with a nurse or with another physician, to assess the patient, get history while patient is simultaneously having intravenous line, blood, all other procedures necessary in this concrete setting. So the single intervention, it is already well registered that intervention of in-room registration can decrease the length of stay of the patient for about 15 minutes on average. As you know, emergency department overcrowding is one of the plague of our daily practice. So a cornerstone of emergency physician practice is recognition of patterns in a patient presentation. That's why as we are understanding now, and it's more and more developed or underlined, that the prudent emergency physician must be a detective and scientist in the same time, or another one, Sherlock Holmes and Einstein, having the new patient and having another way of understanding of this patient. He has to muddle through the mug of vague signs and symptoms to find the real one, the real problem, the pattern of this concrete patient. It is well-known fact about emergency department patients that their presentation do not fit specific textbook diagnosis or classical presentation of illness. This we know from everyday practice. If you look to the most common presented symptoms from patients coming to emergency departments, there is a list. The list looks easy way and not very huge list, but if you look more details to each one of those points, you have to realize that each one of these manifestations in effect is another textbook. So to pass through this mass of possibilities, that's the art of emergency physician working in emergency department everyday practice. To pass through this, the main principle of this practice is to be able to state a simple questions that must be answered to provide effective care as a simple method to guide the emergency physician through the quagmire of clinical emergency medicine. So the first question which we are stating on the very beginning, seeing first time the patient, is the question, is this patient about to die? And that's the basic divagation. If he's a critical, having symptoms of life-threatening illness or injury which need to be immediate intervented, or is this patient emergent? His symptoms of illness or injury that may progress in severity treatment is not begun quickly. So usually following the, let's say, standards still existing as a standards, this moment relations between emergency physician first seeing the patient and the patient should not take more than about 10-15 minutes. And then the non-urgent patient, having low probability of progression, but still looking for symptoms and for life-threatening emergency, not a specific disease entity. You still need to anticipate impending life treatment. The next step, the next question is, what must be the next step undertaken to stabilize the patient? You must be quick, stabilize the critically or injured patient, focus on the primary survey, make necessary intervention, do not delay necessity primary intervention while awaiting completion of ancillary testing. Again, the main point of thinking for emergency physician. The third question is, if what you see, the serious case of the patient presentation, will this kill your patient or not yet? Maybe. This list is developed, you need to establish the history, examination broad, and ancillary assessment should identify to confirm if you are right or not. Then you are coming to another question, what saying true means if there are another multiple causes of the patient's presentation. It means if this what you see is the only what you see, or maybe there is something else which may be covered somewhere and you need to be closer observing a patient. There is example, very, very classical example. if they near syncope and abdominal pain, a young woman apparently intoxicated from rupture ectopic pregnancy, or maybe there is rupture spleen secondary to undisclosed physical abuse by her boyfriend. So again and again, frequent reassessment of patient condition is imperative. The next question, can a treat assist the diagnosis in otherwise undifferentiation illness? Often in emergency medicine, treatment response further before diagnosis. In emergency medicine, philosophy and established diagnosis is not a prerequisite to initiate appropriate treatment. So this, all those questions are running through your head during this second stage of patient's presentation in emergency department. And as I said before, this period is getting longer and longer in our daily practice in emergency departments, because we have more and more tools, first to diagnose, but then to intervene to the patients. In that point, I would like to underline that there is a changing character of emergency medicine. We are becoming more and more intensive care practitioners, which is very important, and in my opinion, it is the future of emergency medicine, become more and more practically intensive care area. So the further questions are if diagnosis is mandatory or even possible. Sometimes it's impossible. So you are treating the patients, you're having treating symptoms and excluding emergency condition without giving a specific diagnosis, and that's also normal. Does the patient need to be admitted to the hospital? You are coming to the final point, what to decide about this patient. Not always you are able to answer appropriately. So sometimes those questions are not answered. Once assessment and treatment are underway, decide whether an emergency condition exists. If you, as an emergency physician, are comfortable, not always. That's the point of your practice. So then you are coming to the final decision. What to do with the patients? Should he be hospitalized? Should he be discharged? Sometimes those patients are dying, which is, of course, one of the standards of our daily practice. Sometimes patients escape from emergency department, which also happened, without being seen by doctor or without following rules already given to him. So your responsibility mostly are in this area. Hospitalize him or discharge him. If patient is not admitted, disposition is safe and adequate. In many cases, more frequently than not, patients are discharged. And then the question, how this happened? How many patients do not receive specific diagnosis? How many and if any symptoms were persist? What is recommendation given to this patient? What is your final talk with the patient, disposition? Did you give him any advices, instructed him when to return for further evaluation, and so on? All those points should be documented. Documentation of your decision is very important. As Dr. Abdul Belou already said, this is a part of quality, documentation. And of course, this documentation, if it's good enough, it gives type of safety for you, for yourself as a physician, this decision giving. So risk assessment and disposition of the critically patient is guided by impression of clinical trajectory as well as presumed diagnosis. While diagnosis very often is based on information you receive from the patient, but also from your experience and intuition. So clinical picture is dictated by the state of tissue perfusion and patient ability to compensate physiologic perturbances. For example, if patient with positive troponin, ST segment changes, mean arterial pressure low, may be having simple coronary insufficiency, but another patient with the same signs is already in cardiogenic shock. So this is your art as a physician, as an emergency physician, as your intuition should decide how to interpret this, what you see with your patient. Or another example, low blood pressure in patient may result from therapeutic lowering of vascular tone. Sometimes when you are using sedation or analgesic sedation, this low pressure is just a result of your procedure. But same level of blood pressure in different individual patient may significantly distribute shock. So probably this patient may be in the first stage of sepsis. So differentiating these possibilities enable appropriate disposition and treatment, and is essential in the practice of emergency physician. Organ dysfunction arising from emergency critical illness can be treated to abnormalities in either one or both of the following physiological relationships. This is very important. Relationship between organ blood flow and mean arterial pressure. And another relation between oxygen supply and oxygen consumption. You need to realize in which state of this balance, in which point in this balance is your patient. You must be able to evaluate those two key hemostatic relationships: mean arterial pressure, blood flow, and oxygen supply to oxygen demand. These presentations are essential for your decision. Failure to do commonly results in misdiagnosis and delayed recognition of clinical deterioration. I will not go more to details, but you need to be able to recognize this patient consumption, in which state he is, oxygen delivery, which is again dependent from cardiac output, and oxygen content of arterial blood. Then cardiac output, stroke volume, contra heart rate, oxygen content that's determined by hemoglobin concentration and saturation, so those are classical points. So then evaluation of oxygen delivery, low stroke volume. Is this because of hypovolemia or maybe not? Maybe it's already because some constraints dedicated to status of heart and his vascular system. Then you need to evaluate blood pressure, which is low because of low cardiac volume or low systemic vascular resistance or opposite. Then again, your art of understanding what's going on with patients, observing him, will bring you to the final decision. The same evaluation of hemorrhage. I will not go more to this detail. This is our daily classical practice. So having this pressure and knowing that another group of patients waiting for you, you are working in type of, let's say, chaotic environments. So as already Abdel Belou taught some moments concerning errors which may occur in emergency department. So saying true, the emergency department environment is complex, time pressure and dynamic, and generally saying is the most environment, as people are saying, perfectly designed for errors to occur. This we should always remember. Nowhere else in medical practice...
Sorry, time is up.
Yeah, I'm coming to the end. Wait a moment. And this is the last one. We just need to understand and come back to hierarchy of factors influencing safety of clinical practice. Institutional context, organization, work environments, team factors, individual staff factors, task forces, patient factors, all those factors influencing our decision to discharge or not discharge your patient. Thank you for your attention, references. Thank you.
Thanks for your excellent presentation. Dear participant, is there any question? Unfortunately, one question, I think, or contribution.
No.
Okay, thanks.
Right, well, we'll let you all have your coffee break and see you again in 20 minutes or so. Thanks.
For the great presentation. I am Dr. Samir. I want to ask you, Doctor, do you use fibrinolytic therapy in the pre-hospital setting or care here in Turkey? Fibrinolytic therapy, or do you use tegretol or clopidogrel in the pre-hospital? Or if there is any study about to use it?
Sorry, I cannot hear it. The voice is very, it is not clear to me.
Hastane öncesinde fibrinotik kullanıyor musunuz diye sordu.
Yok, buraya sesli iyi gelmiyor.
Okay.
Geliyor da.
Do you use fibrinolytic therapy in the pre-hospital care in Turkey?
Yes.
Or,
Hocam siz cevap vermek istiyorsanız.
Yani siz de söyleyebilirsiniz geneline, çünkü Türkiye'nin geneline soruyor. Yani çok her tarafa biz de hakim değiliz çünkü sonuç itibariyle.
If your diagnosis is clear, is actually clear for pro-hospital, you are talking for pro-hospital, isn't it?
Yes.
Okay. If your diagnosis is clear, you have an ECG, and an ECG that the patient is ST elevation or non-ST elevation, it is possible to start to initiate this fibrinolytic treatment for pre-hospital. But actually, it is not common. It is not common. Some centers are using it. It's possible. There is no contraindication to use it.
and maybe there's
we do it.
Comment from my side. Sometimes if we have STEMI elevation, I think it's better to take the patient to cath lab direct without emergency department, so you save the time for it. Because we have in our practice, we have advanced unit who use ECG and STEMI, and we be on telephone or online with the cath lab if they have this patient.
You are completely right. We are completely agree with you, because the time is very important. That is mentioned in this slide. We have to do it. We are using it, but not the common.
Okay. Thank you very much. Thank you.
Any comment or question from the audience? We have foreigner listeners.
İngilizce geçiyoruz.
Evet. Ben sorayım o zaman. Yani salona sormak istiyorum. Biraz basit bir soru olacak ama acil serviste bunları başlamayan bir bölüm var mı? Niye sordum bunu? Çünkü bazı yerlerde kardiyologlar yapmayın, biz başlayacağız. Serviste biz, anjiyografide biz vereceğiz falan. Öyle yapan yerimiz var mı acil serviste? Olmadığını düşünüyorum. Olmaması gerekiyor. Demek ki yani doğru yoldayız. Bunu tekrarlıyorum. Bazı yerlerde kardiyologlar siz vermeyin. Biz işte anjiyografide vereceğiz. Serviste çıkınca vereceğiz. Ve yoğun bakıma çıkarınca vereceğiz. Böyle bir şey yapmayacağız. Burada zamanın ne kadar emniyetli olduğu burada vurgulandı. Dolayısıyla acil servislerde bunu başlayacağız. Başta bir şey söylemiştim. Onu sormak istiyorum. Anjiyografinin de acil serviste yapılması gerektiğine inanmayan var mı? Çok güzel. Herkes istiyor, değil mi? Buyurun.
Doktor Hakkan, ben şehir hastanesinde, Adana Şehir Eğitim Araştırma Hastanesi'nde çalışıyorum. Şimdi şehir hastanelerinin büyüklüğünü biliyoruz, yani yüz ölçümü olarak. Biz ilk taşındığımızda anjiyo ünitesinin acil servise mesafesi yaklaşık bir kilometrenin üzerinde. Ve asansör kullanıyorsunuz. Bayağı uzun koridorlardan geçiyorsunuz.
Acil servisten 1 kilometre ötede.
Ötede koroner
Başka bir mahallede
ünitesi.
yani.
Evet, biz mesela B bloğun biraz daha iç şeyindeyiz, bacağındayız. İşte koroner anjiyografi ünitesi 2 kat yukarıda ve A blok. Diğer tam tersi bir alanda bulunuyor. Şimdi bu mesafe tabii çok önemli. Bizim gece saat 2'de 3'te arrest nedeniyle gelip döndürdüğümüz zaman dirençli fibrilasyon nedeniyle işte hastayı transfer ederken anjiyo ünitesine birkaç kez defalarca defibrilasyon uygulamak zorunda kaldığımız ama buna rağmen kurtarabildiğimiz hastalarımız oldu anjiyoya yetiştirirken. Şimdi siz bunu söyleyince direkt 1-1,5 yıldır bu yaşadığımız mesafe sıkıntılarından dolayı aslında acil servislerde özellikle şimdi bir de ülkemizde şehir hastanelerinin yaygınlaşmasıyla beraber bunun ciddi gündeme gelmesi gerekir. Evet. Acil serviste koroner anjiyografinin olması bu önemli bir adım olacaktır. Ben bu anlamda hem şeyi söylemek isterim. Bir de ayrıca aslında biz hastane öncesi fibrinotikten önce hastane öncesi acil sağlık hizmetlerini yürüten arkadaşlarımızın aspirin kullanımı konusunda ciddi eksiklikleri var. Yani fibrinolizisten önce aspirinin kullanımında çok ciddi uygulama problemleri var. Ben sahada çalışan bir acil hekimi olarak gelen...
Destekliyorsunuz bunu.
Destekliyorum bir. İkincisi şunu sahada gördüğüm eksik. Gerçekten göğüs ağrısı, alt koroner sendromla gelen hastalara ne yazık ki hastane öncesinde aspirin dahi verilmiyor ne yazık ki.
Teşekkür ederim. Sağ olun. Şimdi burada bu konuyla ilgilenen firmalarımız var biliyorum. Ben herhangi bir firma veya ajan ismini zikretmeyeceğim. Ama yılda 139 milyon acil servis başvurularının olduğu bir yerde, bir ülkede ve bu akut koroner sendromu hastaların ilk başvurduğu yerlerin acil olduğu bir yerde ki gayet doğal bir şey. Yani bu firmaların veya bu ajanları bu ülkede satışa sunan firmaların nerede durmaları gerektiği, hiç çıkmamaları gereken yerin neresi olduğu, kendilerini çok iyi tanıtmaları gerektiği gayet net bir şekilde anlaşılıyor. Sanırım onlar da bu durumun farkındalar. Değillerse de olmaları gerekiyor mutlak surette. Adeta acil servislerin etrafında nöbet tutmaları gerekiyor. Başka bir soru daha alalım. Evet, şurada bir soru daha var.
Ben İstanbul Bakırköy Devlet Hastanesi'nden Doktor Taha. Ben de az önceki katkıya benzer bir katkıda ve gözlemde bulunmak isterim. Elbette ki bu konudaki araştırmalar çok değerli. Fibrinolitik tedaviler, antitrombotik tedaviler ve bunun farmakolojisi, bunun ekonomisi çok büyük ve değerli. Çünkü bu hastaları daha öncesinde müdahale ederek daha morbid ve mortal gitmesini önlemek devletlerin işte sağlık politikalarının, ekonomik harcamaların da önüne geçmek açısından değerli. Ama bence bundan daha değerli ve önemli olan bir şey var ki sizin de bahsettiğiniz gibi acil sağlık hizmetleri artık bu konuda primer temas noktası oldu bizim ülkemizde veya acil tıp olan birçok ülkede. Biz kardiyologlardan veya kardiyoloji eğitimi alan, eğitim araştırma hastanelerindeki asistanlardan veya alandaki herhangi bir kardiyoloji uzmanının olduğu merkezlerde göğüs ağrısıyla gelen sizin söylediğiniz sayıdaki hastalarla direkt temas eden klinik bizleriz. Dolayısıyla bu hastaları öncelikle görüp tanıması gereken, tanımadığımız zaman çok kötü sonuçlara giden sonuçlara ne yazık ki olabilecek yerler de bizleriz. Bence bu yüzden çok over diagnoz gittiğimiz bu şartlarda işte beta anjiyoların artık acillerde bile neredeyse beta anjiyolar çekilebilecek hale geldi. Veya markerların güdümünde gittiğimiz bir yerde bizim için hem farklılık oluşturan hem de en önemli şey olan ki öyle bir tanı var ki unstable angiopectoris diye hiçbir marker veya görüntüleme olmadan sadece hekimlik bilgisi, tecrübesi ve olaya olan şeyiyle, efektivitesiyle tanı koyulacak bir şey. Angina pectoris'i bile tanıyamadan bu konudaki kötü sonuçlara neden olmamamız için bizim bu konuda çok daha dikkatli olmamız lazım. Bu farmakolojik şeylerden önce diye düşünüyorum.
Evet, teşekkür ediyorum. Evet, kısaca yani Yunus Hocam'ın bahsettiği şeyi iki cümlede söylemem gerekirse yani benim anladığım kadarıyla akut koroner sendromlarda etkisinin erken başlamış, daha erken başlaması ve komplikasyonların daha az olması nedeniyle şu anda ticagrelor hakikaten önde görünüyor. Zaten çoğu merkezde aynı ajan kullanılıyor. Biz kendimiz de aynı şeyi kullanıyoruz. Eğer başka bir katkı yoksa ben bu oturumu kapatmak istiyorum. Çünkü hemen diğer oturumlara geçeceğiz. Bu arada bir şey duyurmak istiyorum. Biraz önce şurada da yansıdı. ATÜDER borç sınavı, 3. yazılı borç sınavı 12.40'da B salonunda yapılacak. İlgili olan uzman arkadaşlarımızı ve asistan arkadaşlarımıza duyurmak istiyoruz. Yunsur Hocam çok teşekkür ediyoruz tekrar.
Ben teşekkür ederim.
Sizlerin de katıldığınız için sizlere de çok teşekkür ediyorum. Çok sağ olun.
Can I just test the sound as well? Yes.
Of the end. But it is perhaps the end of the beginning. This is not the end. It is not even the beginning. of the end. But it is perhaps the end of the beginning. This is not the end. It is not even the beginning of the end. But it is perhaps the end of the beginning.
got a taste for something sweet. My daytime dress, your rolled up sleeves. There's something about your slick back hair. I feel the magic in the air. I can show you pretty things, waves on water glistening. Just take a breath. I can show you charm and style. We can go for miles and miles. No, don't forget, it's glamorous, so glamorous. It's glamorous. It's glamorous, so glamorous. It's glamorous. Diamonds in the sky, lovely lullabies. You know how I love to keep it classic. Sunsets on the sea, color changing leaves. You know how I love to keep it classic. You know how I love to keep it classic. I can show you pretty things, waves on water glistening. Just take a breath. I can show you charm and style. We can go for miles and miles, no don't forget. It's glamorous, so glamorous. It's glamorous. It's glamorous, so glamorous.
Welcome everyone to the afternoon session, starting with resuscitation. So we've got an exciting lineup for you today with some great speakers. I'm Paul Pajot from Canada, and this is Dr. Luis Garcia from Spain.
Thank you, Paul, for the introduction. Today we have the pleasure to have a group of speakers that are not only well-known but also friends of us, so it's a pleasure to chair and co-chair this session with two Pauls, I would say. So, to be on time, because we are a few minutes out of schedule, we are going to start with the first speaker. And I have the pleasure to introduce you Paul Kibela. He is the past president of ACEP, a well-known and friend of all of us. So please, Paul, you have the floor.
Well, thank you very much. I was asked to speak today about airway management. And in the United States, I do a lot on risk management and air reduction. And airway is one of the most stressful events that actually happen in the United States in the emergency department. In fact, in the hospital. And we talked a lot with my colleagues here, Luis, about what is value. And in the United States, the value of an intubation has been increased 3 times because of that stress value. And what I'm going to try to do is talk to you a little bit about how I approach a difficult airway and what to do when everything goes wrong. And I think the important thing here is to remember that there's a lot of options and there's not one single option, but you should have a strategy of how you deal with airways. You know, some airways that are going to be challenging when they come in. When you have the little old person that is flexed at the neck looking forward and has severe arthritis, you might want to anticipate a problem. And in the United States, we have a tremendous problem with obesity. And we will have patients come in sometimes that weigh 300 kilos or 400 kilos. And putting an airway in those patients can be extremely difficult. And so I'll talk about some of the strategies there. The other thing that can happen is patients can come in where they might have an airway problem. And there's some violence in Turkey, and this is my wife beating up a Roman gladiator at Aspendos. And so they might come in like this. And you don't know if this is going to be an airway problem or not. But with a broken jaw, with a crushed airway, they can oftentimes have a problem, so you have to suspect it. The other thing that happens, and this happens relatively commonly, unfortunately, as well, it's happened to me 4 or 5 times in my career, is you go into the airway and there's some type of cancer or a foreign body obstructing that airway. And that's when things get a little more scary because you weren't anticipating having a problem. And I'm sure in Turkey and the rest of the world, we all have a tremendous number of intubation assist devices. Pretty much everywhere, even when I go into Asia, they don't have a lot of technology, but they have glide scopes, they have CMAX, they have a lot of different devices. They also have LMAs, they have nasal airways, they have oral airways, and they have different types of stylets. In the US also we have basically flexible bronchoscopy that we now use to intubate as well. And I think the thing here that, again, I want to implore upon you is to really figure out what is easy for you and not to try to master all of these devices. And I think they say, they have an idiom that if you try to master or you try to learn everything, you will be a master of nothing. And you will lead to problems. So my personal favorite is the bougie. Why? Because it's usually always available every place I work. It's inexpensive and it's relatively useful to intubate around a tumor, to intubate, and it's sturdy enough that I can intubate if someone's bleeding blindly. So that's something that is my strategy. And if I do that, I will go to a surgical airway, and I'll spend a little bit of time talking about that as well. Still, if you do everything right, everything can still go wrong. And so one of the things that I want to implore upon everyone is, again, to look at whether this is an airflow problem, whether it's a breathing problem, whether the person is oxygenating, and so certainly monitoring is important. If the person is oxygenating and they're exchanging airway and you have a CO2 detector monitor on them, you have much more time than if their pulse ox is dropping quickly or they're accumulating oxygen, or accumulating, carbon dioxide. So that's the panic mode there. If they're oxygenating, the frequent thing that I do is to take time and reposition the patient. I think the main problem that I've seen when I've seen other people have problems intubating, they are not positioned appropriately. What happens oftentimes is their head is off to the side, or if they're obese, their airway is not opened all the way up and they're not dorsiflexed at the neck. So that is one of the problems. The second problem that I've seen is a lot of our patients, if I go to intubate them, guess what? They've been intubated before. And oftentimes from the trauma being intubated before, their airway may be narrowed already. And sometimes we also have now patients that come in, we're at a tertiary care center, and the patients are much older. They often have cancer and sometimes diabetes, and they've even had abscesses in the airway, which is highly problematic. The other issue that we're facing in the United States right now is a lot of our patients are no longer vaccinated. And so we're seeing some of the disease processes, including epiglottitis, that we thought were eliminated many, many years ago. So these things are all coming back to us. One of the things that I've learned particularly, and hopefully you don't have the same amount of problems that we do in the United States, is our patients can be very, very obese. They're very large, and getting an open airway can be a challenge. And oftentimes, if you don't have the right equipment, that can be very, very difficult. And I've been called to the floor one time when the anesthesiologist was unable to intubate the patient. The anesthesiologist actually left as I got there and ran to the operating room to get more equipment. I went in, positioned the patient appropriately, put something underneath their shoulders, got their head dorsiflexed, and I was able to intubate. And by the time the anesthesiologist had came back with the equipment, I already had the patient intubated and I had left and gone back to the emergency department. So again, I think the important thing here is to make sure that if you position the patient appropriately, you can eliminate a lot of the problems. And if the patient's oxygenating, you have time to do that. As I mentioned, it's certainly helpful to have a monitor on the patient. One of the things that we do is fortunately, we oftentimes have respiratory and other therapy that are able to help us monitor so we know how much time we have. Because I think the important thing here is also not to panic in these situations, even though this can be an extremely stressful situation. So if the patient's still not oxygenating and there's still an airway exchange issue, you can try these various devices. As I mentioned, my favorite is the bougie. I can work that around a lot of tumors, around a hematoma, around an abscess, and that works well for me. And one of the things I try to do every year is, even on a normal patient, I try to practice using that bougie. And I would recommend all of you that if you're going to have a strategy, that you practice it. Because if you don't practice it and then you have to use it, that can be as stressful as having nothing at all. So again, whatever strategy you use, I think it's important to practice that at the same time, even on normal patients, even though you may not need it, because when you need it, you need to be able to feel comfortable using that procedure. Some of the other things that happen, again, is bag valve mask. Oftentimes, I've gotten to patients and they seem to be oxygenating appropriately, and I've been called in to say, do you need to intubate this patient? Well, if their oxygen is okay and their carbon dioxide is okay, the question is, do they really need to be intubated? Oftentimes they do, but sometimes if the patient is actually on medications, sometimes we can forego that. So there may not need to be that necessary. I know a lot of my colleagues actually use LMAs or oral airways, just to maintain that until they find out whether the patient actually truly needs to be intubated. Nasal airways, I have to say, I grew up with those. I rarely use them anymore. Why? I think we're all forced to kind of move to a definitive airway. And I can understand that as we have less and less support resources, that oftentimes that's the way we go, or oftentimes we go to CPAP or another type of airway addition. There are some people that use a retrograde airway. And I have to say, I've practiced this before on models and mannequins, but I've never actually done it. And so I'd be very hesitant in an emergency situation to do something that I really haven't done or feel comfortable doing. And certainly the thing that you always need to be ready to do, and this is my go-to, is to go to a surgical airway or a cricothyroidotomy or even a tracheostomy. The issue here with this is when everything fails, the surgical airway, you need to be able to feel comfortable to do it and to do it very, very quickly. You know, certainly the patient that we have that has airway hemorrhage, it's like the patient that had the trauma. When there's a lot of blood back there in the back of the airway, a lot of these fiber optic scopes, a lot of these intubation assist devices are not very helpful. Secondly, when you actually go to open the jaw and the entire face moves, that's also a patient that you want to be very careful. You can sometimes intubate orally, but oftentimes it's a problem. The other thing that rarely happens is we do have patients with facial cancers and laryngeal cancers where their anatomy, you look in there and you don't even know what you're looking at. And that can be further problematic. We also have several patients that will come in with either allergic reactions or genetic problems where they actually can develop edema in their airway. And certainly the thing that I see probably most commonly here as well is unfortunately is tumors and abscesses that honestly I never saw in the first part of my career, but I tend to see more commonly. Some of the problems of not doing these include, you know, young of age. So if there are absolute contraindications, there's anatomy, there's hematomas, and obviously coagulopathies. The other thing is, once you have to decide is if you're going to go to a surgical airway, you have to decide what to do. Classically, as emergency physicians, we're trained to do cricothyroidotomies. And that is an easy airway, relatively speaking. How many have you done a cricothyroidotomy? A number of you have. How many of you done a tracheostomy? And I think the challenge here, not a lot of you have done it, is one of the problems that you have is when you look in the airway, and if you cannot see the cords and something's coming from behind the cords, you're going to have to decide whether you should try a cricothyroidotomy or go to a tracheostomy. Unfortunately, I've had patients before where I looked and I could see the tumor coming from behind the cords towards me. And I knew at that point in time that had I done a cricothyroidotomy, I'd very likely be cutting into a tumor and potentially making the dry airway that's occluded now a bloody occluded airway. And so I think at that point in time you have to be comfortable not just being able to do a cricothyroidotomy, but also to do a tracheostomy. It's interesting as I did this lecture that a tracheotomy was actually described centuries ago that had been done with airway obstructions and had been done successfully. So this is not a new procedure. This is not a complicated procedure. It does not require a lot of technology. It's really an issue of understanding the anatomy and feeling comfortable doing this. And I think that's the important aspect here. There's a lot of kits out there in the market, and in the United States it seems like every year there's a new kit in the emergency department that I'm not familiar with because they've changed it since every time someone does one, which is relatively uncommon, there's a new kit. Personally, I've opened up the kits and I didn't even know what was inside half of them. I personally like it if it's very, very simple. I try to use either a tracheostomy tube or a 6-0 ET tube. I try to use an 11-blade scalpel if it's available, and a pair of hemostats. A lot of people said, well, there's suture material. Well, heck, if I just get the airway in, we'll figure out how to secure it later. I've used tape, I've used suture, I've used a lot of different things to try to hold it in place. I've had people just hold it in place till the patient got to the operating room. So there's a lot of different options there. So for me personally, I'm a pretty simple person. I like it basic. I wish they just gave me the basics of a scalpel and hemostats and some material to clean the area rather than a complicated kit that I'm not sure what's going to be inside. The steps are also relatively easy, and I think it behooves all of us to understand the anatomy. And some of the problems is sometimes is that if you get an obese person, you're not going to feel any anatomy. So oftentimes when I've done that is I'm feeling it on myself, judge approximately where that is, make a larger suture. If you can feel the cricoid membrane, I've done it with as small as a 2-centimeter vertical incision, but sometimes in a larger person, I've done 5 or almost 7 centimeters to cut down to where the cricothyroid membrane is. And once you visualize it, honestly, maybe I've been pretty lucky. And again, it's positioning the patient in the right manner. I found it relatively simple, and honestly, it looks very, very similar to this when I've found it. The third step that I do is I actually use the scalpel. I make another vertical incision there, and I use the back end of the scalpel. And then what I do is I either insert that tracheostomy tube or I use a set of hemostats, and I then place the tube in there, and making sure always to go caudal towards the person's feet. You want to not make sure you're going up cephalad, because you can actually wound or injure the vocal cords. So if you make sure you're always going down lower, I've never really had any of the bleeding problems that people talk about. But again, I think the important thing here is, again, positioning and stay completely in the midline as always. I'm not sure I'm going to the next slide here. I think I'm frozen. Oops. I was going to have a video here, but I think I'm having some Turkish internet issues here with a link. Here we go. Anyways, the video is very similar to this. It shows the procedure in action, but it can go very, very quickly. And I think, you know, this is how I would do things, and I would be prepared to do this. And if you don't do this every 3 or 4 years, I think the important thing is to actually practice this. Do it on a mannequin. Do it on a cadaver. Have you done cadaver labs, any of you? If you have an opportunity, or if you come to the ACEP meeting, they actually have live cadavers. And to actually see this in person is something that's worth at least looking at every couple of years, just because it's such an infrequent procedure. But again, it can be extremely life-saving. And here, I invite you again. I know a lot of people have invited you to their courses. The American College of Emergency Physicians meeting does have a cadaver lab where they do practice cricothyroidotomies there, and you can actually do one on a cadaver. I'd encourage you to sign up for that early, as that's one of our courses that sells out every year. And again, encourage you also to even consider international membership in ACEP. And I think I have a minute here for questions, or I can hold them for the end. Thank you very much. Takashura Dira.
Thank you, Dr. Kivela, for your clarifying presentation. Is there any question from the audience? If we have some time at the end, we will put all the questions together to save time. So thank you again. Now, our next speaker is Dr. Paul Paquet, the past president of the Canadian Association for Emergency Medicine, that is going to introduce us in the world of extracorporeal cardiopulmonary resuscitation. The floor is yours, Paul.
Thank you. Thank you. So it's an honor to speak here today, and thank you to Dr. Basar Kandar for asking me to come. It's actually it's a topic that was relatively new to me, extracorporeal cardiopulmonary resuscitation and trauma, and the initial title had when to initiate, but I would add also if to initiate. So I'm from Ottawa. It's the capital of Canada. It's a beautiful place. In Canada, we have universal health care, where we have a single payer, which is the government, for all essential health services. So there's often quite a balance between universality and accessibility. We place a high value on, or we value the cost per life saved and the cost of morbidity prevented. This is where I work, at the Ottawa Civic Campus of the Ottawa Hospital. It's a tertiary care facility, level 1 trauma. We have cardiac surgery, we have primary PCI, and we have a cardiac ICU. So coming from that lens, the objectives of the next 20 minutes here is describe how extracorporeal cardiopulmonary resuscitation can be used in severe trauma and traumatic arrest. Identify which trauma patients may benefit from ECPR, and recognize the system resources for ECPR in traumatic arrest. So I do have to oversimplify things, and my apologies to those of you who use ECMO and ECPR already, but essentially ECPR is the use of ECMO as a resuscitation tool. And we all know our major traumas and how chaotic that can be, and we're adding in another complexity to that chaos. Again, to oversimplify, I'm going to talk about the two main types of ECMO that are used in the emergency department. The veno-venous ECMO, which involves a line in the femoral vein and a line in the upper central vein. Basically, it's taking blood from the IVC out through the femoral vein, running it through an oxygenator, and then pumped back into the SVC through a central vein in the upper body. Veno-arterial ECMO is a little bit different. In the emergency department setting, this often involves two lines in the groin. So a line in the femoral vein, which again draws blood from the IVC, runs through a pump, an oxygenator, a gas exchange, and so temperature regulation, and then inserted back in through the femoral artery and deposited in the mid-artery, where through retrograde flow, it perfuses the brain and the vital organs. So one important concept with ECMO and the emergency department is ECMO does not heal, it buys time. And I think we've seen this best with our out-of-hospital cardiac arrest. Although the data is accumulating and not definitive, it does demonstrate that ECMO in the refractory VFib arrest may play a role. It's actually buying some time until you can get a primary PCI for that patient, and there's been some extraordinary results. I would say, though, there are defined patient populations where this works best, and I'd keep that in mind as we think about the traumatic patient. So through a fairly large registry, Debetti et al. From France looked at hundreds of patients and found that there were some indicators of success. And these include less than 10 minutes of no flow state, which is no CPR, and less than 60 minutes of CPR would benefit most. There's also some biochemical parameters, which include a pH of greater than 7 and a lactic acid less than 13. There's another interesting phenomenon that also Debati talks about is the signs of life. So that's a patient that, while CPR is ongoing, you get some pupillary restriction. You also get perhaps some movement. And I think we've all seen this when we've done CPR. The patient seems to be responding even though they have a non-perfusing rhythm. Or the other indication would be agonal breathing. So all these things together tell us that the patient may have a very good outcome. And in Canada, we deal with severe hypothermia, perhaps more frequently than other places in the world, and ECMO has played a successful role in that as well. So let's turn back to trauma again. So the veno-venous ECMO in trauma. There seems to be the best data, and that's been summarized by Bosarge et al. In 2016, mainly in ARDS, severe pulmonary hemorrhage, transfusion-associated lung injury, and lung contusion. So these are all gas exchange problems that it's been shown benefit. In veno-arterial ECMO in trauma, I think it's very debatable whether it's helpful. Perhaps this plays a role in cardiogenic shock in your trauma patient, refractory shock in your trauma patient, the one you can't get ahead of with your blood products. Perhaps it's a bridge to damage control surgery. One of the issues with ECMO and why it's not been looked at for many years is ECMO does require systemic heparin. And that is probably the last drug I want to give my hemorrhaging trauma patients is systemic heparin. But there's been advances over the years. There's heparin-infused lines in the ECMO circuitry. And there's been some case reports of running ECMO in the severe trauma patient without systemic heparin, and there's been some success. Again, not randomized controlled trials, but some reported success, and Mullenbach summarized that in 2012. So let's talk for a minute about the lethal triad of trauma. We know with poor perfusion and hypovolemia, we get acidosis. From that acidosis and from the other aspects of the trauma, the blood loss, you'll get hypothermia, and that affects your coagulation and you become coagulopathic. Further bleeding, causing poor perfusion, more acidosis, and the cycle goes around. So I want you to think for a minute the concept of taking physiological control of the patient. So controlling some of these factors so that you can change this spiral. The example would be you improve perfusion with a veno-arterial ECMO. In there, you would have less acidosis, you'd have better myocardial perfusion, you can control temperature as well and have less hypothermia and have decreased coagulopathy. So this is Dr. Magnus Larsson from Sweden. He has been championing this idea of taking physiologic control of the patient, and he's seen here with one of his ECMO survivors, by instituting ECMO in the severe trauma patient. But he's only shown most success with rabbits, unfortunately, at the moment. His experiments to this point have involved traumatizing a rabbit, removing half their blood volume, and then waiting for an hour, and then either routine post-rabbit trauma care or routine post-trauma care with ECMO. And he's actually proven that point in animals, that if he takes physiologic control, he'll drastically improve their outcomes. And he summarized that in 2016. So he's now working on human patients. More on that to come in the years, I'm sure. So the next thing I want to consider is traumatic arrest. So imagine for a minute you're penetrating trauma patient, and either just before arriving to your emergency department or as they enter the emergency department, they go into cardiac arrest. No, ATLS guidelines do tell us that we have a systematic approach to these patients, but I would argue that CPR in a low volume state is not very effective, and I'm not sure if anybody else has had success with closed compressions on an empty tank. But I think we still do have this systemic approach to these patients. We're infusing as much blood products as possible in a 1-to-1-to-1 ratio of blood cells, platelets, and plasma. We do bilateral needle decompressions or finger thoracostomy in the 5th intercostal space. We do emergency thoracotomy, usually on the left-hand side. And if we see a cardiac pericardium full of blood, we open that and hopefully release cardiac tamponade. If we see a major cardiac injury that we can repair, we might do that, or potentially a major vessel. From there, internal cardiac massage, cross-clamping the aorta, and potentially internal defibrillation. You may end up at this at the end of your algorithm. Basically, a non-beating heart, an open chest, and you're wondering, that's it, what are we gonna do now? And I think you're right, and that's often the endpoint to many of our patients who go through this trauma pathway. But there's some interesting things. This is actually where we get a little bit experimental and perhaps science fiction. There's a concept of suspended animation. So Tischerman in Baltimore is working on a protocol at the moment where he takes these patients and he cools them immediately to 10 degrees, takes them to the OR, damage control surgery to repair and improve hemostasis, and then puts them on pump. So it does sound a little bit unreal, and he's not had data to report yet, but the trial is ongoing. And although they look really friendly, these two gentlemen essentially are operating on cold, dead bodies with the goal of improving outcomes. So I just want to go through their algorithm just to give you a sneak idea of what's coming. It's actually quite fascinating what they're doing, and it's initially funded by the US military. So a patient has a traumatic cardiac arrest. They have an ED thoracotomy. No response from that. It meets their criteria for enrollment, and the team is available. Then the aorta gets cannulized through the open thoracotomy. Immediately flushed with cold saline, and the patient's cooled to 10 degrees. They're transported to the OR. Hemostasis surgery is attempted. And then they're put on cardiopulmonary bypass pump at that point and rewarmed. It sounds a little bit quite astounding that may happen. They are showing some results in animal studies and ongoing recruitment in patients. And these are patients that would be non-salvageable after their open thoracotomy. It requires a huge team. So not only with this protocol, but with all ECMO, you need a coordinated and well-functioning team if you want to use ECMO in the emergency department. And remember, this is a setting that is often can be quite chaotic. You of course need your emergency physician, you need your trauma and cardiac surgeons, perfusionists, trauma anesthetists, and your ED and OR nurses. It's suggested actually that a lot of simulation training is done for providing ECMO in the emergency department, and repeated simulation training, and mapping out what each step is along the way. So, in summary, ECPR is essentially ECMO in the trauma emergency department, or ECMO in the emergency department. In the trauma setting, acute lung injury with refractory hypoxia appears to show the most benefit with the best evidence. However, I look forward to the future where we may see ECMO used more freely in the exsanguinating multi-trauma patient to control that physiological spiral of the lethal triad. And potentially even in the future, we can look at traumatic cardiac arrest and the role of ECMO for these patients. Thank you, and here's some resources for you.
Thank you, Dr. Paquet, for your clarifying presentation and for putting us the view in the future and how can be the treatment of these very specific patients. Is there any question from the floor? Again, at the end of this session, we will have some time to put all the questions together, and if there is anyone. Thank you, Dr. Paquet, again.
All right, now I'm wearing my other hat. So as the next speaker prepares, I'll take a moment to introduce them. So many of you know Dr. Roger Dickerson. He's an emergency physician and intensivist. He's recently relocated to beautiful Cape Town. He's the past president of the College of Emergency Medicine of South Africa. And I'm really looking forward to him answering this question of, is adrenaline falling from grace? Please welcome Dr. Roger Dickerson.
Paul, thank you so much for that very warm welcome. It is an absolute pleasure to be in Antalya once again and to be able to catch up with people who've become fast friends. But let's get going. Just to get a bit into the mood, did anyone find their pulse rate rising a little bit when they heard that music? You could say that's adrenaline. This is my hometown now, and in fact this is my hospital that is based right in the Cape Town waterfront and sits squarely between the Cape Town waterfront and Table Mountain. But what I'm going to be focusing on for the next 45 years or so is whether adrenaline is in fact falling from grace. And it is in fact a difficult question to answer. I don't have anything to disclose other than the fact that I am an emergency doctor. and I come with the requisite warnings that need caffeine in order to maintain function. In the beginning, there was death, and we didn't know what to do. And it created great stress in our lives because we were not able to manage this concept of death, to prevent death, or get people back once they had already, in fact, died. And this created great stress in our lives. We didn't know what to do. And then came a fantastic moment. And this moment brought together several unique factors. And it was the year 1898. And what in fact we saw was the discovery of radium by Marie Curie. We saw the patenting of cornflakes by William Kellogg's. We saw the proclamation of the city of New York. And we saw the land speed record being set at a blistering 6